focal lesion not involving the
Yeah, but
ostial
then leave
proximal
the
part.
ostium and proximal stent, proximal part free of the stent, go little distal so that you don't end up doing a bifurcation. And decide if you want to go for bifurcation, come into left main, do crush stenting or some mini crush and then finish it off. So try initially to decide whether you want to go for bifurcation or not, and then do decide strategy accordingly. You protected the vessels with the wire, that was a nice thing.
Yeah, you said it's a focal lesion in diagonal.
Yes, sir.
So you should have stented only that part.
Yes.
You brought the stent very close to the LAD.
Yes. Yes.
And this uncovered part of the ostium and diagonal junction is going to give you trouble after a few months with the restenosis.
What do you say about using DEB in diagonal instead of putting a stent?
Yes, a good option, sir. Because
Okay. Can we have the second speaker, please?
Thank you,
Second presenter. Dr. Praveen Kumar, again second year from IGIMS. While he's loading the presentation, there is a very strong wind blowing in favor of DEB. It's a very strong wind that avoid the second stent as much as possible. So if there is a lesion which is not very critical, not in the main vessel, then DEB always remains a very good option. Very good option, because stent is producing another disease. There is no doubt about that. What is the opinion of Dr. Goyal and Sandeep? Good morning to all of you.
But my personal experience, I don't do DEB. That I have to admit and commit what I do. I don't do DEB. And wherever I see patients who have had DEB here, there in different centers, I am yet to see a patient whose DEB is continuing okay. This is my, but I know literature talks of some DEB. Earlier it used to be only small vessel. Now they're talking of trying to avoid a stent and use DEB. But I am not very convinced about
at the moment.
Yes.
Actually, I am Dr. Pradap. I have a different opinion. In a bifurcation lesion, especially when I do LM bifurcation now, ostial circ, if it is very tight, I just do a cutting balloon. I don't think actually in a ACS where the finances is a big problem, you can't do these things. Cutting balloon and then just do a DEB on that and then leave it. And patients are doing very well. We have check and juice also done. But this is actually the DEB which is available for the last nearly 7-8 years in India. Now it has become very prominent because this is taken up by Dr. Colombo. That is why now that is why people are telling it's a wonderful device. We are using this thing for a long time. Probably, as Dr. Goyal told, there are two aspects of that. Whether simple balloon angioplasty would have done the same trick or not, which we don't know. So it is a tricky question. But in bifurcation lesion, where you have a real tough situation in the ostial lesion, which is only less than 5 millimeters and very tight, TIMI flow is less, you can actually definitely try. But in normal vessels, proximal LAD, I think it is a question mark.
Yeah, sure. So DEB, I'm sure we'll have more discussions on DEB. It's a very upcoming, and the DEB technology has improved.
Yeah.
The latest DEB balloons are much better than what we used to have.
If you allow me a minute,
Yeah,
actually
sure.
I'm a little more aware because I did a talk on this topic in a recent national conference. So one thing we need to understand that the strongest and the only proven indication is ISR. That's a class 1 indication. If you have an ISR, as you rightly said, don't put in another metal. do the DEB, particularly if it is a neointimal hyperplasia. All the more the reason you should do DEB. Use a cutting balloon, do the DEB, that's the strongest indication. The second thing is that till now we had only paclitaxel based balloons. But now the pharmacokinetics and the drug delivery methods have changed so well that you have nanoparticle based drug-eluting balloons. So even sirolimus is now being used. In fact, the first sirolimus-based balloon was approved by the US FDA as late as March 24. So they have been tried in every single situation, including what he is doing. A very popular indication is if you're doing a bifurcation, stent the main vessel, DEB the branch. That's absolutely in thing. People have used it even in calcified vessels, total occlusions, every place people have tried DEB. But to say everybody will convincingly be able to use it, the answer is no.
So
Not in every situation.
It's an evolving technique.
It's an evolving
It's the bed
technique,
preparation
sure.
again, which is extremely important.
Sure. So the
recommendation is that the lesion should be 1:1 when you're putting.
Yes.
So once you have reached that,
Yes.
and then you are putting a DEB,
Yes.
especially with these newer techniques where it is for 3 months.
Yes.
The
So
previous one was only for 24 hours or so.
So the important point is you've not had a major dissection after you've dilated 1:1. That is the kind of patient where you like to do the DEB. Otherwise,
Even for dissection, I'll tell you.
yeah,
I'll
also
tell
there.
you that unless and until it's in a spiral and flow limiting, you should
dissection.
leave that.
Sure, sure.
There is an elegant study where they have studied more than 100 patients with dissections, and majority of them have actually healed. And the another beautiful thing is that there is a post-DEB dilatation of the vessel, like which we used to see with BMS. There is a luminal gain
Yes,
over a period
yes,
of time.
yes.
So DEB is a beautiful.
Yes, it is
I am a
advancing.
great fan of DEB.
Sure.
So I use it very frequently. Almost 20% of my patients have DEB. Multi-vessel, one stent, one DEB. So let's go to the presentation, please.
Good morning, everyone. First of all, I would like to thank Dr. Ravi Vishnu Prasad sir, Professor and Head Department of Cardiology, IGMS Patna, and my other faculties, Dr. Neerav Kumar sir, Dr. Gautam Kumar sir, Dr. Bhanu Chandan sir, Dr. Sambhu sir, and all esteemed dignitaries, my seniors and colleagues. This case was done in my department. This was the case of a percutaneous balloon valvuloplasty with Inoue balloon technique in a patient with pulmonary valve stenosis. So this patient, Riva Kumari, 16-year-old female, presented to our OPD with chief complaint of dyspnea on exertion and fatigue on exertion. On examination, systolic ejection murmur was present in left upper parasternal region. Along with right ventricular lift was also palpable, and patient was sent for echo assessment, and on echo assessment pulmonary valves were thickened and doming was present. There was also post-stenotic dilatations, and on Doppler studies the peak gradient was of around 70 mm of Hg with Vmax more than 4 millimeter per second. On further assessment, there was no significant regurgitant lesion, pulmonary regurgitation, and no other associated congenital anomaly was present. So the plan was to go for valvuloplasty. Previously, we used Tysec balloon for pulmonary valvuloplasty, but the disadvantage of the balloon was that it takes more time, have stretch-induced injury to vessels. There is balloon slippage issues and more frequently injuring the pulmonary valves. So we decided to go with the Inoue balloon, which is commonly used in mitral valve. It is basically a 2-layer of latex and a fine layer of nylon mesh sandwich. It has a good built-in safety margin. So balloon size was decided using the balloon to annulus ratio, which is ideally 1.2 to 1.25. In our case, the annulus was around 19 mm, so we decided to go with the balloon size of 24 mm. So after taking total aseptic precaution and giving adequate anticoagulation, femoral vein was punctured, 6 French sheath was placed, and a guide wire was introduced through IVC to RA to RV, crossed pulmonary valve and placed into pulmonary artery digitally. After which multi-purpose catheter was introduced and secured in RBOT and along distal pulmonary arteries. The guide wire was removed and a spring wire was introduced and it was secured in distal pulmonary artery. So this is spring wire in the distal pulmonary artery, multipurpose catheter removed, and now the Inouye balloon was introduced over the wire. Once it crossed the pulmonary valve, we removed the spring balloon, a spring wire, and dilated the Inouye balloon using 3 atmospheric pressure. So after inflation, a tug was created around the pulmonary valve, and after that angio was performed. We don't have angio seen here, but after procedure it was seen that the peak gradient decreased to 28 mm of Hg. Previously it was around 70 mm of Hg, and there was mild PR after procedure. So there was no complication during the procedure except mild PR. Thank you.
There is a steel tube inside that Inouye balloon. So you remove the steel tube after you cross the valve, isn't it?
Yes.
So that is, well, you did it all right in the sense it was okay, but we can't keep doing like that because the steel tube has to go through the tricuspid valve, come from the IVC, tricuspid valve, and then go into the pulmonary valve. 2 bends. So that is not a good thing. So what is required is that the steel tube should be removed before you get into the tricuspid valve. So the balloon will become small, short, but it will go over the wire, no problem. It will go over the wire and it will cross the valve also. So the steel tube should be removed first. Second thing is, you have a choice of that Inouye wire that you put in. Now Inouye wire has a big loop. Pulmonary artery and distal pulmonary artery don't have that much space. So it can damage that area. You know, it's a big loop. So what you can still do with the Inouye balloon, you take an extra stiff wire. So once you have crossed the valve and you have a multi-purpose catheter or something, put an extra stiff, extra support wire in the pulmonary artery. And then from the groin itself, when you take the Inouye balloon, do not have the steel tube at all. You don't have the steel tube. The shaft of the this extra support wire is strong enough to stretch that balloon when you are entering the groin. You know, that's the time you need some strength and straight, stiff part. So that wire itself will act as the support, and you stretch that balloon on that wire only, instead of a steel tube. And then it goes all the way, and then you do the job. So these are two things. Next time when you do, think about these two things. Okay?
The only advantage I see in this is that the stabilization is probably a little better. You know, if you're using a tie shack, you may have to actually pace the right ventricle.
Yeah, tie shack jumps up and down.
Otherwise, I don't see any advantage of using any now.
No, but this
It's
can
more
be
expensive
used.
also.
No,
It's much more expensive.
This is reusable. So without any cost, you can do it. Because
In
Inoi
our- in
balloon is
ours,
always there.
reusability is not very good. I tell you.
I don't know. Because I do it the same with Inoi balloon only. That is. And the reusability is quite a lot, and here you don't need much this thing. So it works very well.
But I wanted to tell a technical problem. You should not never mention the name of the patient.
Yeah.
Actually, that is very bad, because actually this is legally is not correct.
So again, take it as your training. Don't take it otherwise. This is all part of your training.
See, one small thing I had learnt during my DM and practiced it thereafter. When you've taken the picture in lateral view, see, where does the main problem arise? We don't know where exactly to position the center of a tie shack. So what trick I play is, when we've taken the picture in the lateral view, I generally use a normal needle that we have, the injection needle, and I position it in the place where you see the pulmonary annulus, and that acts as a guide. That's a perfect guide. You bring the center of the tie shack balloon there, you never ever miss the positioning does not become a problem.
We used to do that for peripherals.
Yes.
We still do it for peripherals.
What you do is you push the Inoi balloon across all the way down. No. हाँ. अच्छा, tie shack. हाँ. करके हाँ.
Okay, thank you very much. So this session is over. Okay, thank you very much.
Thank you, Honorable Chairpersons. With this, we conclude the CD presentation session. Moving ahead, we had the first session on imaging. For this, I would request our Honorable Chairpersons to kindly grace the stage, calling on Professor Dr. D.S. Chadha. He is Professor and Head from Manipal Hospital, Bengaluru. He'll also be a Master Faculty and Speaker for this session. Dr. B.P. Singh, ex-Vice President, CSI Bihar, Chapter, former Head of Department and Professor Cardiology from IJIMS Patna. Dr. Anupama Bambani, who's Head of the Department Cardiology from AIIMS Patna. Dr. P.C. Sinha, Consultant Cardiologist from Patna. Dr. Amir Kazmi, Consultant CTVS Surgeon from Heart Hospital, Patna. Dr. Ram Sagar Roy, Consultant Cardiologist from HDNA, Patna. And Dr. Amit Kumar, who is a Consultant Cardiologist from Ash Hospital, Gaya. Over to you, Honorable Chairpersons.
Next speaker is Dr. Gautam Kumar, will present it about IVUS guided osteal LED stenting. Dr. Gautam, please.
A warm good morning to one and all present here. It's my great pleasure to being part of this event. Respected chairpersons, all the dignitaries, and my dear colleague. Today I am presenting a case of intravascular ultrasound guided osteal left anterior descending percutaneous coronary intervention, crossover left main LED stenting technique. This is case detail. 42 years old hypertensive diabetic female patient presented with non-ST elevation MI she did have normal ejection fraction. Her clinical examination was unremarkable. Diagnostic angiography shows significant ostial LAD lesion with mild plaquing in distal left main as well as in the ostial left circumflex. In different projection, you can see intermediate lesion in the inferior branch of the mid LAD, which is a dual LAD sort of thing, and right coronary artery was normal. Regarding procedural plan, clearly the key lesion is ostial LAD. So when we are going to treat a bifurcation lesion, two questions needs to be answered. First one is side branch, whether side branch needs to be preserved. Here the side branch is left circumflex, definitely it needs to be preserved. So the second question is, what is the likelihood of side branch occlusion? So here you can see there is no significant lesion in the left circumflex. So it seems to be very low risk of occluding left circumflex after left main LAD stenting. So the plan is to do provisional single stent strategy. So the plan is PCI of LM-LAD crossover stenting, provisional single stent strategy to begin with. Second is plaque modification of ostial LAD. As you know, ostial lesions are different breed. They are very rigid, they are very fibrotic, maybe calcified, and there is a large tendency of recoil. So plaque modification is must. And finally, imaging guided PCI optimization. As you know, most of the ostial LAD lesion having distal left main plaquing. In more than 90% of the IVAS studies, it has been shown that LAD ostial lesion mostly having distal left main lesion. So both LAD and LCX is wired with workhorse guide wire. And it was decided to pre-dilate with semi-compliant 2.5 by 8 balloon. Subsequently with 3.5 by 10 angiosculp, and after pre-dilation, this is angiogram. And here is the IVAS coming back from LAD. There is a small caliber distal LAD with mild plaquing. This is the mid LAD with LAD branch, and after plaque modification, there is a significant plaque in the ostium of LAD. Significant plaque in the ostium of LAD. And this is left main. Left main looks good, having no plaque. This is again the same IVAS run. So it was decided to take 40 by 16 synergy stent, as it can be post dilated up to 5.5. So we have taken this stent, and subsequently it was deployed. LED size was, sir, 3.5. It was deployed at under pressure. This is immediate post-deployment result. LED looks good with excellent TIMI3 flow, as well as circ also looks good with slight pinching in the ostial circ, having TIMI3 flow. This is in another projection. Again, it was decided to post-dilate with non-compliant 4/8 balloon, followed by proximal optimization with non-compliant 4.5/8 NC balloon. So this is result after post dilation.
So
No,
I
it was
think we let him present and we can have the questions after he's presented. He's not.
So this is final result, having excellent result with TIMI3 flow in LED as well as in the left circumflex. In epicranial view. And here is the IVUS coming back from LED. Again, this is distal LED having some plaque. And here comes stent. It is we have good expansion, having no malopposition. Slight malopposition was there, but we have corrected it with the post dilatation of 4/10 NC balloon. So there is good expansion, no malopposition, and there is no edge dissection. So this seems to be adequate result. Again, this is the same run. So the message is there are two techniques, nailed ostium and crossover stenting technique. Nailed ostium technique or having some limitation, as there is a high likelihood of geographic miss, and when you will try to avoid geographic miss, there may be floating stent struts into the left main. So there is no randomized trial, but in almost all observational studies, it has been seen that there is a high likelihood of target lesion revascularization in nailed ostium technique. So crossover stenting technique has upper hand over nailed ostium technique. In conclusion, ostial LAD lesion is often associated with distal left main disease. In more than 90% of IVUS studies it has been seen. And IVUS is helpful to decide about the plaque distribution and vessel size determination. And crossover stenting has better outcome as compared to precised ostial stenting. Thank you.
Thank you. That was a nice presentation. Are there any questions from the house?
Sir, actually this was a nice case to optimize the stent from the left main to LED basically. But more question need to be answered with the IVUS if you are using is. First thing is protecting that big circumflex was no question visually angiographically. What was important is whether you want a bifurcation or not. passing IVUS probably will tell you that the ostium is disease-free in the circumflex
No,
or
it was
not.
a small circ supplying hardly 5 to 6% of the myocardium.
It was a large
So
circ. I mean,
distorting main vessel stent at the cost of such a small vessel is not.
so passing IVUS
sense to be-
beforehand, before doing a strategy, whether you want to protect that is one
We had a plan. There was a significant ostial circ pinch.
Yeah, there was a
And-
pinch, yeah. And second thing, the distal, I mean the
And if
proximal-
there will less than TIMI through flow, then we
Yeah,
have
distal to
decided to do DAB.
Yeah, and distal
After
to
cutting
LED,
balloon, we'll-
distal LED there was little bit of lesion there. Probably IVUS would have gone little deeper and we could have stented or left it alone. So more question was not to protect or not, it was with the wire, but whether to stent or not is to be the proper question for the that particular circumflex.
So, what he is trying to tell you is that if you have the imaging, it's nice in a distal left main scenario to do a pullback from both the vessels. That will make you more confident about the strategy. That is point number one. And as you correctly pointed out, there is never a, if you do imaging, there is no 001 or 010.
Yes.
Angiographically also distal left main appeared to be diseased, and there was some plaque in the LCX ostium. And if you apply imaging, there are distinct criteria which have been mentioned, which tell you whether you're going to lose the side branch or not, which basically indirectly tell you about the cross-sectional area of the side branch. These steps are, one is the cross-sectional area, two is the plaque burden. So there are some ratios. I'll not go into the details, but it is always of help if you're doing distal left main to do a pullback from both sides.
Yes.
Correct? And it's also a nice strategy to start IVUS, whichever vessel you are doing, from the normal segment. Like your first run came with a little plaque, so true assessment of the vessel sizes becomes difficult. And I think the third thing which I would have done differently is that I would have taken a 3.5 stent, because that would have, when you do imaging and you get sizes, it's always nice to get a stent matching the distal diameter. All these stents you can blow up. So 3.5 can easily be blown up to 4.5 without any problem, the platform which you've used in this index case. That basically ensures there will be less carina shift, there will be less plaque shift into your side branch. Otherwise, a well done case.
The
Dr. Gautam,
only-
very
Yeah, sorry. The only other thing I wanted to say was that when you're doing a pot, the positioning of the balloon is very important. Whether you should go right across the branch or not, you should not.
Yes.
Because again, the plaque shift, carina deformity goes up. So I would have used a smaller one, even a 6 balloon, just to go to the left main part.
nice case, Dr. Gautam. And one thing, even the experts at the house can also comment on that, because in most of the studies conducted on left main bifurcation interventions, it is conclusion was that it is always better to open the struts on the side branch, circumflex usually.
But ma'am,
And
no data,
because no data, that's what
no
I'm
data support.
that's what I'm saying, that in most of the studies it has been seen that if the struts of the side branch were open, even in IVUS proven true 110 case, even in those cases, if it was just open and for just to optimize the carina, if kissing balloon dilatation was done before the final port, then definitely the circumflex ostial restenosis in single stent strategy is also lesser. This is this is an Italian study in which they have shown that routine, definitely they say that for a routine bifurcation like LED diagonal or OM, it should not be, it is up to operator's discretion. But in left main, they say that probably it should be preferred.
I think this is absolutely correct what she is saying. It is the EBC left main, the study, that's how left main guidelines came up. So if you do a crossover stent, you must recross and open the strut and probably do a final kissing balloon if it is left main. If it is other vessels, you need not do it. So that is EBC left main.
So EBC left main, Dr. Goel, 1 year follow-up did not show any difference between kissing and no. There is absolutely no difference. So the final verdict on this is still not out. So EBC left main, 1 year follow-up, maybe 2-3 years follow-up, you can have fenestrated restenosis. We see it. So it's best left to the operator. And if you are trying to do a kissing, then it's always nice to undersize. That is where the significance of side branch IVUS will come. Because if you cause dissection now in the side branch, you will perforce be required to convert it into two stents.
There's also an issue of the stent struts hanging over the left circumflex ostium. So for that reason, perhaps OCT is a slightly better option, because you can visualize whether the circumflex ostium is having some struts hanging on. Some people have seen that you should recross for that reason, because that is one of the factors responsible for restenosis.
Sandeep, if you've done a nice pot, you will have very big cell sizes, so that will negate. And yes, OCT has a 3D imaging available.
But this is again, what I'm saying is again EBC recommendation. The EBC is also evolved over some time.
Hello. Next speaker is Dr. Anup. He will present the case IVUS guided pelvic lesion PTCA. Dr. Anup.
Good morning, sir. Today I'm going to present a case. This is the patient profile. 61-year female, old patient, diabetic, known case of CAD, having AOE class 3. Angiography done, which shows TBD. We have advised for CABG, but patient was not willing for that. We did PTCA to RCA, that was CTO lesion 6 months back. And at present, patient having angina on exertion, LVF is normal, ECG normal. And we planned for PTCA to LAD and DEB in next sitting. DEB to LCX in next sitting. Run कैसे हुए? Yes. इसके बाद ये रन कैसे होगा? इसी से रन करना है. ओके. अच्छा वहाँ चल रहा है. I have just shown the CTO lesion of RCA. 3 stent was implanted. And this was the final shoot. And before PTCA to LAD, 2 weeks back, I have taken this shot, and stent was doing well. And this is the LAD. And now we are planning for PTCA to LAD. This is a long segment in heavily calcified lesion in proximal to mid LAD. Also distally having significant lesion. We did pre-dilatation of distal lesion with semi-compliant balloon 2x10, and with the same balloon dilated in proximal and mid part lesion. After that, I have taken semi-compliant balloon of larger size, 2.5 into 12 mm, and also dilate the proximal and mid segment lesion. Proximal and mid part having heavy calcified lesion, and after that, IVUS run was taken. This is the IVUS run. We start from distally to proximal part. Yes, this is a slight calcified lesion and also fibrous lesion. A chunk of calcium. This is mid part of LAD, heavily calcified lesion. Proximal LAD, heavily calcified. Ostial LAD, towards ostial LAD. Now entry into the left main, slightly calcification. Yes, now into the left main. Then shockwave balloon of size 2.5 into 12 was taken, and 4 cycle was given from starting from mid part to proximal part. Total 4 cycle was given. And after 4 cycle, again next 3 cycle was also given because result was not satisfactory in IVUS run. And next, after total 7 cycle, this was the IVUS run. This is the IVUS run after 7 cycle of IVL shock. Slight breakage of calcium. A reverberation also. This is the proximal part, side breakage of the calcium. Shows broken part of the calcium now entering into the left main. Then distally 2.5 into 38 stent was placed, and proximally 3 into 24 and put from the ostium. Then lesion was post-dilated from mid to proximal part with 3.5 into 12 NC balloon, and serially dilated, and distally it was dilated with 3 into 12 NC balloon, mid to distal part. And final IVUS run was taken. Now strut, well opposed strut from distal part, strut opposed, no any protrusion of plaque visible at this part. This is the osteoproximal part of LAD, well opposite strut. Now intrigue into the left main. No dissection, and this is the final shot. So conclusion, I was having only visual assessment, but it is not physiological and having more artifact than the OCT. It is inferior for detection of intracoronary thrombus, and also having similar echo texture, represent different tissue component. Example, thrombus and lipid-rich atheroma having both radiolucent structure. Most of the operators are reluctant to use IVUS because of increased procedural time, lack of expertise, and lack of conviction for the need of IVUS. But still, it is very user-friendly. Thank you.
Any questions from the house, panelists?
Dr. Goyal, do you have any comment?
Where did you do the?
No, sir. I am planning for DEB in next sitting in LCX, sir. Since patient had developed hematoma at the femoral side, so I deferred. Planning for DEB in LCX, sir. Only.
No, but why electively you will call him again and then do DEB? I don't think that is just needed. You see, you have done the procedure, whatever it is. Now, if he is doing all right, because you do best procedures, they don't do well sometimes, and you do worse procedures, they may do all right. Finally, we want the patient doing all right. So I don't think I will electively call him back for a DEB or anything. Whatever has been
Sir,
done,
sir,
if it is okay, it's okay.
Sir, patient had developed
Talking about
hematoma at the femoral side, sir.
circumflex lesion. Tight
But circumflex is quite open.
tight lesion. Tight lesion.
Acha, oh, I'm sorry. Okay, okay. For the distal circum. That's okay. That's okay.
Demonstrated cracks in the calcium after IVL, so I think that worked very well, and without that probably it would have not been a good result because it was circumferential 360-degree calcium as seen in IVUS. So well done case, nice.
Thank you.
I just will make one comment. Very well done case. IVL is a tool which induces cracks in a given vessel. IVL should be followed by NC or cutting balloons or whatever you think.
Yes.
You cannot, a lot of people do IVL and then take the stent.
Yeah,
You should prepare the bed well and then...
Sir, I have not shown this slide, sir, but I have used 2.5 into 12 subcut balloon, SC balloon.
You should, after that, you should, like disease segment is small, you use the IVL, it will not open up. The fracture fragments have to be separated and some dissections have to be induced. Once you do that, the compliance of vessel is restored. So that's the only point. A very well done case.
Thank you, sir.
I have one question, please. I would like to know that what are the limitation of IVS in such a setting? Does it detect the soft aroma in arteries, like it detects like calcium, thrombus?
Yes, but it is for thrombus OCT is better, but it can also detect calcium, fibrofatty tissue, atheroma, all can detect.
Thank you.
I can assure you that this was not a planted question because I'm going to answer in my talk.
Speaker is Dr. Chadda, who will speak on IVUS needs. It is a new modality where the liquid flow content can be estimated. And Dr. Chadda is with us since last 2 days doing different cases, and he's a wonderful teacher and wonderful operator. Dr. Chadda, please.
Thank you. Always happy to be here. Yes, imaging is catching on. Imaging is catching on in a big way because there are meta-analysis, there are multiple trials which are happening and which are kind of proving that imaging helps. And this was one of the meta-analysis which came this year, which clearly showed that everything was going in favor of imaging, where your target vessel failure, stent thrombosis, myocardial infarction all cause death. So the outcomes are definitely better if you use either OCT or IVUS and perform your angioplasties. And it basically adds a little safety and to the given procedure, and your end results are much better and you sleep well because you're kind of assured that you've done a neat job. Does imaging predict the future coronary events? There's a little important issue. This is an important issue which is now burning, and one wants to know whether I have done a procedure under imaging, whether my patient is going to come back or not. We typically know that ACS happens because of the lipid plaque. So if you have a lipid in any of the coronary vessels, it's going to induce instability, whether it can lead to non-STEMI, but it can happen in the or STEMI, it can happen in the non-culprit vessels. So there's considerable risk of these events, but we are not looking into it. So it's important to know the plaque composition, and the existing imaging modalities, whether it's IVUS or OCT, they are not going to tell you about what the plaque composition really is. So we can know the plaque composition on histopathology, that okay, if you do a cut section of a vessel, you will get to know there's lipid in it or not, but not on imaging. So none of the imaging modalities currently being used tell you about the plaque composition. So there is a need felt for having a modality which tells you what this plaque is made of, and we have a new machine from Mercato. It's from the Nipro family. It's a dual imaging modality. It uses both the IVUS and NIRS together. So you have a co-registered image of both these section-wise of a given coronary vessel. Now you get twice from the same pullback. That means you get the infrared images as well as the IVUS images from the same catheter, and the catheter is no different from the existing IVUS catheters in terms of its profile. It's again 3 French catheter. It works for the extended bandwidth of 35 to 65 megahertz. Now, how is it different? It's different. It's got 3 pullback speeds, 0.5, 1 and 2 millimeters. It interrogates about 150 millimeters of the coronary length at 3 different manual speeds. Now, it's got a bidirectional movement, so you don't have to kind of get the catheter back into position manually. You have a button on the console, you press it and the camera gets back to its original position. It's 6 French compatible, goes on 014 wire, and I told you that the profile of the catheter is no different from the existing IVUS catheters. It's already US FDA and PMDA approved. What in addition to IVUS it does is that it generates a chemogram. So it sends some NIRS rays into the coronary vessel, and the same are captured back, and they give you a probability score from 0 to 1. And if you have a score coming closer to 1, those areas turn yellow, and those with the probability score of 0, they remain red. Now this essentially helps you localize lipid. So wherever it is yellow, that means the plaque composition is essentially made of cholesterol and cholesterol esters. Now this has kind of been checked through histopathological studies, and there's been 95% sensitivity, specificity of this modality in picking up lipid plaques, and this is what gave this tool a US FDA approval. Well, what we get, what chemogram looks like is as is displayed on your slide, and this kind of marks the section of the vessel which has been interrogated into 2 basic color zones, which could be either red or yellow. Yellow is the area which is lipid rich, and you score this by using an index called LCBI or Lipid Core Burden Index. Now it scores from 0 to 1000, and I'll not go into details of how you calculate this, but if you get a score of more than 400, that is considered to be significant, and it's basically localized to a 4 millimeter segment, so it's called max LCBI 4 millimeter. So this is the maximum amount of lipid which is present in the vessel in a 4 millimeter segment, and the higher the lipid content, more are the chances of having future events. We kind of generate a spatial map which is correlated both longitudinally and axially to the given coronary vessel. Now, this has been in trials shown to be a predictor, and this is one of the cases from the Prospect trial, which was where this modality was used. So there was a plaque which was lipid rich, and subsequently at the end of 7 months, it ruptured and led to an event. Now, NIS is a tool which can prevent these acute events by stratifying these patients. Okay, you have high lipid content, you are at risk of future events, and accordingly, we can tailor the prescription. Well, the clinical evidence of this comes from, I'll quickly glance through two or three trials. LRP was the first study which looked at about 1,500 plus patients. It was a multi-center study. It basically gave us the information that it picks up vulnerable vessel and the vulnerable patient, and the importance is that this study kind of established that the procedure is safe, it can pick up the vulnerable patient and the plaque, and the score, what we use now for most of the trial, that is LCBI score of 400, was validated in this study. Prospect 2 was another, a small arm of this, use LCBI score along with the plaque burden calculated from the IVUS. And if you see the graphs here, those patients who had plaque burden of more than 70% and LCBI score of above 324 had the highest risk. So what we gather from both these studies is that a high lipid rich plaque is a predictor of acute events and should be identified in a given patient to prevent future events. Well, it's also got applicability in acute MI situation where the non-culprit vessels are interrogated, and whether it's going to help or not, no. The important thing is how do we manage ACS patients, those who have high plaque burden. We really don't know what exactly is the lipid content in these plaques. We put them in 80 or 40 milligram of atorvastatin and the patient comes for follow-up. We have a very, very kind of a variable approach. If you are busy, you tell him to continue same. If you are not busy, you say, okay, today I will reduce your statins. Now, it's absolutely not governed by the prescription or the duration, but if you notice, what Pacman showed was that if you put these patients on high dose, here ipilimumab was used, if these patients showed percentage atheroma reduction, they also showed reduction in the LCBI score, which translated into fewer events and better results. So study highlights that this is one tool which will help you kind of validate and bring objectivity to your prescriptions outside the cath lab. It's also been validated, or it's also been tried in 200 patients where a residual LCBI score higher than 200 was predictor of stent failure. We need some more trials in this section to know whether it really works or not. So if you leave behind a higher LCBI score, your stents are likely to fail at a future date. Now, this is one aspect which has not been studied very well, but I noticed this while doing my cases, that nerves can penetrate the calcific plate. Till now, IVUS studies have shown that you get an acoustic dropout. OCT doesn't have the kind of penetration to tell you it will give you the thickness of calcium, but what is lying behind the calcium you don't get to know. But nerves can penetrate the calcific plate and can give you as to how much lipid is there, if it is there behind the calcific plate. This not only helps you predict events, but it also helps you choose the tools for dealing with this calcium, because if there is a lipid plaque behind the calcium plate, then NC balloons are good enough. You don't need cutting balloons or IVL for this calcium. Well, there's one observational study where 20 patients were studied, and what they noticed was that those with coronary artery calcium score of more than 300, when they were analyzed, the calcium score matched with the atheroma burden, but it did not match with the lipid pool behind. So what it was telling that there is no certainty of having a lipid plaque behind the calcific plate. Lipid definitely marks the inflammatory stage of atherosclerosis, but once that passes off, the entire chunk is converted into basically calcium, and the chances of picking up this is very less. But if you pick up, you can kind of stratify these patients in terms of risk of future events. Well, to summarize, before I show you a couple of cases, how is IVUS nurse different? Number one, it's a dual modality, so it's giving you the morphology as well as the chemical composition of the plaque. The catheter is very sturdy, so it's got very good pushability, and I can assure you that this will translate into very good reusability. It's got a bigger imaging range of 150 millimeters. It's got higher pullback speeds compared to the existing catheters. It moves bidirectionally, so you don't have to manually get the lens back in position. Its advantages, it helps you detect as well as quantify the lipid content of the plaque, which no other imaging modality does. It characterizes the chemical composition, which probably helps us in preventing events. It rationalizes your lipid management, because you would know those who have very high LCBI score, they will need statins for a longer period of time. And in a calcific plate, detecting lipid behind the plate helps you use the right tools for treating these lesions. So I'll just show you quickly two cases. This was a 73-year-old diabetic hypertensive with class 3 angina. This was Murphy's law. Can you play it from there? Playing, okay, sorry. It's not. So this was an osteoproximal LAD lesion. We thought it's a garden variety, but the balloons did not cross, so we had to use rote ablation, and this was done as live for ICCON. So we had to, it took quite some time to burr this lesion. We used a 1.5 millimeter burr, and this was the IVUS image of the lesion, starting from the distal LAD coming to the proximal part. You can see the clarity of image. The black band which you see clearly shows you the media, the intima is there. Now you come to the calcific plate. Wherever you see in the axial plane a yellow line coming, that means there is lipid behind the calcium. This is a circumferential calcific plate. It turns orange. And you get the color code, so it axially places the lipid content, and you get a chemogram commensurate. That, see, there's a lot of lipid in this section from... So it's quite self-explanatory, and you pick up this, and you get a chemogram. On the chemogram on the left side, you get LCBI, which is blue colored. That means the total score is about 230, and the max LCBI, that is the point where you have maximum lipid core, is about 764. Anything more than 400 is very, very significant. So there was a considerable lipid plaque burden here, and as I was telling you, there are cracks, and you can see lipid pool behind. So we went ahead and then stented this vessel with 3.528 and 424, and this was the post, well-opposed stent. There was a little plaque burden. So, okay, there's considerable reduction of the LCBI score. Probably it exudes into the vessel and it passes off. So this was the post images. As is expected in any calcific milieu, you will have malappositions because you can't oppose everything in a calcific platform. This was the final run. Now the second case was an osteoproximal LAD disease extending onto the left main. So we took two runs. This was from the LAD. Now you can clearly make out the plaque and the vessel wall. So the clarity of images are there to see, and the calcific plate coming in the LAD run. So it's turned yellow. That means there is a lipid plaque behind this calcium. So it clearly demonstrates that there is a lot of lipid in this. And a run from the circumflex. Circumflex, that's the LAD joining, LAD calcium. This is the distal left main calcium where there is, and this is the distal left main part. So there's the image quality is pretty good, and that's what impressed me. So this is the lipid pool behind the calcium plate, as you can see. And this was the post-PCI IVUS nurse. There was a calcium plate there, and there was a distinct under-expansion of the stent, and we couldn't go very aggressive at this point because there was a big nodule which was sitting there, and it would have compromised the safety. The left main part of the stent was quite well opposed, and you can see considerable under-expansion there. We optimized it further. This is in the left main where the stent is very well opposed, and kind of couple of struts hanging into the aorta, probably a millimeter or so. This was post-optimization. This was the final run which we got. So to conclude, I would say that the Dual Pro imaging catheter is one of the only ones which has got US FDA approval for characterizing the plaque morphology and its chemical composition. And from this you generate a chemogram which helps you not only stratify these patients in the lab in terms of the tools which are required for treating them, but it also helps you carry the prescription out of the lab that yes, I have a patient who has very high LCBI score, I'm going to continue statins for a little longer period than I would have conventionally used. We know that a single stat dose of 20 or 30 milligram in the Indian patients brings down the cholesterol considerably. So, but once you know that there is considerable cholesterol deposition within the vessels, you would like to rationalize and continue with the prescription for a longer period of time. We certainly need some more trials with this tool before it gets wider acceptance. Thank you. No, we did everything. We did cutting also, and we did NC balloon. Both were done. I just wanted to show more images than the procedure. Lipid. Red means there is no lipid. It will not tell you what it is. Only yellow. Only yellow. You have to concentrate only yellow, and you get a score for that.
We are very sure that
what
it is.
happens, Dr. Pratap, is that when I have a calcific plate, OCT will tell me the width is about 0.8 or 1 millimeter, but I don't know what is behind. IVUS will create a complete acoustic window. I really don't get to see anything what is behind. Now, if I see a lipid pool behind this, I don't need IVL here. I'll use just NC balloon. It's like what has been described, that pebble sitting on a pillow, pebble sitting on a rock. Pebble sitting on a pillow means this is a soft plaque behind. So this calcific plate is sitting on a very soft plaque. I can easily use an NC balloon and crack it, and it will get pushed, and I'll get good expansion.
But even in this, we will be having a difficulty of identifying the thickness of the calcium. Can we?
So no, this will not identify thickness of the calcium. It's akin to normal IVUS.
Correct.
So how do we see in the sense, IVUS does not tell you about calcium plate thickness. IVUS can just tell you whether it's a superficial calcific plate or nodular. Calcific plate will appear uniform, smooth. Nodular calcium will have, irregularity over its surface. So, and it will be more segmental than circumferential. Plus, third thing which tells us about thickness on IVUS is reverberations. If you see multiple layers of reverberations coming, that means it's a thick plate calcium which you are dealing with. So these are the only clues indirectly which you get from IVUS for calcium thickness. OCT is a much better tool to find out the thickness of calcium.
Correct. But by this we can specifically tell that NC balloon or cutting balloon
Yes,
or OPD and IVL.
if I have a calcific plate which on the run, it is sitting on a lipid plaque, I will just use NC balloons. I don't need any other special tool because the plaque behind is very soft, and I'll be able to push it behind.
If it is lipid seen, it is very good.
Pardon?
If lipid is seen, we are very happy.
Absolutely. Absolutely.
My question is, we have 3 hybrid imaging modalities now. You showed one, the IVUS NIRS. There's OCT NIRS and there's OCT IVUS. So right now I'm in a dilemma. I work in a public hospital. I have to choose one of the 3. Which one should I choose?
Try and work on all the 3 modalities, whichever you think you are going to. So I'll tell you something, It's like physical activity for obesity. Some is better than none. Imaging similarly, any one imaging modality you choose, imaging is better than doing angiographic guided
I
PCR.
have both OCT
So
and
OCT NIRS is going to take time. It is going to take time to come. Hybrid IVUS and OCT are already FDA approved. There's one from Termo and one from...
I'm aware of that. I'm asking which do you think is the better one?
If you ask me, I would like to have all of them in my lab, but but I would still say that IVUS will have little wider applicability in presence in the osteal lesions, LV dysfunction, renal failures, and I make a very fond, this is one of my very fond statements. In IVUS, you have to just de-air the catheter and do nothing. Your assistant can put the catheter inside, de-air it nicely, you can de-glove, come outside, have a cup of tea, job is done. But in OCT, you have to practice, you have to be coaxial, you have to time your injection, you have to produce very good clear images. If you don't produce those clear images, you will be absolutely disgruntled that I have not done a good job and this image has not given me any additional information.
Actually, if you have an IVUS and OCT in your cath lab, better to have a NIRS IVUS is preferable. That is what I personally, if you have OCT also in the cath lab.
Absolutely. I'm blessed because we have Valcano, we have Boston IVUS, we have NIRS IVUS and OCT.
Sir, suppose for a non-critical lesion, you find a large lipid core. So in that case, would you want to stent it or want to just high
absolutely
medical
no, that I think only Prospect 2 sub-study was doing this and they showed benefit. There is no end to this, and we know that if we put these patients on statins, we put them on other therapies, we get plaque atheroma reduction, we get thickening of the fibrous cap which is on top. I will tell you something, a term which is used in this part of the country, stents are not a Ramban, that you shoot a arrow and that solves all the problems. Stent is not one of them. Stent will set into motion a lot of other problems, which, I have treated patients who got a stent when they didn't need, then they got additional stent because of stent failure, and then at a very young age of 40, 42, they have been bypassed. So, I mean, giving us unnecessary stent is absolutely not. I would never recommend that. I answered your question with a plaque characterization. Okay.
In your personal experience, what are the advantage you are getting when you are using IVUS with NIRS in comparison to if you are using only IVUS? What are the advantages?
I think my whole talk was on that only, but I'll repeat it. Number one, that I get to know the chemical composition of the plaque. So if I see large lipid content, then I can probably change the prescription and continue statins in higher dosages. What normally happens, ACS, we give them 40, 80, and then we kind of, it depends on our mood. 3 months, 6 months, 8 months, 9 months, we'll either change or not change or bring them down on idiosyncrasies. But if you demonstrated large pool, you'll continue it for longer period of time. Number two, as I was saying, if you have a calcific plate and you see lipid behind, it helps you choose your tools much better. Number three, all the virtues of IVUS are there in it, but it gives you some additional information in terms of telling you composition of plaque. And you must remember, it is the lipid and only the lipid which leads to thrombus formation in the vessel. Plaque, when you see a remodeled vessel, the extracellular matrix has got lipid, it's got dead cells, macrophages, dead smooth muscle cells. So everything is there, but it's only the lipid which is most important.
Thank you, Dr. Chadha.
One more question, sir, please. Sir, does this IVUS with NRS has got any role in putting a stent like carotid stenting and just to prevent any procedural complication of the events?
I'll tell you, IVUS has additional advantage that it can interrogate larger vessels. So probably I'll leave it at that. So we generally don't do IVUS to detect the plaque morphology for stenting carotids. It is essentially governed by the symptoms. This is one segment which is essentially governed. You don't unnecessarily stent carotids till the time that lesion is producing problems.
Thank you.
Thank you. Yes, Chani Jawahar.
Thank you so much, sir. With this, we conclude our session on imaging. Now, may I request honorable chairpersons for the second session, that is on the innovation in intervention cardiology. Requesting the presence of honorable chairpersons Dr. B.B. Bharti, who is the director and consultant cardiologist from Ford Hospital, Dr. Neerav Kumar, professor cardiology from IJIMS, Dr. Rajiv Krishna, consultant cardiologist from Mediversal, Dr. Nitish Ranjan, consultant cardiologist from IJIC, Dr. Kamlesh Kumar, consultant cardiologist from IJIC, Dr. Sudhir Kumar, professor medicine from IJIMS, and Dr. Pramod Kumar, who is a consultant cardiologist from Kurji Artemis, Patna. I would request Dr. Bharti to kindly call on the stage the speakers. And there's also a small change in the speakers of the master faculty. The third speaker would be Professor Dr. P.K. Goyal instead of Dr. Dilip Kumar.
Sorry. Good morning to everybody. Already we are going late. And I request to all the speakers, please finish the talk within times. And more time give on the question and answer session. The first speaker is Dr. Abhijit Palsikar from Pune. He will speak on the metal-less PCI. Doctor.
Good morning, everybody. This is going to be controversial and interesting because Dr. Goyal is on one side, Dr. Pratap Kumar on another side with Dr. Antano Columbio. So, metal-less angioplasty has been there. We had been there with the drug-coated balloon for a long time. We had with the absorb stent for a long time, but because of probably misuse and misunderstanding, they gradually went out of the flavor. Now, then again with, how can I forward this? No, it's not going. No, no, it's not working. किया नहीं हो रहा किसे आएगा अच्छा ओके so 1977 the PTCA was invented, 88 bare metal stents, and then ultimately we are doing with drug eluting stents for a long time now. Now problem with the stents is that with the drug coated balloons, drug coated stents, the restenosis has come down significantly, but still we have got a restenosis. Second thing, DAPT has to be continued for longer time till the endothelization happens. And obviously the inhomogeneous application of the drug in the coronaries is another issue with that. So now next revolution probably coming up is the nothing to be left behind, neither the metal, nothing behind. So now the metal-less PCI is coming up with the two arms. One is drug-coated balloons and by reabsorbable scaffolds. Let us remember that when we are treating a coronary artery, it is not the metal tube which is lying there. It is a live organ. It has got own vasomotor tone. So when we are treating the artery with a metal, we are not preserving the vasomotor tone. We are making it a fixed metal tube. And obviously, although it is a good therapy, but ultimately we are leaving the metal there for a long time, especially for the young individuals. And obviously you need to give DAPT for longer times, and it is a problem with the high risk bleeding risk patients as well as for the younger patients. So we are leaving a permanent implant. So with the metal-less angioplasty, we are not leaving any permanent implant. We are preserving the vasomotor tone of the vessel, and it gives the positive remodeling basically. So what is drug eluting balloon? It is not drug coated balloon. Coating is just a coating because it gets washed off. What is important is drug eluting balloon. That balloon has to go there and elute the drug rather than just coating with the balloon with the particular drug. So it's a semi-compliant balloon. It's not non-compliant. It is compliant or semi-compliant. I'll explain why it is semi-compliant. It has got anti-proliferative drug and has to be delivered there with specific minimum inflation time. So that drug has to be delivered to the intima and media, and the substance has to be lipophilic. Now why lipophilic? Because we are passing from the catheter to the coronary artery and to the lesion. The drug has to quickly delivered to the lesion rather than washing off with the blood, because we have got very short time to inflate that balloon because we are inducing the ischemia. So component of DEB is the active drug which has to have some agent. Traditionally, it has been used the urea excipient as the molecule. When you inflate it, the lipophilic character of the drug which delivers there in the intima. So why paclitaxel? I mean, we have been using sirolimus for a long time for the drug-eluting stents. We are very friendly, proven results, it's a proven friend, but why paclitaxel for the drug-eluting balloons? Because it is only character is that it is lipophilic. It is not hydrophilic, so it acts by immediately transferring to the vessel wall, and it binds to the lipid core. So it has to be delivered in a short intubation time. I mean, as you inflate the balloon, it immediately gets transferred within that time. So you cannot prolong the ischemia, and balloon has to be there. And you can observe that when you study the drug-eluting balloons, the concentration of the paclitaxel is much higher, almost 3 times what we use for the drug-coated stents, basically, because 90% of the drug is washed away when you are passing through the hemostatic valve, the catheter, and the coronary artery. So only 10 to 20% of the paclitaxel is transferred from the balloon surface to the vessel wall, actually. So that's why you need lot more concentration of the drug on the balloon, and traditionally it has been long because these higher concentration needed to be coated on the balloon. So when we use the drug coated stents, we use the polymer which causes inflammation and which is absent here. Now this is not new. I mean, drug-eluting balloon we have been using first generation, second generation, sequent please, we used personally many times the second generation. Now the third generation drug-eluting balloons are coming with no carriers for the paclitaxel eluting balloons. One of the example is Proteage, which is recently available. They are trying to innovate newer technologies whereby the drug is not lost while the transit. This is the wing seal technology used by Proteage balloon. It has got the wings which on unfolding they are coated with the paclitaxel. They fold and cram the balloon, and then when you pass the balloon, the drug doesn't get lost when you are passing across the blood vessel. Now, sirolimus has been friendly, but problem with the hydrophilic coating of the balloon. Now, the newer technology, mosaic balloon by the company has come with the nanotechnology. It has got a different formulation for sirolimus. It is solid lipid nanotechnology, they call it as. It is released in multiple layers and multiple phases. First is the burst effect and the reservoir effect, and histopathologically it has been shown that if particles are less than 30 nanometers, it penetrates up to media and the adventitia as well. Now using drug-coated balloon, I mean the practical points is, most important thing is you have to prepare your vessel very well. The preparation is the most important key in the using of the drug-coated balloons. Proper predilatation with either NC balloon, your cutting balloon, rotablation, or whatever tools IVL you want to use, the proper vessel preparation is very well important, because that is where the point of using drug-coated balloon comes. Ensure 1:1 sizing between the vessel and the drug-eluting balloon. The shortest time of inflation has to be there. Ideally, it has to be 60 seconds, but many times major arteries or major ischemia is not tolerated. At least 30 seconds of inflation which is recommended. So how to use the drug-coated balloon? Pre-treatment is very important. The vessel has to very well prepared. You don't have to, you should not be touching the balloon, wiping the balloon, bending the balloon, and coming in contact with liquid prior to the insertion. Go to the side straight as fast as possible. Inflate the balloon to the desired inflation pressure, and at least be there for 30 seconds, ideally for the 60 seconds. Now let's say indications and evidences in for the drug-coated balloons. The class 1A indication, I mean only indication which is approved is the ISR. ISR is the one indication. Other indication which are interesting is small vessel disease, bifurcation lesions, and de novo lesions. So only ISR which has been approved for the DEBs at the moment. Small vessel disease, there are a lot of studies. De novo lesions, there are a lot of studies, but major vessels, proximal vessels is again a question like proximal LAD. Indications like diabetes mellitus and high bleeding risk. I mean, this is very interesting where we are trying to use all these drug-coated balloons. Is diabetes mellitus where you have got long and diffuse diseases where you don't want to put a metal for the future reference, and high bleeding risk patients where you want to cut down the DAPT as soon as possible. Another indication coming up very frequently is the chronic total occlusions, where you don't want to lose the bifurcation this thing, and this is another club coming up trying to use drug-coated balloon in CTO. I mean, personally, I won't like to open up the CTO and leave it with the drug-coated balloon. So ISR is the class 1 indication for DEB. Paclitaxel at the moment is only approved drug. Sirolimus is emerging with the nanotechnology. One beautiful sentence I read in European Bifurcation Club, that you have to paint the artery with DEB. I mean, it is not like you pre-dilate or you crack the lesion with the drug-eluting balloon. You have to prepare very well and just go slow, 1:1 balloon, release the drug there and come out. So this is what I call it as a paint the DEB. And final kissing with DEB is not absolutely no. I mean, it should not be used at the cracking strategy. Final kissing with the DEB is not in this thing. And you should not image after DEB. DEB inflation has to be final stage. After that, you pass a catheter IVUS or OCT, it is going to wash off the drug there. So never try to do a imaging after you put a DEB. Dissection up to class B can be left alone. I mean, it has been proved that non-flow limiting, non-spiral dissection can be left alone with DEB. 30-second or if preferably 60-second has to be there, and never crack the lesion with DEB. Now absorbable scaffolds probably absorb, we used very abused absorb with using multiple absorb, overlapping absorb in the bifurcation, CTOs, calcification. So at the moment Merrill's 100, Merrill has come up with a absorbable scaffold. It has closed cell on the end and open cell on the middle size where you can access. The width is 100 nanometers. So you can see after 1, 2 and 3 years you can actually see which is the studs getting absorbed absolutely. So when you are using a bioabsorbable scaffold, what is important again is the pre-dilatation. Metal-less angioplasty, first thing you prepare, you are preparing for the metal-less angioplasty, pre-dilate and pre-dilate. Vessel has to be properly prepared with whatever modality you want to do. Second thing, proper sizing important. Here comes the importance of imaging. It has to be IVUS or OCT. 1:1 sizing of the bioabsorbable scaffold is very important. And third thing is the post dilatation. I mean, it is not the scaffold actually, it is you are plastering the wall with the absorbable scaffold. So post dilatation with a proper sizing balloon so that it is opposed is very important. So when you do a drug-eluting balloon or stent, antiplatelet has to be fully given. Guide support has to be good because you are to be quick, and for the drug absorbable scaffolds, it is a little stiff to pass to the lesion. Use extra support wire if needed. Pre-dilate is very important. Optimize the size of the instrument you are using. Post-dilate, OCT is important for initial uses of the bioabsorbable scaffold, and post-dilate all. Avoid absorbable scaffolds in complex angioplasties, chronic total occlusion, calciums, extreme tortuosity and small vessels. In short, DCB for the small vessels, ISR, bifurcation, side branch, again no kissing, high bleeding risk patients and hybrid PCI whereby you don't want long metal and leave some space for the surgeons. BRS for the young patients, mid to distal size vessel, but the reference size has to be 2.75 to 3.5. You cannot use BRS in a small vessel and not at the ostium because it's a fibrotic lesion, and crossover patients. So algorithm we try to follow is pre-dilate, see if the lesion is less than 30% residual lesion, there is no dissection, you can live with the drug coated balloon. If the lesion is less than 20% and dissection is there, C or F type of dissection, then bioabsorbable scaffold is very important, or you can use that. And if it's more than that, there is residual stenosis more than 30%, then you have to use the drug coated stent. So this technology is promising technology in coronary arteries, but not suitable for all. For technical success, proper patient selection, clinical angiographic character, proper imaging and vessel preparation has to be very important, so that you get a long-term good results. Thank you.
What is your opinion in acute coronary syndrome? The recent trial has come with in acute coronary syndrome.
Sir, large thrombus burden for BRS is a problem, because if you leave a thrombus behind the BRS, what is important in BRS is to approximate the scaffold to the vessel wall. If there is a large thrombus burden, if in ACS you come down with the thrombus burden with the thrombus suction or water modalities, there is no significant thrombus before putting BRS, then it's a good modality.
One of the indication you told is bifurcation lesion for drug coated balloon. So at what stage this should be done? Because you told that final kissing balloon should not be done. So what is the stage where we should go for that?
Before coming out, that Dr. Pratap Kumar said, the side branch we use, it is to, once you put a drug coated balloon, no second balloon or nothing there. So last, side branch probably just paint the balloon and come out, because it's a non-compliant or semi-compliant balloon, you are not distorting. Probably then side pot and again pot is the strategy.
No, Medina 111 lesion, you put a stent and you want to DCB in the side branch. So at what stage we should do?
Yes, side branch you prepare very well. Put a drug coated balloon there, come out, and don't do the kissing now. Then just do the pot and come out.
So before putting the stent or after putting the stent we should do that?
After putting the stent, yes.
After putting the stent, then making a channel and then
a channel, yeah, and then do the pot and no final kissing.
So what should be the duration of dual antiplatelet after BRS?
BRS to be standard, one year. 3 years is the ideal. We have seen the study, after 3 years it completely gets absorbed. So it has to be longer than the drug coated.
They generally told to give for 3 years until the scaffold.
Absolutely.
And what is your personal experience with long-term outcome with drug-eluting balloon?
Drug-eluting balloon I try to use in ISR basically. Small vessels or hybrid angioplasties, whereby the long LAD is there, diffuse lead disease in diabetic young patient. We put a drug coated stent in proximal segment, and distal diffuse disease you do a drug eluting balloon and leave it alone, because we want the surgeon to have some space for the if needed in the future to put a graft.
What is the result after long-term follow-up?
Yeah, it is well. Many times I feel like putting a 2.5 or 2.25 millimeter of stent, long stent, 48 millimeter. It is much better to put a drug-eluting balloon.
Dr. Vijit, one question. If we are putting drug-eluting balloon in side branch, the osteal portion of the side branch is muscular one, the fibrous one is there. So don't you think there is a negative remodeling fear is there?
No,
that can shrink after the...
No, the side branch ostium we are preparing with a cutting balloon or NC balloon basically. We are not preparing with the drug-eluting balloon. After we prepare with the cutting balloon, we just paint it with the drug coated balloon.
When we open it with a cutting balloon, there is fear of dissection also.
Yeah, if there is a significant dissection, then you put a stent.
So we are in mess.
No, if you put you make a dissection, you are in mess. Either you use a drug coated stent. If there is no dissection, then you can leave it alone.
But the mechanism of balloon angioplasty is making a dissection. It always causes dissection.
Micro dissections are there, but then type A and type B you can safely leave with the drug coated balloons.
Thank you. Is there any question from house? Thank you very much, Dr. Vijay.
3 times, yes. That's what they claim.
So it will become economical for the patient also. You can use the same balloon you have inflated distally in the LAD.
Yes.
You can come out and again do it in middle part. But they don't recommend taking it out and going into RCA.
Yeah, exactly. That's what they recommend. Once you inflate the wings, there, then you can go little distally, inflate again. 3 times they have shown that there is a drug and which gets eluting. So ultimately what you are trying to conserve the drug and wrap around so that when you go in the coronary artery, the drug doesn't get lost. So everybody is trying to fight the drug should be there on the balloon till it reaches the lesion.
Thank you very much, Dr. Abhijit. Our next speaker is Dr. Rajaram from Hyderabad, the Sunshine Hospital. He is senior interventional cardiologist. So he will talk about interventional management of severe TR in trick valve.
Good morning, everyone. Not this one. Right. At the outset, I would like to thank the organizers of the Bihar Interventional Council as well as the CSI chapter of the Bihar, Organizing Secretary Dr. Ravi Vishnu Prasad particularly. Today I am going to present my case. In severe TR, usually the TR is most neglected lesion. I feel we are not giving that much of importance. Suppose if you see the moderate MR, you will closely follow up the patient regularly, 6 months or 1 year, then you will take the decisions appropriately at that time. Then you would like to treat the patient, but same thing has to be applied to the tricuspid regurgitation also. So that is the importance. My patient is a 54-year-old female patient. She is a teacher by occupation. Presented to us with a dyspnea on exertion since 3 years, which was progressed from class 2 to class 4, and pedal edema, fatigue and loss of appetite since 3 months. On examination, patient was having mild ascites, pedal edema, which is pitting in type. So diagnosed to have the chronic rheumatic heart disease with the status post mitral valve replacement with the bioprosthetic valve in 2013. Now in congestive cardiac failure, function class 3 to 4 in atrial fibrillation. And she is also on maximum dose of diuretic therapy as per the hemodynamics. Her echo showed that she is having good LV systolic function with the prosthetic valve functioning well with mild paravalvular leak. There is mild RV systolic dysfunction with the TAPSE of 1.4. There is no PAH, mild PAH with the RVSP of 36 millimeters of Hg. And there is a torrential TR with a wide coaptation gap that is almost 16 mm in our case. I will show you the 2D echo in next slide. And other blood parameters showed that creatinine is normal, but NT-proBNP is only 2100. Total bilirubin is elevated, that is 3.2. So cardiac cirrhosis with a Child-Pugh stage A we have diagnosed. So heart team approach was consulted. Euroscore was calculated, it is 6.1%, which comes out to be the mortality of surgical mortality of 10 to 11%. And tri-score we have calculated is 6 out of 12. That indicates that predicted in-hospital mortality is almost 22% with the surgery. So these are the echo images where you are showing that please, can you play? Yeah. Okay, we have to play. So there is a torrential tricuspid regurgitation, you can see, with a wide coaptation gap that is almost 16 mm when we have calculated. So what are the options left? The patient is having severe TR, symptomatic, maximal medical therapy. She is a teacher by occupation. She wants to continue her profession. So the options here we are either it is surgery or transcatheter therapies. So these are the approved drugs. So this is the algorithm we follow for the tricuspid regurgitation. If it is a secondary severe TR with the severe dilatation of the tricuspid annulus, so options are either orthotopic implantation of the sapien valve or heterotopic implantation of the tric valve or medical management. And this strike clip is not an option. Coaptation gap of 16 mm. So there is no question of another transcatheter therapy which is available in our case. So what are the guidelines say? ACCHA guidelines say that the surgery in these patients is class 2B indication. ESC guidelines in 2021 said that the transcatheter therapy is also having the same indication of class 2B. So indication wise, as per the guidelines, it is class 2B, both surgery as well as this thing, but the mortality is very, very high, almost 22% with the tri-score. So there is obvious reason that patient will definitely reduce, and then we have gone for the heterotopic implantation of the cavity, that is a trick valve. So basically this trick valve is, it is a bioprosthetic valve made from the bovine pericardium, which is implanted on the nitinol mesh. It has got the two components. One is in the IVC component as well as SVC. This is the IVC component, this is SVC component. So we did the venogram, CT venogram, which requires anatomical delineation as well as sizing for the valve. So various parameters you will see, diameters as well as the length of the SVC as well as IVC. Yeah, this is the anatomical criteria we take before choosing the stent sizes. In our case, we have chosen for SVC it is 25 mm, for IVC it is a 41 mm size we have chosen. And it is basically a simple procedure, doesn't require much skills. Basic training is enough. Only venous punctures are required. So right femoral vein is punctured and secured with the 7 French sheath, and the left femoral vein with the 7 French sheath for the multi-purpose catheter, which you need to keep in the right pulmonary artery. And then left cubital vein, again for the multi-purpose catheter, to be kept in the innominate vein as a marker, and injection to see the flow in the SVC. And this is the procedure, simple procedure, where you can see the RV pressure as well as PA pressure. And then this is the PA pressure we have noticed, it is 65. The upper limit or contraindication for the severe PAH is more than 65. So this is the multi-purpose catheter we have kept in the right pulmonary artery to make sure that the belly portion of the SVC stent should be above the pulmonary artery for retention sake. Then you have to take Amplat's extra stiff wire from right femoral vein axis, and you have to pass it up to the angle of the mandible. Then it is pre-dilated with the 14 French dilator followed by 18 French dilator, then followed by, if necessary, you can put 20 or 24, then you can finally, that preloaded sheath will have around 28 French. So after pre-dilatation, we have advanced the SVC valve, and here it has to be this belly portion. This is the belly portion. This belly portion has to be kept above the right pulmonary artery to make sure that it will not dislodge or it will not migrate to the RA. And this multi-purpose catheter in the innominate vein is to make sure that your venous flow is good. Innominate vein is flowing well into the SVC valve. So this is the final deployment procedure, where you can see that belly portion is above the pulmonary artery and it is flowing well. So here we are checking, and we are going for the complete deployment, and SVC trick valve was deployed completely. It has to be done very slowly. Then nose cone removed slowly under the fluoroscopic guidance. And then same multipurpose which you have kept in the pulmonary artery, which needs to be pulled, and then you keep in the right hepatic vein, and then check the pressures. Then you take the preloaded IVC trick valve. We have taken the 41 mm in our case, and you need to pass. So this is the hepatic vein pressure. You can see that it is the upper pressure is 28. So upper limit for the higher venous V wave should be more than 25. So it is 28 here. So here you can see it has got two components. One is radiolucent area has to be above the hepatic vein inflow. So that you have to take care. Here you are seeing the radiolucent area is much above the hepatic vein, and then you gradually withdraw the cath. It is a self-expanding valve. So here the valve is completely deployed. These are the check images after deployment of the trick valve. So the prognosis of the tricuspid valve is very, very worse. If you see the literature, the 1 year survival with the severe TR is almost 64%, and moderate is around 70 to 80%. But the 5 year survival of the severe TR, irrespective of the etiology, it is 20%, both moderate as well as severe TR, irrespective of the TR etiology. So prognosis is very, very bad. Only 5 year survival, almost 80% mortality. 80% of them are going to die within 5 years. So it also depends upon the EROA. Suppose if EROA is more than 40 mm, that is severe TR, again it has got very bad prognosis. So basically right now the transcatheter therapy is used only in the high surgical risk patients or patients who are not willing for the surgery, with the maxed out medical therapy, unsuitable anatomy for the surgery, the presence of pacemaker, lead or peri-procedural imaging challenges are there, then you are using this. And what is the basic mechanism of this trick valve is basically to avoid the backflow into the liver as well as the kidney congestion. It will reduce the congestion and thereby promoting the RV remodeling and reducing the symptoms, as well as it has to improve the mortality also. But right now we have only short term. So this is the after implantation. These are the images of the trick valve. So what is the evidence now? Initially it was used as an compassionate grounds in the Europe in 27 patients. With the encouraging results, they have conducted the early feasibility study of tricus study. Then followed by they have used this. Yeah, I'll finish. So this is the first in man study which was published in 2018. Bicable valve was implanted in 6 patients, and then it was found to be more safe, feasible, and with a high success rate. And these are all the indications as well as contraindications. So I'll read out these. One is that the patient has to be symptomatic, functionally class 3 to 4. LV function has to be more than moderate, that is 40% at least. And 6-minute walk distance should be more than 60 meters. And then V wave has to be more than 25 millimeters of Hg. And there should not be any, if there is any severe PH, again it is a contraindication. The PA pressure should be less than 65. So it was tested in various comorbid conditions like atrial fibrillation, pacemaker, peripheral arterial disease, COPD, etc. with the good success rate. In all these patients you can easily deploy the portions. And it was found that in the tricus as well as tricus euro study, there is an improvement in the quality of the life. Here you can see. These are all the 6 months reports where you can see the improvement in the functional class. The patients who are on class 3, class 4 symptoms converted to class 1 and 2 almost 80 and 90% of the time. and there is increased 6-minute walk distance are also noted. Recently, in the month of January of this year, they have published the 1-year results. It is clearly showing that there is an improved quality of the life, improved functional class, 6-minute walk distance is increased, decreased dosing of the diuretics, and NT-proBNP is also decreased. But again, there is a congestion, again recurrence of the congestion, recurrence of the hospitalization is almost 30%, it has noted. It is basically because there is the compensatory mechanisms in the RV is very, very weak when compared with the LV. If you treat the MR, then because of efficient compensatory mechanisms, the LV will recover very fast, whereas RV, it is not that good. So that indicates that we have to intervene a little bit early. As of now, there is no clear-cut timing when to intervene with the procedures, these tricuspid valve procedures. Now they are planning TRICAV registry. Probably in next month or so, they are going to plan with a much higher number of the patients, that is around 400 to 500 patients they want to include, and they want to compare with the medical therapy versus the tric valve. And it is going to be the long-term follow-up case, almost 5 years they want to see. Another interesting article they have recently published in the Tricus Euro study. What they have done is, they have done the CT study where they have demonstrated that there is also a myocardial remodeling is also taking place. There is a decrease in volumes in both RA as well as RV. So what are the limitations of this procedure? It is associated with some anchoring and as well as sizing, and ventricularization of the RA pressure may lead to volume overload as well as atrial fibrillation, but so far that kind of experiences was not there, and it is currently used as a last resort only. Advantages is effective. It is a low risk solution for patients who are severely symptomatic patients, and it is a shallow learning curve is there. It is easily implanted, safe, simple and suitable for many anatomies. Allows all future tricuspid interventions, whether it is TER, that is edge-to-edge repair, or tricuspid valve replacement. To conclude, TR is associated with high mortality in the short term as well with the medical short and long term with the medical treatment. Current knowledge gaps are significant. Earlier referral and treatment of patients with significant TR to avoid end-stage right heart failure. Better patient selection and pre-procedural screening is required, and long-term studies are required to provide clinical benefits. Thank you very much.
Thank you, sir. Only one thing, when to interfere the tricuspid regurgitation, it is a major issue.
Yes, sir.
Because there is the broad spectrum of the NOH class, someone in NOH class, but is still severe RV dysfunction, severe TR, someone in class 3. When to interfere, where is the ideal time to interfere?
Even now, because of very limited number of patients, only 35 patients or 40 patients they have studied. Even in the guidelines also, there are no clear-cut guidelines when to intervene in the isolated tricuspid valve cases. Usually, this American guidelines say that if the patient becomes symptomatic, then we have to intervene. But European are more in favor of before developing the symptoms. If you find that severe TR is there, you can go for the treatment, or either with the surgery or this tric valve or some edge-to-edge repair.
Sir, these are slow flow area, low pressure area. Don't you think that will increase the prothrombotic event in the SVC and IVC? The other thing is, if these patients will require pacemaker in future, what will happen with these valve?
You are absolutely right, sir. But in tric valve, this anticoagulation is it is a lifetime, because it is a low pressure area, so you require lifetime anticoagulation. So far with the anticoagulation, they have not found any thrombotic events over the valves, and regarding the durability of the valve, only short duration, only 1 to 2 years are there, so it is still premature to comment about the valve duration.
So it's not going to reduce the severity of the TR, it just will reduce the complication.
Yes, purely it is to reduce the symptoms. This, that is what the only hope is, that recently they have published it in the 1 year ago, that CT evaluation has shown that it is also showing some myocardial remodeling effect in the RA and RV. If that is so, it is going to be a boon for us. So far, the myocardial remodeling effect in the right side is very, very weak when compared with the left.
Thank you, sir. Thank you, sir.
Thank you. Thank you, sir.
The next speaker is my teacher, and it is my proud privilege to introduce Dr. P.K. Goyal, presently the director, Medanta, Lucknow. Dr. Goyal always tell me that I look coronary from inside, not from outside. And there are many of the things famous for the Dr. Goyal. He has innovated many of the intervention and started many of the new intervention in this area. Dr. Goyal, please.
Thank you, Bharti. It's indeed a pleasure to come here, and grateful to everyone. I had multiple invitations, so I'm really grateful to the Bihar Intervention Council. So this is an add-on talk that was given to me today. So I'm just going to talk a little on the status of TAVI today. So TAVI, this is again new therapy. I won't say it is very new, it is about 20 years old, but in the country it is still in the formative stages. So TAVI is one of the most exciting advancements in the interventional cardiology therapy area. If you see, the first TAVI was done by Professor Alan Crebier in 2002, and incidentally he passed away just a year back. We all know that. And TAVI today is the standard of care for aortic stenosis, even in patients with low and intermediate risk. That is what I'll highlight, so that it's more of awareness talk than really anything else. So causes of aortic stenosis, we know: increasing age, congenital bicuspid valves, rheumatic heart disease, radiation exposure. These are things which can produce it. And we all know the symptoms: shortness of breath, dizziness or fainting on exertion, chest pain, angina on exertion, feeling tired or fatigued, especially in older people, and swelling in your legs. So the symptoms of aortic stenosis have a long latent period, one has to understand. And once the symptoms start, then you have a really strong downhill course. And survival after onset of symptoms, 50% at 2 years, that's it. And only 20% take this into heed. If you see, it has a worse prognosis than many metastatic cancers, like severe inoperable AS. The 5-year survival is so it has to be handled. Well, simple to diagnose. I don't think we need anything much for that. But do exclude AS sometimes in patients which you see like dilated cardiomyopathy, because the murmur is not heard as well, and these patients sometimes are detected to have aortic stenosis. And we know that the velocity of 4 is diagnostic. So now, as far as the treatment, valvuloplasty, well, is palliative but doesn't give much long-term benefit. Surgical aortic valve replacement is the standard of care, and today we are talking of the transcatheter aortic valve. So the benefits of transcatheter aortic valve: minimally invasive procedure, less painful than traditional open heart surgery, hospital stay is shorter, and offers improved quality of life in patients who cannot undergo traditional aortic valve replacement. So this usually we would do a CT, and then you select the valve based on the CT, and access site also has to be studied on CT. That is very important, because that is what will tell you which valve will go and which will not go. So TAVI in the 2020s, if you see the summary of what the trial data shows, you see initially it was done in inoperable high-risk patients, where TAVI was found to be better than optimal medical therapy. Then with the Partner 1A trial, high-risk TAVI patients for high risk for surgery, TAVI was better than aortic valve surgical. Then came intermediate risk in the Partner 2 trial and the SURTAVI, the self-expanding valve trial, where TAVI was non-inferior to surgery. And in fact, the latest low-risk trials show that TAVI is at least as good as AVR or even better than AVR. I'll show you some of these. So these are the trials. So the partner 1B and the US core pivotal trial in inoperable patient, TAVI better than medical therapy. Then these are the ones which have put things into perspective. And high-risk patients, TAVI was better 1-year survival than surgical AVR. And here you see the intermediate risk patients, it is non-inferior to AVR. And the low-risk patients, which is the partner 3 trial and the low-risk core valve trial, shows that death, stroke, rehospitalization with TAVR was in fact lower than surgical AVR, absolute risk reduction of 6.1% with a relative risk reduction of nearly 50%. So which is trying to say that TAVR maybe could be better than AVR also. And that is how FDA approved it in 2019 for low-risk patients with all the multiple trials and the presentations that were there. So then we had the 5-year clinical follow-up study which showed that the outcomes with TAVI and the surgical valves were similar. If you see the valve areas, in fact, surgery produces lesser valve area than what TAVR produces over time, same to same. And the gradients also are a shade higher with surgery, that is in red, than TAVR. So what I'm trying to impress is that the new paradigm today, the earlier it used to be said that when there is symptomatic AS in a 75, 80-year-old person who's high risk for surgery or inoperable, then you do TAVI. But today in the 2020, if you have symptomatic aortic stenosis, patients not suitable for TAVI should have AVR. So what I'm trying to say is that TAVI is today maybe the standard of care. There could be situations where, like the femorals are very small and you can't access, you can't have the valve go through, then he may not be a case for percutaneous. But otherwise, majority of the patients, because this, again, the valve is similar to the surgical valve, and you put it through transcatheter route versus the surgical route. So now here, as you see, the access has now come down from 21 French to 14 to 16 French. Complications are less. The need for PPI is much less. Earlier it used to be more than 10%. Today it is less than 5%. Hospital stays hardly 48 hours. Well, the cost still remains high, and I think that is the main barrier to therapy. And the other thing is, aortic valve disease is coming in younger patients. When it's coming in younger patients, then you have to think of how it will go on further. So because most of these valves, whether you do surgical bioprosthetic valve or TAVR, they will last about 10 to 15 years, not more than that. So so you have to have a strategy that you maybe have surgery earlier and then TAVR in the post-surgical valve-in-valve, or if you have earlier, if you have a TAVI now, maybe 10, 12 years down the line, you can have another valve-in-valve, so that can go on. So more indications, as I said, is valve-in-valve, pure AR also sometimes it can be done. And even in asymptomatic severe aortic stenosis, we have a trial which is going to come up. So the barriers in therapy is primarily therapy awareness. One is the physicians have to understand the need for aortic valve replacement in older patients, availability and benefits over surgery. Affordability is an issue, and patient identification and a proper referral path. So I'll just show you a couple of examples. So I'll not go into the details. Like this was a patient who's 60-year-old male, severe aortic stenosis, bicuspid aortic valve, severe LV dysfunction, 20% ejection fraction. So you do the CT analysis and you see that the area derived diameter is 28 mm of the annulus, and with that 28 mm, so you can you do these pictures, and this is actually a bicuspid. You have a fused raphe here. Okay. Are you seeing my arrows? No. Oh, you're not seeing the arrows. You are not seeing the arrows. How do you show the arrows?
So they might be in case you have, no, sorry. So in case you can use the laser if you
like that. Okay, that's anyhow. So you have fused raphe here, and that is what is making it bicuspid. This is acquired bicuspid. So the tortuosity in the femorals, but no calcium, so that is okay. Size is okay. So 28 millimeter put in here. So the valve that comes is 34 for a self-expanding valve, and these are. How do you run them? It's working there. Okay. So that's the basal angiogram. You see there is amount of AR is also there, quite significant AR. And then you cross the valve with a AL1 catheter, have a stiff wire across that catheter, pre-dilate. The size of the balloon is decided by the annulus size, and then placement of the valve. Well, I'm not going into the technicalities because I think this may not be much useful maybe unless you do the procedure, and then you start the deployment. This is a self-expanding valve, and you confirm the position at the annulus level. You see the valve has to be just at the annulus or a millimeter or two below, and then you release the valve, which is very slow. Slowly this will come out. There are two tabs which will come out. One, because that's the time it can sometimes jump out. So, and then you get a final angio. So there's no AR. The gradients were also 0. Another case, now this is a 69 male nocturnal angina. This patient was admitted with hypertension and LVF. He didn't know that he had aortic stenosis, was controlled on diuretic and this thing, and then we found that he had a aortic peak velocity of 3.4, peak gradient about 50, but he had again moderate to severe AR, and that is what was probably you see that's a dilated LV. So the gradient is about 3.5, 3.6, but because of the AR and dilated LV, he needed something to be done. Again, the CT is done there. I'll skip the CT part. So valve cross with a safari wire placed in position. This is a balloon expanding valve. This is my valve, which is very similar to the Edward Sapien, which is now available in the country. So it gives results almost like the Sapien valve. So once you place it at the right point and then you balloon expand it under pacing, and then immediately you can get a good result. So the procedure is technically easy, so that's the gradients that is seen. Just one more patient. Sometimes, when the coronaries are low, you see this patient. This is a bicuspid with big non-coronary sinus and a small. Can it run again? This side is small if you see the left coronary side, and the coronary height is less. So here there is a chance of occluding the coronary, so you have to do with coronary protection. So we have wired the coronary here along with it, and that's a guide liner which is inside, and the stent is inside the guide liner, otherwise it can scrape out. So you have to do that, and if the coronary remains patent, then you can pull out the stent. So while we are doing the procedure, you inflate. With the inflated balloon, I do angio, and at that time I see that the coronaries are probably flowing, and this balloon size is very much similar to the valve size that is going to come up. So we are now confident that because the space here sometimes can occupy for the valve leaflets and it may not close. So then we pulled the stent back into the guide liner, and this was managed without putting a stent in the coronary. And that's the final angiogram. Okay, so no AR and gradients. Just one last case I want to show. The same technology can be used for tricuspid valve. We were talking of tricuspid valve just now. For valve-in-valve replacement of the tricuspid valve, this was a patient, 53-year-old female. This was a case of Epstein's anomaly, who had surgery for tricuspid valve, and a bioprosthetic valve was placed in the tricuspid position in 2013. I think this procedure I did in 2020, if I'm not wrong. 7 years later, that valve had deteriorated, and so now the patient was markedly symptomatic. So you can put a valve inside this tricuspid valve. So this is the original tricuspid valve. You have to know the details of it. It's very Mount 31. So 28, you have to know what is the internal diameter. It's 28.5. So you will size your transcatheter valve based on this diameter. So you choose a 29 millimeter valve, and you profile this original surgical valve and then cross it with a similar wire going into the pulmonary artery, and then place the balloon this can only be done with a balloon expandable valve. Place the balloon expandable valve there, inflate the balloon, and so now you have a valve-in-valve. So you see this, there's a valve-in-valve in addition to the surgical valve. And that's the final echo after 3 months. You see there is no TR, as you see, and the patient is doing well. She was actually a nurse with us. That's all. So the bottom lines I just wanted to conclude, all patients beyond 70 years or maybe even 65 in our country, because we get this disease earlier and we know that we are 10 years faster than the West, with severe aortic stenosis and in sinus rhythm, are best given a bioprosthetic valve even if undergoing surgical AVR. We know that. And TAVR is a possible safer and more efficient or patient-friendly means of implanting the same bioprosthetic valve in the aortic position. And there is no question of any of the higher risk patients to be advised surgery, where TAVR is definitely shown to be much better than surgery. So with that, but still, we still continue to refer all such cases directly to the surgeon, who will only cut anything and everything whatsoever better the non-surgical option could be, because we have a reflex that it has to go to the surgeon. Valve disease means to go to the surgeon. So my only submission is patients certainly deserve a better decision making. Thank you.
Is there any question from the house? Sir, don't you think in future the tower can replace the SAVR?
TAVR can replace the
SAVR if cost is less.
Yes, you are right. This is what I try to tell to the company guys. You know, we should be able to give it to everyone, because the studies have shown even in low risk patients TAVR is at least equal to surgery. So why not do TAVR? Why do surgery? But the issue is cost is the main issue, I think. One is the awareness and the patient acceptance. Because what happens is this is a disease of the older age. So if there is a 75, 80-year-old person, even if he has the funds, this is what I have observed, he tells his children, why do you want to spend on me? I have done my life. But they don't realize that the symptoms are because of aortic stenosis. If you do this, he will have a very good leash of a good quality life. Well, he dies of whatever reason, that's a different matter later. But this is problem in the society also. And certainly, yes, if the cost could be less, then things could be much better.
How long the life of this newer valve, sir?
This will last 10 to 15 years. It will not last more than 15 years, but yes, it will go for 10 years. On an average, it will go for 10 years. So the best patient is a patient who is about 70 years of age. You do him and he's done his life, if 80 is it. Else, you can also put one more valve at that time. So if you're doing it at 65, say he goes on till 75, 76, I do one more valve. His thing is taken care of.
The newer disease appearing after 10 years, the most of the patients require the valve-in-valve?
Yes.
Or the surgical intervention is better?
No, valve-in-valve. That's what I said, lifetime management. What happens once you have put a valve, to remove this valve and do surgery is more difficult. So I have to be very choosy and careful as to which patient should get it. I only advise in 65 years and plus. So, but anyone who's 65, there is no problem. You can always have two valves, means one now and one at about 75, 76 years of age, which will go up till 85, 88. That's good enough.
Thank you very much, sir, for enlightening us.
Right.
Thank you.
Thank you.
Now we conclude the session.
Thank you so much, sir. Before we move on to the next session, I have an important announcement to make. There are two vehicles with the number BR01EP4407. I repeat, BR01EP4407, and the second vehicle RJ27CH2452. I repeat, RJ27CH2452. These two vehicles are parked at the wrong place and they are most likely to be towed. If the owner is here somewhere, please kindly relocate your vehicles. Moving on to the session on peripheral and aortic interventions. May I request our distinguished chairpersons to kindly grace the stage. Calling on Professor Sanjay Tyagi, President-elect 2024 for Cardiological Society of India National and former Director and Head for GB Pant Hospital, New Delhi. Professor Sandeep Bansal, Professor and former Head for Cardiology Department, Safdarjung Hospital, New Delhi. Dr. Arvind Kumar, President for CSI Bihar Chapter. Professor U.C. Samal Sir, Professor and former Head for Medicine Department, PMCH, Patna. Dr. Ajit Pradhan, Chief Cardiac Surgeon for Jeevak Heart Hospital, Patna. Dr. Ashish Sinha, who is a Consultant Cardiologist for KK Hospital, Bhagalpur. Dr. O.P. Saha, who is the Joint Director for and Head of the Department in CTVS, IGIC, Patna. And Dr. Shambhu Kumar, who is a Consultant Cardiologist at IGIMS, Patna.
So it's my profound pleasure to invite Professor Dr. Sanjay Tyagi. He's been the Chief of Cardiology at the GB Pant Hospital for many, many years and also been the Director General of Health Services and the best person in the peripheral arterial disease that we know of. He's going to tell us about endovascular management of aortic aneurysms.
Good morning, friends. At the onset, I'd like to thank the Bihar Interventional Council, especially Professor Ravi, Professor Arvind, Dr. Samal and Dr. B.B. Singh, and for their kind invitation to this very important interventional meeting. And I congratulate the CSI Bihar chapter for organizing this interventional council meeting, because this will go a long way in upgrading the interventional managements, particularly for the younger lots in this area of our country. Thank you once again. And I would like to speak on the endovascular management of aortic aneurysms. As you know, last 2 decades have revolutionized the endovascular management of aortic aneurysms by these newer interventional techniques. The most important problem with these aortic aneurysms that if they are not treated adequately, then there are high chances of rupture, and rupture is almost always fatal in these patients. So now we have a new interventional technique, that the endovascular placement of aortic stent grafts without the need of invasive surgery and its morbidity and mortality to reduce this risk of aortic rupture. Because once there is a rupture, there is high chances of death in these patients. This involves the placement of a bifurcated or tubular stent graft to exclude the aneurysm from the from the arterial circulation. Thereby, the pressure that is being transmitted into the aneurysms that causes the rupture is eliminated. Previously, the technique that was used is the open repair, and the open abdominal repair required the use of the opening up of the abdomen, both the groins, and doing the repair, the excluding aneurysm by surgical technique by placement of a surgical bypass graft. This had a very high morbidity and mortality, because aortic aneurysm is usually a disease of elderly population which have their own morbidities, and so it was had a very high complication rate, one of the highest risk of surgery. The endovascular technique, which now is a totally percutaneous technique, we do not require any cuts, and can be done within a very short period of time, and patient can be discharged in next day or two. This has revolutionized the management of these patients with aortic aneurysms, whether in the abdominal aorta, which is the commonest site of aortic aneurysms, or the thoracic aorta. Nowadays, we have a wide variety of these endovascular stent graft from different manufacturers, which have their own morphologies and the implantation techniques. These grafts most commonly used is a Medtronic graft, this is Endurant graft, and then Zenith, and other companies are also there. Most importantly, for doing the endovascular aneurysm repair is the pre-procedural planning, similar to that for aortic valve replacement, transcatheter aortic valve replacement. Similarly, this technique also requires a very close pre-procedural planning, particularly with CT angiography with 12 millimeter cuts in the axial plane, to know the location of the renal arteries, the dimensions of the aorta below the level of the renal arteries, the length of the stent graft that is required, and bifurcation, the entry site, just almost similar to that of TAVI procedures that is done nowadays. The diameter of the aorta is very important, because the diameter of the graft that has to be implanted should be 10 to 20% oversized than the neck of the aorta at that site. The angulation should be minimal, like this. You can see here, this is an angulated aorta. So if there should not be marked angulation at the aorta, otherwise there can be migration of the stent graft, and endovascular leak can be there. Also, high calcium at that site and thrombus can also lead to the further leakage of these after implantation. That is called endoleak. The proximal length has to be more than 10 millimeters in length, and diameter has to be less than 28 millimeters, so as to the currently available stent grafts can be implanted if the diameter is, because we have to do 10 to 20% of oversizing. So diameter of the aorta at just below the level of renal arteries has to be less than 28 millimeter. Angulation has to be less than 60 degrees. Also, the iliac artery diameter is also important, and severe tortuosity, calcification are also problematic. Also, these patients should not have other mesenteric artery occlusions, because one of these arteries may get occluded during implantation stent graft, particularly inferior mesenteric artery may be occluded and excluded from the circulation. This is how endovascular stent graft is implanted in these patients. How to play this and video? Can we play this video, please? Anybody to assist in the playing of the video? So as you can see here, from the percutaneous femoral approach, the wire is passed across the aneurysm, and just below the level of renal arteries, the graft is implanted, gradually released, and so as to the covered stent graft is excluded from the aneurysmal from the aorta. The aneurysm is excluded, and then the other side, by the iliac limb, is implanted from the other femoral artery approach, and then the junction is done, and then the post dilatation is done in these patients with the help of a balloon, as you can see here. And then after post dilatation, a well opposed stent graft is there, and then gradually it is released. This is a release technique for the stent graft that you can see here, and then the contralateral limb is implanted from the other side to create a junction, as is being done here. The contralateral limb is then gradually released. device is then taken out after post-balloon dilatation at the junction to smoothen out the fabric. This is one of our case who had a massive, large aortic aneurysms in the infrahelial segment of the abdominal aorta. It would have ruptured any time. This patient came to me from Rajasthan, and then we implanted a bifurcated aortic stent graft in the infrahelial abdominal aorta. You can see here, after implantation of the stent graft, both the aneurysm has been completely excluded from the circulation, so as to reduce the chances of rupture of this massive aneurysms. This is the CT angiogram of this patient on follow-up after 5 years, and patient continues to do well without any endo leak or an aneurysm formation. We published our initial results in JAPI in 2002, and now we have almost more than 2 decades of experience in this technique of endovascular stent graft, and majority of these patients with suitable anatomy can be done by endovascular percutaneous approach nowadays. Similarly, now the thoracic aortic aneurysms can also be taken care with the help of endovascular stent graft. Like you see here, this was a patient with large thoracic aortic aneurysms, which we implanted the endovascular stent graft. This distal to the subclavian artery, could without occluding the subclavian artery, and after placement of the stent graft, the aortic aneurysms has been excluded. There was a thrombus outside. The diameter was markedly much more than that on CT angiogram, and the aneurysm was completely excluded from the circulation, reducing the chances of rupture. We published this way back 2 decades back in Indian Heart Journal, and now we have more than 2 decades of experience in not only in the thoracic and abdominal aortic aneurysm, but also importantly in dissection of aorta. Type B dissection of aorta can be easily treated with the help of endovascular stent grafts. In fact, it has become a treatment of choice for these patients with type B aortic dissection, though type A aortic dissection still requires the surgical approach. The most common complication after placement of endovascular stent graft is the endo leak, which needs to careful follow-up of these patients. There are the proximal and distal site of the stent graft may leak. This is called type 1 dissection, and the bleeding from the vessels is another type, endo leak type, where the lumbar arteries or the inferior mesenteric artery or the branches of aorta may cause the endo leak. If there is significant, these branches are there, then they have to occlude it before the placement of the endovascular stent graft. Then the fabric of the graft, there may be leakage from the fabric, and there may be development of endotension, and there may be chance of rupture. So all these require careful long-term follow-up. Nowadays, the different techniques are there to prevent the development of these endo leak techniques, which I shall be showing you in the follow-up. The challenges for endovascular graft is a short neck and excessive angulation, and because many of the times the aneurysms extend across the branches, particularly renal arteries, suprarenal fixation has to be done. So these can lead to some patient being excluded from the endovascular aneurysm repair. Though now we have newer techniques of placement of endovascular stent grafts, particularly branch stent grafts, are used in such patients. The chimney stent grafts are used in such patients with major vessels across the aorta having an aneurysmal segment. This is another development which has occurred recently, is the development of the stent graft, which can cause the occlusion and sealing of the aortic aneurysms, so preventing the chances of endo leak and preventing the chances of aneurysmal expansion. Also, the migration of the stent graft can be prevented by these new techniques of active fixation with the help of these anchors, which I shall be showing you subsequently. This is the Nellix endovascular stent graft system, where both the limbs are implanted separately, and then the biostable polymer is extruded out from this segment, and then this causes complete occlusion of the aneurysms, causing the prevention of the abdominal aortic aneurysm endo leak in these patients. These are the anesmotic aneurysm. These are these anchors which are implanted to prevent the migration of the endovascular graft. These are anchors like suturing, the endovascular suturing of this stent graft to the aortic wall, and then the migration of the stent graft is prevented by these endo-anchoring techniques. These are the branch stent graft which are now available even by these manufacturers, but most commonly one needs to do it on the maybe in the cardiac cath lab. The branching may be done, and the flow into the main branches, major branches, is preserved by these the branching techniques. This is how in the cath lab the branching is done. The fabric is, the holes are created at the particular sites, and then the stent grafts are implanted, and further the branch grafts are placed into these through the holes into the major vessels to continue the circulation. These are the fenestrated stent graft which are now available from the manufacturers and are much easier to implant in these patients, particularly those patients. But these mesenteric arteries which can get occluded with the help, if there is large aortic aneurysm from the abdominal aorta into the thoracoabdominal aorta, then these multi-branch endovascular stent graft have to be implanted. This is how a stent graft is implanted. This is a video, and this is a technique of implantation of these endovascular stent grafts into the branches, and thus preserving the flow into the branch vessels. Another major area where these endovascular stent graft can be used in the arch vessels, where the similar technique of branch graft implantation has been used to preserve the flow into the major vessels, or hybrid debranching technique, particularly doing a surgical procedure to place a surgical graft into the major vessels, innominate and carotid arteries, then doing a endovascular covered stent graft into the arch of aorta has helped to treat these patients. So dear friends, these ruptured aneurysms are always almost fatal, because these can cause immediate mortality in these patients, and mortality can be reduced by treatment of these aortic aneurysms in the asymptomatic stage. So it is important to diagnose and follow up these patients of aortic aneurysms initially by these ultrasound techniques to know the dimensions of the aortic aneurysms. And in the US, there is all patients about 65 years of age have to undergo examination to detect these aneurysms and to follow up these aneurysms on a yearly basis, depending on the size and expansion. In the males, more than 5.5 centimeter diameter of aneurysms needs to be treated with the help of these endovascular stent graft. Female have a higher chances of rupture at a lower diameter, so a 4.5 to 5 centimeter diameter is an indication for doing endovascular stent graft in these patients. The now newer techniques of branch stent graft, fenestrated stent grafts, are being used for treatment and expanding the reach of the endovascular stent graft in many patients, which could not be done with in the previous techniques. So percutaneous techniques are especially useful as they reduce the morbidity and mortality, reduce the procedure time, and recovery is very fast in these patients, so as to improve the risk associated with these procedures of aortic aneurysms surgery. These patients are now but need careful follow-up because the endo leak may be a problem, and the careful follow-up is done with the help of CT angiogram or the ultrasound to do follow-up of these patients on long-term follow-up. Once the stent grafts are properly implanted and the endo leak are not there in the close follow-up of 5 to 6 months, usually the endovascular leak does not develop unless there is migration of the stent graft. Thank you very much for your patient listening.
Thank you, Doctor. I can't get this mic working. Yeah, that's right. Thank you, Dr. Yagi. That is a wonderful presentation. Really enjoyed it. As a cardiovascular surgeon, I'd like to make a comment. I think I remember it's about, the story is about 16 summers ago. My friends were celebrating my birthday at Hotel Chanakya, and I told them that I'll join them in time for cutting the cake at least, if not earlier. And I was doing a type B aortic dissection, surgical, obviously those days. I think it was past 8. I was still trying to control the leaks and everything, and couldn't join them for the birthday they had planned to celebrate of mine. Then I remembered what Sir William Osler has said. There is no disease more conducive to clinical humility than aneurysm of the aorta. And that's what I quoted to my friends. You see. And then last year, I switched on to doing a TEVAR myself, being a cardiothoracic surgeon. And I was home in about 1.5 hours after finishing the procedure. So I rethought about what William Osler had said. I think it is probably true when we as a surgeons used to do all that. Given the anatomy today, if it was the proper anatomy, there's nothing like doing a EVAR procedures, because as a surgeon, I've done plenty of aneurysms surgically, and I see the problems that we face. But I'd like to end that the person who's actually credited for the TEVAR and the history of TEVAR is actually a surgeon from the much talked about Kharkov area of Ukraine these days where the fight is going on. It was Professor Waldos, who was a surgeon himself, who actually devised and came up. So the credit goes again to a surgeon.
Yes,
thank you so much.
Sure. We always work together.
Yeah, great points made. Any questions from the house? Well, if there are none, thank you so very much, sir. Please join me here.
The next speaker is Dr. Siddhanath Singh, Patna, and his topic is EMAR of thoracic aortic aneurysm.
Good evening, everyone. Today I am going to present a case of pseudoaneurysm of aortic arch arising just distal to the left subclavian artery. So a 76-year female complaining of hoarseness of voice for 6 months along with a dry cough and chest pain on and off for last 4 months with hemoptysis 4 episodes in last 2 months. There was no history of the COPD, a stroke, hypertension and tuberculosis. And CT brain and MRI brain for hoarseness of voice was done 6 months back, which was normal, and visited multiple times with pulmonologist and neurologist for a speech difficulty and cough, and came in the cardiology OPD when she developed chest pain. During investigation, ECG, 2D echocardiography and cardiac marker was normal. So for hemoptysis, I sent him for the HRCT thorax, and we shows there is 4.2 into 48 mm of pseudoaneurysm arises posterior inferiorly from the distal portion of the aortic isthmus, and also there is a clot. So for further evaluation, I sent him for CT aortogram. CT aortogram shows that there is confirmed the position of the pseudoaneurysm. The size of the pseudoaneurysm was more than 50 mm and is originate from the inferiorly and posteriorly just distal to the left subclavian artery. So we plan for, this is the CT aortogram. So we plan for the vascular closure of the pseudoaneurysm. But the issue was that there is very little or deficit landing zone for proximal deployment of the graft. From the left subclavian artery, the landing zone was only 7 mm on the outer surface and 5 mm on the inner surface. So, and the distance from the left common carotid artery was 27 mm on the outer surface and 25 mm on the inner surface. So we plan to do endovascular closure across the left subclavian artery.
this is the exact diameter or landing zone distance from the different reference vessels. So procedure was started under the general anesthesia along with antibiotic heparin was given, and the surgical access for exposure of right femoral artery was done, and for left femoral artery we done the puncture, percutaneous puncture, and from the left puncture we put a 6 French sheath along with pterymo wire, move to the aortic arch with multi-purpose catheter, remove the pterymo wire, keep a marker pigtail catheter in the arch, and from the right side along with pterymo wire and the multi-purpose catheter, we again go inside the arch, remove the wire and keep a LQ wire which is super stiff wire. Oh, sorry. Video for video. Okay, I will play that. From where video will play? No. For video playing.
Video playing, sir. So let's play.
I want to play my video.
This one? Click कर दो. वहाँ play कर दो, sir.
This is from the left femoral axis. We put the guiding pigtail catheter in the aortic arch. Now from the right femoral artery, we kept the LQ wire in the aortic arch. And at the same time, video is playing where not here. Okay. At the same time, a third puncture was done the left brachial artery and kept a JR catheter so that if there is endoleak, we can manage easily. Now from the guiding pigtail, we took a shoot, mark the position. In guiding pigtail, there was 20 markers. The distance between each marker is the 1 centimeter. So after taking a shoot, we mark the position of the proximal landing zone on the screen and fix the table so that the patient doesn't move. Now from the right femoral artery axis, keep the 20 frames of the sheath, and over the LQ wire, we move the delivery system along with the endovascular graft and reach in the aortic arch. After proper position, we take a DA shape to confirm the position of the graft. In the graft, at the proximal end, there are the two markers. One is the 8 marker and another is the 0 marker. 8 marker should be kept on the outer surface toward the left subclavian artery, and 0 marker should be kept on the inner surface. And the stent deployment should be done at the 0 marker because graft are started from the 8 marker, and just proximal to 8 marker there are 70 mm non-grafted metallic part. So by keeping on the exact position, I started the deployment of the graft, and the graft is completely deployed. Here the proximal part of also open. After the deployment, we removed the marker pigtail catheter and kept in the arch across the lumen of the graft. Then remove the delivery system. After removal of the delivery system, we take the DSA, and this shows that there is the endo leak from the left subclavian artery filling the pseudoaneurysm. So we decided to close the left subclavian artery. The diameter of the left subclavian artery was the 6 mm. So we plan to put a vascular plug of 8 mm in the left subclavian artery. And before planning, in CT aortogram, it has shown that the vertebral artery in this patient was the right dominance, means the right vertebral artery diameter of this patient was dominant compared to the left, and she is very old and muscle mass is very less. So we plan that there will be no much issue of the ischemia or any problem after closing the left subclavian artery. So we plug with 8 mm of the vascular plug with the left subclavian artery. After that, we take a cine and it shows that there is no endo leak more. Then we remove the JR catheter from the left subclavian artery and the LQ wire from the aortic arch. And the procedure was completed. Patient discharged after 2 days with single antiplatelet drug and antibiotic. After 6 months during follow-up, there was no cough, hemoptysis and chest pain, but till now patient is complaining of the hoarseness of the voice. CT aortogram was done at 6 months of the follow-up. There was no endo leak. Thank you.
Well done. I think the procedure was well done, and you close the endo leak also. One the technique that is used is the from right in this patient, like you could have seen the integrity of the circle of Willis by injecting into the right vertebral artery and see whether the flow into the left vertebral segment is completely there. Similar technique used for type B aortic dissection. Often we need to close the because the dissection arises very close to the subclavian artery. Then also we need to cover the left subclavian artery origin, and that is what is required. So integrity of the circle of Willis is checked in those situations, and otherwise we may need to put in a chimney graft and to continue the circulation into the subclavian artery also. So congratulations for doing a nice case.
I think this is the end of your talk, and we have another speaker. I think we are done. We are done here. Thank you so much. And we have a very interesting topic today about uterine artery embolization. And I'd like to call Dr. Neerav Kumar over the dais, please. Thank you.
there is some problem, sir. They are uploading. Can you ask next speaker before you? Yeah, definitely.
Your slide is ready? Okay. I tell you about this uterine artery embolization before he begins his lecture. So we started uterine artery embolization way back in 1998 in our country, for the first time in the country, for the uterine fibroids which had menorrhagia, and it proved to be a very useful technique. In 95% of these ladies, the problem menorrhagia disappeared, the uterine fibroid used to shrink, and then we did a thesis with one of my postgraduates, which is now a professor in GB Pant Hospital, Dr. Mohit. I did a thesis on uterine artery embolization by these techniques, and the technique that is used is going into the iliac artery, selectively into the uterine artery, and doing a PVA particle embolization into these arteries, and then these PVA particles float and go to the fibroids, and they cause ischemic necrosis of these fibroids, leading on to the reduction in the size of these fibroids. And menorrhagia is the main problem that disappears, and patients do not need this surgical removal of these. Particularly hysterectomy has to be done in many of these patients. Many of the younger patients who would have otherwise undergone hysterectomy have their uterus preserved for the future fertility. So that is one of the major advantages of doing uterine artery embolization. Then our gynecologists, the obstetrician, required these patients, particularly for postpartum hemorrhage, to be treated. Do you start your procedure? Okay.
Yeah.
Okay. Then we talk about this later on. Thank you.
There is some delay in that talk, so I am going to present next.
Let me introduce Dr. Vipin, Chairman, Scientific Committee. There's a change of guard because of some issue with the slide, but we have a very interesting topic on endovascular exclusion of common iliac artery aneurysm. So, Dr. Vipin, please go ahead with your talk. Thank you.
Thank you. So, I'm going to present one case of large common iliac artery aneurysm, which were excluded endovascularly. So, it's a patient, 65-year-old female, presented with a back pain and lower abdominal pain, and ultrasound was done for delineation of abdominal pain. So, that showed some large vascular swelling in the right iliac fossa. So, after that, CT was done, which showed common iliac artery aneurysm. Sorry. Oh. It is playing. So this is a large aneurysm, 40 centimeter into 40 into 42 millimeter common iliac artery aneurysm, and internal iliac was arising from the aneurysm neck. So we selectively engaged the internal iliac artery, and internal iliac artery angiogram was done, and vessel diameter was measured. And after that, from the opposite side, we have taken, initially I have measured 7 to 8 millimeter internal iliac artery. So I have taken a vascular plug of 10 millimeter, but still it was not occluding properly. So later on, I have taken a 12 millimeter of vascular plug, and there was a constricted segment in the internal iliac artery. So that was occluded with the 12 millimeter of cerebrovascular occluder from the opposite side. And after that, ipsilateral side, 18 into 18 into 1 20 millimeter vascular graft was taken, and which was deployed across the common iliac. And it showed good exclusion of the iliac artery aneurysm, and no endo leak, and internal iliac was occluded with the vascular plug. So in these cases, because aneurysm, this internal iliac was arising from the aneurysm and nearby the common iliac artery, so it has to be occluded before putting a vascular graft, because from opposite side it will still continue flowing if we don't occlude the internal iliac artery. So for complete endovascular occlusion, we need to occlude the internal iliac and then put a vascular graft. So this was the result after 3 months CT angiogram. The aneurysm was completely excluded and thrombosed and no endo leak. Thank you.
I think very well done. And you had shown that the closure of one internal iliac artery does not matter. The pelvic circulation continues, and you had caused the occlusion of that artery. So to prevent the endo leak, so it was perfectly done, I think. Any questions from the audience, or the aneurysms are not uncommon, and these patients who have iliac artery aneurysms often present later on with the abdominal aortic aneurysms also. So these patients should be carefully followed up by this technique, non-surgical technique of endovascular stent graft but is aneurysms from any site, particularly these large vessels, iliac arteries, can be closed easily with the help of these techniques. So it has been beautifully shown by Dr. Vipin. Any questions from the audience? Thank you. Thank you very much.
Thank you, sir.
Thank you. Since the need of slides is still awaiting, now I take the opportunity and I am privileged to invite Professor Sandeep Banshal from Safdarjung Hospital, Delhi. He will be speaking on interventional management of pulmonary embolism. Very exciting topic and very less often discussed in our CME. Dr. Bansal, please go ahead.
Yes. Okay, point. Thank you very much. I thank the Bihar Interventional Council, and I also thank Dr. Vipin Kumar, especially he's been with us, one of the brightest boys we've had. And this would be perhaps the first talk where there will be no videos, because as we'll see, most of the interventions that are done in pulmonary embolism that I'm going to talk about, we don't have the equipment in our country. The Penumbra device has been recently available. I have no experience with the Penumbra device. So the important thing is, why are we so worried about this particular topic? This is oven fresh. This is on June 5th of 2024, and this was from the US. Data of an insurance company analyzed of 105 million diagnoses that were made in a 5-year period from 2018 to 2023. About 500,000 of these were pulmonary embolism, and only 2,000 patients got the advanced therapies for pulmonary embolism. We all know that pulmonary embolism is classified into 3 major categories. The massive pulmonary embolism, whenever there is a sustained hypotension that occurs, or the other features are highlighted here, but the main thing is, if you have a patient of pulmonary embolism with hypotension or a fall in systolic pressure of more than 40 millimeters of mercury, that is suggestive of a massive pulmonary embolism. On the other hand, if you have no right ventricular dysfunction or myocardial necrosis and normal pressure, those are low risk pulmonary embolisms. And there is a moderate risk category which has been again subdivided by the European Society of Cardiology into intermediate high and intermediate low risk categories. And this is the category which is currently also in contention. When we look at the overall population of pulmonary embolism, we find that approximately half or little more than half of the patients are actually, fortunately, in the low risk category. There are about 40% of them who are in the moderate risk category, and they carry a 3-month mortality of about 20%. And massive pulmonary embolism, 2 out of 3 people die within the coming 3 months, but fortunately these are present in less than 5% of the total number of PE patients. The main aim and management of pulmonary embolism is to prevent the spiral of death of right ventricle, because when the right ventricle starts to dilate, tricuspid valve insufficiency occurs, there is neurohumeral activation, there's RV ischemia, decreased contractility, and it ultimately leads to death. This actually outlines the major options that are available for management of acute pulmonary embolism. So we have anticoagulation, which can be with the heparins or the DOACs or warfarin. We have thrombolytic therapies, which can be systemic thrombolysis, which we currently do. There can be catheter-directed thrombolysis, and there can be pharmacomechanical catheter-directed thrombolysis. You can do a surgical thrombectomy. You can aspirate the thrombi, or you can macerate the clots whenever the clot is actually completely obstructing the pulmonary arteries. Then you can macerate the clots to ensure that some flow starts. And of course, there is role of adjunctive treatment. When we look at what the trials or what the studies have actually tried to see, most people have tried to see the RV to LV ratio as an indication of success. We all know when pulmonary embolism occurs, one of the things that happens is that the right ventricle dilates, and the right ventricle to left ventricle ratio of more than 0.9 is taken as a sinister sign. It is a sign of right ventricular overload. The patients are hemodynamically compromised, so we want that their hemodynamics in the form of blood pressure should improve, their oxygenation should improve. We also know that bleeding occurs because of thrombolysis, so the bleeding complications need to be reduced. We also look at mortality, which may be in hospital or 7-day mortality, and then 30-day, 9 days, and longer term, 3-year mortality. One of the complications of pulmonary thromboembolism is the CTEPH, or chronic thromboembolic pulmonary hypertension. And the trials have also tried to see if any one of the therapies can prevent this type of complications also. When we look at the general scheme for pulmonary embolism interventions, the newer things that have happened is, one is ultrasound assisted thrombolysis. So you have a catheter in which there is an ultrasound catheter also, and the ultrasound breaks the fibrin and gives a better penetration to the thrombolytic therapy. You have rheolytic thrombectomies. These are high pressurized saline injectors which also macerate and suction out the thrombus. You can aspirate the thrombus manually or also mechanically. You can cause an extraction thrombectomy, or you can cause thrombus fragmentation, as I said, the maceration or churning of the thrombus. The various pulmonary embolism devices that we all have at the present, I'm not aware if any one of these is available in India, but a few of them, the Ecosonic and the Craig McNamara and Bashir endovascular catheter and AngioVac. So except for Unifuse, all others are approved in the US. So in the first four, the first three are basically ultrasound based catheters, which will give ultrasound delivery, break the thrombus, and help a better delivery of the thrombolytic therapy, and result in better management. AngioVac is a suction system, and further we have larger devices such as the flow retriever or the Indigo system or the AngioJet system. This is the acoustic pulse therapy, or a catheter inside of which there is another catheter which delivers ultrasound. Multiple lengths have to be kept within the pulmonary artery, and these give ultrasounds and they break the thrombus. There is another catheter called Bashir's catheter. This has also been recently approved by the US FDA, which again delivers, which churns the catheters, the thrombus, and at the same time also delivers the thrombolytic. So on the left side of the screen, we can see before the ultrasound has been delivered, there is a dense, fibrin network, and after the ultrasound has been given, it breaks into very fine mesh through which the thrombolytics can be delivered much better. The access is usually femoral, and one can use a number of catheters. We usually use only the angled pigtail in our center for catheter-directed thrombolysis in the pulmonary artery, and stiff guide wires are used. Another advantage of these catheter-directed therapies has been that you can use much lower doses of the thrombolytic therapies. In order to prevent bleeding with the high doses, you can use TPA, which will be total of about 18 to 20 milligrams, and you're able to achieve a flow in the pulmonary artery and an improvement with the help of low dose of thrombolytic. So, as one can see in this, there are two catheters. The dotted lines are the catheters which have been put in both the pulmonary arteries, and through these the ultrasound waves are given, and at the same time the thrombolytic is injected. Now, what has been seen is that there is a reduction, and this Bashir's catheter has been found to be slightly better than others in terms of this. Also, the bleeding complications, the comparative safety has improved with these delivery catheters, and so you are able to have lower bleeds, and you are able to have a better efficacy as compared to the peripheral, as also against a plain catheter in the pulmonary artery delivering the thrombolytic agents. There are others where you can have the powered aspirations, means there is a mechanical suction device which can aspirate the thrombus. So this is one. There are others like the penumbra device. Penumbra I saw very recently. There are some people who have started to use this in coronaries as also in the peripheral veins, but I'm not aware of cases where penumbra has been used in pulmonary artery in our country. There are other devices like the flow retriever. This is a diagram which shows the different types of catheter-directed therapies that are available. I already talked about the ultrasound. There is a flow retriever catheter which also churns the catheter, the thrombus in the pulmonary artery, and the others can be rheolytic based, means breaking the clot, or lysing the clot based. This is the penumbra indigo system. See the difference between manual suction, and the mechanical suction is that whenever we apply a suction, when we stop to change the the suction syringe, then at that particular time, howsoever accurate we may be using a three-way catheter, the negative pressure is lost, and that causes a lot of problem. But if you have a continuous suction system as with the pumps, then they work better. Manual aspiration catheters are also available. So this is a kind of a manual retriever that we have. This is yet another kind, because these are not available. I could only get the diagrams of these from the literature. So these are other manual aspiration catheters. And then you have the power aspiration catheters that are highlighted here. The important thing is, as we increase the size of the catheter, the suction power increases. You can extract out larger clots, and this is the kind of clot that we are actually looking at. But as was being discussed in the morning, remember Dr. Goel said in the morning regarding the pulmonary valve dilatation that if you go with too thick and too stiff a system, the right ventricle gets compromised. So similarly, if you go with a catheter system which is beyond 14 French, it has been seen that an already sick patient who is sick with pulmonary embolism, he falls even sicker, and there is a decompensation further of the right ventricular system. So that is one of the limitations of these large bore catheters. There are a lot of studies. These are largely small studies. So these are basically studies which have tested, catheter-directed thrombolysis with the with the conventional thrombolysis. And at the bottom of this is the PITHO study, which had used intravenous tenecteplase in the pulmonary embolism. There are others which have used which have just tested the single arm systems of pulmonary catheter directed thrombolysis systems, and there are others in the bottom which have used the ultrasound based systems. There are still others which have tested the mechanical thrombectomy, but this is actually the main summary of these trials, that as far as the primary efficacy is concerned, they do cause a change in the RV to LV ratio. These have been found to be safer, except for the larger flow retrievers. If we see the orange one, the very large bore systems, they continue to have higher adverse events. They also have higher bleeding events, and they do not cause a greater reduction in hospital mortality. So although these systems are in place, at the present time they are being used in minuscule population. Secondly, at the present time the guidelines recommend them in only the massive pulmonary embolism. These patients are already at high risk for mortality, number one, and secondly, a large amount of their morbidity is actually contributed by their comorbidities. Whether the patient has underlying cancer which has caused thromboembolism, we are working with our backs to the wall, because majority of the times pulmonary embolism is because of surgical causes, where patients have been operated recently and a lot of thrombolytic therapies cannot be used. So the current understanding is that perhaps the intermediate high risk of category, they should be given also these catheter directed therapies. So this is a real world database of pulmonary embolism patients. So we see 500,000 patients in one and nearly 3.5 lakh patients in others, and in very minuscule numbers these therapies have been used. The second thing is, we don't know which is the best therapy, or we can just we can pick and choose whatever we get, or is there any therapy which is superior? There is one analysis which has again come in 2024, which has seen that the advantage of catheter directed thrombolysis in intermediate high risk patients are tremendous. You are able to manage these patients with a low dose of TPA, almost 18 milligrams, and 30% of them actually receive much lesser doses. The 30-day mortality has been 1%, which is quite low, and there is a statistically significant reduction in the RV to LV ratio. This is the basic algorithm. So if your patient has hemodynamic instability, he is already a high risk patient. If he doesn't have that, do the enzymes like troponin. If the patient has a troponin positive, he is an intermediate high risk category. So in these patients, all these catheter directed therapies or thrombus extraction system therapies, they need to be used, particularly if your thrombolysis fails. So this is from the European Society of Cardiology, that in the highest risk, the interventions are used, including the thrombolytics, catheter-directed thrombolytics, along with thrombectomy. In the intermediate high, there is a question mark still, but increasing evidence thinks that perhaps using these therapies in this category of patients may perhaps prevent the patients from going into the high risk category, and it should be used in those patients. Another, this is the first trial which has compared which is comparing the medical, mechanical thrombectomy versus catheter-directed thrombolysis as a means of, as a mode of therapy. And this trial, called the Peerless trial, will perhaps give us an answer as to which is the best form of therapy in massive and high-risk submassive pulmonary embolisms. As far as my experience is concerned, this is a patient I could get, which we treated about 3 weeks back. This was the thrombus. So CTPA needs to be done. You don't treat these patients without a CT pulmonary angiography. You have to document the thrombus, and these thrombi are marked here. So after the this is after the COVID period, say Jan 21, we've had 23 patients. Most of them we have treated with thrombolytics. We have tenecteplase available on the house. In 2 patients, we did catheter-directed thrombolysis using a pigtail catheter because it has multiple holes. In 2 patients, we macerated again using the pigtail. We also realized that on the on the CTPA, it was a central thrombus. So we sent these to our patients, to our surgeon for surgical thrombectomy. One of them died and one survived. That is all that I have to say. I thank you for your kind attention.
Thank you. Thank you, Dr. Bansal, for the wonderful presentation. Really enjoyed listening to it. I'd like to share one experience, an experience which I think will probably become a part of the history with all the advances in interventional cardiology. This is about 25 years ago. One of the leading physicians of this town and leading diabetologist, Dr. Ajay Kumar, referred a case to me. A patient was I don't know why, he was conservatively being managed after a fracture femur. He was bedridden. He referred the patient to me. The patient was in cardiogenic shock, thin, steady pulse, blood pressure of barely 60 systolic, cyanosed, with a clinical diagnosis of massive pulmonary embolism. My cardiologist took him to the cath lab, took a shot, and the pulmonary artery was totally cut off. I took the patient to the theater straight away. Before I could put the knife on the sternum, he had a cardiac arrest. Went to crash on bypass, was able to retrieve that massive pulmonary embolism. The patient walked home. So I guess with all the advent in this, what I saw today, this had probably become a part of the history. I don't think we'll be getting a chance ever to handle such patients again.
See, I think surgical thrombectomy has an absolute role, because if the thrombus is central particularly, then taking out the thrombus is curative. There is absolutely no substitute for surgical thrombectomy done in an appropriate patient. So we are partners again. We are not competitors in that.
Actually, the Penumbra device for pulmonary embolism is available, and it is being used quite a lot in my hospital. So, because I don't do that, the pulmonary embolisms are done by the interventional radiologist. So, but they do a lot of them, I know that. Okay. And it is really, and we get patients, maybe one massive pulmonary embolism in 15 days, certainly there'll be there a patient, 1 or 2 patients a month, certainly they will do.
Just a quick comment. We have used 2 Penumbra devices in pulmonary embolism, and the problem with this Penumbra at this moment is a huge, blood loss. So it will keep on suctioning with the 8 French catheter, and in 3-4 minutes time, you have 300-400 ml, coming out. Now they are coming with a lightning system in this Penumbra device, where the suction will start once the catheter engages the thrombus. Suppose there is no thrombus is engaged, so thrombossuction will not happen. So I think this lightning system will be a real advancement once it comes.
That bleeding is a problem, and actually the angiovac system that I showed, that takes care of that.
The biggest problem is that, so once you use it and you see the amount of blood that is coming out, patient is in hypotension, and suddenly you find it is very difficult to supplement immediately the same amount of fluid. That's a problem with penumbra.
Sure.
We've
Yes.
used it, but it's threatening to, it just very difficult to see that blood loss that is happening immediately.
The lightning will be the game changer. I think
Yes.
it's
Just a very short comment. In those patients who are coming with pulmonary artery hypertension is not uncommon. One should always look for repeated pulmonary thromboembolism that is now treatable with the help of balloon angioplasty in many of these patients. That is a treatable cause of pulmonary artery hypertension. So always in those patients, we all see patients with pulmonary artery hypertension. The thromboembolic pulmonary artery hypertension should be excluded, and if it is there, like Dr. Bansal has shown, a CT angiogram is very helpful in diagnosis of these patients who have occluded pulmonary arteries and are treatable. Like major pulmonary arteries, central pulmonary arteries can be treated easily with the help of surgical techniques, peripheral pulmonary arteries by balloon angioplasty.
Yes. And we also have Riociguat now. For
Thank you,
CT.
sir. Since we are already 1 hour late, I straightforwardly invite Nirav Kumar. His slide is ready to speak on uterine artery embolization.
Good afternoon, everybody. So this is uterine artery embolization. I am going to talk about the uterine artery embolization. So historically, when anything goes wrong with the uterus, the gynecologists used to remove the uterus. That was the normal from 60s. So these are the recent innovation, and in first case was done worldwide in 1976. And definitely it is very good modality to treat, and it is good for us also to break the boredom of doing coronary every time. This is one of the gratifying one thing which comes out with a gratifying result. So this is uterine artery is branch of internal iliac artery. Here you can see, and it is usually first and second the branch. So uterine artery, it comes out from the internal iliac artery. It goes vertically up to the cervix, then it ascend upward, and it also supply the fallopian tube and upper portion of the ovarian artery. So another important artery which is emerging is the vaginal artery. So if anything goes wrong, it can damage the vaginal artery also, and if PVA particle or glue or something which goes into the fallopian artery and ovarian artery, it can cause menopause, as well as it can cause damage to the fallopian tube, and next pregnancy can be hampered. So that is the problem. So this is the usual, and if uterine artery get blocked, it can be supplied through the ovarian artery, through the interconnection between that, and also through the vaginal artery. So if uterine artery, if we are going to close the uterine artery, it is not the end of the uterus, but definitely the major portion of the uterine blood supply is get clamped. So this is the usual radiological view. This is the internal iliac artery, and this artery is uterine artery. So we can go in uterine artery with the catheter from opposite side, or we can go with the catheter from the same side. We can use the 3 French catheter. In that condition, we can go in the similar way. Otherwise, what I used to do using the RDC catheter, that is also very useful. 6 French RDC catheter, that gives very good visualization. First, this is the first shot, and this was the case of uterine AV malformation. Very massive bleeding was there, and the hemoglobin was around 4. No gynecologists were interested in doing this case. That's why it was sent. Usually it is being done in our institute by interventional radiologists. When patient is more sicker, they used to send us this patient. So here we can see the uterine artery. Uterine artery origin visualization is very important, and it can be visualized from opposite or oblique view. Here this is the AV malformation. So we pass the normal coronary wire, BMW wire, through the uterine artery. Here we can see the wire is passing into the uterine artery. We confirm it that it is in uterine artery. So through that wire we used to pass the micro catheter through it. Micro catheter is going into the, it should be, we should go as distal as possible so that vaginal artery should not get blocked. And here we can see, we can confirm it with the dye through the micro catheter also. So here we can see the uterine artery and AV malformation is visualized, and we can deliver the coil at the appropriate side. Mostly near the curve, it is better to deliver the coil. So the first coil was delivered. Then we check whether uterine artery, after 5 minutes we checked whether uterine artery is blocked or not. It was not blocked. Then we delivered the second coil, and then we confirm it. So it was completely blocked because after 2 coil, the coagulation material is being formed in between the 2 coil, and the uterine artery was completely blocked. Similarly, the opposite side of uterine. Opposite side of uterine artery is being recognized. Similarly, the coil was passed through it, and after delivering the coil, we confirmed that the uterine artery is completely blocked. You can see the backflow from here. So uterine artery of opposite side is being blocked. So we are doing it regularly, particularly in AV malformation, that is rare congenital anomaly, which cause massive bleeding, or it can be acquired because of DNC and other surgical procedure. AV malformation can be formed, and it is being used for uterine fibroid also. In uterine fibroid, the menorrhagia, the pain is being relieved with this procedure. It was better than doing the uterine removal of the uterus through the operation method, but the pregnancy was better with the future pregnancy was better with the uterine artery with the operation than uterine artery embolization. Uterine AV malformation, particularly in sicker patient, it is treatment of choice. In postpartum hemorrhage, if uterine atony is there, heavy bleeding is there, hemoglobin is low general condition, so it can be done quickly, and it can stop the bleeding in almost more than 94-95% cases. In gynecological malignancy, surgeon want that there should less bleeding during the operation, or if because of gynecological malignancy bleeding is there, in that condition uterine artery can be blocked. If there is abnormal placental accreta type of thing, if the bleeding is there and the surgeon want to preserve the uterus, in that condition also uterine artery embolization is a good choice. In case of ectopic pregnancy site is in fallopian tube, the uterine artery can be blocked. So these are important indications in which uterine artery embolization is emerging good choice in treatment of the patient. Thank you.
Thank you. I'd like to highlight that this is a very useful technique. I'm happy Dr. Neerav has elaborated this and his experience in this, because it has, in particular, it is very useful in patients with postpartum hemorrhage. Those patients with low hemoglobin, surgeons don't want to operate, and the treatment of uterine artery embolization is life-saving. So this technique is available here. So I compliment Dr. Neerav for his wonderful work.
Most of the time, actually, when you do uterine artery embolization, the gynecologist will not be happy, sir. Gynecologist will not be happy. So, you actually, when I was doing in 2004, 2006, I stopped it because many gynecologists opposed me, and then they were not referring even cardiac patients to me. So I decided that better to have more cardiac patients than uterine artery embolization. But I will still tell you that there are submucous fibroid, subserous fibroid. Submucous fibroid is very good because the hemorrhage. Patient will have bleeding per uterus, and they will be having more benefit than, and severe pain will be there, those patients, and young people. And subserous is a large one, and it's mainly in the older population, where you allow the surgeons to do that. Let them remove the uterus and be happy. Thank you.
No, that is certainly right. The fibroids they want to take over, but postpartum hemorrhage they want to thrust over the cardiologist if that facility is available, because then otherwise that patient would die. Postpartum hemorrhage is the commonest cause of maternal mortality in our country, and this technique of uterine artery embolization should be available at every place, every center, every cardiologist should get experience in uterine artery embolization. That is what I would like to say that.
I request Dr. Kunal Kishore to come in dialysis. He is at present posted in Indira Gandhi Institute of Cardiology. He is hello. He is posted in Indira Gandhi Institute of Cardiology at present. The topic is ascending aorta replacement. Please proceed.
Very pleasant good afternoon to all the respected people on the dais and the esteemed faculties and the guests here. Actually, the topic, as you must have gone through, is Wheat's procedure with DVR. Being a group of mainly cardiologists here, I thought that it will be difficult for you to understand, like, Wheat's procedure is a type of aortic valve replacement. Till now, for most of you people, it's synonymous with Bentall procedure, where we replace the ascending aorta, the aortic valve, and replace the coronary artery buttons over this place. So I had the privilege of performing both these procedures within a span of 1 week. So even before directly going on to the Wheat's procedure, I would like to just elaborate a few steps of Bentall so that you can compare what is the difference between the two procedures. Now, this was the first patient who was referred to me, 36 years old male, with history of typical symptoms of severe AS. And on echo, we found it to have a bicuspid aortic valve with severe AS, moderate AR, mild to moderate AR. And the ascending aorta was supposed to be dilated on echo. So we went ahead with CCT, and we found that the ascending aorta was about 5.2 centimeter, which was a clear indication to go ahead with the Bentall procedure. Now, this was the intro of photo where you can see. Marker, please. Can I have the marker? This one. Okay, this one. So this is the intro picture. You can see the ascending aorta is dilated and the sinus is hugely dilated for this patient. So we dissected this, and you can see this coronary buttons here. This is the left coronary button, this is the right coronary button, this is the non-coronary sinus. And okay, this is the video where you see we have dissected and we have introduced that flushed with the coronary buttons with cardioplegia so as to arrest the heart. And this will be the next video where we see the surgeon preparing the graft, where we suture this valve along with the aortic conduit. Usually the valve is odd in number and the conduit is even, so we place suture the valve with a higher number of conduit, just one number higher. And this is the picture where we see, you can see you have taken the sutures, pleated sutures to the aortic annulus, and the next picture you can see we have sutured, taken these sutures from that conduit, and when we and then finally we implant that conduit there. Now coming up to the final outcome, this was the post-op picture. We have lowered the conduit, and this is the final outcome where you can see the well beating heart with the normal hemodynamics and the conduit in place. So this was all about the Bentall procedure. Now this was the post-op CT where you can see the valve in place and the normal appearing aorta, all starting from the root up to the arch. Now coming to the patient proper, that is the Wheat's procedure. He was a middle-aged man, 29 years of age with recent history of breathlessness and history of orthopnea with chest pain. And he was a known case of rheumatic heart disease for which he had underwent a closed mitral valvotomy about 10 years back. Now the first thing which came to our mind was restenosis of the mitral valve. But on examination we found a systolic murmur in the aortic area, and we thought that something different is there. So we did an echo and we found the patient had a moderate MS and a severe AS. So he had to be planned for a double valve procedure, which is a redo procedure in considering post CMV status. And in addition to that, we found that he had this was a shock, that he had a dilated ascending aorta with a suspected flap in the ascending aorta. CT was done and it confirmed that the ascending aorta was dilated with a dissection flap, and it was extending up to the proximal arch, just up to the origin of innominate artery. Now, this is the CT picture, CT X-ray where you can see the dilated aortic root, and this is a CT where you can clearly see the ascending aorta which is dissected right from the root up to the origin of the brachiocephalic trunk. So the procedure we planned was, since it is a case of aortic dissection and a redo case, even when we start dissecting the pericardium, there were high chances that the aorta will give way and the patient will have catastrophic bleed and we will leave the patient on table. So according to the plan, we had dissected the groin, exposed the femoral arteries so that we can go ahead with the emergency bypass. Now this was the echo where you can see that the aortic valve is, there is a stenosis of the aortic valve and there is a false lumen here, and the true lumen is smaller as compared to the false lumen. Just opposite to this is the left main coronary artery. So just opposite to that, there is a dissection flap here, this side. Now this was another echo window where you can see, as we go ahead, you can see the dissection flap in the ascending aorta. Here you can see the dissection flap. So this was the intro picture where you can see, as compared to the Bental here, the anatomy is not very delineated because it was a redo case post CMV and there was a lot of additions. So here you can see we have dissected the pericardium, and the whole the heart does not have a very good markings where we can dissect each and every structure. Now this is final dissection of the pericardium where we can see we are dissecting of the pericardium from the aorta. Usually when we open the heart chest, we start dissecting opening the pericardium over the aorta because that is the most stable structure as compared to the beating heart under it. But since this was a case of aortic dissection, we started dissecting the pericardium right from the its reflection over the diaphragm. So the lower part of the pericardium is dissected first, and then we go ahead up to the ascending aorta. And this next picture you can see the dissection is complete, and this up till this end where you can see this clip. This is the dissected segment of the aorta, and beyond this the arch appears to be normal. So we went ahead with the cardiopulmonary bypass, and we cannulated the arch, the IVC, and the innominate vein. Now this is after we have opened the aorta, and you can see we are trying to delineate the anatomy here, and you can see this dissection flap here on the right side. While this is the right coronary sinus here, and the right coronary sinus appears to be normal, there is no dissection there. So for Bental procedure, we had to dissect this right coronary sinus, left coronary sinus, and raise the flap of this coronary arteries. But because of these additions, this was not possible, so we changed the plan to a wheat procedure. Now this you can see, we have after the DVR, means replacing the aortic valve and the mitral valve. Now we are finally replacing the ascending aorta, and here you can see this is the end point here, where just above the sinus we end the proximal end of the aorta, prosthetic aorta, and this is the distal end being sutured to the distal end of the graft being sutured to the arch of the aorta. Just few minutes more, and this is the final outcome. You can see the dissected aorta here, and this is the remnant of the graft, where you can see we have fashioned it so that it extends into the non-coronary sinus, but the right and the left coronary sinus of the patient is retained here. And you can very well appreciate the difference. This is the case of redo case, where none of the anatomies are very clear, while this is the Bental where we had done initially, and the anatomy is very clear. So here we could replace the coronary buttons, and we proceeded with Bental, while here the dissection of the coronaries was difficult, and so we proceeded with the Wheats procedure. And this is the post of CT. You can see the two valves in place, and here you can see the valves in place, and the normal appearing aorta right from the root up to the ascending arch of aorta. So finally, to summarize, the ascending aorta replacement does not only mean Bental procedure where you replace the ascending aorta, aortic valve, and reimplant the coronaries, but there are other procedures like valve sparing procedures where you replace only the ascending aorta and reimplant the coronaries, leave alone the native valve of the patient, which is Yakub procedure and David procedure, while this procedure, which was coronary sparing procedure, where you replace, which is called the Wheats procedure, where you replace the ascending aorta, the aortic valve, and you spare of the coronaries there. Thus the aortic sinuses are retained, while rest of the ascending aorta and the aortic valve is replaced here. So this is a diagrammatic representation where you can see this is the Bental procedure and this is the Wheats procedure. What we did was a mixture of this Wheats procedure and coronary sparing Yakub procedures, where you can see this is the prosthetic graft extending to the non-coronary sinus. So it's a mixture of both Yakub procedure and Wheats procedure, which may later be named according to our choice. And thank you. This is the team which performed this surgery. To the left, we have the surgeon and the OT staff, while to the left, to the right of the patient is the ICU staff. I would like here to mention that this would not have been possible without the mentorship of Dr. Arvind sir, who just pushed me to go ahead with this surgery, and also the anesthetist, Dr. Rajneesh, and my two colleagues, Dr. Aditya and Dr. Ghaznafar. Thank you.
Congratulations, Kunal. Well done.
Thank you, sir.
And what was the diameter, although it's immaterial, at the sinotubular junction, the aortic diameter?
So it was actually the main true lumen was very small. But the actual lumen was, the total diameter was 6.5, which included the dissected segment and this.
Okay. I mean, it seldom comes across Wheat procedure in the days of Bental. I'd just like to make a comment, which is that traditionally we've been taught that bicuspid aortic valve, once there's an aneurysm, you're supposed to do a Bental procedure. But coronary sparing operations are seldom done in a aortic bicuspid aortic valve, aortic stenosis with a aneurysm or a dissection. But Wheat procedure actually simplifies things, or if you, because, but then was it a supracoronary implantation or supracommissural?
It was
because a lot of people confuse supracoronary with supracommissural. You retain the aortic sinuses, I see.
Yes, sir.
Yeah. So it's actually a supracommissural replacement, and I just end up here because we're running short of time. There was a recent paper from Japan coming out. This is 10 years of study. Traditionally we've been taught that we have to remove everything because the residual aorta is going to dilate in case of bicuspid aortic valve because that aorta is diseased. They did a supracommissural, just the graft replacement of what you had done, yes. Okay? And they replaced the aortic valve. And they followed the patient for 10 years. There was no dilatation of the aortic sinuses. So that probably brings to the point, should we go ahead with a more exhaustive and prohibitive procedures like Bental when we can just go ahead and do a aortic replacement, supracommissural, which is very simple, and replace the aortic valve. That's all. But well done. Thank you.
Thank you, sir. Sir, one thing I would like to mention here, it was not a case of acute dissection. But when we opened it, the dissection flap and the original aorta was very thick enough to hold the sutures. That's why we went ahead with Wheats rather than going ahead with the Bental procedure. Thank you, sir.
Thank you. I think it was a wonderful session, and I think we close this session because in the interest of time, and we can have questions and answers during the lunch time.
Thank you so much.
Thank you so much, sir. There is a slight change in the schedule. We'll be preponing the chronic total occlusion session, and we'll be having it now before the inauguration. Calling upon the distinguished chairpersons for this session, Professor Dr. S.K. Dwivedi, Professor and Head, Department of Cardiology, KGMU, Lucknow, Professor Dr. P.K. Goyal, who is Director, Medanta, Lucknow, and has also been a professor and former head for SGPGI, Lucknow, Dr. Sanjeev Kumar, Consultant, CTVA Surgeon, AIMS, Patna, Dr. Nishant Tripathi, Consultant Cardiologist, HDNE Arogyam Hospital, Patna, Dr. Sandeep Kumar, Consultant Cardiologist, IJIC, Dr. Ravi Vishnu Prasad, who is the Professor and Head of Department, IMS Cardiology, and also the Organizing Secretary, Dr. Arvind Goyal, Director, Cardiac Surgery and CTVS Surgeon, Paras Hospital, Patna, and Dr. Abhinav Bhagat, Consultant Cardiologist, Heart Hospital, Patna. I would request the speakers to kindly adhere to the timings as we are already running an hour behind the schedule. Thank you.
Good afternoon, everyone. So, I'm privileged to chair a session in which my two teachers are going to speak. Without wasting much time, I'd like Professor P.K. Goyal needs no introduction to this audience, and who else to speak on approach to a case of CTO. So, I will invite my teacher, Professor P.K. Goyal, first to speak on approach to a case of CTO. Thank you, sir.
Where is it?
Can someone have the slide up, please?
Yeah, PK Goyal 2. Okay. Okay, thank you, friends, and once again, my gratitude to the Bihar Intervention Council and all the Dr. Nishant, Dr. Bharti, and everyone. Okay, so I'm going to talk on CTO intervention, approach to CTOs. So actually, if you see, no CTO may be non-operable in the hands of some operators, especially those with retrograde skills. So individually, probably every CTO can be done. But then should I then do all CTOs and or all cases with CTO? I think the answer is no. When would I not do a CTO? A vessel or territory subtended is very small, less than 10% of the LV. It's not worth the effort. First primary thing I would always say that you should have angina or evidence of ischemia. Without that, there is no use. Correct. But multiple CTOs in the same case calling for too much of an effort, then the cost risk benefit doesn't favor us. You may do one CTO, then you end up with another one which is there. So if other vessels are okay and there's one CTO, then it's a good case to do. associated lesion producing complexity that may not be ideal for good long-term outcomes. There are multiple complex lesions, diffuse disease that may not be manageable by PCI as such. So there are situations, and then you have to really choose your patients right. A few basic guiding thoughts for any CTO. This is technically, understand the CTO in three parts: the proximal cap, body, and distal cap. This is how one can do it. Understanding CTO pathology with respect to intima or subintima and the presence and location of microchannels, if any. Judging the length of occlusion, wiring, the very basic principles, wiring only under distal vessel vision. So the distal vessel has to be seen when you're doing CTO, and you have to show it somehow or the other. Wiring only with microcatheter support. You cannot do it without a microcatheter support. And then you have to, of course, shape the wire appropriately. So now this is what it shows. So CTO is proximal cap, body, distal cap. So that is what you have to keep in mind. You have to understand if there are micro channels and which ones can be tracked and which ones cannot. And you wouldn't be surprised that up to 78% of patients which have CTOs have some recanalized channels, and these are the ones that we use for CTO crossing. And several times some things that look very tough can also go if you done appropriately. Okay. Judging length of occlusion, well, CT angio is the ideal one that people say should be done, but not everyone needs it. A good angiogram can always show you the length of occlusion if you run the angio long enough for the collateral to fill the distal vessel well enough. Like you see it here, so that's the length of the occlusion. We have given time for the contralateral to fill it till it stops filling. So you have to do the angiogram, run it till it stops filling distally. Wiring only under distal vessel vision. What does it mean? The distal vessel is always there and should be visible in any CTO which is worth an intervention. If the distal vessel is not there, then either it is an acute occlusion or that area is totally dead and then it cannot be done and does not need to be done. Distal filling contralateral injection is usually a must as a guide to antegrade wiring, because sometimes even when you see vessels in ipsilateral filling, then when you do the CTO wiring, some of the collaterals, bridging collaterals stop, and then you don't see the antegrade filling, and then the contralateral comes up. Wiring only with microcatheter support, because this is what will give you extra support on the wire, reduce wire bias, and improve the penetrating power of the wire. In fact, if you put a microcatheter right at the tip of the wire, your penetrating power of a soft wire also increases, and sometimes it is negative. Now, this is a basic physics of CTO wire tackling lumen to lumen. You see, basically, there are three types of resistances that we have to go through. One is the wire tip force. Second is the resistance in the loose tissue or the fibrous tissue of the lesion. And third is the resistance in the plaque, which will get you out. So what you ideally need is that the wire tip force should be more than the resistance in the loose tissue, but less than in the plaque, less than 3. But that always doesn't happen. You have different wires to do different things here then. And guiding catheter backup force adds to the wire penetration force. If you don't have a good guiding catheter backup, then even the toughest wires will not cross. So if during wire advancement you see that the guiding catheter is backing out, it suggests that the wire is too weak compared to the resistance in the lesion, or you are heading a wrong way. So always be understanding as to what's happening to the guiding catheter when you are wiring. Dedicated CTO wires, I don't think I'll go into details of things. We talk in terms of tip loads, tapered versus non-tapered. As the tip load increases, you increase the penetrating power. Tapered wires have more penetrating force. Coatings, hydrophilic polymer jacket for more semi-occluded or semi-recent occlusions. Penetration force versus efficiency. Now there is a wire like the Gaia wires where the tip loads are less, but the penetration efficiency is more because they have tapered tip and they have something called a compact composite core or Act 1 tip, and then a torque transmission 1:1, whether the wire takes 1:1 transmission or not. So these are things one has to understand, and there are factors by which you make choices for wires. How long is the occlusion? Is it a post-MI setting? This is where polymeric wires might work. If there are micro channels, then something like XT or wires will work. Proximal cap is tapered versus blunt. If it is blunt, then you need penetration force, which will be given by something like conquest or something. And if there's a bend or tortuosity in the segment, calcification and branch point at the distal cap. Wiring techniques, well, usually is antigrade wire escalation, then you have antigrade directional penetration, and then step down. If you have penetrated the cap with a stiffer wire, then you step down, because usually it is the proximal cap that is tough and the distal cap also is tough, but the body is usually softer and you can traverse much better with a softer, less penetrative wire. Directional re-entry in cases of inadvertent subintimal entry. There is a 3D wiring concept by which you can do those wirings. If you get subintimal, parallel wiring can be done. An elective antigrade dissection re-entry using either a crossbars or knuckle wire technique, and a salvage ADR. If you get subintimal, you're trying to get back into the true lumen through something called a stingray balloon. Sometimes you feel that the softer is safer, but it may not be so. What happens with a softer wire is that it gets deflected through some obstruction like a calcium there and goes out, but a stiffer wire, if you direct it well, can continue to stay in the lumen. Usual choice of wires for me for antigrade approach is step 1 is a Fielder XT or XTA, step 2 is a Gaia 2, and step 3 is Gaia 3 or Conquest. What is step down? Once proximal cap penetration done with a stiffer wire and microcatheter to follow into it, and then you step it down to a softer wire till you exit the CTO on decide at the distal cap what else is happening. Parallel wire technique, if you get subintimal, then the second wire has to be, this is done through a dual lumen catheter, and the second wire has to be stronger than the first, and it will usually trace the outer side of the previous wire. And I'll just show you an example for that, something like this. Is it running? Yes. So that's the CTO of the LED, if you see. So that's the first wire there. Initial attempt, we're trying to do it with the XTA, but soon you see that it is getting stuck, and then we have changed into a Gaia also, but it is stuck. So what you do is you have a parallel wire, you change to a Crusade catheter, and there's a second wire that comes down, because the first wire lies in the space which it is there, and the second wire takes a new space, and with this increased penetration force it goes down. So that's what, and then you can, once you are crossed, then you exchange it. A dual lumen catheter can also be used for entering. You get into a side branch and then you enter the main branch using a dual lumen catheter. Basically, the two types of wires. One is a control drill, especially with the polymer jacketed wires and the like the XT type of wires, where you will find the resistance or the loose tissue in the lesion, and you just have to rotate in the right rotation, and the wire will find its way. And second is the penetrative wires, where you have to do directional penetration, especially with the Gaia type of wires. So this is now you see this is another case. You see the amount of collateral. It's such a strong collateral, but because it has a tapered tip, we have just tried to do it with a XT wire and just controlling it. Here the most important thing is the control in your hand that you have to do, and you have to get that feel and the feedback, and gradually you proceed with cross-checking, because this is a very strong ipsilateral collateral, so that's why we don't have the other injector, the contralateral injection, and then you can confirm it that it is going in the right direction, and then you can move down. And all these CTO wires are radio opaque, so moment you are down, then you advance your microcatheter, exchange to a regular wire and workhorse wire, and then do it. A general guideline on the softer wires, intermediate and stiffer wires, the single core and the composite core ones. The composite core ones, as I told you,
get you more 1:1 torque, and you can direct them better. So I think this is just a chart. The Gaia wire is one wire now which you can deflect. It has a strong penetrative power because of a tapered tip, which is an Act 1 tip, and a good deflection control because of 1:1 torque. And so you can literally guide your wire provided you know where to go. So that is most important. You should know your trajectory of the distal lesion. So that's the Act 1 tip there, which is conical, and then as I told you, it has deflectibility, and the tip load is less, so it has less penetrative but the force is much higher. Like the Gaia first, second, and third with a lesser tip load have much more penetration power. And because of the lesser tip load, sometimes the only downside is it goes down into a calcific part and gets stuck here, and when you start rotating, this one can break. So this is a problem. So the tips to Gaia manipulation, never over rotate, always advance 2 millimeter and withdraw a millimeter to ensure that the wire trip is not stuck, and always redirect and advance. So this is a new wire that is now there against Gaia. This is Gaia Next. Here the advantage is that this will probably not get stuck because what it has, instead of a single wire coil, it has multiple, it is made of multiple rope coils, and I think this is not running anyhow. So it preserves the Gaia concept with an enhanced ability to avoid getting trapped. As I showed you, the other one could get trapped, and it avoids coil stretching when fractured. So this is the 3D wiring concept that I was talking. I don't think it's a platform to explain all that, but you must understand that with this 3D concept you can, this is what we published in JSCC, I published in 2021, and this is a concept which is catching up very fast. We are trying to make an app for that, and then you locate where the wire is in 3D space and where the tip is directed, and according to that you then rotate. It gives you the direction how to rotate how much, and you will be able to enter the lumen. I think then when to go retrograde, well, if you fail antigrade or when there are good interventional collaterals, the occlusion is long, or maybe sometimes in osteal occlusions, retrograde may be a good option because you don't have an access antigrade. This is just one example of a, is it running? This is a RCA CTO which is being done retrograde. So after antigrade failure, so that's the occlusion there, and then so that's the wire that will cross through the septal collaterals towards the RCA. That's a collateral crossing wire, the SU03, and then you can complete the case with a guide liner here because with the retrograde wire, and then final completion of the case. So my CTO intervention algorithm, there are several algorithms. I have summarized it into one. What you need to do first is to do a dual injection and look for appropriate interventional collaterals. If there are no appropriate interventional collaterals, then the only way to do the case is antigrade or ADR. If there are interventional collaterals, then you can either do retrograde or antigrade, in which if the proximal cap is good and the distal target is good, length is less than 20, then go antigrade. If you succeed, good. If you don't, then you have the option to go retrograde. And if you don't have that and the length is less than 20, no calcium, no tortuosity, then you can do retrograde dissection re-entry or true retrograde. So the 10 commandments to CTO success, what I want to summarize is have a right patient, clinical assessment showing evidence of reversible ischemia, understanding the CTO lesion pathology, good angiographic analysis pre-procedure, frame by frame, shoot by shoot. That is what will show you
how it is filling, what is happening distally, the right technique, and always have a plan. Wiring only with microcatheter support, wire advancement only under distal vessel visualization, good guide backup and coaxiality, understanding the CTO wires and wiring techniques. Wire crossed, are problems over? Sometimes you still could have problems. The balloon will not cross. Lesion, balloon cross, but lesion not responding. Lesion responding, now stent not crossing. So all those things can always be there. Niche technologies, when to use, and when to switch gears. You have to switch gears fast, otherwise you will not be able to complete. So antegrade wiring to parallel wire to ADR to retrograde. And always know when to call it a day. You can't keep going on and on. So to conclude, friends, CTO intervention needs a good understanding of CTO hardwares, a plan to progress, and timely switch from one to the next for a final success. It needs perseverance, some patience, and of course perfection, and know when to stop. Thank you.
Thank you, sir. One P I will add, last slide is there should be passion also, which I have witnessed.
Great. So I'll add it in my slide.
Yeah.
Good.
Passion for
Yes.
CTO intervention.
Yeah, I have a passion. That's how I continue. Otherwise, people don't have passion.
Yes. And any quick question from the audience, because otherwise, young colleagues, if you want to ask any question to sir.
Sorry? Well, whatever it is, I think he gave me the keyword. That will come in the slide. I have the passion, and that's how it continues. Because otherwise, it's a very time-taking thing, and it's not so. People might find something else easier to do, and so that's like that.
I remember that every year you have been doing this annual CTO.
Yeah. My friend is here. Yeah. We do it. Yeah.
That is a great thing, because this is a thing which all of us should learn. I always feel that our junior colleagues, they are easygoing life, simpler to do, but I think little bit of hard work.
You should. I agree. Yeah. You should have some principles in doing CTO. Like I told you, for 10 commandments or some basic thing. If you will not follow it, you will not succeed. And one hit and try, you succeed, you say, I done CTO. That's not correct. And if you follow the principles, it's not as difficult. But you have to understand and follow the principles. That's my only submission.
Thank you, sir. I think we are all running short of time. I'd like to invite Dr. S.K. Dwivedi, sir. Half of us are privileged to be students of sir. In audience also, there are students of Dwivedi, sir. So, sir will talk when to intervene in this table.
अब पीछे जितने लोग खड़े हैं उनसे रिक्वेस्ट है कृपया साइलेंस बनाए रहें, काफी डिस्टर्बेंस होता है आगे, एकदम बात नहीं करें.
My thanks to the organizers, particularly Ravi and his team who invited me to share this thought here. And greetings from Lucknow to all the seniors who are present, Dr. Tyagi, Dr. Sarma. So yesterday we started a discussion during the dinner with Dr. Pratap and PK, and here I come. Where do we advance from here? When to intervene in stable angina? These are okay. So a patient comes to you with LED proximal 80% lesion. Let us make it interesting. LED proximal, day in and day out, bread and butter. Should we intervene in them? So before that, let's talk about, they have categorized into chronic coronary disease, both the recent guideline of ACC 23 and European. These are 5 categories that we'll be talking about: stable angina or angina ischemic equivalent with or without positive results on the imaging. The other categories being post-ACS or revascularization managed patient or LV systolic dysfunction. They're all considered now as a group of chronic coronary artery disease. So I'll be talking about this. The approach is a standard risk stratification once you make a diagnosis, and then treatment, be it a drug therapy alone or with or without revascularization by PCI and CABG. Risk stratification, so many tools are there. Commonest which we use here in Lucknow and probably in Patna also is a Duke treadmill score we categorize. We see the perfusion imaging, and there are various criterias they have mentioned. Why they have mentioned is that we know from the literature that patients who are having moderate or large ischemia on imaging modalities, they fare worse, and their outcome, if the area is moderate to large, has been correlated with unfavorable outcome. And we try and plan to change the outcome. Let's see how the management has evolved. So management of stable angina in last 5 decades can be divided in 3 periods. This pre-70s period where we managed only risk factors. Then came surgery. In 70s, 80s, and rapidly 2 or 3 trials were planned, which told us that probably surgical therapy is better than the medical therapy in a select subgroup of patients who are having multivessel disease and reduced ejection fraction. Then came stent era. And PCI versus medical therapy was planned in 80s to 90s. ECME trial, RITA trial, they showed that it is a very good therapy to reduce the symptoms. And recall that 1/3 of them were having proximal. In fact, RITA 1 had all the proximal LEDs. So by the end of 2000, both patients and cardiologists believed that PCI offers symptomatic relief and it is going to modify the outcome or the adverse outcome. And currently what is happening is nearly 500,000 PCIs annually are done for stable CAD. Then came 2000 when a drug, that is risk modifiers came, something like statin or preventive strategies where targeted lipid and blood pressure therapy were given. And then came this trial which changed the paradigm of the management. Aggressive lipid lowering therapy compared with angioplasty, ever trial. 340 patients were randomized to PCI or high dose statin. PCI or high dose statin, and the result was that atorvastatin came to be superior. However, this was the era where probably the stents were not used. But with the arrival of stent, these 3 large trials were also done. Bari 2D, Courage, and in 2012, FAME2 trials came. They did not show any significant difference in MI, stroke, or death collectively when PCI or CABG was added to optimal medical therapy. In fact, this is a meta-analysis of all these 3 trials, and you can see that there is no difference in death, MI, urgent revascularization, or angina. Though urgent revascularization tended to be lower, but it was not significant. They were all combined trial stable patients. And why did it not benefit? The trend of intervening in stable angina continued. The critics said that there was no threshold of baseline ischemia, so low or lower ischemic load was taken, patients were randomized after angiogram, so higher or complex disease were not taken up, or they were not drug-eluting stents, or the total revascularization was not done. These were the theories that were advanced. That paved the way for ischemia trial, which in itself was of the same magnitude of the meta-analysis, that is more than 5,000 patients. They enrolled high-risk patients from the outset. They took moderate, at least moderate ischemia as shown by the imaging. They randomized patients prior to diagnostic angiogram. They incorporated contemporary disease-modifying strategies. They employed state-of-art revascularization, including FFR, and both the modalities can be put in, whether it is PCI or surgery, and they chose high-volume centers. Why? Because it was also a criticism that in Courage trial, low-volume centers were involved. And this was published here. All patients underwent CTCA. So normal or non-obstructive CAD was removed. Primary endpoint was composite as usual. They were randomized to receive either initial invasive strategy or good guideline-directed medical treatment with an option if the patient is angina is not controlled, can go to revascularization. After a median follow-up of about 3 years, there was no difference in the combined endpoint. in any of the parameters, whether it is primary outcome or death from cardiovascular causes or death from any cause or myocardial infarction. And what they concluded is, among patients with stable coronary artery disease and moderate to severe documented ischemia, there is no evidence that initial invasive strategy as compared with an initial conservative strategy reduced the risk of ischemic cardiovascular events combined or death. So that was the data that came. And see here, the stenosis of proximal LAD, that is a large area which we are always afraid of, that proximal LAD 80% cannot be left. It has to be intervened because patients are going to die. No. More than half of the patients were intervened in proximal LAD and there was no difference in event rate. The data has extended now. Extended ischemia follow-up has been now 7 years and still the cumulative event rate has been same. What has ischemia shown us? Ischemia has shown us that primary outcome did not correlate with severity of ischemia, and event rate at 5 years was similar in both the groups. There are similar results from COURAGE. Treatment effect on CV endpoints were similar irrespective of ischemia severity, whether it is large or small, treatment effect will be same. And sudden death in the whole group, that is 5,170, over a period of 3 years was 1.3% only. Remember, they were moderate or large ischemia. So what they concluded, the conclusion can be that amongst patients with stable angina with moderate to large severe ischemia based on stress test or imaging, initial invasive strategy is not superior. Therefore, we may not need invasive coronary angiography in these patients with moderate to large ischemia detected by stress imaging if they are asymptomatic on medical management. And this is another one. Why I am showing is important. I'll tell you in the end. This is the COURAGE sub-study of 470 patients. Death and MI was similar in moderate to large ischemia, whether on medical treatment or PCI. These were having large ischemia areas. This is in the background of this, because earlier than that, large data set in registry showed that larger ischemic area translates into a higher event rate. And why I am showing is that Shaw and his colleagues in 2000 were strong critics. They had shown and documented that imaging, PET imaging with a larger area had shown to be poor outcome. But this article 10 years down the line was published by them, the COURAGE trial. They were the PIs of COURAGE trial and reverted their statement that no, they can do equally well if they are followed in medical treatment. So the dilemma of conservationist, or let's say referring physician, is that by holding a patient of effort angina, probably he is exposing it to a higher risk. No, that is not correct. The strategy of initial guideline-directed medical treatment is not harmful, and CV events will not be higher than PCI. Now, there are two other trials that I would briefly touch upon. People also said that probably PCI, the procedure itself has a placebo effect, something like a renal artery modification, where the radiofrequency ablation did have a placebo effect. And then Orbita was planned. What was this trial? 200 patients were enrolled after a very good guideline-directed anti-anginal therapy to PCI or a sham procedure. Sham procedure means angiogram is done, but procedure is not done. No stenting is done. They were high-risk patients. LAD was 70% proximal LAD. The FFR was 0.7. So they did have ischemia. And they were all blinded to the PCI procedure. And see what happened in that group where PCI was done. The exercise time was only 16 seconds more. Remember, a single anti-anginal can give an increase of 60 seconds on an average. So PCI did not increase exercise time. And what was more important is Canadian Cardiovascular Society angina grade was similar in both the groups, who underwent PCI or who did not undergo PCI, if guideline-directed medical treatment was adequate. But one word about the guideline-directed medical treatment is that nearly 70% of patients were receiving a combination of calcium blockers, amlodipine, and beta blockers, bisoprolol in higher doses. In this population, probably PCI did not add to therapy. So the false belief that interventionists have is PCI is better than conservative approach is probably not so proven by the scientific data. Now what if we compare sham procedure with PCI? I hope you understand this, that what they did is that they gave, this was the Orbita 2 published last year in December. What did they do? They gave all patients very good guideline directed medical treatment. Then prior to procedure, they stopped the drug. And what they wanted to see, they again randomized into two groups. Once a sham procedure was done and other the PCI was done. So by stopping the drug, they were trying to compare the true efficacy of PCI. And the primary endpoint was angina symptom score. PCI did improve the angina score. PCI did improve the exercise duration. So as compared to no anti-anginal therapy, PCI is better. That means if you are not giving any anti-anginal therapy, PCI does help reducing the symptoms. So what is the lesson from these two trials? Orbita 1 showed that PCI does not add to exercise capacity once a good guideline directed medical treatment is there. Orbita 2 showed that PCI relieves angina significantly as a standalone therapy if you are not choosing guideline directed treatment and want PCI as the first option. Both these approaches can be taken care of and they can be taken in a particular patient. So there is no need to go or no need to be worried about whether you are treating your patient on good anti-anginal treatment. The patient is asymptomatic. Am I doing harm to the patient in a proximality? No, you are not doing a harm. There are further meta-analyses by Bangalore, large data set, about 13 trials, 12,000 patients, no difference in death, no difference in CV death. Another randomized trial published recently, total death or CV death or total MI, they are not different once PCI is being compared to medical treatment. So the suggested approach for stable angina can be, there should be an initiation of intensive medical therapy. If adequate anti-anginals are unable to control, PCI may be offered and only those patients may be subjected to angiogram rather than all patients. Performance of PCI without anti-anginal therapy after explaining that it should be done. After explaining the risk of PCI, leading risk of dual antiplatelets and associated stent thrombosis risk. Remember, even after PCI, 1/3 of patients will continue to have angina. That is what Orbita 1 told us. So appropriate treatment pathways must be chosen by the patient himself. The current guideline of American College Guideline has said this as a class 1 indication that patient must be told about the benefits of both the approaches and only then a combined decision is taken. The problem here all over the world is that I am seeing the patient, I am advising him an angiogram, I am reviewing the angiogram, I am deciding that PCI has to be done and I am doing the PCI. There cannot be a better example of self-referral. So, the last slide is not there. So last slide was from the American College of Cardiology guideline, which have last guideline, which they have suggested which patient require. One is that where the medical therapy has failed, or second is where the recent change in the symptomatic status, or recent change in ejection fraction, or the patient is having a lower ejection fraction. These are the patient who should upfront go into the coronary revascularization rather than going for GDMT. Thank you very much.
Thank you, sir. Thanks for such a nice presentation. Any question?
Just the comment. Thank you, Guruji. Thank you very much. This opens a new, era for all the physicians who are practicing cardiology.
That was the purpose.
I think everybody would be happy. So the narrow scope of doing angioplasty is limited to only primaries, that means, do you agree on that point?
I agree. The problem here is that a physician who is not into invasive procedures, he believes that if I am not asking the patient to get angioplasty done, if he has effort angina, I am doing some harm. No. You can get a CT angio done, see if it is left main or not. If it is left main, not left main, start medical treatment. In fact, the guideline goes further. Guideline says a patient of stable angina does not require any investigation. Therapy should be started. If he is controlled, he probably requires guideline-directed medical therapy alone. That is what the guideline says.
Dr. Dwivedi,
Sir.
Congratulations for a brilliant talk. But one question, preventive VCI, do you have anything to say about preventive VCI?
So there has been some recent confusions, and these kind of confusions come every 2 decades.
Prevention trial, rather than asking.
I'm talking about that. So about 25 years back, earlier there were articles that if we manage 30%, less than 30% lesions, there will be no infarction. And there is a very recent article probably that you are referring to that. I would request the postgraduates and the younger colleagues to read an article by Greg Stone published in 2015 in Circulation, where what they have done is a beautiful small piece of work. They did the acute coronary syndrome, they did the procedure and did IVUS of all the patients. Then they followed up the culprit lesion and non-culprit lesion which were not intervened. And after a 3-year follow-up, there were events in both the groups and they were similar, treated as well as untreated. So how many would you like to prevent? Which one would you like to do? All patients, should he go to IVUS? Whenever a patient is going on table, should he go to IVUS? These are the questions which are being raised by a preventive strategy. The article itself has a lot of limitations, not the time to discuss this, but I don't agree with preventive strategy.
Sir, after an acute coronary syndrome, when do you call a stable angina? After how much of time?
So the duration they have not described, but what they have said in the current guideline 23 is that reasonable period. And that reasonable period, if we go by the pathology, should be somewhere around 4 to 6 weeks, when the endothelialization of the vessel has occurred or the endothelialization has started. Thank you very much.
Thank you, sir. There was
next there will be CD presentations. I invite Dr. Advait Akash from Heart Hospital, Patna to present his case, lost CTO.
Good afternoon, everyone. So let's start with the history. So it was a 61-year-old male, history of diabetes. He had an episode of chest pain in November last year and has been having class 3 angina since then. The ECG showed T-wave inversions in the anterior leads. Echo was 40 to 45%, anterior territory had RWMA, and the thickness was preserved. So this was the angiogram. It's not working. Okay. Okay. So this was the angiogram. Let's see the angiogram first and then we'll discuss.
This was the RCA. There was no filling from the right side. Now the question arises: where is the LED? We can see that this particular vessel appears to be the LED arising on the left side, but this particular branch, that is small branch that we can see, it appears to be a small RI, but there were no septals arising from this. So we actually considered that this could be the LED. So we started with the 7 French gel guide catheter, and right femoral access was engaged, and we started with Fielder FC just to test the waters first. Fielder FC obviously couldn't just enter the stump, but started buckling after a small distance. So we exchanged it with XT with the supercross microcatheter. Now XT couldn't cross after a small distance, so we had to escalate to Gaia 2. We could cross with the Gaia 2 to some distance, and afterwards, when the path was smooth, then the Gaia 2 was exchanged with Fielder XT, and afterwards. Yeah, so as we can see, the wire entered into first the diagonal and then the septal. So we had some evidence that we were in the true lumen. Then the microcatheter was removed using the guide wire extension system. Then actually we couldn't pass the microcatheter to further distance than what we could see there. So we had to start with serial balloon dilatation. We actually tried first with the 1 mm balloon, but it couldn't cross. So we started with 0.85 mm. Then we serially upgraded it. Further, we exchanged the XT with FC, and we used a 1.5 into 10 mm balloon. So this was the post-ballooning flow. And as we can see, the LED was a big vessel. It was a big vessel. Now, to complete the procedure, we did the parallel wiring with Fielder FC and removed the XT. Further, we ballooned with semi-compliant 1.5 into 10 mm and then 2 into 8 mm. But then again, the clear flow couldn't be seen afterwards. So we had to go with 2.5 into 12 NC balloon. Then a stent of 2.5 into 38 was placed distally. Now after we placed the stent, we could see a bit of haziness in the proximal part of the vessel. Could be a thrombus. So we placed another stent, was deployed proximally. Now after this, we saw there was slow flow. So because of that, we started the intracoronary, we gave intracoronary terofevan and nicorandil as is the standard protocol. And afterwards, we could achieve relatively good flow. But then the flow was improved, but not completely normal. So post-dilatation was deferred for after 2 days, and till then the patient was administered IV terofevan. Post-dilatation was done after 2 days with 3 into 12 mm balloon, and this was the final result. So the take-home message would be the aberrant anatomy can cause confusion, so we must expect the unexpected. Serial balloon dilatations can seem cumbersome, but it is useful. And deferring the post-dilatation in slow flow cases can be a wise strategy if the stent is not grossly underexpanded. Thank you.
Any questions from any expert comment from Pratap sir?
I just think that why supercross is used. You told supercross microcatheter is used, right?
Sir,
basically that I just wanted to tell you, supercross is actually a catheter used for if you have an aberrant anatomy, you just want to enter there. That catheter is not a good catheter. You can use a fine cross or the Corsair or Caravel as the microcatheter to be used. That is number one. Number two, even the first angiogram itself, I understood there is an osteoproximal LED is totally occluded. Probably it is a thrombotic occlusion. That is what is my impression, because it was not seen from the other vessel. If it is a chronic total occlusion, you should see the distal vessel. The interventional CTO principle is actually, that is what Dr. Goyal earlier told, that you should see the distal segment. You should have the proximal segment, distal segment, and the length of the CTO, which was not very clear. And supercross is not the catheter to use, number one. Number two, definitely I think it was a thrombotic occlusion. Probably it is delayed arrival. That is my personal impression.
Sir, the original the first episode of chest pain was in November, so a lot of time had passed, and also there was faint flow that we could see. Yes, it was not a very good flow that we can see in the proper CTO cases, but there was a faint flow that we could see. If I can.
That is correct, but actually sometimes if people have a pre-infarction angina, maybe having a long lesion for a long time, 95% or 98%, they do angina, then subsequently they will get 100% occlusion immediately and come back. There was definitely no flow from the right side, right?
Yes, sir.
That is what I was telling.
That is why we took Fielder FC first, sir. Just
No,
to
the
see
taken wire is actually wire and all your choice, but you should take a microcatheter different. That's what I'm telling.
Okay.
Supercross is not the microcatheter used. It is actually an angle microcatheter.
Yes.
90 degree, 60 degree, 120 degree. That is an angle it's an angle vessel. It was not an angle vessel, straight vessel.
Okay.
A very good clue it's a LED is there or not. And second important thing, please defer this to after 2 days post balloon dilatation. These all things should be stopped. I am senior to you, but I am 100% sure. Don't intervene unnecessarily in this patient. If you want to do in the first procedure. Don't recap them. It creates more complication than any advantage.
Actually, Rakesh is telling a very important point. Orthogonal projections are not taken properly. Yes. You actually did not take you have taken always an areocranial projection. If you have taken epicranial projection, you could have seen exactly the distal part of the very well. An orthogonal projection to be taken. I am not telling about interventional, when to do and all. I am just telling when you do intervention, you should do in this type of things. Orthogonal projection, understand the anatomy, then only intervene. Otherwise, you may be landing in problems.
Yes.
Actually, nicely done. Final result is very good, and probably after this, Tirupati patient would have done a very good outcome. That is all different.
Thank you, Advait. Actually, we are due for the inauguration ceremony, so I will request the speakers to stay back. Their CD presentation will commence after the inauguration ceremony. So I'll ask the organizers to take over for the inauguration ceremony. Thank you.
Thank you so much, sir. Since there has been an inadvertent delay, so we'll proceed with the inauguration ceremony. So once again, good afternoon, everyone. It is with great pleasure and honor that I, Akanksha, welcome you to the inaugural ceremony of the second annual conference of the Bihar Intervention Council. Without further ado, let us commence the ceremony. Please join me in welcoming our distinguished guest on the diet. Our inaugurator and chief guest, Professor Dr. Sanjay Tyagi, President-elect 2024 for the CSI National. I request you, sir, to kindly come on stage. Our guest of honor, Professor Dr. Binde Kumar, who is Director, IJIMS Patna. Dr. Arvind Kumar, who is the President of CSI Bihar. Professor Dr. BP Singh, Chairman of the Organizing Committee. Dr. Vipin Kumar, Chairman of the Scientific Committee. And Dr. UN Singh, Secretary, CSI Bihar. And also Dr. Professor Ravi Vishnu. I request Dr. Manish Mandal, sir, to kindly join us on the stage. I now request Dr. Shiv Kamal to kindly do the honors for the floral welcome. To our guest of honor, Dr. Binde Kumar. Dr. Arvind Kumar. To Professor Dr. B.P. Singh. To Dr. Vipin Kumar. To Dr. Manish Mandal. To Dr. Ravi Vishnu. इससे पहले कि हम उद्घाटन सत्र की औपचारिक शुरुआत करें, मैं ईश्वर के आशीर्वाद प्राप्ति के लिए सबसे अनुरोध करूंगी कि हम सभी सरस्वती वंदना के लिए प्लीज खड़े हो जाएं।
शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता।
धन्यवाद। मैं सभी अतिथिगण से अनुरोध करूंगी कि कृपया वो दीप प्रज्वलित करके औपचारिक सत्र को आगे बढ़ाएं। I know we all are hungry, but could I request everyone to have a huge round of applause, please, for once? Thank you. May I now request our organizing chairman, Professor Dr. B.P. Singh, sir, to kindly come and welcome and give the welcome address.
Dr. Sanjay Tyagi, President-elect CSI, Dr. Vinde Kumar, Director IGIMS, Dr. Arvind Kumar, President CSI Bihar, Dr. Vipin Kumar, Chairman Scientific Committee, Dr. Ravi Vishnu Prasad, द डायनामिक ऑर्गेनाइजिंग सेक्रेटरी जो महीने 2 महीने से लगे हुए हैं, छुट्टी लेकर लगे हुए हैं इस कॉन्फ्रेंस को ऑर्गेनाइज करने में, हमारे सेक्रेटरी साहब डॉक्टर मनीष मंडल एंड अदर डिग्निटी, हमारे लोग के टीचर प्रोफेसर यूसी सावल हैं, डॉक्टर हरेंद्र कुमार हैं, राकेश कुमार यादव जी जो हैं विख्यात कार्डियोलॉजिस्ट दिल्ली से वो हैं, डॉक्टर प्रताप राव, आई एम सेइंग डॉक्टर चटर्जी, और माय कलीग्स, फ्रेंड्स, स्टूडेंट्स हैं हमारे, डीएम और डीएनवी कर रहे हैं जो, और टेक्नीशियंस, फ्रेंड्स फ्रॉम इंडिया। मुझे अत्यंत खुशी और प्रसन्नता हो रही है देख करके, पूरा हॉल भरा हुआ है। 10-20 साल पहले यहाँ कॉन्फ्रेंस करते सीएसआई का, तो सब कहते भाई इंटरवेंशन का टॉपिक मत रखिए, कोई सुनता नहीं है, पूरा हॉल खाली रहता है, बेकार रखते हैं, एक हॉल रखिए। अभी देखिए पूरा इंटरवेंशन का कॉन्फ्रेंस हो रहा है। द सैपलिंग, द प्लांट which we planted 20 or 25 years back is now fully grown up, 25 years young and fully grown up. All types of interventional work is being done in this state, like Delhi, Maharashtra, Bombay, Kerala, etc. And definitely इसमें सबका सहयोग रहा है, सब लोग साथ रहे हैं। इतना बढ़ने से today there are about more than 50 labs in Bihar and more than 100 qualified cardiologists DNV doing in practicing in Bihar. I will request you all people to do the work very scientifically, ethically, so that all good name goes for the work being done in Bihar. We are lagging in certain fields, the arrhythmia ablation, so the research activity. The WIFIN has started the heart attack registry. We will come out with the data within a few years. So I wish all good to this conference, and I hope all the faculty who have come from very distant, Dr. Rajaram Prasad, who has come from Hyderabad, have enjoyed the hospitality given by the organizing secretary and the whole organizing team. Dr. Chadda is here with us for performing function today, great teacher. While I was doing my job, I did some intervention with the help of my colleague, but imaging was not so frequently used. A few cases we did with our younger colleagues. I hope now they will do the PCI angioplasty with the help of the imaging IVAS and IVAS needs, as Dr. Chadda suggested. Thank you, everybody. Thank you.
Thank you so much, sir. Now may I request our Chairman Scientific Committee, Dr. Vipin Kumar, for his address.
Thank you. Respected Dr. Binde sir, respected Dr. Sanjay Tyagi, President-elect CSI, dear distinguished guests, speakers of national, state faculties and delegates, it is my pleasure to welcome you all in this year BIC 2024 conference. The field of interventional cardiology has made significant progress in recent years, and this meet provides an excellent opportunity for us to reflect on this progress and discuss latest advancement in this field. And our team, we all in CSI has made enormous efforts in put up a good scientific program, and we have 15 national faculties of national and international repute who are stalwarts in their own fields, and 40 challenging case presentations from our state faculty. So as we engage in discussions, share insights and collaborate on latest technology during this conference, let us remember the importance of continuous learning and growth. So I'd like to encourage all attendees to participate actively in this conference, and I am confident that the discussions and interactions that take place during this meet will inspire us to elevate our practice and make a lasting impact on the field of interventional cardiology. So I look forward to the enlightening discussions and fruitful collaborations that lies ahead. Together we will continue to make a difference in the lives of our patients. Thank you. And on this occasion also, I want to let you know that we in CSI we have started Bihar ACS registry from January this year, and many of the centers are participating. So I'd like to invite all the other centers who are not participating, so will contact me, and then all of us from Bihar will collect data of our ACS patients, so that in future we can modify our strategies to improve our patient life. So thank you.
Thank you, sir. May I now request Dr. UN Singh, Secretary CSI Bihar, for his welcome address.
Respected dignitary on the dais, of the dais and faculties, we CSI Bihar are growing in each and every sphere, whether it's a preventive cardiology, academics, interventional cardiology. There are so many cath labs. Almost each and every district of Bihar has a cath labs, and 2 to 3 cardiologists in each and every district of the Bihar. So I don't have to so much time because we are all running late, and with that I'm stopping here. Thank you all.
Thank you, sir. May I now request our President for CSI Bihar, Dr. Arvind Kumar, for his welcome address.
Thank you. Being President CSI Bihar chapter, I am extremely delighted to welcome you all to this second annual conference of BIC at Patna. My special welcome to our President-elect National CSI, Professor Sanjay Tyagi sir, Dr. K. Pratap Kumar sir, Rajaram sir, Chadda Saab, and all our national faculty. Despite their busy schedule, they have accepted our invitations. You know, the tremendous development has been observed in the field of intervention cardiology in Bihar because of establishment of cath lab, many cath labs, and availability of many intervention cardiology even in the district town of the Bihar. And I must appreciate our organizing team led by Dr. Ravi Vishnu Prasad, and scientific team led by Dr. Bipin Kumar has done great work to make this conference a great success. So I congratulate both of them and their entire team. So I believe this conference will provide you a platform where you will interact with each other, you will share your experience with each other, and you will learn from our masters speakers to help in the growth of intervention cardiology in Bihar. Thank you.
Thank you, sir. May I now request Dr. Manish Mandal, who is Deputy Director Admin and Medical Superintendent at IJMS, to kindly say a few words.
मंच पे बैठे सीएसआई के सर्वे सर्वा और हम लोग के बीच हमारे प्रिय प्रेसिडेंट साहब, हमारे संस्थान के निदेशक डॉक्टर प्रोफेसर बिंदे कुमार, हमारे गार्जियन शुरू से डॉक्टर बीपी सिंह सर, हमारे बड़े भाई डॉक्टर अरविंद कुमार जो सीएसआई प्रेसिडेंट हैं भी, डॉक्टर रवि विष्णु चेयरमैन सेक्रेटरी साइंटिफिक कमेटी, ऑर्गेनाइजिंग चेयरमैन ऑर्गेनाइजिंग सेक्रेटरी, मन से इतर जितने भी महानुभाव बिहार नहीं बिहार के बाहर से जो भी लोग आए हैं, डॉक्टर प्रोफेसर राकेश कुमार यादव और जितने भी गणमान्य कार्डियोलॉजी के डॉइन जो बिहार में आए हैं, उनका स्वागत मैं करता हूं आईजीएमएस प्रशासन की ओर से। मंच पे बैठे और मंच के इतर बहुत से ऐसे चेहरे हैं जिनको सब लोग जानना, सुनना और देखना चाहता है, और वो सब यहाँ हैं, और वो इसलिए यहाँ है कि इंटरवेंशनल रेडियोलॉजी अब बहुत ग्रो किया है। पिछले 25 सालों से मैं संस्थान में हूँ और इंटरवेंशनल रेडियोलॉजी जिस तरीके से टेक ओवर कर रहा है, तो कार्डियोलॉजी में सर्जन के लिए बहुत कम ही रोल रह गया है, और इसका निदान और इलाज बिहार में सुलभ हो रहा है, ये बहुत बड़ी बात है। कुछ देर पहले मैं डॉक्टर अरविंद सर से बात कर रहा था तो उन्होंने मुझे बताया कि जब वो संस्थान में थे, यानी 25 साल पहले जब मैं उनके साथ संस्थान में था, तो उस समय लिमिटेड लोग थे। आज के डेट में 25 लोग पटना के अंदर और 20 लोग बिहार के अंदर, तो 45 लोग की फौज है कार्डियोलॉजी में काम करने के लिए। बहुत बड़ी बात है, और की ज़रूरत है। ये मैं नहीं कहता हूँ कि ये कम है या ज़्यादा है, ज़रूरत तो और है, लेकिन इसका फ़ायदा बिहार की जनता को हो रहा है, ये समझने की बात है। और रेडियोलॉजी और कार्डियोलॉजी इस दोनों का जो समीकरण हुआ और इससे जो लोगों को फ़ायदा हो रहा है, ये बहुत अच्छी बात है हम लोग सबके लिए। मैं धन्यवाद देता हूँ पूरी टीम को, स्पेशली डॉक्टर रवि विष्णु को, जिन्होंने लगातार, मैं जान रहा हूँ क्योंकि मैं मेडिकल स्टूडेंट हूँ तो मेरा पैरवी आती रहती है कि रवि विष्णु से दिखाना है, मिलना है, और ये लगातार इसमें लगे हुए थे। तो मैं समझ रहा था इनकी बात, और मैं धन्यवाद देता हूँ उनको। बहुत अच्छी टीम है आपकी, जो इतने पूरा हॉल भरा हुआ है, और शुभकामना देता हूँ कि आगे भी ये अच्छा होता रहे। धन्यवाद।
धन्यवाद सर। May I now request our guest of honor, Professor Dr. Binde Kumar, Director IJIMS, for his inaugural address.
Very good afternoon, dignitaries on the dais, Professor Sanjay Tyagi, Chairman, CSI elect, Professor BP Singh, my elder brother, Arvind ji, our senior, Dr. Bipin Kumar, Dr. Ravi Vishnu, Manish Pandal ji, the Deputy Director and Medical Superintendent IGMS. In the audience, I can see faces, my seniors, Ajay ji is sitting there, Dr. Sanjeev sir is sitting there, all dignitaries which have come from outside, Dr. Rakesh Yadav from Delhi, who is also a governing board member of IGIMS, and all the faculty and dear friends. I was ruminating the day the cardiology was started at Indira Gandhi Institute of Medical Sciences. Both the doyen of the cardiology now are sitting on the dais, and it's a very pleasant moment for me to share a dais with them. Professor BP Singh and Professor Arvind Kumar, the two people who have started the show, and now the whole Bihar is seeing the film they have started. And this is one thing we can always boast upon. And I tell you, IGMS, under the leadership of Ravi Vishnu, we are going to have a primary angioplasty from this month, and this everything has been done, and we are there. And who can say better for the need of angioplasty, a person who is speaking to you, who has undergone himself an angioplasty, and was saved by you people only. So all kudos and all thanks to everybody sitting here, and I see brighter things in coming future. Thank you very much.
Thank you so much, sir. Now may I request Professor Dr. Sanjay Tyagi, who is the President-elect 2024 for CSI National, for his inaugural speech.
दोस्तों, ज़्यादा शब्द तो मैं नहीं कहूँगा, समय बहुत कम है, पर मैं आप सबका बहुत धन्यवाद करना चाहता हूँ, तहे दिल से धन्यवाद करना चाहता हूँ प्रोफेसर डॉक्टर रवि का, डॉक्टर अरविंद, डॉक्टर बीपी सिंह, डॉक्टर सामल, और बहुत हमारे डायरेक्टर आईजीएमएस हैं, और डॉक्टर बीपी सिंह का पर्टिकुलरली इन्होंने आईजीएमएस इंस्टीट्यूट में कार्डियोलॉजी डिपार्टमेंट को एक विश्व स्तर पर पहुंचा दिया। जैसे अभी मुझे मालूम हुआ कि वहाँ पर जो सारी लेटेस्ट फैसिलिटीज़ हैं वहाँ अवेलेबल है। सो बिहार की जनता और पूरा देश आपका धन्यवाद करता है इन फैसिलिटी करने के लिए। और आज मुझे ये देख के बड़ी खुशी हो रही है कि जो हमारी फैसिलिटीज़ जो और किसी भी स्टेट में है, जिसको हम कहते हैं डेवलप्ड स्टेट में है या किसी में भी है, वो आज आपने बिहार के हर डिस्ट्रिक्ट में पहुंचा दी है। तो आप सब जो जितने भी कार्डियोलॉजिस्ट हैं, इंटरवेंशनल कार्डियोलॉजिस्ट हैं, बडिंग कार्डियोलॉजिस्ट हैं, सबका बहुत बहुत मैं आपको सबका बहुत आभारी हूं कि आपने ये फैसिलिटीज़ एक जैसे कि हार्ट अटैक में हम कहते हैं कि पहला घंटा या पहले 6 घंटे बहुत इंपॉर्टेंट होते हैं, इमीडिएट इलाज मिलना चाहिए, तो वो आपने फैसिलिटीज़ यहाँ हर जनता के हर वर्ग के लोगों को आपने प्रोवाइड करा रहे हैं। तो ये देख के बड़ी खुशी है कि ये बिहार और ने बहुत तेज़ी से प्रोग्रेस की है कार्डियोलॉजी, इंटरवेंशन कार्डियोलॉजी में। सब ये जो हमारे जो मंच पर आसीन सीनियर प्रोफेसर्स, हेड्स ऑफ डिपार्टमेंट, प्रोफेसर पहले डॉक्टर रविंद्र थे, उससे पहले डॉक्टर बीपी सिंह थे, और अब प्रोफेसर रवि संभाल रहे हैं इसकी कमान। तो इन सब लोगों का बहुत धन्यवाद। और मुझे आशा है कि ये जो आपने प्रोग्राम किया, जो बिहार इंटरवेंशन काउंसिल का, जो कि अब दूसरा प्रोग्राम सेकंड इशू है ये इसका, और उसमें इतनी तेज़ी से प्रोग्रेस हो रही है कि हम देख रहे हैं पूरा हॉल भरा हुआ है और लोगों में इंटरेस्ट भी है। और जो यहाँ पे आपने फैकल्टीज़ इनवाइट की हैं पूरे देश से, बड़े बड़े आपने सीनियर प्रोफेसर्स और जो लीडर्स ऑफ इंटरवेंशनल कार्डियोलॉजी हैं, उनको यहाँ इनवाइट किया जिससे कि वो अपने एक्सपीरियंस से, अपनी एक्सपर्टाइज से यहाँ को अपडेट कर सकें और जो फैसिलिटीज़ किसी भी जगह अवेलेबल है वो यहाँ आपने ट्रांसप्लांट कर दी है। तो उसके लिए आपको सबका मैं बहुत धन्यवाद करता हूँ और बहुत मेरा पूरा विश्वास है कि ये जो प्रोग्राम किया बिहार इंटरवेंशनल काउंसिल, इससे इस क्षेत्र में, बिहार के क्षेत्र में बहुत तेज़ी से प्रोग्रेस होगी, जो कि हम देख भी रहे हैं। और once again I like to thank you for your kind invitation and for this important conference. I think I wish this conference a great success. Thank you very much.
Thank you so much, sir. May I now request Professor Ravi Vishnu sir to kindly propose the vote of thanks.
Very good afternoon, distinguished guests, ladies and gentlemen. It is a great honor and proud moment for me to propose the vote of thanks to all the dignitaries who are on the dais and off the dais. Today is a great moment for the BIC 2024. First and foremost, I convey my regards and my heartfelt thanks to Professor Sanjay Tyagi, President CSI-elect 2024, to be the chief guest and the master speaker and gracing this occasion. My special thanks to Professor Binde Kumar sir, Director, IGMS, for coming out of his busy schedule and be the part of this event. My sincere thanks to Professor Manish Mandal sir for coming and gracing this occasion. My sincere thanks to all the master faculties, Professor D.S. Jadda sir, Professor S.K. Dwivedi, Professor Rakesh Yadav, Professor Sandeep Bansal, Dr. N. Pratap Kumar sir, Dr. Pramod Kumar sir, Dr. Dilip Kumar sir, Dr. Abhijit, Dr. Raja Ram sir, and Dr. R.D. Yadav, who spared their busy schedule and have come here to teach us and interact with us. I must thank our President CSI, Dr. Arvind Kumar sir, Professor B.P. Singh, Chairman Scientific Committee, Dr. Vipin Kumar, Scientific Committee Chairman, Dr. B.B. Bharti sir, and all other organizing committees who helped me continuously throughout the conference and had a faith in me to organize such a mega conference. My special thanks to all the past presidents of the CSI, senior cardiologists from the Bihar, faculties of the Bihar, and my own IGMS faculties and the residents that made this conference memorable. Of course, none of the conference success would have been possible without the active participation of all our delegates, your enthusiasm, your engagement, and your eagerness to learn. Everything has been driving force behind this vibrant conference. I also acknowledge the cath lab technicians and my cath lab students who came all over from the Bihar to attend and to learn the skills, and this will definitely support their consultant skills also. My special thanks to all the device companies and the pharma companies who have supported this event without their unrestricted grant. My special thanks to media persons who are for covering this event successfully. I want to give special thanks to this hotel stars volunteers to make this conference successful. And in the last, I would thank my family, Darvesh Jhaji and his team, who worked 24/7 with me and to make the event memorable. मैंने इस कॉन्फ्रेंस में दिल से काम किया है. अगर मैं दिमाग से काम करता तो तर करता. Thank you once again. Thank you once again for participating and making this conference memorable. Long live your intervention. Thank you.
Thank you, sir, for the overwhelming speech. Before we conclude the inaugural ceremony, may I request everyone to kindly stand up for the national anthem.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. Now we'll proceed with the session on the CTO and stable cat.
हम लोग अभी लंच में हाफ एन आवर डिले है. Please bear with us. We will continue with the portion we have left in CTO session. First, I will invite the same chairpersons to please come on the dash. Nishant Tripathi ji, Sandeep Kumar, Ravi Vishnu, Dr. Arvind Goyal, Abhinav Bhagat, Parveen Jha, Sanjeev Kumar CTVS. And we'll invite Dr. Binit Kumar, followed by Dr. Samsad Alam, to present his cases. And then we will have one guest lecture by Professor Chadda. And then we will break for the lunch. So we'll have to... इसी कंटिन्यू हाँ जी पहले आप इन विनीत का संसार उसका चला सा
Sir, Mike.
Without wasting time, I will ask Vinit to go ahead with his case.
Very warm good afternoon to everyone. All my respected senior and dear friend, I am just going to see
Just a second, Vinit. I'll ask everyone to settle down, please, and we are going ahead with this session. So I'll request people at the back, please. Vinit.
This is the story of a 55-year-old gentleman, old history of infraval MI, now having the effort angina symptom on effort, function class 2. Echo was saying LV ejection fraction was good. There was RWMA in RCA territory, and there was definite ischemia evidence on stress testing. Angiography was done that saw single vessel disease, only RCA having the lesions, CTU. This is the RCO. From the proximal mid junction, it was occluded. Lesion was crossed with a Gaia 2 wire with microcatheter support. So after crossing the lesion, we have advanced the microcatheter, and fortunately it crossed the lesion. After that, we have removed the Gaia wire and exchanged with the Felder FC wire, and we have dilated serially with a semi-compliant balloon. And after serial dilation with the semi-compliant balloon, we can see the RCA very well. We think it was dilated properly, so we have used the long stent 48, but unfortunately it was not going into the lesion. So we think we'll dilate it again with some higher balloon with high pressure. Now we have taken the non-compliant balloon, but still it was not crossing. So we think we will use a smaller stent, 2.75 24. But unfortunately that was also not going. So we have dilated with a bigger non-compliant balloon with high pressure. But after the dilations, we can see that RC was perforated and there was extravasations of dye, and there was no flow distally also. So now we think we'll use cover stent. Good thing was wire was in situ. That was a very big relief for us. So we have taken a cover stent. But one dilemma was because there was no distal flow, so RPDA was not visible, and that was a big RPDA. So we want to save it. So with reference images that we have taken earlier, we have placed our stent and by fortune the stent was placed such that that RPTA was not blocked and it was flowing well. So now after that our job became relatively easy. So now we have used that bigger stent up to the ostial part and serially post dilated with the non-compliant balloon at high pressure, and after that post dilations we can see the RC is flowing well. There was no extravasations of the dye also, and you can see it's almost we have lost RC. Finally we can compare both the images before procedure and after procedure, and echo was showing only mild diffusion but hemodynamically stable, so need not to do anything. Patient was discharged on day 3 and everything was uneventful after that. Thank you for the patience listening.
Any comment from the audience?
Why you used gas second wire?
No sir, it was not the initial wire.
But you told that you passed initially with the gas second wire. Then you should have told it was not the first wire.
No, because they have told you have to show only 8 slide only, so I have make it a smaller
But
and
you can tell that I used this many wires and this wire is closed.
Yeah.
Basically, I just want to tell you that when you see a lesion which is probably a CTO or CTO, don't try with the gas second. It's a very dangerous wire.
Yes, sir.
That's just wanted to tell the crowd, because don't start with this wire. This wire is actually can perforate and create problems. So when you should not be unhappy that I did not put stent and all. You can keep a wire into the PLV. If it is not affordable, take an Oaks wire and keep a wire into the PDA and then put the stent exactly on the junction. Then you can save both the branches, even if there is a problem happens.
It
you
was
told I put
wire
a stent.
induced perforation.
That is okay, but the PDA to be preserved,
Yes. And
so preservation of PDA and PLV in a junction just before the stenting, you please put the wire into the PDA. PDA is a very important vessel. If you lose the PDA, then rewiring may be difficult. If you are, especially when you keep a stent exactly at the PDA PLV junction, if one strut is moving into the PDA, then rewiring will be difficult. So if you have a wire into the PDA, then what is the problem? After
sir,
putting the stent, you can
initial our intention was not to stent up to that point because of that balloon induced extravasation of the dye perforation.
It is balloon induced extra perforation, which I don't know. I personally feel that it is because of the Gaia wire. That is what I just wanted to tell you again.
Yeah, after wiring, I have shown some images. I removed the Gaia wire and after that routine wire.
The wire would have created dissection. The balloon would have caused the perforation. That is what I'm telling. The wire is actually not the ideal wire to use in that lesion. The lesion was I have seen in the first angiogram. I personally feel that it would have easily crossed by the maximum by filter FC wire. That is what I feel. Maybe I'm wrong.
Used earlier, it was not going.
See, wire you have gone with a microcatheter?
Yes, sir.
Your microcatheter easily crossed with the Gaia second. You told that.
No, sir, not easily, because it was NY microcatheter that we are usually not getting.
NY
always.
microcatheter is the wire to be used in CTO.
Yeah.
CTO is an expensive business. These are all my comments. Don't think that actually, if at all you can, if that makes you some change in the next practice. it is
No,
good.
sir, definitely. Whatever we are doing, I have learned a lot of things from you only, sir. So nothing.
Vinith, the whole point of the discussion is we should learn from all these things. And as Dr. Goel in the morning and sir is saying, we should follow the basic principles of CTO intervention from the start. In the previous case also, the distal vessel was not visible. It still went ahead with the intervention. So these are the principles, 10 commandments of CTO, so precisely said. Yes. And I also agree with Pratap sir that it was more of a wire-induced dissection, which is parallel dissection, which increased by the ballooning. Yeah. Okay, thank you. Thank you, Vinith.
Thank you, sir.
So I'll ask the next speaker, Dr. Samshad, who will be speaking on Carolina technique for RCCTU.
Good morning, everyone. There is a RCCTO in which we use Carlino's microdissection technique because antegrade wire escalation was not in the proper channel every time. Brief history: she was a 50 years old hypertensive female, effort angina, even on optimal medical therapy. She was on almost 3 to 4 months of optimal medical therapy. Proximal RCA was 100% occluded. This is the angiogram. It was near the ostia. There were good collaterals from left septum. It was almost filling up till the crux. So the plan was, should we go retrograde? Should we go antegrade? Because as what we can see, the length of the CTO segment, it is very long. It is almost 40 to 50 mm. So ideally, a retrograde approach should have been the approach of choice. But the problem was that after starting the CTO program at our center, we were not in that stage to go with a retrograde. Earlier we had only experience of 2 retrograde procedures, which were not that much successful, and we had to shift to antegrade approach. So we started with a JR guide. It was initially good. We thought that it will give good support, but because it was well aligned with the RCA origin. Initially we started with XT, then we exchanged with it Gaia 2. We repeatedly moved forward, but every time we thought that we are not in the true lumen, and moving forward and distally it was not possible. It almost took us 45 to 50 minutes with this Gaia 2, but we were not able to enter the distal part of the RCA. So now what we did, then we thought that we can go for Carlino's technique with a microcatheter induced dissection. So we injected 0.5 ml of contrast with a controlled pressure in the proximal cap of the CTO segment. But now we also thought that guiding support, we will go in a full-blown thing. Guiding support should have to be good. So we exchanged it. We took a AL 0.75 guide catheter. And now this time gradually with time we were able to progress our Gaia 2 wire, and we were also able to see that there are controlled dissection all over the proximal to mid segment of RCA after that microcatheter induced injection. Now after going through the distal part through the lumen and after confirmation from the contralateral injection, now we were sure that we are in the true lumen. After that, we removed the microcatheter and 1 mm of Reuro balloon was used over the same Gaia 2 wire. We were unable to advance our Corsair microcatheter through that over that Gaia 2 wire. It was great difficulty. So we exchanged with a 1 mm Reuro balloon, and then we pre-dilated that segment. After that, things were easy. All over the pre-dilatation was done 1 mm followed by 1.5 mm over a whisper wire, and after that a 2.25 mm of Enso balloon was used, In between, we also used a cutting balloon of 2.25 mm, a Wolverine, because we thought the lesion, what it looks like, the slight calcification was there, because we were unable to track our microcatheter. So we thought that we have to prepare the lesion also. Then we proceeded with stenting. Distal RCA was stented with 2.75 into 38 mm synergy stent, the same stent balloon. We again used that to prepare the proximal to mid part of the bed, and we were able to prepare that. In proximal part, we deployed a 3 into 38 mm synergy stent in overlapping with the distal stent, and then high pressure post dilatation was done by 3 into 15 mm NC balloon, followed by 3.25 mm of NC balloon in the proximal part, and this was the final result which we got. So few important things, some mistakes what we did. What was the most important thing was the guiding support. Initially we thought that JR will give a good guide support, but day by day we learned. So what we learned, that a good guide support should be there from the initial part. We might have crossed Gaia 2 with AL2 guide, AL.75 guide support, but we were not sure. If the antegrade wire tracking is difficult, we should always think that we are every time entering the subintimal space. So the Carlino's technique, what they have said earlier, that you should induce microcatheter into dissection as distal as possible. But in this case, we thought that we were not in the intimal space, we were in the subintimal space from the starting point. That's why we thought that we will give microcatheter dissection as proximal as possible. We will not enter midway with the Gaia wire, and it should be always in a controlled fashion. Initially, when Carlino technique was started, then they used 3 to 4 ml of contrast, 3 to 4 ml. It was a very huge amount. Then gradually that decreased to 2 ml, then 1 ml, and then 0.5 ml. And that pressure, what we should give, it is very important. So, so this was the case. Thank you.
Comments actually, Dilip.
So 2-3 points. One is Carlino is not in use nowadays, and your wire was, if your wire was already in subintimal plane, the thing was already done. You could have done the knuckle. Second is why were you giving so much of injections? So many injections. When the dissection flap was there, you have done at the Carlino, still the antegrade injection should not be given. And third, the last shot which you showed us shows some perforation.
Yes, there was some, it was not a perforation, but it was a small coronary cavernous kind of fistula. No effusion was noted, because whenever we do CTO, we repeatedly do echoes. At least we did 3 to 4 echoes every hourly to ensure that there is no vascular leak.
Actually, one thing I do, Carlino is an Italian cardiologist, not well accepted in Eurocito Club also. He is actually given a talk only for the sake of giving talk. This is actually a technique not well versed by people. That is actually a last resort. The first thing is actually you yourself committed that I did not take an excellent catheter. So initially in any CTO, even if this CTO, 0.75 actually itself is not a good supporting catheter, but 0.75 AL should be in the first catheter, number one. Number two, if you take a wire does not cross, keep the wire there, take another wire. Keep the same wire there, take a parallel wire. That would have been the ideal technique. Then you told that your balloon was not going. Balloon was not going because you are in the subintimal space, in the proximal part. If Chadda is there, Chadda will tell you what is the IVUS. IVUS will be showing definitely subintimal stenting. So these are the things to be remembered, and rest of the things are very good. Finally, the results are very good, but you should not translate this as the practice to do Carlino for everybody here and for you also. Yeah. Carlino should be the last choice, and that too, if you fail miserably, otherwise no.
And the Carlino which is now being used in a situation where you are not able to do a knuckle, there you give a little bit of Carlino, make a dissection, and then you go and do a knuckle. And also it is replaced by power knuckle nowadays. Just before the occlusion, if you are not getting the wire into a subintimal plane, if you want to do that, then you inflate a larger size balloon, make a dissection, and then you can do that.
Actually, knuckling also be a little difficult here because your catheter is not sitting properly. That is why actually you should have gone for AL catheter and all. Ideal choice in this case, if I am doing this case, I will go retrograde.
Retrograde is the ideal choice.
Okay, thank you, Shamshad. Thank you. Good result, yeah. So, I'll request our guest speaker, Professor Dr. D.S. Chadha from Bangalore, to speak on coronary plaque modification tips and tricks. Sir has been here for last couple of days enlightening us with his IVAS knowledge, and I hope we all be benefited with his talk. Thank you, sir.
Thank you. I can see a lot of hungry eyes. I won't take long. I won't keep you away from lunch. Well, management of calcium is a very complex issue. Patients have very high syntax source, so the lesions are tight, angulated, osteal. CTOs are commonly encountered, left main invariably involved. The lesion, the complex morphology goes into the lesion as well. You have nodules, you have thick plates, you have undilatable, uncrossable lesions, and most of these patients are elderly with LV dysfunction, and they have associated comorbidities like CKD, COPD. So all in all, it's a very complex package because we get to see calcium in diabetics, in elderly, and patients of CKD. These are three major groups where you will encounter calcium. They are associated with very high rates of MACE, and in the recent paper from Samin Sharma group shows that MACE rates are as high as 24%. Well, plaque modification is very, very important in this subset because this will enable you to deliver the stent. It minimizes the trauma, and if you are not leaving your drug-eluting stents well opposed, you are not doing a good job because the drug will elute on to the blood and come out in urine. And it's very important that you achieve good MSAs. That is the final frontier. If you have achieved good MSA, whether it's a bare or a drug-eluting stent, you are assured of good results. Well, so it's plaque modification, in fact, amounts to changing the compliance of the vessel. Step one in this direction is that you need to visualize, you need to see as to what the plaque is made of, what is the extent and severity of distribution of calcium in this, because this will help you pick up tools. Now, angio has got sensitivity of about 39%, but if you have either IVAS or OCT, this goes up to almost 73 to 90% compared to angio. So the OCT has an additional advantage in the calcific milieu. It tells you about the thickness of the plaque, so it can tell you about severity and distribution in a much better way than IVAS. So we'll start with this very simple algorithm of a calcific plaque. The first thing which you need to do is the lesion balloon crossable? If the answer is yes, the job is done. You cross, dilate, use different tools, and go ahead. If the lesion is not crossable, then you need some atherectomy devices, laser, rotablation, orbital, and finally, once you cross, dilated a little, you must image to find out the severity and distribution of calcium, and based on this, you go ahead and select your tools, which could be, in majority of the cases, multi-adjunctive tools. You cannot do things with just one tool. Ultimate goal is to achieve good stent expansion because this will translate into good results. So what I'm saying is that imaging occupies the center stage. You need to image to find out what you are dealing with. Well, these are the plaque modification tools. I don't think we need to go into these tools. So let's see as to each one of them as to how we use them. So amongst the non-atherectomy devices, plain balloon angioplasty or the plain POBA works. If the arc of the calcium is 220 and the thickness is less than 230 microns, you can easily go ahead, crack these calciums and achieve good results. The point to remember is it is fractures and dissections which produce good results. We have OPNNC balloon, a double layered balloon, a very nice tool which works very well in a calcific milieu. The only precaution is that you must check the inflation of this balloon in two orthogonal views while going up from 20 atmospheres and above, because the chances of complications are high if you don't do that. Cutting balloons have been around. They kind of use the atherotomes to crack the calcific plate. Thereafter, you get the restoration of the vessel compliance. So, and it indirectly ensures very good vessel compliance. Wolverine is now 5 French compatible. The 3.5 and 4 need 6 French, but smaller balloons can even, the profile has come down tremendously. Well, one or two case examples. This was one of the circumflex, sorry, is it playing? It's not playing. Anyway, proximal lesion. Anyway, it's not playing, so I will just skip this part and I'll show you the ostium of the circumflex was free, but there was a concentric lesion in the middle part, and there was calcium also in the left main. So all what we did was that we used a cutting balloon, and you can very well appreciate the cuts being made by the atherotomes. And this was the kind of luminal gain which we got with the cutting balloons. In balloon uncrossable lesions, you need the atherectomy devices. So invariably here the calcium plate thickness is more than 630 microns. Basic idea of using these devices is to make the plate thinner at a particular point. Thereafter your tools can get in. And in this regard, ROTA is one of the most important tools. It is the only front cutting device. The burr has got diamond chips right at the peak. So this will get through. It's also used in CTO lesions with calcium. The approach is very simple. You rotablate, and if you can cross the lesion, I mean, you won the frontier. If it doesn't cross, then you need to change the wire. You need to go into exchange the wire, and then try rotablation. If it helps, you thereafter can do, that means if the lesion is absolutely not crossable, then if you have the choice of laser, you can do laser, or otherwise use a 0.75 millimeter balloon, because this is what is called granuloplasty. This will let the microcatheter go in. Once the microcatheter goes in, then you can exchange it with the rotawire and rotablate the lesion. So what I'm in effect telling you is that you need to park a microcatheter in an uncrossable lesion at the site of lesion, and then try and cross these lesions. If it is not going through, use a CTA wire, cross the lesion, dilate it, use either a laser if you have facilities. If not, you can use a 0.75 balloon, do granuloplasty, get in with a microcatheter, exchange, and then rotablate the lesion. So you need to use combination of wires and microcatheter to cross an uncrossable lesion. One such case, I hope it plays. So proximal lady had chalk-like calcium. So we went ahead. Wiring was very, very difficult. This is, I think, one of the fielder wires which was being used. We thought it will slip through, and we had problems. So finally we put a wire down, and then we used 0.75 balloon, did granuloplasty, exchanged it to the microcatheter, and then we rotablated. So it took us quite some time to rotablate this lesion because it was chalky white. Having done that, we had some fractures on IVUS. You can see displaced fractures, and thereafter the lesion was stented with fair results. So tips for using ROTA in a calcified milieu is that 1.5 is the default burr. It will work in most of the situations. You need to downgrade if 1.5 is not getting into the lesion, or in tortuous circumflex anatomies where there is calcium, 1.25 can be preferred. You must do a draw test. That means you must check that the drip is on, the rotational speed are properly selected, the advancer knob is kept in the optimal position, and the wire is kept in as distal as possible. You must do slow pecking movement, never trench because the burr will get stuck. If you are using 1.25, never go on high speeds. It can lead to stuck burr by what is described as Cocchesi phenomenon. And ballooning post rotablation is a must, because if you've not cracked that region, your stent will not kind of open up well. Now, if you still see dog boning of the balloon after doing rotablation, then it means that you need to upsize your burr and ablate a little more. Well, it's avoided in thrombotic lesions because you will release so much of thrombin that there will be slow flow in patients with severe LV dysfunction, because you will cause sludging of the microvasculature leading to arrest on the table, and you have to do it very carefully in dissected vessels, especially if they are of very small caliber. Excessive rotablation increases the chances of peri-procedural MI. Now, in uncrossable lesion, we always start with 1.5 lesion crossed happiness. If it doesn't, you downsize to 1.25 lesion crossed happiness. If it does not, you change from a floppy to an extra stiff wire, because this changes the wire bias. With the change of wire bias, the burr might go in, lesion crossed happiness. If not, then you need to get back to 1.5 again on an extra stiff wire. Why do you do that? Because it's got greater diamond coating, and this will help you ablate the lesion properly. So you have to have a combination of wires and burrs for an uncrossable lesion. Never ever forcibly manipulate the burrs in calcific lesions, because the chances of stuck burr are very high. And if you have the fear of stuck burr, then these are the situations where you can develop stuck burr. That means angulated lesions, long lesions, where there is large burr to artery ratio, and if you are ablating implanted stents. Well, preventive measures, always gentle pecking motion, never ever a dance or a trench, avoid high speeds while using small burrs, and watch out for significant decelerations. Yes, this is most important. Maintain cordial relations with your surgeons. You never know when you'll need them. Well, orbital atherectomy is also here in our country, and it's slowly picking up. Well, this uses a single diamond black fund burr, which is about 1.25. It basically rotates on the wire in a centrifugal manner. You have to advance it very slowly. It's essentially reserved for large calcium burden where you have to do atherectomy. This is one such case with calcific nodule in the proximal part of the RCA. You cross the nose cone and the ring if you have an ostial lesion. We did that in this case. First ambulate backwards and then you can move forwards and backwards. One size burr does it all at 80,000 RPM. Very rarely you need to go to 120 RPM speeds. And once you've done that, you can probably stent, and we got good results in this. Well, limitation of atherectomy tools are that you can ablate only one branch. You cannot leave another wire inside because it will get ablated. There is a large learning curve, and it's relatively contraindicated in the situations which I've already enumerated. So there is a need felt for some other tool. Intravascular lithotripsy fills in that gap. So lithotripsy, I think everybody is aware, nothing but very high pressure acoustic waves being sent into the vessel, which kind of cracks the calcium. It works both for the superficial and deep calcium. And if I have to show, these are the lesion subsets where I prefer. That means longer calcific lesions in dissected vessels, superficial and deep calcium. Calcific lesions in ACS where there is thrombus, you cannot use rotablation. Under expanded stents, it works very well and it's proven its merit there. And calcific tortuous vessels where you kind of will be discouraged to use ablation techniques. So it can produce very good results, and the trials have shown the maximum gain of lumen is with IVL. It increases the lumen by about 1.7 millimeters. This is only because it works both at the superficial and deep plates. You can then combine, once the IVL has been used, I told in the morning also, you have to combine it with the other tools for the optimal results. Well, tips and tricks, it doesn't work in vessels more than 4 millimeter. Select a balloon size which kind of fits into the diseased artery diameter. You have to de-air the balloon well, so if as long as it's hugging the vessel, it will deliver the therapy, because the impedance of the balloon and the vessel wall has to match. So lesion crossing profile of this is very high, so you need to kind of start from distal to proximal, and you need to use guide extensions to deliver the balloon, because it's an expensive balloon and you must use up all the cycles which are there. In multi-layered stents, if you have more than 2 layers of stents, it's not proven to be efficacious. Balloon might rupture in tight tortuous vessels, so you have to be careful. Never ever use it at higher pressures. Now the IFUs are being revised, and it is being said that even at 1 or 2 atmosphere inflation, the device is going to work. All it needs is the balloon should be hugging the vessel wall. That's about it. Shock topics are there, more common in the distal LAD territory. They are not seen in circumflex. Now you need to be careful with shock topics. There is one reported case of VT being induced, VT degenerating into VF, where R1T happened because of the shock topics. This is because of mechanical stimulation of heart. At least check your defibrillators in the cath lab. It's very, very important. Well, laser is penetrated very few centers because it's an expensive tool. It's essentially used for CTOs, ISRs, and some cases of ACS where they are using it to treat the thrombus. And in moderately calcific, I won't say in severely calcific lesions, because the penetration of laser is only about 50 micron. It works with photochemical, photomechanical, and photothermal mechanisms. So that means you break the bonds, you push mechanically forward, and the heat generated also helps you soften the plaque. And thereafter the same can be treated. Well, plaque modification is challenging. The challenges are there with each of the therapies as listed on the slide. Some have got learning curve, the others are expensive. And you need to use a combination of these devices. So rotatripsy is a very popular thing where rota paves the way and the IVL balloon kind of dilates the lesion or makes them more compliant for stent dilatation. So it's essentially reserved for very tight, long lesions. So I will kind of just run through this case. There was calcific nodule in the distal left main. Again, the wiring was very, very difficult. So post-wiring, we had to do granuloplasty followed by rotablation. We had to do step burring with 1.25, 1.5, IVL cutting balloon, and finally he was stented. This was the sole surviving vessel. The circumflex was totally knocked off and RCA was feeling retrograde, and he was not a candidate for CABG. This case was done under IABP because he had severe LV dysfunction. So successful basically plaque modification involves image-guided delineation of the lesion, choosing the correct atherectomy tools and using combination of these tools in majority of the cases. We need to be watchful of following things. Most of your patients are going to be elderly with LV dysfunction, so you have to select the strategy of revascularization sitting with your heart team, because the right choice should be made. These are complex lesion subsets, so aim for the least possible residual syntax score if you are doing angioplasty, because that is what is going to translate into good long-term results. The lesions are complex, so use combination of atherectomy tools for optimal results. To conclude, I would say that there is no competent medical therapy available for calcified disease. You need to have atherectomy tools by your side, and we are getting to see a lot of calcific coronary artery disease in our setup. This is probably because of the aging population. A heart team approach is required. Most of the patients are at high risk of surgical intervention, so if you are selecting angioplasty, you must have a plan in place, and you must perform a procedure which will translate into good long-term results. Thank you so much for your patient hearing. Good to see you, Sandeep.
Any question?
I think everybody is hungry.
So we can conclude this session.
Thank you. Thank you. Thank you.
Thank you, sir. Thank you, honorable chairpersons. With this, with your due permission, we'll conclude this session. Now we'll break for lunch. We'll have a quick lunch and get back to this auditorium by 3:15. Thank you.
Faculties are requested to have lunch in the faculty lounge. All
right, sir. We'll have 15 plus 15 minutes.
जितेंद्र जा इधर आओ आओ ना
Hello, 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 chick. Hello. Hello, check. Hello. Hello. Hello, check. 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 Hello. Hello.
Hello, hello. I would just announce the speakers for the next session and just raise your hand if you're there in the house. Dr. Amrendra Kumar. Dr. Amrendra Kumar, who's a consultant cardiologist at Sai Hospital. All right. Dr. Shaukat Ali. Dr. Shaukat Ali. Dr. Mani Shankar Pandey. Dr. Aditya Bhaskar. Not present. Hello, hello. I would request everyone to kindly gather back in the hall, please. We'll begin the session. I once again announce the speakers for the next session, the session on coronary plaque modification and calcified lesion. Speakers are Dr. Shaukat Ali from Purnia. Are you there in the house? Dr. Shaukat Ali? Dr. Mani Shankar Pandey, Dr. Aditya Bhaskar,
Hello. Hello. Hello, check.
For the session on coronary plaque modification and calcified lesion, I would request our honorable chairpersons to kindly grace the dais. Professor Hemant Narayan Roy, who is a professor and head of cardiology from RIMS Ranchi. Dr. D.K. Srivastav, professor and former head of department PMCH Patna. Dr. S.K. Didwania, professor and former head of department medicine PMCH Patna. Dr. S.S. Chatterjee, former director of cardiology from IGIC Patna. Dr. Arvind Kumar, former CSI president and head CTVS department IGIC Patna. And Dr. V.P. Sinha, professor and former head Department of Cardiology from PMCH Patna. I would request the honorable chairpersons to kindly grace the stage. I once again request our honorable chairpersons, Professor Hemant Narayan Roy, Dr. D.K. Srivastav, Dr. S.K. Didwania, Dr. S.S. Chatterjee, Dr. Arvind Kumar and Dr. V.P. Sinha.
S.K. Didwania and D.K.
I would request Dr. Neerav Kumar, Professor IJMS, to kindly take place as chairperson.
Good afternoon, sir. Good afternoon, chairperson and all the delegates. I am going to present a case of primary PCI in case of anastomia with thrombocytopenia. The patient was 55-year male with having complaint of chest pain from last 2 days with pulse rate of 78, blood pressure of 128 by 76. Chest was clear and there was a history of hypertension and diabetes mellitus. ECG showing normal sinus rhythm with T-wave inversion in lead 3 and AVF and ST elevation in V5, V6. On investigation, his hemoglobin was 8.9 and platelet count was 53,000 only. Echo was LVEF of 40 to 45% with akinetic lateral wall and posterior wall with moderate MR. As per the case scenario, patient was having thrombocytopenia with anemia. According to the reality trial, the restricted transfusion in case of acute coronary syndrome is non-inferior to the liberal transfusion. That is, the keep hemoglobin more than 8 is well sufficient. And for the thrombocytopenia, there was an article for the management of antithrombotics and anticoagulants in case of thrombocytopenia patient, that we can use heparin and DAPT in the patients who are having platelet count of more than 30,000. So I've decided to take this patient to the cath lab for the angiography. On angiography, this is RO caudal view taken from the right radial artery with a tiger catheter. रन नहीं हो रहा एक्चुअली नहीं इसके बैक on angiogram showing LCX 100% stenosis with LAD 50 to 70% stenosis and RCA was insignificant. Right coronary angiogram showing insignificant stenosis, but plaque was present diffusely throughout the RCA. As per the lesion appears simple and with short left main, so I have decided to take only GL guide for the angioplasty in place of EBU, and after that I have wired through the run-through floppy wire and pre-dilatation done with the 2.10 Ryuri balloon. After that, we have taken a stent of 2.5 28 size balloon stent, but the stent was not going through distal through the bend of LCX. So for that, I have taken body wire for straightening the vessels. But even after using body wire, the stent was not going through distal to the target lesion. After that, I have wired LAD to the diagonal and use the balloon anchoring technique for the stabilization of guide, so that we can push through the stent through the target lesion. But even after that, the stent was not going. last chance was either we should change the guide to the EBU or we can use the guide extension catheter. So I have used guide extension catheter because in case of radial artery that was spasmed, and so I have decided we can use only guide extension catheter. We had guide liner in my cath lab, so I have decided to choose guide liner. There are some difference between guidezilla and guide liner. That is, the proximal shaft of guidezilla is stainless steel hypotube, but guide liner has a ribbon, and outer diameter of guidezilla is 0.057 and guide liner is slightly less. There is a guide liner in the catheter, and I have used the balloon surfing technique for the guide liner placement till the angle of LCX at here. Yes, sure. Guide liner and stent was placed after the lesion, and shot taken for the proper placement of stent distal to the LCX in OM, and stent was 2.532 size Bromas elite and inflated at the nominal pressure. After angiogram taken to see any dissections, and after that post dilatation done with 2.7512 balloon. And this is the final result, and showing the bend even after stenting in the LCX, and this is the final result, is showing good inflation opposition and without any perforation and dissections. The complication associated with using the guide extension catheter is coronary dissection and wire and push rod wrapping, air embolism and ischemia. We should wait for the backflow in the even using guide extension catheter because of dampening of the pressure, and prolonged use of a guide extension catheter can cause ischemia of the vessel. And there are the three techniques, that is balloon surfing technique, balloon anchor technique and inchworm technique. In balloon surfing technique, which I have used in this case, that is the positioning of balloon slight protruding to the guide extension catheter and inflating at the nominal pressure. 6 French catheter having diameter of around 2 millimeters, so I had used 210 balloon and inflated at the nominal pressure, and at the half slight protrusion at the guide extension catheter and progress through the left main to the LCX. There is sub technique, that is inchworm technique, in which the balloon inflated and same side of deflation we should progress the guide extension catheter. This is the new second generation guide extension catheter, that is cross liner. In this case, the distal extent is monorail microcatheter tip, which is 0.018, and in this case we should there is no need of using of balloon tracking. So there is a less chances of coronary dissection in using cross liner as the guide extension catheter. The summary is, the guiding catheter can make our procedure simple by appropriate use. Selection of guide catheter is associated with making strong backup force and setting of coaxial position of system, and appropriate use of guide extension catheter can solve difficulties in complex coronary procedure. Thank you.
Nice case, Dr. Saugar. Can we go back to the lesion? It looked like there was some thrombus also. It was full of thrombus. So don't you think if we are using guide liner as well as balloon surfing technique, the thrombus can get dislodged, can go to up also, and it can go into the distal LCX, it can create a problem. What was the reason behind using the GL in place of EBU in this patient?
Sir, as per look, the lesion appears was very simple, and there is a short left main, and so we have decided that we can use only GL guide, and we come out easily.
Yeah, even with Judkins, you have used, there is called emplaging the Judkins. So even you can push the Judkins further so that it
Yes,
can
sir,
work
I-
as a employed catheter,
Yes,
so
sir,
that
I have
can give good support in circ lesion.
Yes, sir. I have intubated this Judkins catheter, but there is a short left main. So I have not pushed for the further complication in left main dissection. Because patient was already having platelet count of 53,000 only, there could be chances of further complication that will end up in severe complexities. Sir, we had Nagomi stent and Promas Elite. Initially, we had progressed Nagomi 2.528, but it was not gone through.
Nagomi is a very trackable stent, but I will tell you that if you tell the anchor balloon technique,
Yeah.
why did you anchor the diagonal? Why don't you anchor the circumflex branch?
Actually, sir, two balloon catheter shaft can compromise the placement of stent in the LCX.
No. That is actually wrong. You should actually, when you have a wire there, the anchor would have been easily done to the circumflex branch. That was the best anchoring one rather than LED and diagonal, number one. Number two, if it is not crossing, you can put one more the wire, you can have a distal anchoring. Same vessel, you can keep the wire down and just have a distal anchoring. The stent will go down. These are the techniques, other techniques than that. Why the stent is not going? There are two things. One, the lesion preparation is not adequate. Number two is angulation. Angulation always, anger helps. Distal preparation is not, lesion preparation is not done. You have to prepare with a much better balloon.
Yes, sir, we had used two with well inflation. We can see
No.
in the angiogram that
I'm just
before-
telling you about
Yeah.
the options of the, if the stent does not go. That's
But
all I'm telling.
in this
Not
case,
like
in this case, the main reason was the bend in the LCX.
That's what I'm telling. If there is a bent, the anchoring and the same vessel will be easier than the other one. That is
Yes.
what I'm telling.
Thank you, Dr. Sokar. So we'll proceed with the next case. Next case will be presented by Dr. Chandraket, IVL assisted PCI in severely calcific RCA. Dr. Chandraket.
Good afternoon, faculty, my senior colleagues. I would like to present a case which is done by Dr. Mani Shankar. However, he is absent due to personal reasons, so I will continue with the case. It's not.
Presentation of Dr. Mani Shankar Pandey.
It's not opening.
डॉक्टर मणिशंकर पांडे का है
सर मेरे नाम से ही है।
अच्छा इनके नाम से
because of the technical glitch, we'll shift this presentation in the next session. We'll proceed with the left main intervention and bifurcation session. May I request the Honorable Chairperson for this session to kindly grace the stage. Dr. Rakesh Yadav, who's Professor of Cardiology from AIIMS, New Delhi. Dr. Pratap Kumar N, who's the Chairman of Mediterranean Group of Hospital from Kollam, Kerala. Dr. Harendra Kumar, who's former Director IGIC Patna and past President CSI Bihar. Dr. Jyoti Prakash, Head Medicine Department, AIIMS Patna. Dr. Sheil Avnish, Head CTVS Department, IGMS Patna. Dr. Anshu Agrawal, Senior Consultant Interventional Cardiologist from Muzaffarpur. Dr. J.P. Karn, Senior Consultant Cardiologist from Darbhanga. And Dr. Ishad Alam, who's also a Senior Consultant Cardiologist from Darbhanga. I would request Dr. Pratap to kindly call on the first speaker.
Hello, can I have Rakesh on the chair?
Sir.
One of the major problem in any bifurcation lesion is to access the side branch, that he will be talking how to tackle side branch.
Welcome after the post-lunch session, and first of all I sincerely thanks all the members of organizing committee, and Bihar is always said to be my second home. And I love coming here, and thank you for calling me, for giving me this, though it is a very simple talk. If I ask any cardiologist, have you difficulty in assessing the side branch, they say, no, Dr. Saab, I have done everything. But really, in my view, in my practice, I always say at least 5%, even with all maneuver, I could not cross the side branch. And if it is not enough, I don't struggle a lot, because putting a stent in the main branch, leaving will not harm. Fiddling more will call perforation, will call dissection in the native branch, and unnecessary fiddling should always be avoided in this situation. We all know that true coronary bifurcation remains one of the most complex yet besides CTO, because Dr. Saab is sitting here, so I will say, besides CTO, the bifurcation angioplasty is really very tricky one. And we all know that about 15 to 20% of all the lesions need a bifurcation stenting. Now, compared to non-bifurcation, why it is important? Because there's a lot of technical complexity, higher incidence of procedure complication, and increased rate of adverse effect. We all know that if you put a 2 stent in a bifurcation lesion versus a 1 stent versus leaving a side branch, they have higher chances of restenosis and other adverse effect. Now, we all believe at present, because there is a bifurcation club also, there is a intervention cardiologist also, there's a lot of clubs which are being framed. But at present, what we believe, that provisional stenting based on the implantation of the single stent on the main branch with the addition of a second stent on the side branch, only if it is needed, is the treatment of choice for majority of the bifurcation. Is that even now in a left main bifurcation, they say that this strategy should be the first strategy. Now, provisional side branch stenting, we all know a lot of techniques. I'm not going to detail telling about the techniques because my talk is entirely different. But what is the most important thing when you are tackling a bifurcation? That is the safe guide wire placement in both vessels, whether it's a main vessel or the side branch. So this should be the first approach when you are tackling a bifurcation stenting, that you have to place safely 2 wires in main branch and a side branch. Now there is many classification which has been promoted. I personally believe that Medina classification is the classification which is used by everybody and which is left by everybody. And I'm not going to describe this classification. Now, first of all, when you should wire a side branch, that is very important. When it is relevant, we all believe if reference diameter is more than 2, if it's supplying more than 10% of the myocardium, and by definition, if it's more than 7 centimeter, we presume that it will supply 10% of the myocardium. And if, as an operator, you want that, I don't want to sacrifice this side branch, then probably you can try a bifurcation stenting. Now, this is very important. when you are doing a bifurcation stenting, the mechanism of shift is two, by carinal shift and longitudinal plaque shift. This is the two important cause which can cause blockage of the bifurcation stent. And these are various predictor. In IVUS, it's carina with spiky morphology, in OCT, and in angiography, it's the severe diameter stenosis, angle is more. So these are the predictor. When you predict that if I am going to perform a single main branch angioplasty, they probably close. Now, these are basically detailed angiographic predictors. You should always know. Severe calcific involvement of the proximal vessels, severe stenosis with a large plaque burden in the proximal vessel, tortuosity, severe stenosis of the side branch, timid free flow, angulation, which is very important. If the angulation of main branch and side branch. Now let us go to actually of my talk, how to negotiate your wire in a difficult side branch SS. We all know there is three important factors. First of all, it's a main branch, it's a distal main vessels, and it's a side branch. The bifurcation angle, we all believe, is a very, very important factor when there's a difficult SS of side branch. Second important is a plaque distribution. Plaque distribution at the site of bifurcation. It is 1-1-1 or 1-1-0 or 1-1-0, whatever this is, you can in classification. A plaque distribution is very important. And third is a tortuosity of the side branch. So these three important factors, if all three are unfavorable, it is the most difficult side branch SS. Now this, if you can see, this is angle between main branch and side branch is very, very straight. But the plaque burden is such that the negotiation is very, very difficult. So always look on angiography, a plaque. Now this is an angiographic view of one angiogram. If you see side branch, you can think it's a very easy to negotiate side branch. But if you go thoroughly, the plaque distribution is such that the simple wire will not go. If you want to, though, you have to make curves because you have to go from the below. And after the tight stenosis, just proximal to the side branch. These are the most difficult, because we all say that until you cross both branch, you should not dilate the main vessel first. There's a tendency, okay, let us dilate it. Practically, in majority of the cases, we block off. Now, how to pre-shape wire? Tip according to bifurcation anatomy. It's very important. There's a 4, if you want to a single bend, there may be a short bend, there may be a long bend, and there may be a smooth bend, depending upon the angulation, plaque morphology, the vessel size. Believe me, and a double bend. All this you have to see by seeing the anatomy of the bifurcation, which will negotiate. The double bend, this is the most important thing, is a hinge, where you want to put a hinge. So a proximal bend should be larger than the proximal vessel, which is not a stenote vessel. So if you want to place a hinge which is very short, where proximal curve is short, distal curve is short, you may not be able to negotiate the side branch. So this is very important depending upon the angulation, depending upon the plaque burden. You have to make a double bend, and double bend depends upon the size of the vessel, the placement of the plaque, so that you can easily negotiate into the side branch. Same thing with the progressive curve. So you have to thoroughly see what is a side branch, how is a side branch. Now, sometimes what happens, you are not able to negotiate directly, so a pullback technique is advocated. You place your wire and you pull back, it will fall into the side branch. These are the various techniques which need to be understood. Then a rotation, hinge joint rotation. If it is not going by simple pushing, you have to rotate something. Sometimes what happens, pushing will cause buckling, but rotation will cause rotation will introduce your wire into the side branch. And in the last, we always say pre-dilation should be kept in the last when all your maneuver fail. Don't pre-dilate initially, because it may become more difficult to cross the side branch. Sometimes you have to block the distal part. If it is not going, a distal balloon occlusion is indicated, but the balloon distally which is placed should be not placed more than the vessel size distally, and it should not be inflated more than 2 to 3 atmosphere pressure. And this balloon may sometimes help it in negotiating the side branch. A reverse loop technique. The reverse loop technique is usually advised when the angle of the side branch is very less. Suppose it is the angle is very less. Now, how it is being done? It is being done that you have to make a loop in a main branch, and you can preform the loop outside also. You can place the wire into the distal side branch and make this loop. That you can choose according to your experience. So if you make this loop, the loop is negotiated and then it is withdrawn. So sometimes it anchors it, and then it is easy to negotiate these vessels. So reverse wire technique, you can also make a loop outside, but if you make a loop outside, you can only go to the micro catheter. Now this is a very simple way, that is a diagrammatic and the video representation how to do the reverse loop, because this is the things which majority of us uses when it is very difficult to introduce as a branch. So you first place a microcatheter, you have placed the microcatheter, and then you withdraw the microcatheter, and this loop will negotiate into the side branch. Because so this reverse loop techniques, and it's a very old technique, not a very new technique. 2006 it has been shown to do it. And same thing is with this. Sometime what happened, if you see this angiogram, a side branch, it seems very simple. But if you zoom it, the angle of origin of the side branch is just after the stenosis. So you have to go from below. There's no technique by which from up you can negotiate the side branch. Everything is being tried. We are not able to negotiate. Regular dual lumen catheter. Then we have made a loop by using a dual lumen catheters. The wire is negotiated into a side branch. The catheter is pushed so that it makes a reverse loop here. And then when you withdraw it, this will go to the side branch. So these are the various techniques by which you can negotiate are difficult when angle is more. Then I have told you, I have demonstrated you balloon block technique. The distal to the, these are the various lesions you have negotiated. This is the left side, this is the right side. You block in the main branch or any branch, and this balloon should not be a larger size balloon depending upon the lumen of that branch, and it should not be inflated with a high pressure. So sometime if you block the proximal, you are able to negotiate your wire distally. These are the various catheters: a dual lumen catheter, angulated microcatheter, deflected microcatheter, which are useful. Now this is a twin pass catheter. There's a two lumen. One lumen is monorail, another lumen is over the wire. Now this is very simple. You have to place the lumen just adjacent to side branch, curve your wire, and you can negotiate these very well. Cruciate lumen, there's two double lumen catheter available, and this is a deflectable. This is how a deflectable or angulated microcatheter helps. You place the wire, you withdraw the wire, your microcatheter will take its pre-shape, and this will, it is a pre-shaped microcatheter. So, and depending upon the bend, you can choose it, and then it may be easy to negotiate the wire. This is same venture catheter, which is a pre-shaped microcatheter, and you can use, I have shown you a video of that. Again, odd tortuous vessels can be negotiated simply by these microcatheters. This is just a diagrammatic representation place a wire, put a microcatheter, withdraw the wire, the microcatheter will take a shape and you can easily negotiate it. Now there is also a deflectable guide wire are available in the market, by which you can deflect the tip of guide wire. You need not to, because if you shape the guide wire, it will be only one shape. So these are also available in the market, but these guide wire not a very good guide wire to negotiate, but these are available in the market, steerable deflectable tip guide wire. Now this is very important. This should be a last resort when you need for main vessel plug modification. Either you can do a plug debulking or a balloon pre-dilatation, but in this situation never do a full size balloon pre-dilatation. Do it with a small balloon, never try to do it with a bigger balloon, because it will more cause plug shifting and it will lead to occlusion of the side branch. Now if you want to rewire after main vessel stenting, all previous steps are going to help. So there's no new things when you have to. You are not able to do the proximal pot. That is very important. If suppose you have put a main branch stenting and the side branch you are not able to negotiate, do a proper pot. That is very, very important, and it should be just proximal to the origin of the side branch. It should not be covering the side branch. So a proper pot sometimes help. Use of these catheter will help, and usually the pullback technique is more important. So the slides are moving very slow. So in the last, I just said that bifurcation remains a technically challenging. Always having two views. That is very, very important. We have a tendency to perform all the cases by just doing one or two views. No, absolutely no. That is very, very orthogonal views are mandatory when you are doing the difficult lesions. You may have taken is equipped with tools to face such challenges, because it's a say, by failing to prepare, you are preparing to fail. That is very important when you are doing a difficult bifurcation stenting. Thank you very much.
A wonderful, wonderful talk. Actually, today morning, one case, somebody showed a supercross catheter. That is actually the catheter which is available, deflectable. And two dual lumen catheters available in India are actually Crusade and Sasuke is available with some people. And Recross is also available now. So that is actually the third double lumen catheter with 3 lumens available. Again, these are the catheters available and different techniques, because side branch crossing is not an easy game, and that is actually one area many of the people fail. Actually, Colombo once told that he failed in nearly 15% of the cases to recross, even though many people, as Rakesh told, I never failed to cross the side. It's not true. People fail. And I think if any comments, any questions to Rakesh, not to me.
You prefer
usually filter hydrophilic wires are preferred. Always remember, if you want to post stenting, you want to cross the hydrophilic wire, my choice is always a filter, because it is available only in AIMS. It is available, but I feel it is the best wire. Filter.
I think that is also my choice. Also, many other people's choice.
Filter.
Twin pass is not available in India. I think twin pass
is a American thing.
Yeah, so we have the Crusade one.
Crusade, Crusade is available. Sasuke is available in few places. Now Trapliner is also available.
Trapliner is available.
Find is also not available. Actually, available things are two: Crusade and Sasuke. Recross is available with 3 lumens are there, but actually it's a dual lumen catheter. 3 pots are there. I think Rakesh, thank you very much.
Thank you, sir.
Thank you, sir, for such a wonderful presentation.
You are also leaving.
Our next presenter is Dr. Pratap Kumar Ansar from Kerala. He is going to present on left main interventions, case-based discussion.
Please pass. connect? आ गया तो अच्छा है. Why I choose my laptop? Because there is an audiovisual issues there. I was actually given a talk on topic is little different, but I changed the topic to tips and tricks of left main intervention. You should understand that the large and the highly variable diameter of the left main, which is extending in a larger way, you can extend 3 millimeters, 5 millimeters up to that. So you should understand that there is a large and highly variable angle for the LMCA bifurcation, and it's actually having a curved course. And the atherosclerosis distally in the longitudinal lesion actually extending from LMCA to circumflex and LAD. Why LM needs expertise? Number one is actually large area of supply. More than 75% of the left ventricle is supplied actually in the right dominant, and 100% in the left dominance is supplied by LM. And it is usually associated with a multivessel disease. There are three important things to be. You should anticipate potential problems. Number two, use imaging. You can use IVUS or OCT. Number three, keep it simple. What are the, make sure that disease is there. You should understand that LMCS, sometimes you may think LMCS is there. You should understand it is there or not. Number one, lack of appropriate angiogram use. Those are the technical difficulties. Interaction with the intubating catheter and possible absence of undeceased reference segment. Basically, in access site, you can get a sheathless guide in a 7 French catheter. People are very adamant that I will do only radial, just like Dilip and all. Then you can take a 7 French sheathless guide, and that will help you. But I am actually a femoral, still now a lot of femoral case I do. I will take a 7 French. 7 French is a minimum catheter took in LMC intervention. Guiding can be 7 or 8 because better lesion preparation, you may require a rotablation or thrombus. Thrombus aspiration. You can have a better maneuverability. You can have a device injection and dye injection and a device trackability. You may require a triple kissing. Again, 7 French is required. IVUS usage. In general, soft-tipped spring wires can be used, but you may require a hydrophilic wire if you have major vessel calcification, excess winding, extremely acute angle between LM and circumflex, lesion eccentricity, and ulcerated plaque at the risk of destabilization. You may require actually plaque only in the ostium and midshaft. You can get away with a single wire. But in all other cases, you require 2 wires. And wire both the branches except when you are using a rotablation in both the vessels. Advantages of the jailed wire. One, it modifies the bifurcation angle. As a marker to locate the branch ostium in case of there is actually an occlusion. To maintain the side branch patency after the main vessel pre-dilatation and stenting. And lastly, to re-access the side branch. Most challenging branch should be wired first. That is the principle. You may ask me which vessel to be branch. Most challenging vessel to be branch. And limit wire wrap risk. Side branch severe osteostenosis, very calcified lesion, difficult side branch access. I will always tell you should have both the wires to be there. You should understand that actually the target lift main stenting only wire in the main vessel, otherwise you should have both the wires should be there. Selection of the stent size. If ostial or shaft only lesions, you can actually select the size with the left main size only. If you are actually looking of the bifurcation stenting, LM, LAD, circumflex, you should always go for the distal vessel sizing. And you take single stent, LAD vessel, you do an imaging, that should be the size of the stent. LM size, when this with a normal size of 3 to 4 millimeters expanded to higher diameters. You have different size of stents are available. Expansion may be limited. What is the problem? I always take, if you actually difference between the distal LM, LAD and the LM ostium is actually more than 1.5 millimeters, I usually take 0.5 more than the distal size and inflate 2 atmosphere less and then go with the proximal part. Basically because expansion may be limited, suboptimal plaque coverage is possible, and drug elution kinetics may be preserved, may not be preserved if you dilate high pressure.
These are the stent designs. I'm not going to that. Ostial lesions, there is a greater risk of elastic recoil. Risk of stent malposition, actually that is most important, hangout or ostial hanging. Where should be the ideal position? Risk of the longitudinal stent deformation due to 1. Interference with the guide catheter, occurrence of the stent malposition, possible need of advancing the device through the implanted stent. These are actually the aorto-ostial landings on AOLS, basically defined as the area along the axis of the coronary artery located within 1 millimeter of the aorto-ostial line. This should be the ideal one. What should be the ideal replacement? That is, A is the ideal placement. You can have 1 or 2 millimeters away from the branch down. Other things you may overhang when at least a segment of the stent angle is located within the aorto-ostial segment. These are the stent position. Stent is too distal means you may miss the ostium. Stent is too proximal means second procedure will be having a difficulty. Left coronary artery, actually ostial engagement, ostial lesion. This is the way it should be engaged. You have other techniques. You can have a stent tail wire or a sabot technique to use. Many people may not use. We have done cases actually called stent tail wire. You have to take one wire which should actually go to the first stent strut. You rewire and position it. Second is actually you can have a sepal wiring, actually the wire actually kept inside the ostium of the. That is one of the easiest technique to use. These are the two techniques used for the wiring. This is an ostial lesion of LMCA. We wired actually circumflex and LMCA. We did an IVUS done. Sepal wire is placed. You can see the sepal wire in the third film. Then we put the stent exactly away from the bifurcation, and you can see the positioning of the stent, inflated. Then you should look at the final result. This is the final result. The points to remember: adopt the single stent technique. In a LM bifurcation, what is to be done? This is actually ostial and shaft I have shown you. Single stent technique whenever is possible. Final kissing balloon inflation basically is required specifically. Large subtended myocardial mass or stent implant in LM to circumflex. Stent should have sufficient length, 8 to 9 millimeters for the pot. Repot is advisable whenever there is a long kissing balloon overlap in the LM's area. Final IVUS to be done to ensure that the stent is supposed very well. If you actually look at the Y-shaped angle less than 60, easier wire access, you may come away with single wire technique. Otherwise, rewiring is difficult. You should have 2 wires there. These are the things. What are the size of the circumflex to be bothered? If the size is actually more than 2.5 millimeters, you should actually require to protect the vessel. Then you should have 2 wires. You can have 2 techniques, Y-shaped or a T-shaped. If it is a Y-shape, you can have mini crush technique or a culotte technique or a T-standing. T-standing is not recommended there. In a T-shape, you can have a T-standing or a mini crush technique. Whenever the plaque involves one branch only, it can have a provisional standing. That means 110, 101. When both the branches are significantly affected, more diseased branch standard first from the LM and TO tap or culotte technique as the bailout and side branch technique. Always DK crush or mini crush as the better technique, which I feel always my choice is mini crush or DK crush in LMCA bifurcation. LMCA bifurcation, I don't do any other technique. Whenever I did a teeth or tap, those patients came back with restenosis to me. Angle between circ and LMCA is 90%, 90 degree, T standing. Narrow angle, DK crush, culotte or mini crush or tap. If you go to European people, they will tell T, tap and culotte. You go to China, DK crush. You go to US, your Mount Sinai, only mini crush. I, mini crush or DK crush, if the time permits, DK, otherwise mini. Which lesion to stent first? Distal and proximal. Always the downstream stent first for the people, but I always do the proximal stent first. When to use the intra-aortic balloon pump, I don't use it. Systolic blood pressure less than 110, RCA is occluded, severe LV systolic dysfunction, LM, AD or circumflex are significantly calcified. T-shaped bifurcation, operator choice to place a protective wire. Y-shaped protective wire is always recommended. removal of the jail wire may cause proximal coronary dissection. I usually don't remove the wire. Avoid hydrophilic wire for the jailing. This is actually slides, but my practice always hydrophilic wire. And I always prefer Philrepsi wire. And don't take an oaks wire, that you may land in problem. Entering the side branch after the main vessel stemming, keep the jail wire in the side branch until complete recrossing. These are the steps. What has to be done? In difficulty in negotiating the balloon through the stent strut. If the balloon is not going, what are the things you can use? You can use a 1.5 millimeter Ryujin, 1.25 or 1 millimeter, or a mini truck balloon to actually to separate the strut, number one. Number two, recross with a second wire with the first wire is in place. Number three, further actually dilate the main vessel stent so that you can actually cross it. Number four, inflate the balloon at least 12 to 14 atmosphere, 20 seconds, and try to advance the balloon further while deflating. Number four. Number five, try with a small fixed wire balloon. Number six, try orientable microcatheters, actually Wenger catheter or a supercross catheter. Number seven, actually advance and inflate a very small balloon over the jailed wire. I did not have any problem. We usually do without any problems. Size discrepancy, one of the two of the branches are similar in LM size. Display the stent. Actually, you can actually deploy the stent from the main to distal vessel having the similar size. And both the branches are clearly smaller than LMCA. Actually, I usually prefer to do LM to LAD than LM to circumflex. Circ is very big, LAD is small. I actually take LM to circ as the main vessel. Sending LM to LAD, size discrepancy, dilatation with the balloon that is adequate for the LAD size. Then angulator takeoff, how to cross the circumflex. You actually see this one. Deep engagement and rotation, number one. Body wire in the circumflex is number two. Number three, use a short, low profile, flexible stents you can take to the circumflex, and anchor technique in the LAD or ramus intermediates to take the balloon down. Body wire is good. Rotablation is one. Considering the dimension of LMCA, always, if you wanted to do a rota in LM, I always prefer 1.5 to 1. Finished? 3 minutes more. Okay. I will finish before that. 1.5 or 1.75 rota. This is actually a provisional stenting. CAG shows a distal vessel. We actually put a wire into the circumflex also. Just did an IVUS. We always do IVUS for both the vessels. Then provisional stenting, balloon dilatation, post IVUS, this is the result. Single stent strategy. Then V stenting. I'm just showing the all tech. You have two branches vessel, both the branches dilated, simultaneous inflation, check angio before removing the wire, very important, otherwise you may not be able to recross the wire. And both the wires. We are not taking the stent into the V stenting is actually exactly up to the ostium and keeping. Exactly means probably for me. This is actually tab stenting. We decided to put a single stent strategy. I was done. LM to LAD stent placed. You just look at ostium is pinched. When we did IVUS, there was significant disease, plaque shift. Circ wired, ostium pre-dilated. Then two stent together, pot again, final result. Mini crush, both the vessels wired, circ inflated while the balloon in the LAD, circ stent placed, LM to LAD, circ is wired through the proximal to mid strut, pot done, ostium pre-dilated, kissing balloon inflation, second pot, final result. Go to the DK crush, both the vessels wired, balloon crush, LAD rewired, ostium dilated, initial KBI, LM to circ stenting we did, final KBI, final pot, this is the final result. Imaging and physiology important. Class 1A is the imaging. Recommendation is like this. Now there is a change. IVUS in LMCA is assessment of severity of disease, plaque burden, measurement, stent crossover. You can actually do stent strategy whenever the circ ostium is more than 5.5 millimeters, you can just leave with one stent. Non-distal lesions, selection of the stent length and diameter, selection of the suitable landing site. Constructive remodeling is important. IVUS is useful to define. Usually, actually, the smallest MLA is always the best to accurate. Don't think that the smallest is important. And usually assessment, both circ as well as LED to be done, never with one. Assessment is important because of this one. This angulation make a totally different, so you should do both. This is the measurement. Physiology, I'm not going. Tips of FFR, both the vessels. This is actually a angiogram showing calcium was there. We did an IVUS to understand the vessel size. Proximal LED, mid LMC is tight disease. Calcium more than 180. Distal reference was 3.2 LED. So the stent in LED should be minimum 3.25. That was my assessment. Stent in LMC was 5 millimeters. We did a rota because of the calcium. After the rota, I'll just go fast. You can see the calcium. Then 3x10 flex storm we used, cutting balloon. Created a good area. Ostial circus can accommodate 3.5. We put a stent down. 3x48 down. 4x18 stent LM to LED. Even though LED was looking small, after the cutting balloon, the area was 3.5x23. We got an area of 3.2 that time. But after cutting balloon inflation, we got a very good area. 4x12, 3x12, 5x8, we got a final area like this. So if you look at 4x12 circ, 4x12, 3x12. Final IVUS done. So the pre-stent area of LMCA was 9, it became 17, LED was 11.2, circ is actually 6.86. Now the latest recommendation, initially we tell 5, 6, 7, 8, that is gone. Then you please came 6, 7, 8. The latest is actually 6, 8, 12. Easy to remember. 6.2, 8, 7.9 like that, and 12. I usually remember 6, 8, 12. 6, 8, 12 is the best now. That is actually the latest recommendation by Korean group published just now. This is actually the final result of that case. You can actually do even OCT. People may think that OCT is not possible. I just wanted to show that I am doing a study of LMC, actually published, going to be published. 100 cases we have done, LM bifurcation only with OCT. And result is excellent. This is actually RCA CTO. I'm not going. LM trifurcation lesion. We did everything. Actually, this is actually done only with OCT. Ramus tendon. I was done. We were not happy with the result, so we just went. Lesion length is 48. I just wanted to tell you that OCT is also one way of understanding the lesion. Significant fibrofatty lesion with a spotty calcium. One stent. We did 3 stents together, LM to circ, Ramus and LED, and a triple kissing with the 7 French catheter. This is actually triple kissing. 3.5, 12, 2.75 into 12, and 3 into 12. If you take 3 new balloons, you can carry, otherwise no. Trissing, pot. This is actually the trissing. You can see that angle. OCT done. We got a significantly excellent area. All the vessels we did OCT, not one vessel. This is the final result. So it is possible with the trissing. So the mini crush technique we have done. So LM intervention is challenging. Expertise required. Proper planning, image guidance is important. Thank you very much.
Thank you, sir, for a nice presentation, sir. My question is only the last case. Can we do tempering pacing during the angioplasty, sir?
Temporary pacing I don't even do for rotablation.
Because sometimes because of bradycardia, sir.
Bradycardia to be managed by atropine is available in the hospital. I managed that. Actually, I will be showing the next case. My talk is tuck rota, that I am showing my rota data also. More than 512 rotablation I have done so far. In that, I have used this pacing, temporary pacing in only one case. In my initial career, when I did a rotablation, everything was successful. Finally, the patient perforation. After that, I am afraid of rotablation. So I don't do rotablation. If I get recurrent CHB during my rota burring, then I usually do that. Even for RCA, I don't do. But basic problem is actually why you are getting a CHB. You are actually burring for 20 seconds, 30 seconds continuously. No. I usually burr only 10 seconds. Number one. Number two, if you use a larger burr, you may get CHB. Otherwise, adequate 1.5 burr, definitely not. I never got anything, and I'm telling about the number is very huge for the country. This number, I used rotablation, a temporary pacemaker for only one. I have published the largest data in the country, 670 patients, 4 years back. I do LMC in many places, but I have taken 7-year data of my own hospital where I am working main time, most of the time. 600 patients, we are going to publish the data. Not even a single case I have used temporary pacemaker.
Sir, when you use IABP, if the patient is having recurrent angina or recurrent hypotension during left vein angioplasty, do you routinely use IABP?
Sir, actually I have done, to be sincerely, I don't know whether you should replicate my practice. I have used only 2 cases IABP in my life, and in both the cases patient died. So I never used after that. And Impella, I used only for the live cases where I do lot of live cases, live cases if I do in some other hospital. In last NIC, I have done a CTO. They claimed it is a CTO, but I crossed with a normal wire. Normal wire means Philrevsy was a normal wire for me that I crossed. In that case, they used an Impella. I still feel that, I don't know, I would not have used it, but that is used.
So we do IVAS, like both circumflex and LED leftman pullback, and the IVAS measured angle. It's not the angiographic and visual angle which we make. The IVAS, the angulation which we get, and also the plaque distribution. Like the plaque is around the circumflex ostium and all. So it gives us an idea whether your future wire, like after putting a stent as a decay crush in circumflex, how much chances are there that you will be going successful in wiring. So these are very important. But I have one question to ask you. Like if there is a controversy regarding left main bifurcation angioplasty versus surgery, all of our Excel novel, why the penetration of IVAS was around 30-35%? Actually, if we are looking and set to see the CABG versus angioplasty result, we should be going full throttle, going with maximum imaging and giving the best results. 35% was the penetration of IVAS.
No, that is actually not true. I'm just telling you. Nearly when you actually, I'm just taking the NIC data. I'm not believing that NIC data is correct. I have collected 1,400, nearly 2,800 cath labs are available in India. I tried my level best to collect the data. People have given 1,200 labs has given data, including Rakesh Yadav who was sitting here. He has not given the data. They are telling it is not possible to give data. Many people don't give data. Lot of reasons. Let me finish that one. Then actually I have taken the data. Whoever has given the data, I myself analyze. That's all wrong also. Many people given data wrong. When somebody is telling I have done 700 angioplasty, 450 CTOs, do you believe that? Wrong. And somebody is telling 1,200 angioplasty, 1,500 death in the hospital. Do you believe? Wrong. I have actually, you never seen my NIC data presentation. It was thought-provoking. Even after that, I have done 2 years, and both the years, the last year I got much better number, but even then, the number was approximately correct, was 640 cases, 40 cath labs. In that, the imaging people presume to tell, the LM imaging was done in nearly less than 10% of the cases. That is what is actually the report I have got. But I am just telling you, even that is wrong. Probably it is much less. But in my cath lab, I was telling about the data in the last 4.5 years. We have not done 95% of the cases we do with imaging. Some of the cases coming in the night and all, where the acute coronary syndrome,
That is only situation. We don't do imaging. Earlier, we were not doing imaging. But actually, many cath labs may not be having imaging. They wanted to do LMCA. How to do it? This is a very important question. So you cannot pressurize all the cardiologists to do imaging in every case of LMCA. But LMCA, if you have an imaging facility in your hospital, spend 10 more minutes to do that. And now you tell that there is a cost problem. I think OCT you can use 3 to 4 times. And Madras Medical Mission actually, Ajit Mullasheri claiming that they have used more than 5 times. But I'm just telling that if you properly wash the catheter and keep it perfectly, I think you can easily use more than 5 times. And you charge nothing for the patient if you have an LMCA disease. You charge for the patient who is paying for that. Don't charge for every patient. It is an academic interest, your own skill development, everything is there. Now, when I analyze my data of imaging, without imaging LMCA, sizing of the LMCA is almost similar. Once you do regular imaging, you know, even looking at the angiogram, you will tell this is a 4 millimeter vessel. And people put a 2.75 stent. Actually, what we see. So I think by doing this, we gradually improve. So imaging is a must. I think imaging will make our data also will be better. And we are actually doing much better than Europeans and Americans because they all still depending on culotte and TAP stenting. We are actually most of the time doing DK crush. Why DK crush is not popular in Europe? Those people are not ready to accept an Asian data. That is the fact.
Yesterday I was on a webinar with Dr. Goran Stankovic. I was presenting a left main and he gave a very, very categorical comment that I can't convince myself that DK crush with 3 stent layer in circumflex ostium, where chances of ISR is much higher, can give you better result than culotte and all. So he is not convinced at all.
Actually, why Dilip, you know, these people are less skilled people. Actually, I can tell you, last Gulf Interventional Society meeting, Antonio Colombo was there in the chair.
Dr.
One
Pratap,
fellow.
Sorry to interrupt because we have only
1 second.
Four speakers are there. I think the discussion can be.
I am also a chair. 1 second I will take. I am also a chair. Actually, equal stance like you. 1 second. Otherwise, I'll sit and talk there. I'll just make only one statement. Colombo, one fellow asked, so why do you think that the LMCA data from Korea is better than US and Europe? He told that Asians are more skilled and Asians follow guidelines than Americans and Europeans. That is why. He told Colombo. Thank you very much.
Thank you very much.
Thank you, sir. Our next speaker is Dr. Z.S. Jha from Sarsa, and he is going to talk on acute left main lesion. Dr. Z.S. Jha, please.
Okay, Dr. Chandraket, you please proceed your.
Yes. He's going to talk on.
Good morning, senior faculties and my dear colleagues. I would like to present a case which is done in our hospital by Manisankar Pandey sir. I was co-operator in this case. So the case was a 65-year-old gentleman, which is known case of hypertensive and diabetes for the last 6 months. Also presented with angina class 3 for the last 6 months. Diagnosed on evaluation, ECG shows normal sinus rhythm. Echo was normally function. No RWMA. Underwent CAG which shows double vessel disease. LAD has proximal 80% which was stented. Now presented with stage PCI for a calcific RCA lesion. So it's a proximal to distal diffuse calcific RCA lesion. So you can see the liver phase which shows that diffuse calcium which is there present. So initially we hooked with a JR 3.5 whisper coronary wire was used to cross the lesion. We initially tried to do OCT, but OCT catheter could not cross. So we initially pre-dilated with NC balloon 2 into 8. After which OCT run was taken. OCT run was could not be fully completed, which only taken up to the mid RCA, which shows diffuse calcium with calcium score of around 4, OCT calcium score of around 4. You can see the circumferential and calcium which is all around the vessel. So as the OCT catheter could not cross, we pre-dilated again with a open NC balloon 2.5 into 12, followed by a 2.5 into 12 IVL shockwave catheter, which initially could not able to cross it. So we had to use a guide wire extension. We deliver around 20 to 30 pulses in the first settings from distal to proximal RCA. So we also deliver the shockwave 20 to 30 pulses in the proximal RCA and again to the mid RCA, where we find probably thought there is a calcium nodule over there. So we give the different pulses there. So post IVL, the lesion was again pre-dilated with NC balloon of 2.5 into 10 at 12 to 14 ATM. Again re-dilated with 2.75 into 8. After which the mid to distal RCA was stented with a DES 3.5 into 12 and proximal to mid RCA was stented with 3.5 into 18. The overlap segment was post-dilated with 3.5 into 8 and we achieved a reasonable result. This is the pre and post. Thank you, sir. Sir.
Next speaker, GS Jha.
Yes. Dr. GS Jha. Oh, sir.
For saving the time, let him ask one question. I will be keeping quiet. But now I have given chance. Now next I will ask.
No, it's a lot of calcium. You need to push things. So I will use M+ guide. M+ AL1 is my what is more common RCO guide.
Good afternoon all. At the August, I would like to thank Dr. Arvind Kumar, Dr. Vipin sir, Dr. Professor R.P. Singh, and Dr. Raghu Prasad, and also I like to thank my seniors and juniors whom I have been continuing learning throughout my life, and Dr. Pratap Kumar, Dr. Dilip Kumar, and R.D. Yadav sir, whom I have been learning in the conferences for last 10 years. So my patient is how to take next? Okay, it was a 70-year male who had a chest pain for 12 hours and he was sweating and he collapsed in emergency.
and I had in a couple of hours I did all the basic things, and I have to intubate the patient, and poor prognosis was explained. ABG was done, which showed severe metabolic acidosis. ECG and echo was also done. IIPP was not put, as I had some issue with the IIPP machine. ECG was showing elevation in AVR and diffuse ST segment depression. Next slide. Okay. Okay, and for videos. Okay. Okay, echo showed global hypokinesia with EF of 30%, and this was the patient was taken to cath lab, where patient was taken to cath lab, and it was angio was done through femoral route as okay. 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 So it was showing RCA was dominant and it was patent, but left main was 100% block. So how to take next slide? Why like this? No, no. Okay. Yeah, we crossed the wire. The wire was not going, so I took the second wire and in LCX and LED, and I pre-dilated the relation with the 2 balloon, and subsequently 2 into 10 balloon, and subsequently 3 balloon, 2.5 into 10 balloon. I had a placed stent, 4 into 19 stent was deployed, and subsequently it was post dilated. It was post dilated with 4 into 8 mm, 4.5 into 8 balloon. You went away back. So LED was restored, and patient was intubated, and he was extubated 2 days later. We have to in this case, we have to see that patient doesn't develop acidosis, because once the acidosis develop, it even if we restore the flow, we may not be able to survive the patient. So in acute left hemic total occlusion, time is muscle. Survival of the patient is good. The patient is viability of left main occlusion. One should not waste precious minute in assessing the viability of target territory. In spite of all support, risk of pre-procedural mortality is high in acute MI with cardiac shock and heart failure. Patient was in failure also, and patient had acute pulmonary edema, and BP was also low. But if there is a good retrograde filling, dual simultaneous angiography may help guide wiring even in acute setting. Keep all your TPI, IBP, impeller, ventilator, anesthesia ready and standby. Do not, this is the most important thing, do not let acidosis be present. Take early precaution and ventilatory support. This told me just right now, this is 6-8-12. It's not the 5-6-7 is not there. It's 6-8-12. Pratap sir just told us right now. So key point is that we should have a minimal procedure time is the key to avoid hemodynamic deterioration. Left main to LED wiring and stenting is priority. LCX is to be tackled later. Left main stent observation is a must in the same setting. Final outcome require coordinated and dedicated team support of intervention cardiologist, intensivist, and anesthesia and critical care. Thank you.
Thank you, Dr. Jha. Actually, wonderfully done case. Actually, the stenting was LMCA to LED, right?
Yes, sir.
Because we could not identify where the LMCA to LED was stuck. The vessels are not very clearly seen. Initial angiogram, when I was thinking that you are showing renal arteries. And then only I understood it is LMCA because of the image problems, you know. Any questions from you?
It's a very nicely done case. I think once in a lifetime one should have this opportunity of taking left 100%. I do also have a similar case 4 years back, and very nicely done case, and it was nicely life-saving procedure, I think so. So well done.
I'll ask you only one question. From the emergency department to the cath lab, how much time you took?
So it was 1 hour, sir. Probably
that is actually too much, you know.
Because
for preparing for the IAVP, if you take in 10 minutes, the patient was on the cath lab. Our principle is actually when a patient comes to the emergency department, the patient is critically ill, we don't even shift the ICU directly to the cath lab. If that is done, actually I'm telling that 30 minutes is critical for us. Yes. So if you are actually having a system to shift, it was in the daytime or the night time?
It was evening, sir.
Evening,
but
you were there in the hospital? You were there in the hospital or not?
Yes, sir, I was there.
Usually, you know, these are the things which I feel. The patient come to the hospital, emergency department doctor will not do anything, patient will collapse and then patient will die, number one. Number two, the cardiologist, even if they call, they will tell some other lame excuse not to come. You are very good like me, that is why you are interested to come. But many people will not come. These are the areas the patient die. Most of the time patient will die because we are showing some reluctance in coming and approaching them and doing something very fast. These type of the cases, if you do intervention fast, there is a high chance of success.
The patient was intubated and then taken. That's why it took some time, sir.
Intubation do parallelly. You take the patient to the cath lab and let them do the intubation. You do puncture. Immediately puncture here and take the patient or radial, whatever you are comfortable. That is what is to be done.
Sir, I only do intubation, everything. I
oh,
stay in periphery, so it takes
actually you are paid more, huh? Sorry, Ja. Actually, I make a comment to make the people happy, you know. Yes. So, thank you, Ja. Very wonderful case, and we will go to the next case.
Thank you, Dr. Ja. Our next session is Why Hostile LED Stunting is a Myth as well as Future Burden by Dr. Sushil Kumar.
Call the operator, just be fast, you know.
Dr. Sushil.
Actually, the next presenter should be Vikas Singh should be ready. Can sit in the front.
Please keep silence on the backyards. Please.
Sushil, start.
Dr. Sushil, please.
Vikas to be ready for the next person.
Good afternoon, everyone. Today I have very interesting topic with heading Why Ostial LED Stenting is a Myth as well as Future Burden. Okay. I have a case.
Audiovisual, please.
75-year-old hypertensive diabetic male with COPD post PTCA to ostial LED 8 years back. He presented to us with recurrent resting chest pain and angina, even on minimal exertion, almost daily requiring multiple dosage of sublingual nitrates. He had a diabetic wound for which development was done and is in healing phase. Patient has fair LV function with borderline RWMA in L6 territory with EF which is around 45 to 50%. He underwent coronary angiogram which reveals a patent LAD stent but a critical ostial L6 stenosis of 95%. Heart team discussion was done in view of his comorbidities. He was planned for imaging guided PCI to CIRC with proper planning. We can see is a very critical stenosis of L6 ostia. Femoral 7 French axis was taken as per angiogram finding and GL guiding catheter was taken in view of short left main. Okay. I was imaging what was done in LED to exactly know the proximal position of a stent which was seen to be the encroaching the L6 ostia partially. This was a setback to us as it limited our options for the procedure. Now it was decided that we cannot approach L6 ostia with isolated balloon. LED stent strut have to be protected. So every ballooning in L6 has to be kissing balloon inflation. Stepwise kissing balloon inflation was done with 3 mm NC balloon in LED and 1.5 followed by 2.5 NC balloon in CIRC with initial inflation of LED balloon every time. Recheck showed revealed ill-prepared L6 ostium. So again, kissing balloon inflation was done with 3.5 mm NC balloon in LED and 3 mm NC balloon in CIRC. Repeat kissing balloon inflation was done to prepare L6 ostia for DV. After bed preparation for L6 ostia, depth was planned and again it was done by kissing technique with 3.5 NC in LED and 3 mm magic touch DCB in L6. After in 3 cycles of kissing balloon inflation, each lasting for 25 to 30 seconds was done with minimum in between duration so that zone coronary perfusion is also achieved and much drug loss was also not done, and finally some satisfactory result was achieved with IVS run in L6 showing MLA achieved to be near 4 mm square and IVS run in LED showing no stent distortion. We can see there is no stent distortion in LED ostia, and this is our final result. The take-home message is proper planning is must in this type of anatomical situation with a mandatory imaging. It is always prudent to avoid ostial LED stenting and prefer a crossover technique, as one cannot hit the bullseye as origin of LED is almost never perpendicular to L6 origin. While encountering situation like this, it is very important to protect LED stent by avoiding isolated balloon inflation in L6. It should always be a kissing balloon inflation. Ideally, L6 ostia should be prepared with a cutting balloon, but in this situation we cannot do simultaneous kissing ballooning with a cutting balloon in L6 as it might rupture LED balloon. Using DEB in kissing in left main is very tricky substrate as we cannot have a prolonged inflation for 60 seconds. So multiple blessings are needed with a very short interval to avoid drug loss and balance it with intermittent coronary perfusion. Thank you.
I have a lot of questions to ask. Before, actually, Yadav has taken the mic. Before that, I'll ask. Actually, the stenting initially done was only LED stenting or LM2 LED stenting?
Only LED stent, sir.
No.
Across.
He was actually. You give him a chance to talk.
Yes.
Yadav, you give him a chance to talk. You just tell it is LED stenting or LM2 LED stenting. First,
Sir, only LED stenting.
only LED. He was
Without
telling it is
IVAS.
crossover. That's what I'm
Without
asking.
IVAS.
No.
8 years
My
back,
question is, the first stent was LED or LM2 LED?
Only LED, sir.
Only LED. So
Yes.
it was extending up to the ostium.
Up to ostium
And
from else.
whether it was going, when you did an IVAS,
Yes.
actually we could not see the running image. You have shown one picture only.
Yes.
In that, I could not identify the stent was extending even 1 or 2 millimeters into the LMCA or not. It was there?
Yes, sir, of course. 1 to
So,
2 millimeter.
so initially, when you saw that, my question is, that is my question coming. You have seen that stent is extending into the LMCA. In that situation, the catheter choice, you have taken as JL catheter.
Yes.
That I could not understand. Why?
Short left hand, there is short left
Short
hand
left
and
main,
we
nobody
have to
told
intervene.
short left main you cannot take an EBU catheter. There is
we have
no
to-
support of the catheter. When you have no support of the catheter, we wanted to wire into the circumflex. I will never ever take an JL catheter.
But sir, left main is very short.
I actually,
we have
in
to
my talk, I told you I have done more than 700 LMCS 10 data is already published 3 years back. I'm just telling that it is possible. You actually have a fear sense that it is not possible. No. When you have a supportive catheter, is very good. Even if it is there is a CTO with a short LMCA, I will always take an EBU catheter. Actually, in the morning when I have seen a small RCA lesion, we were actually telling that he shifted from the JR to AL1, AL.75. You remember? So the catheter should be strong, means you can easily fire the pass. That is what I was actually concerned. Actually, the stent ostial, people will tell that it is purely ostial. It is not ostial. It is 2 or 3 struts into the LMCA, making your life miserable in the second intervention. That is, if it was a crossover, it was much easier. I think Yadav wanted to ask some questions. Everybody, Yadav actually given first choice.
Why you could not use cutting balloon? It is a good case for cutting balloon. 10 millimeter cutting balloon, 340 looks like 3. You can use it. Number one.
I did not ask every
we are
question.
kissing. Basically, pattern is kissing. We use simultaneous.
You did simultaneous kissing drug-eluting balloon. Why not? It doesn't perforate. It doesn't perforate. So
No, actually, Yadav, these are the actually concerns. You have a stent start. You take you actually open with a smaller balloon. You can easily take a Wolverine cutting balloon easily there. You can open the ostium of the circ very well. And why I have shown in TCT one case. You have a LM and LED, both the ostia were re-stenosis came back. What I did is, I used 2 drug-eluting balloon at the same time. What I did is actually, I have taken 1 drug-eluting balloon inflated for not 30 seconds. Actually, the drug-eluting balloon should inflate minimum 60 seconds, and most of the drug-eluting balloon come from Boston and all. The data is telling 1.5 to 2 minutes is sufficient, and 60 seconds. If the patient is actually having a problem, you have a balloon there, other balloon is also there. This balloon I inflate, and I go to 30, 40, 50, 60 seconds. If there is no problem, then I deflate. Then I go with the other balloon 60 seconds. You got the point? I will not inflate both together. The other balloon in the LED, I will go for 60 seconds. And then both the balloons together for 5 to 7 seconds and deflate and take it out. Normal kissing balloon type. I will not inflate both the balloons together for 60 seconds. That will deleterious to the patient. I think Yadav wanted to make any other comment
if you
also.
want to keep left main occluded for 1 minute with the
We will
drug-eluting
not.
balloon,
We are not including. I'm just telling it is not occluding. Actually, you are totally, since you did not do, you are having a feeling that it is not like that. You can actually
I
occlude.
could have stented. I could have done the culotte from circumflex to left main.
That
and
is
then recross
actually,
and kiss.
in this case,
rather than
no.
DES.
In this case, I would have done, that is actually like a mini culotte. So you have two stents strut into the LMCA. You can actually convert this LM to circuit, this LM to circ, you put a stent, then recross into the LED, two balloons together, kissing inflation. Actually, that is the best option. Since you've done drug-eluting balloon, how do you do a drug-eluting balloon in LMC? I'm just explaining, that's all.
Drug-eluting balloon, you have to prepare the lesion properly so that well
With
expanded.
drug-eluting balloon is actually painting. Today morning also there is somebody told, DEB is actually painting with the drug. It is not preparing the lesion, is done by balloons, NC balloon or cutting balloon or some other device. Actually he will kill me. I cannot talk more than this. Thank you, sir. Actually we will discuss later. One comment by the Dilip.
I have a point. Sushil,
our next session is
Sushil,
by
Yes.
most important part was the idea that you have to kiss every time you're dilating circumflex or the stent part. It was absolutely not taken well by us. You can make the stent properly formed, and the structure will be absolutely what you desire if you do a final kissing properly. So you just recross it, the circumflex, do it, prepare it well with 2.5, 3 mm good balloon, and then from left main to circumflex one stand, recross, final kissing, and you are out.
Actually,
so every time you are kissing, 1.5, 2, it is absolutely not necessary. Yeah.
Dilip, actually it is becoming almost like a culotte stenting. Actually people in Europe actually use a mini culotte like.
I think you didn't follow. Every time he is doing a circumflex ballooning, he's also kissing.
Every time.
Oh,
yeah. So that's what. Yeah. So 3 times he has kissed.
I cannot see everything because he will not allow. I cannot listen everything. Actually, 3 times kissing means
You cannot keep drug-eluting balloon kissed for 1 minute.
Yadav, the problem with you and Dilip is you are not happy with kissing. He always happy with kissing. Thank you. So we will go with the next presenter. Please come. So kissing is not good all the time. You can kiss occasionally. That is what Dilip wanted to tell. In the meantime, the kissing is going on. Kissing is actually a type of folk dance also. You have a lot of cases.
I'll just show two or three, sir.
Two or three name, two. He will.
So, very good afternoon, everyone. And after those cases of left main bifurcation shown by Pratap sir, I will be taking you through some cases of non-left main bifurcation, and I'll be taking you through them quickly. So, this is a mini crush done in an ACS sitting. A 50-year male diabetic with an effort angina history for last 1 year, severe chest pain with sweating a day prior to presentation. He was diagnosed as acute anterior wall MI, thrombolyzed with tenicty plaque. And after initial pain and ST settlement, he started having episodes of rest pain for which he was referred for further management. So this was the initial angiography that was done. So you can see a tight lesion in mid-LAD and a large diagonal which is originating from that part, a lesion for which we planned for a bifurcation stenting. We went ahead with a 7 French radial axis. LAD wiring was very easy, and that is expected also, but D1 wiring was very difficult. So we managed wiring diagonal with a whisper wire. And then we dilated both the main branch and the side vessel. As with any crush stent, the diagonal was stented first with a 2.7518 drug-eluting stent, with some part 3-4 millimeter as they say, but it's very difficult to measure the exact part, but the ostia was covered. We had simultaneously placed a 3x15 NC balloon across LAD during the deployment. After confirming the side branch flow, wire and balloon was taken out from the diagonal, and stent was crushed with the balloon in main vessel. Then a 3.5 into 36 drug-eluting stent was then placed in LAD, covering the lesion and deployed. Now, this was the initial angiographic image thereafter. Thereafter, we had to recross to the diagonal, which we did, and balloon with 1.5 into 10 followed by 2.5 into 10 balloon, and thereby opening the diagonal ostia. And this is the final result after the pot. Let me take it back. Can I have the last slide? The previous one? The previous one. The previous one. Okay, leave it. So we now move to the next presentation. As has been discussed many a times, provisional stenting is how we go ahead with our bifurcation cases. Most of the times we put in a wire in the diagonal, we stent the main vessel, and just in case if there is any compromise in the flow of the side branch, that we go ahead with a stenting of the side branch. So here is a case of reverse crush. We did exactly the same, wired the diagonal, stented the LED, but after the stenting, can I have the last slide, the running picture, please? Yes, sir. It's there. The last slide. No. Previous one. Yes. So I think there is some. So there was pinching in the diagonal, a significant pinching of around 90%, which needed to be addressed because patients started having pain also. So we opened up the strut of the diagonal with a small balloon and then went ahead with a 2 into 10 or 12 size balloon. And thereafter the usual steps that you follow in any crush stenting was done. So somehow the images are not playing. Okay, so this is the last image. Now I can also take you probably through the initial picture. So this was after stenting the main vessel that there was significant stenosis of the diagonal, and this is where we landed up after doing a reverse crush.
Actually, we understood that you are telling that there is a significant disease in the Yadav. My very simple question, don't you will answer in 3 or 4 sentences, no, 1 sentence. Will you tell that, do you stent this diagonal or not? After seeing that, a T3 flow in the diagonal.
I will do kissing, balloon dilatation of the first LED and diagonal, and if still it recoils or stenosis is severe, it's not giving way, then I will put stent, and that stent I will reverse crush I will not do. I don't do reverse because I want highway to be clean. So I will do reverse or internal mini culotte. So I will take the stent inside the
culotte would be very difficult because of the size mismatch.
No, standard culotte. No. Mini culotte you can do any size. No different size difference is not a problem.
Let us ask that what is the size of the stent used in this case?
So in the main
in the diagonal.
In the side branch it was 2.25 into 15 size. It was 2.25 in the diagonal.
0.25 actually taking into the main vessel and creating a crush means it is not easy.
You see what if you have stented the main vessel, okay, you have side branch pinching which did not responded with your kissing balloon. What options you have? You have tap and internal crush, that is the reverse crush, whatever you call, and internal culotte or mini culotte or whatever you call.
He is done a reverse crush.
Reverse crush is not like because you want highway to be clean. Highway is the LED. So I don't prefer anything, or you plan, that's why where you think it will pinch, you plan to stent from beforehand and do those technique where the crush will be outside the main vessels.
No, actually he has done, the result is very good. But the result is looking very good now. There is a high chance this patient come back with reblockage in the diagonal. My personal point is actually when you saw that, even though you told severe pain and all, there is a Dimitri flow in the diagonal. So in that vessel with the Dimitri flow, you may leave it also. There is one choice. Actually, we could not see the images properly. Whatever image I could see, I have seen a Dimitri flow in that vessel.
And its vessel is not that big enough. You can finish with a kiss and that's all.
So that was never in the plan. The plan was never to stent the side branch, sir.
Kissed it, and if there is no dissection in the side branch, and Dimitri flow, you can live with that.
No, technically you have done very good, but the long-term result of these things, we have a question. Actually, when you see this angioplasty and all, when you see, we will tell cosmetology. Cosmetic angioplasty is very good, but the result long-term we don't know. That is why the bifurcation people are telling single stent, single stent, single stent. They are also worried about that. We can produce an excellent result. This result cannot be produced by one vessel stent and other vessel is actually having a lesion. You will not see that. This is looking very good. If it is producing the long-term result, this is the best you can get. But the problem is we don't know.
Your aim is what? Highway should be clean. Exit can be slightly narrowed, no problem, because diagonal se marega nahi. Lekin LED mein kuch ho gaya to mar jayega.
Anyway, thank you very much. It is wonderful case and there was a nice explanation and we have to stop it. My co-chair should not be angry. Thank you, and I will please arrange a coffee for me, for I have taken 2 minutes extra. Sorry. Thank you. How can I cannot stay.
So finally, post-lunch session with lot of excitement of kissing, crunch and pinch. Now maybe move forward with the ST elevation myocardial infarction session. For this, may I call upon our honorable chairpersons for this session, Dr. Pramod Kumar, Director of Interventional Cardiology from Medanta, Patna, who is also the master faculty for this session and the speaker, Dr. Praveen Rai, Consultant Cardiologist from Darbhanga, Dr. Uma Shankar, former Head of the Department and Professor Medicine NMCH, Dr. B.C. Jha, Senior Cardiologist and former IGIC from Patna, Dr. Samrendra Jha, Senior Consultant Physician from PMCH, Dr. Pankaj Hans, who's a Senior Consultant Nephrology from PMCH, Dr. Sushant Kumar Pathak, who's a Consultant Cardiologist from IGIC, and Dr. Arshad Alam, who's a Professor of Medicine from IGIMS Patna. I would request Dr. Praveen Rai to kindly introduce the first speaker for the session.
Good afternoon, everyone. Now this session is on STEMI. There are 5 speakers in this session, and the first speaker is none other than Dr. Pramod Kumar, who is the consultant cardiologist at Medanta Hospital, Patna. He is a very senior cardiologist of Bihar. Please, sir. His topic for talk is challenges during primary PCI. Sir, Dr. Pramod.
Very good afternoon to all of you. Many thanks to the organizing team from Bihar Intervention Council and CSI Bihar. So I have been asked to discuss the challenges in primary PCI. We have had discussions on the use of PCI as a therapeutic tool in chronic stable angina, and the consensus was that it really doesn't help. So as we all know that there is one disease where the angioplasty definitely helps, saves life, delays heart failure, morbidity is lessened, that is primary angioplasty. So this is what kind of challenges we have and what special challenges we face in Bihar. So this is a case now.
If you click it, it's already playing this. It's playing there.
Where it is playing?
If you click it, it will play there.
So this is a case from the pandemic era in Delhi which we did. Now, the reason why I'm showing you is that this is a case, most of the cases in Delhi will start coming to you within, the stipulated window period, which we should be doing. Less than 12 hours, less than 4 hours, within 1 hour. So this was a simple case during pandemic, comes to you within 4 hours, and you have a very good result. TIMI-3 flow, good myocardial perfusion flow, everything is there. But this is another, so this is another primary PCI. Now this case is more than 24 years, comes in, second stage of the cardiogenic shock, and this is what he has, totally blocked artery, hypertension on inotrope, and we have to. So this is what we get after struggling for about half an hour. You have done balloon angioplasty, you're giving pharmacotherapy, you have done manual suction, all those things you continue to do. But this is the challenge. This is exactly what we face day in, day out, especially in Bihar. Patients come very, very late. They will come most of the time, they will come more than 12 hours, 24 hours, 3 days, 4 days in shock, and this is what we face. So the timeline of treatment of acute MI, the first PCI, you all know, was started in 1977. The first primary was done by Dr. Hartzler in Kansas City in 1983. Bare metal stent 1991, drug-eluting stents in DES. Radial became a default route in 2013, and it's still. Mortality trends, as I can tell you that AMI constitutes almost 25% of all ACS admission. Global prevalence is about 4% in less than 60, 9.5% in more than 60. The mortality rate has started coming down in both in USA as well as in European countries. We do not have any data, but I have a feeling that it is still going up in our country. So time to treatment, this is the biggest challenge that we face. The need for timely reperfusion therapy and the delays in accessing the catheterization laboratory, coordinating the healthcare team and transporting the patient to a cath lab remains a big challenge for all of us. And this is one of the studies from China of more than 200,000 patients. The risk factors for increased mortality, advanced age, out of hospital cardiac arrest, delay in symptom to balloon time, and delay in door to balloon time. These are very, very important. So the ischemic time, which is the main determinant of the future events, how can we reduce it? Door to balloon time, we have been measuring till now, but it has lost its significance, except in hospital setup. This is really not very helpful. Symptom to balloon time has emerged as the most important parameter, having profound impact on outcome. Pain to first medical contact and first medical contact to balloon time. So these are the better indexes to be measured to, judge your outcome. So there are two kinds of challenges, as I told you. One is socio-economic challenge, and the second is anatomic challenge. So what do we do with socio-economic challenge? There is a Tamil Nadu model of treating, acute MI in that state. And this is the model which is now being followed in Kerala, Karnataka, Maharashtra, Andhra Pradesh, in many states. So what they have done is that there is a Tamil Nadu Accident and Emergency Care Initiative. What they have done is that there is a STEMI program with a hub and spoke model where there are hub hospitals connected to the spoke hospitals outside. And these hospitals, the spoke hospitals have CCU facilities. The hub hospitals have cath labs. There is one which has cath lab round the clock. There is another one which has cath lab only during the office hours. So this is how they have arranged it. They have trained the ambulance drivers. They have trained the primary health centers, the spoke hospitals to get the ECG, transmit the ECG to the hub hospitals, get the patient, let the hub hospital cardiologist decide whether this patient can reach a cath lab in proper time or not, otherwise thrombolize, and then shift the patient to the cath lab. That is the arrangement, and they have done very well. They have excellent outcome in all these states. The another important thing is the financial aspect. So all these patients in most of these states are now covered by either a state scheme or a central scheme where they do not have to pay for the treatment of primary acute myocardial infarction. Of course, training is very, very important. Organizing a referral scheme, organizing the ambulance, equipping the ambulance, everything is absolutely important. Another, challenge that we face is cardiogenic shock. Now, this has becoming more and more a bigger problem because patients are coming late to you. They have worse disease. So this requires a very, very well-organized team, and there are very concerted efforts all over the world to reduce the mortality in cardiogenic shock, which still goes around 70 to 80% in most of the centers. But for the first time, there are some indications with the use of mechanical support, you can reduce the mortality in cardiogenic shock to less than 50%. In fact, the target in many places is now to go below 40-30% in cardiogenic shock. So cardiogenic shock, it is very important to recognize it. This classification, the staging of the cardiogenic shock by the SCI is very, very important. You start at A, which is at risk, then the beginning of cardiogenic shock. C is the classical, D is the deteriorating, and extremis is where the patient is profoundly sick, and most of the time they will not survive. In any of these stages, if there is a cardiac arrest, that increases the mortality and complexity. So it's very important to recognize it early, and then you have to do a quick clinical examination, measure hemodynamics, echocardiography. A lactate measurement is extremely important, and then a right-sided catheter is now almost mandatory if you are trying to manage a cardiogenic shock. Then, whether an IABP is going to help or not, it's very, very debatable now. Most of the time, most of these studies have not shown any benefit of IABP. But VA ECMO, but even more than that, institution of Impella has shown excellent results. Of course, there are, the complications rates with Impella is higher compared to non-Impella setup. But the mortality trend is definitely in favor of instituting an early Impella in cardiogenic shock. So this is the first trial, which is an international multi-center randomized trial called Danger Shock Trial, which is Danish-German shock trial, where they have used Impella in one of the arm of cardiogenic shock, and for the first time, they have shown that the mortality rate definitely is lessened by institution of early Impella. Of course, the complications rates are definitely higher. The bleeding, hemolysis, device failure, and all those things are definitely higher with Impella. But there is a definite trend in patients' survival. There is no doubt about it. So this is the algorithm being followed in most of the USA hospitals where they have a national registry of cardiogenic shock. And this is what they do. The moment the patient comes there, they activate the cath lab, vascular access, confirmation of clinical diagnosis, and mechanical circulatory support is instituted in a very early stage in those patients. In fact, the recommendation is that you first put the patient on mechanical support, only then the patient should be taken for revascularization. That's very important. So this is all the different parameters they do. Right-sided catheterization is mandatory. You have to do it. You have to measure the cardiac output. There is a term called cardiac power output, which has now become very, very important in determining the outcome, which you have to measure, and then follow the de-escalation or escalation of the inotropes based on those parameters. So the next burden, the next challenge that we face is a thrombus burden, microvascular obstruction, and no reflow phenomenon. Now, this has been there right from the beginning, and even till now, we have not had a real good solution to that. And this is basically because the patient is coming in a very delayed fashion to your center. And that delay has led to most of these problems. So what are the strategies that we have used? But most of them have negative trial results: manual aspiration, intracoronary thrombolysis, intracoronary pharmacological agents, distal protection device. But there are certain bright light is now being shown, is that laser therapies, I have not mentioned it, but there are certain indications, there are data which is coming that laser might help in taking care of the thrombus. And that there is a new device called CorFlow, where you occlude the distal coronary bed and give pharmacotherapy in the proximal bed. That has also shown to have some beneficial effect. But there are no trials at the moment to have a recommendation. These are the other trials where they have shown that this might help in, that is LV unloading with Impella, then hyperoxemic therapy of hyperoxemic therapy. That is one again which has shown very good results in small trials, needs a much bigger trial to have a proper recommendation. Stent retriever assisted thrombectomy, what we do for the cerebral artery, is again something which is being tried. There is a trial which has shown some benefits. Then catheter aspiration with the newer device, Penumbra device, has also shown some benefits. So these are some of the things which can be done. Imaging in primary PCI is gaining ground. It's something which is going to help us a lot in identifying the plaque morphology, whether it is a plaque rupture or there is a spontaneous coronary dissection which is leading to MI. So this will help in delineating the plaque morphology, presence of calcium, residual thrombus. If there is a lot of thrombus, you may have a tendency to deferred stenting. So all these things will come more in practice as we grow. But right now, it is a very limited use. A drug-eluting balloon in primary PCI is again something which is of lot of interest to all of us. Our indications of DEB in primary PCI, if there is a visible thrombus but good TIMI3 flow, long diffuse disease, especially in LAD, long lesions, where future grafting will not be possible if a stent is placed, especially in the middle part of the LAD to distal. We try to take care of those lesions with DEB. Some of these situations will put a small stent in the proximal, which is the worst area, and the distal part will just do a DEB to restore the flow and leave the patient like that. So these are some of the strategies that we are using. There are other challenges, bleeding complications, access site complications. So access site complication is very important that you make radial your default access route, because that is the recommendation, and that has shown definite mortality and morbidity benefits. I saw some of the cases coming from other centers that they're still using femoral, and I can tell you that that is not the right thing to do. You must change to radial route. Patient selection, selecting the appropriate patient, high-risk patient population, what to do in multivessel disease, what to do, whether you should only do the culprit artery or the full revascularizations should be done. It continues to be still debatable. There are plus and negative points in favor of each. But as far as we are concerned, most of the time we'll only do culprit artery. We'll not touch the other one. But we do them, before the patient is discharged from the hospital. So this is what for multivessel, and post-procedural care again is a challenge when the patient goes out of the hospital, what needs to be done. So everything has to be a very systematic thing. We have to organize a system where we take acute care of the patient and also post-discharge. So, unfortunately, we do not have. So this was, the patient which I showed you. And after a lot of struggle in the cath lab, thrombosuction, adenosine, we finally got a good result, put the stent, and this is what we got. Thank you. Thank you very much.
Thank you very much, sir, for your nice presentation. And you have given so many challenges for primary PCI, and also you have given some solution also. Now, any question from the floor? Dr. Pramod will be happy to answer the question.
No, I am. No, I'll prefer. No, let me tell you. IABP has a very limited role to play in management of cardiogenic shock. I prefer to use ECMO. I do not have access to Impella. So if I'm putting an ECMO, then I also put an IABP. Both are being used at the same.
If you see the trial of ECMO, ECLS CS trial, where has shown no benefit in
No, it
increased
hasn't.
mortality.
It hasn't. It hasn't. I agree with you.
So why? So you see, the degree of benefit with the 50 ml IABP is 1.5 liter.
No.
Yes.
The maximum
Because
cardiac output
we are using
increase.
40 cc.
Yeah, I
or
know.
34 cc. If you will use 50 cc, the cardiac output increment is 1.5 liters extra.
Let me
So
tell you. See,
that is enough.
No, tell me, how will IABP improve cardiac output in a patient who is in shock with a blood pressure of
Afterloads,
60?
because it reduces afterloads.
So what about myocardial contractility? It doesn't
Yeah.
help. So the maximum gain is not more than 0.5 liters.
Still we are using,
Then
and it's,
again-
let me say,
again-
it's a company driven, sir, let me tell you frankly, it's a company driven trial, the Impella trial, and so costly, no one can afford, very few people can afford, and shown the benefit, and if you see the meta-analysis, there is increased bleeding, increased mortality compared
So
with the IABP.
RD, let me tell you one thing. IABP trials have failed time and again. That
It's
is
not working.
No, so
It doesn't-
Same, no,
the-
same thing with thrombosuction.
The trials which has been conducted, Protect 3 trial, they are all company driven and driven by the Abiomed. Abiomed is from Impella.
That is something.
So believe me, we are using at least 10 to 15 IABP per month, and we are saving a lot of patients with cardiac shock and pulmonary.
Then you must publish your results. You must publish your results. If you are not publishing your results, then it is not valid, unfortunately.
RD, actually, we should understand very clearly that this data is not allowing the usage of routine use of IABP. But IABP, you are telling that it is actually useful. Actually, as he told, you have to publish the data, otherwise it is not.
Several patients comes with pulmonary.
So we are still
patients
RD.
lie down, you can do the PTCA, comes out.
RD,
IABP patient improves.
There is a point like cardiac surgeons, they put a lot of IABPs and
Oh, it does-
they get good results, and in their recommendation it is there. But in cardiology, because of IABP shock 2 trial, we have gone downwards, and we don't have indication to use that. But still, I think it improves a little bit of coronary circulation, 0.5, a little bit of cardiac output is enhanced. So some support can be there, but to
I'm
make
not
it more
saying that.
visible,
We
we need
have
more and
That
more
trial
data.
was done with the 40 cc, not 50 cc.
Dilip, actually, one point is very clear, actually, RD Yadav told me. You are telling that this thrombus aspiration, trials are negative. Routine but actually, they have mentioned one statement in the front.
Yes.
Routine thrombus aspiration.
Yes.
That is actually class 3 indication. Routine IABP is never beneficial, but if you do like this, RD, are you willing to have a trial in India?
Because
But
it's a cheaper best.
whenever I am
easy to
sending
access,
for trials
easy
and
to-
registry, I don't see
bleeding risk
people
is
to
less.
participate.
Why not?
RD, the very basic mechanism of IABP is different from Impella. You need to increase the
That
cardiac
is
output.
enough. You need to support only
No, no,
1.5 liter. That's all.
Have you? No. You need a cardiac output of at least 3 to 4 liters. You cannot
There is
do
no
that.
need of full circulatory support in patients with cardiogenic shock. You need only
Sir,
1 liter enough.
excuse me, sir.
No.
We are running short of time, sir.
I don't agree to that. Anyway, thank you
Sir.
very much.
Nice discussion. Thank you very much, sir, Dr. Pramod Kumar. And there is some change in the order of speaker. And the next speaker for this STEMI session is Dr. Purushottam Kumar, a cardiologist from Sitamarhi. And his topic of talk is complete heart block with cardiogenic shock. Complete heart block with cardiogenic shock, inferior wall MI, interventional management. Sir, please, Purushottam Kumar, sir.
Yes, good evening, sir, and good evening, everyone, and thank you for the opportunity to present my case here. So this was actually a straightforward case. So it is a 56 years old gentleman who is a diabetic, tobacco chewer, presented in emergency with chief complaints of repeated loss of consciousness. He was having accompanied vomiting, cardiogenic shock was there, BP was 80/50, the pulse rate was 36 beats per minute, the JVP was raised. This is the ECG on presentation. You can see the QRS is nearly 120 milliseconds, and the STT changes were there. It is a complete heart block. The echocardiography which I did showed me the valve morphology was normal. There were no mechanical complications. There was regional wall motion abnormality in inferior septal mid plus basal hypokinesia was there. Mild secondary MR was there. TAPSE was around 14 and LVF was 45 to 50%. So I did a temporary pacemaker and CAG was done after the relative's consent. Also, I started noradrenaline and fluid support because the TAPSE was less. It is a RVMI, and I did not have any support of IABP, Impella, or ECMO at my place. So RCA was the dominant lesion, and PDA approximately showed around 60 to 70% stenosis. PLV was 100% occluded. LAD approximately was around 70% stenosed. LCX has a good flow. So this was the lesion. Okay, so this is the lesion. You can see it is a large RCA. The PDA from the ostium is stenosed, and the PLV is just cut off. So, and this is the left system. Left system was, you can see the LCX is normal in the caudal view, and the LAD, the proximate junction, it was around 60 to 70% stenosed. So I took a workhorse wire, floppy wire, and I passed it through the PLV with balloon support. And as the wire passed, you can see it is a very large PLV penetrating very deep into the myocardium. So to maintain the patency of the PDA, I passed another wire into the PDA, and stent was put from the proximal part of the PLV, 2.5 into 24 mm stent. And after placing the stent, I had a TIMI 3 flow. So this is the final result. This is the post PTCA ECG where the ST has resolved and the rhythm is sinus rhythm. So there are the location of the AV conduction disturbances according to Braunwald in AMI. It is if RCA is involved, it is basically intranodal, and if the distal site is blocked or anteroseptal wall MI is there, it is infranodal. Depending on that, the QRS complex, if it is less than 0.12 milliseconds, the mortality is quite low in cases of inferior wall MI and rarely requires any permanent pacing or pacing. And the cardiac arrhythmias which can be there in MI is because of the electrical instability or the pump failure, and Bradley arrhythmias and conduction disturbances can be there. Also, a learning from this case can be how to manage a case of cardiogenic shock with primary PCI, where we have the shock trial, culprit shock trial, which tells you that you have to manage basically the infarct related artery. If the blood pressure is good, you can go for a multi-vessel PCI also. Thank you.
Thank you very much, Dr. Purushottam Kumar, for a nice case presentation. Any comments?
I have a question. I have a question, sir. The BP is 80 by 50, heart rate is 36. Yes, what is the principle? Actually, what I learned.
Actually, if the pulse rate is down, generally we expect higher blood pressure, compensatory mechanism. But in this case, the RV was also not well functioning. We had a TAPSE of around 11.
When they have a heart rate of 36, heart rate with 80 by 50 BP, the first principle is actually when you have a hypotension with a low heart rate, increase the heart rate to increase the BP. That is number one. When you have a normal heart rate with a BP low, that is actually in acute MI and all. When you have a high heart rate with a low BP, that means patient is in LV dysfunction or cardiogenic shock. These are actually principle. I don't know what, I would have given atropine to improve the heart BP. That
You
is
have
the
any
basic
patient
principle.
was under
I had given atropine while shifting to the
patient
cath.
36 heart.
Patient was under influence of increased vagal tone. So there is a reflex going on in infraval MI. And that was probably the reason of block as well as hypotension. You could have given more fluid and atropine, automatically BP could have gone
Do you have any complication with atropine?
I would be reluctant to give
In acute
atropine.
MI?
Atropine, no. Atropine
I don't give
actually
atropine.
increases the VF threshold. It decreases the VF threshold.
So yes, you are right.
You know,
This is
so
pure vagus.
atropine is not
Pure vagal
recommended.
response, RC was
Atropine
flowing.
is not recommended. This is a wide
Atropine
QRS.
should not be
so you
given
know, if you have to do something,
complete
you
heart
could
block.
have paced him. Temporary pacing.
Bilkul.
But a quick.
Don't give
I'm
atropine.
very
It
reluctant.
increases VF incidence. And you know, you have done the angioplasty, patient will have.
Boss,
recurrent
actually,
VF,
before
recurrent
doing
VF.
the angioplasty, patient come to the emergency department with a 36 heart rate, 80 by 50.
Even then, atropine
Basic principle is actually to give atropine.
Do a TPI. Don't give atropine. Don't give atropine.
Yes, I agree.
You actually taken to the cath lab, you are losing time. You should give an atropine. Actually, I am telling you the patient will improve.
Let me tell you, atropine will not work in most of the cases.
Thank you.
I think during my DM days, that was no angioplasty and all. Then medical college, we do all these things, and all the patients of acute inferior MI, they come like this with a low heart rate, with a low BP. That was a standard teaching that when you have fluid and atropine was the treatment, and you can actually tell that these are all will not.
I have lost 3 patients when I was not.
You have gained 100 patients.
They developed VF and died. We could not able to do that time. We don't know how to treat. We recanalized the artery. Stenting was done. TB3 flow. Still die of VF.
Yadav, after angioplasty is a different. After angioplasty is a different game. Actually, I'm just telling you, when patient is in emergency
Now we know
department.
what to do if VF occurs. That time I was not knowing the study. Increases sympathetic overactivity which causes VF even after recanalization.
How many patients of VF? Hardly any.
No,
Don't
it's
say.
not.
Atropine is a lifesaver.
Inferior wall MI is more likely to cause VF because it's, the supply OT, RVOT, where is the epicardial?
But anyway, it is a wrong teaching. You should, whether it is, you want to hear from Yadav or you understand from me, that's a different thing. You follow both and then find out the result next year and tell me whether how many patients died about after hearing Yadav's planning and my
No,
planning.
I know Purushottam. Purushottam is a very well-educated person. Use your wisdom.
Thank you, sir.
Thank you very much, sir, for a nice discussion. And
Yeah, good evening, everyone. So this is a case other than IVL, rota, bifurcation. Everybody have come across this kind of case, like men must have stuck with hooking of the RCA. So I will be presenting this like angioplasty of abdominal origin of RCA with cardiogenic shock. So this is a 59-year male, hypertensive, presented with the history of chest pain since 2 to 3 hours. Shortness in breath and vomiting was present. BP was low, that was 80/60, and pulse rate was 86. ECG was suggestive of ST elevation in 2-3 AVF. So this was the ECG. When I did the echo, RWM was present. Inferior and posterior wall was hypokinetic, and LVF was 30 to 35% with mild MR. So noradrenaline fluid support was started, and CAG was done after the consent. So this is the angiography showing the left side of which shows that L6 was blocked and diffuse disease. LAD was more or less seems to be normal with smile plaque. And in the right side, I started hooking with the initial like JR catheters, but I was not able to hook. So I finally landed up in hooking with JR4, which I was not able to hook. Then I took AR2 catheter. I was not able to hook with the AR2 catheter also. Patient was going on symptomatic and having chest pain on and off. So I hooked with the EBU 3.5. So it was showing that clear flow was coming. So I started crossing the wire with the BM and started ballooning. While ballooning, it was not successful much. So everything came out after this, and so again we landed up the zero level. So I again started hooking with the few more catheters and finally landed up with the JL 3.5. And after few attempts, I hooked with RC with the JL 3.5. I crossed the wire and started ballooning with 2.5 by 15 mm of SC. Then with proper support, stented the lesion and crossed the lesion after the stenting. And a successful stent plantation was done with the guide hook with RCA. So according to me, this was the final shoot of the plastic. According to me, if you have done the multiple attempts of hooking the RCA and you are facing the problem, and if you don't have any options, late night hours, so you can go away with you should be flexible in selecting the catheters or headers as per the need. Thank you.
You could have used guide Gila or guide liner, whichever guide extension catheter.
Yes, sir, but financial issues were
so
there,
that
sir.
Not because once you dilate it, it may dissect. So recrossing may go subintimally. So it's better in where it is anomalous origin of RCA, always try to use 7 French guide, and through the 7 French, you can use the guide extension catheter. Or even 6 French with the guide extension, which goes through the 6 French.
Yes, sir.
I will use a different thing. Actually, if they are not, you are not working in like others hospital, you can use a guide extension, which is expensive. What I do is, I will put one more wire down. You have 2 wires down. You take a small balloon down with the one balloon, and you should actually having an anchor wire technique. Then you take a stent down, definitely no problem. But provided it is a 6 French, 7 French catheter. 6 French means you require a new balloon and all those things. Troublesome. Otherwise, it will easy going there.
So with the GL5 also, it was very much problematic, like continuously. So finally, when I got a cross in the wire cross,
basically, it is an anomalous.
Actually, what happened?
It was a JL5.
Yes, sir.
Catheter.
Actually,
Sorry, GL 3.5, sir.
You should have taken JL3 or EB was a okay choice.
Yeah. Actually, you see,
0.5 less than the normal vessel, that is ideal one, and your catheter.
It depends upon the height. Say you have done the left coronary artery injection, and with that, say you use Judkins 4, gel 4. Then, and if the origin reflects showing the origin of the RCA, and it is lower, then you use one size lower. And if it is higher, then use one size higher.
One size means 0.5 higher. But even then, I will tell you, once you pass the wire down, I take one more wire immediately.
And bend it.
You take 2 wires. That is always a success for you. But if you have 1 wire, you may be landing in problem.
Sir, thank you
All
very much
anomalous
for
vessel
giving the
take 2
guidelines.
wires.
Thank you, sir.
Thank you once again, Dr. Manas Kumar. The next speaker is Dr. Vijay Kumar, and his topic of talk is use of drug-coated balloon in primary PCI. Dr. Vijay Kumar, please. Topic is use of drug-coated balloon in primary PCI. Over to Dr. Vijay Kumar, sir.
So very good evening, respected seniors and my dear colleagues. I have been given a very simple topic, but whenever we find ourselves in the case of ST elevation MI and in the angio, we get this type of yes, I started. No, just from here. Yeah. So I will, because sometimes we come in such situation and we find ourselves very in a critical position what to do here. Like in this case, this is a 40-year young male with a history of only tobacco chewer. Antival MI came in window period of 20 hours and persistent heaviness, chest heaviness, and echo showing the RWM in LED territory. The EF is 40%. Yes. Slide.
Next.
ये ना?
इसमें से वो already play हो रहा है पहला.
हो रहा है, वो तो हो जाएगा. So the LED after giving diagonal is 100% cut off. So in this very case, when the LED after giving diagonal, the distant mid to distant vessels is closed after wiring. Yes, next. Yes. So what to do in these very cases, whether to stent it or not to stent it. So this comes always a problem when we discuss with the attendant, this is the situation, we are going to leave this because they may only we will wire it or only we will balloon it. So comes situation whether if we go for stenting, so it may be there be no flow or no benefit is going to develop, or in the it may produce a problem for the future grafting in the mid vessels. So in these very cases, we think to do the drug-eluting balloon. So here we go with the lesion preparation with the 2.515 balloon, scoring balloon, mid to distal, and again with yes, we go for the lesion preparation, and after that we go with the 3 into 10 Wolverine cutting balloon, using cutting balloon for the lesion preparation, and finally we go with the dip. Likewise, the second case is also there. He was the 22-year-old male only having dyslipidemia and no other risk factor except that the strong family history of CAD in his father has come with anstomy with normal LV function, and when CAG was done, the left dominant circulation and LCX was completely LCX was completely occluded after giving the OM. So LCX was wired with BMW and pre-dilated with 215 NC balloon and followed by 225 Wolverine, and later a dip was done. So here all these two conditions, what we should to do, whether we have to go for the stenting or we have to leave it, or whether we go for simply the POVA or we go with the dip. These situations comes very frequently in our practice. So message is here, we should never hesitate to avoid, to avoid stenting if vessel is well prepared. And to avoid stent in very young percentage also, and to avoid stent in very long segment lesion, especially those zones for which are for graft. As already Dr. Pramod sir has told about this. So the lesion of distal lesions or mid to distal lesion of after giving the diagonal, if it is DG long lesion, we are not keen to stent it, and we should only make it ballooning with the dip. And also we found in the follow-up there the good result. No very frequent stenosis is seen. In the 1 or 2 years follow-up, we are seeing the patent vessels remains patent. Thank you.
So
if there are no questions, then we can proceed to the next.
No, we have a question. You actually used in the first case a scoring balloon, a cutting balloon, a drug-eluting balloon.
Right.
I think if that is, if you take the total cost in that patient, only for 3 devices together, I personally feel that I would have put a stand.
Yes.
I think the same opinion for him and same opinion definitely for Yadav. Yadav can make up.
Do you think in a small vessel below 2.5, this is not, and where 2.5 millimeter and above, is drug-eluting balloon superior than stent, drug-eluting stent? If yes, then I will use drug-eluting balloon. If not, I will use drug-eluting stent.
No, definition of a small vessel in US and all, actually 2.75. They actually tell you the less than 2.75 is small vessel, but I still have a doubt that in Indian population, it's a 3 millimeter vessel.
Anyway,
you did not do an imaging.
2.5 and above I will put a stent. Because in that group, where primary PCI or chronic stable angina patient or unstable angina, there is no difference. Drug-eluting balloon is not superior than the drug-eluting stents. So
STEMI is a different animal.
Because I want to say
STEMI is a different animal where there is a plaque rupture which has already happened. There is a STEMI. So DEB is still not kind of registry data also not there much.
So reocclusion occurs, no, mortality increases by 2 to 4 times. The problem with the MI is that if reocclusion occurs, mortality increases 2 to 4 times. So it is better to stent, fix it.
See, Dr. RD, there are no data where a stent has been compared with DEB in primary angioplasty.
No data.
These are primary angioplasty cases.
Small vessel.
No, this is not a small vessel. No one says that it's a small vessel, but you know, the reocclusion, at least we know that reocclusion rate with DEB is not very high. We know that. There are data from Italy, there are data from many centers, not from primary angioplasty trials, but there are data from, non-primary, even with dissections where they have seen the reocclusion rate is very, very low. And let me tell you, in these situations, if you have a reasonable lumen, DEB should work. I don't know. I cannot say because I have no long-term studies in primary angioplasty. And like you said, stent is another disease. Like you said, primary acute myocardial infarction is a different animal. So is the stent. It's not a disease-free animal. It has its own complications. And if you can do away with stent, I will definitely prefer that.
I use only one place where drug-eluting stent has restenosis, diffuse in-stent restenosis. Only then I will use.
That is the classical indication. No,
yes,
we know that. We are aware of that. That is the classical indication of drug-eluting balloon. But it's an evolving field.
Sir, as of now, what is the contraindication of stent here? Was the patient having high bleeding risk? Was there something contraindicated for dual antiplatelet?
No.
It was a large vessel, acute MI situation. So it was so many things were against DB. But if you have done one or two cases.
See, again, this is an evolving field. Yes, we don't know. We don't know whether it will work or not. When bare metal stent came, everybody thought that, we have reached something. When drug-eluting balloon stent came, the first trial showed a 0 restenosis, but then it was not found to be true. So it's same thing here. I think it's a
drug-eluting balloon is not a new release actually for the last 10 years.
So it's still quite low.
So if after the preparation of lesion and vessels there is flowing vessel, and if you go for stenting, if there comes no flow, again it becomes another problem.
That you can tackle. No flow can be tackled very easily. It's not like it cannot be tackled.
Thank
you. We need whatever made like permanent.
Next, I invite Dr. Sumit Kumar Verma, a consultant cardiologist at Begusarai, to deliberate upon management of acute ischemic MR by revascularization. And I feel privileged to invite Sumit because I had been his guide during his post-graduation at Patna Medical College.
Thank you, sir. Good evening, everyone. Starting with the history, 55-year-old male having diabetes and addicted to tobacco, came to my OPD with complaints of chest pain, perspiration, and dry cough for last 4 hours. At presentation, his vitals were, pulse was 80 per minute, BP was 110 by 70 millimeter of mercury, so his saturation was 96, and his baseline ECG shows ST depressions in lead 2, 3, AVF, V5, V6, and T-wave inversion in 1 AVL. Qualitative troponin was positive, so a diagnosis of anasthenia was made and patient was loaded with antiplatelet. In the meantime, we started counseling to patient attendant regarding the patient's disease severity, its progression, and our plan of management. But within 10 minutes, patient developed sudden shortness of breath. That's so much so, he was unable to lie. His BP was, systolic BP was above 100 millimeter of mercury. His saturation falls below 90. So immediate IVSS was taken and an IV support given to the patient. And since now it is a case of anasthenia with heart failure, so immediate invasive strategy was planned, and the baseline echo, bedside echo, screening echo was done, and that shows regional wall motion abnormality, regional wall motion abnormality both in anterior and inferior territory with moderate grade of MR. The jet area was around more than 5 centimeters squared. So patient was immediately shifted to the cath lab, and since patient was unable to lie, we kept 3 to 4 cushions behind his back and neck, and then radial SS was taken, and his angiogram shows, So his angiogram shows there is thrombotic lesion. Okay, let me tell you the story, and you can just synchronize the slide and present it here. So there was a thrombotic lesion in LCX. That was industrial LCX extending to major OM, and next. You can control it from there only. There is no access from here. Okay. So the LAD lesion was also very critical. It was a critical lesion in mid LAD, and this was a diffuse lesion from proximal to mid LAD. So RCA was okay. So this was a double vessel disease with both lesions are critical. So it was very difficult to decide the culprit vessels, but as the presence of thrombus in LCX, I opted LCX as the culprit lesion. So the revascularization started from the LCX. I crossed the void in LCX. Next, can you run it from there? Okay. Go ahead. 6, This is the LCX was void. Then next, it was pre-dilated with a 2 into 10 mm, 2 into 8 mmNC balloon. Then initially I tried to take a longer stent, but it was very difficult to negotiate it up to the distal mark. So immediately I shifted to the smaller stent of size 2.5 into 28 because the patient condition was not in a good stage. So after stenting LAD, I crossed the lesion in LAD and pre-dilate the mid lesion with 2 into 10 mm balloon, and then proximal lesion sequentially with 2.5 into 12 mm balloon. Then there was a DES of size, no, just previous, DES of size 3 into 48 mm deployed in proximal to mid LAD, and next, and the proximal part was post-dilated with 3.5 into 12 mm balloon. Then, so the next, next, and this was the final result. Please show the next. this was the final result. And by the grace of God, at this time, patient's NIV support was withdrawn, and patient was shifted to CCU, and the repeat echo done. The MR burden was reduced, and the MR jet area was now less than 2 centimeters squared, and that further improved at the end of 30 days follow-up. That MR completely resolved, and his ejection fraction touches the normal baseline. So from my side, this is was a case of ischemic MR due to papillary muscle dysfunction, and I think anterolateral papillary muscle was involved in this case because both the LAD and circ lesion was very critical. One more thing, in LAD, I think LAD lesion was a chronic lesion, and the distal part was primed with ischemia, so there was no ST elevation in anterior lid despite of the slow flow and this critical lesion. Thank you.
So I just have a very irrelevant question. Why did you say that management of MR by angioplasty? It was management of NST elevation MI by your angioplasty, which you did very successfully.
Because
and the MR was as a consequence of NST MI, isn't it?
Yeah, actually, this is ischemic MR, not only
so
MR.
it is the non-ST elevation MI which led to MR.
Yeah.
So you managed NST MI very well.
Yeah, but actually anastomy was the initial presentation, but it changed it into an emergency. That MR leads to heart failures. That's why it was.
I agree.
Yeah.
But what I'm trying to say is that your MR was part of the whole spectrum of the disease.
No, it was a consequence of the disease.
Yes.
It was a consequence
Yes.
that was the, if I delay the treatment from an anastomy point of view, if I delay the management, that it will hamper the progress.
So the present recommendation is that NSTMI has to be treated like STMI.
Yeah.
There is no difference.
Yeah.
You have to take the patient to the cath lab as early as possible, within an hour or two.
Yeah.
That's all the time given.
Yes, sir.
So
Yes,
that's what you did, and you got excellent results.
Thank you, sir.
Great.
Let you come out, but I will just, there is one point you should understand, because he was telling the MR probably because of the ischemia. The OM occlusion is actually causing MR. MR can be because of the severe LV dysfunction also can cause MR. In this case, acute MR probably because of the OM occlusion, but your LAD not treating is a question mark, number one. Number two, you told in echocardiogram there is no RWMA. I don't believe that.
No.
Otherwise,
there was RWMA.
You just look at your angiogram.
He said in LCX territory.
But in echo report,
he said
echo,
LCX.
no RWMA, MR. Actually, I can tell you the slides you would receive again.
Okay.
You just change your slides. And not today, tomorrow, when you present anywhere,
Okay.
change the slides.
Thank you.
I think that is what I just wanted to, because if you present this case, you look at the slides.
I have same, a little comment to make about the previous two speakers who wrote cardiogenic shock. Cardiogenic shock, you have to define exactly cardiogenic shock. There is a PLV which is occluded and there is some hypotension. You will not call it cardiogenic shock straight away. Or you should actually stage it. You should say, what stage of cardiogenic shock was that? Whether it responded to fluid or not.
Now the next speaker is Dr. Amit Kumar. He's from Gaya, and his topic of talk is management of thrombus migration with acute coronary syndrome. Dr. Amit Kumar, please.
Good evening, everyone. Please play the slides. It's not playing there.
Amit is going to Mount Sinai?
It's planning.
Planning. You can tell us about the case. You can start telling us about the case.
is a 50-year male presented with chest pain of 12-hour duration, and ECG there was ST depression in the inferior lead and V4 to V6. So diagnosis of CAD ACS ends TEMI with TEMI score of 3/7 was done. Good evening, everyone. My name is Dr. Amit Kumar. I'm working at Arsh Hospital, Gaya. So I'll be discussing 2 cases of thrombus migration during PCI. So first case, 50-year male presented with ongoing chest pain of 12-hour duration. He was diabetic and history of diabetic dyslipidemic and history of tobacco chewing. In ECG, there was ST depression in inferior lead and V4 to V6. So diagnosis of CAD, ACS, ends TEMI with TEMI score of 3/7 was done. An LV angiogram done in which EF was 30 to 35%, LVEDP were 12 mm Hg, and in the coronary angiography, it was TVD, in which LAD was 100%, L6 90%, RCA mid 90%, distal 95%. Syntax score 1 was 28. So patient was given option of CFG versus PCI, but patient opted for PCI. Now moving back to angiogram. Here we can see. Here we can see the LV angiogram. LV angiogram.
He's the right candidate for US observership. LV angiogram, he's doing it.
LV angiogram was done in which anterior wall was hyperkinetic, and LV DP was 12 mm Hg, and we can see that in RA caudal view, the LAD was 100% occluded, and L6 was 90%, and in LA canal view we can see that there is a of one great collateral going from L6 to the RCA, and RCA was also mid 90% and distal 95%. So I crossed the wire in the LAD, and after that I did pre-dilatation with 2.5 into 12 balloon. Then there was some flow in the LAD and measured diagonal. After that I pulled back the balloon catheter into the guiding. At that time patient complained of chest pain, and his BP dropped to 60/40, and he was hemodynamically unstable. So I just took another shot in the RA caudal view, in which I saw that L6 was approximately 100% occluded. So patient was very sick, so I was no option. So I just crossed a wire into the LCX, and after that I did pre-dilatation with balloon. There was some dissection, and after that I deployed a stent of 3 into 28 mm into the LCX, and there was after that I did post dilatation, and so L6 was saved, and after that I deployed a stent in the LAD of 3 into 23 mm, and this is the shot after plastics of both the arteries, and we can see there is some distal vessel spasm after post to the stent. So after 1 month I did check angio as I was doing the stage PCI to the RCA. At that time I saw that there was no spasm in the vessel, and it was good. And I also did RCA angioplasty. Guidance support was very bad. So I used body wire technique to wire for increasing the support. And after that I deployed a stent distally into the RCA, and then proximally to mid into the RCA. So means all the 3 vessels was perivascularized after 1 month. So this patient was saved from thrombus migration. we can see that I'm using a body wire technique to deploy a stent in the proximal to mid RCA, and so after that it's deployed, and after that I did post dilatation. So it was a good flow. So this is the final shot. I have second case of thrombus migration. So she was a she is a female. She is a 70-year female with chest pain of 6-hour duration. She was diabetic and hypertensive and dyslipidemia, and ECG there was ST elevation with CHB. So diagnosis of CAD, ACS, anti-wall MI, CHB with CLIP2 classification was made. So first I did TPI, followed by I did angiography, in which LED was 100% occluded, L6 90% lesion, RCA mid 90%, syntax score 1 was 29. Patient was given option for CFG versus PCI, but patient opted for PCI. Now moving back to the angiographic scene. So first I did TPI, and after that we can see that in the RA caudal view the LED is approximately 100% occluded, and L6 had diffuse disease of approx 90%, and we can see in the L caudal view that that LED is approximately 100% occluded, and we can see the LED 100% stump, and RCA also had mid 90% lesion. So I just crossed the wire into the LED. There was some flow, and after that I also crossed the wire in the diagonal. Then I started doing P-dilatation, and then some flow came into the LED and that diagonal, and then I again did P-dilatation and brought the balloon back into the guiding catheter. At that time patient complained of severe chest pain. Her BP crashed to 40, and she was very much symptomatic. So I just took another shot, and in this shot I saw that LED had no flow, and L6 was completely thrombotic. So I had the balloon here. So as there was no flow in the LED, I again did P-dilatation of the LED and increased the vasopressor support. So after that I did the P-dilatation, and again after that flow came. After that flow came in the LED and as well as in the circ, and after that so thrombus in the L6 it got resolved automatically. So after that I deployed a stent. I deployed a stent proximally of 3 into 33 into the proximal LED, proximal to mid LED. So this is the stent deployed. So we can see that there was a good flow both in the LED and the circ. So there were the two cases of thrombus migration, and both were saved. So now moving back to take home message. So what the thing we should remember to prevent it? First of all, there are some risk factors for slow flow. So if age is more than 70 or diabetes or longer, time to reperfusion or pre-PCI flow grade less than 1, EF less than 50%, saphenous venous culprit lesion, large thrombus burden, and LED corneal PCI. So in all this case, there is a high risk that there might be slow flow. And so we should have good anticoagulation. So we should measure ACT is very important. So if we are not using GP2B3A, the ACT should be 250 to 300, and if we are using, then it should be 200 to 250 seconds. And we can also use Volrudin in high bleeding risk patients. And we have also the drug cangrelor it has an advantage of rapid onset of action and rapid return of platelet function. It's basically used for bridge for elective non-cardiac surgery, like post PCI after 1 to 3 months or 6 months, or we can use in shock or in high risk angio feature, or ACS patient with clinical features such of CVG like marks depression or non-extensive CAD.
Excuse me for stopping you. I think we should hear from the experts about the cases that you did. You know.
And you did the same mistakes in the second case. In ostial LADs or proximal LADs thrombus, always take longer length balloon and take the balloon from the left main ostia, circumflex ostia, so that balloon will inflate with a dumbbell. You see, 4 millimeter left main, you are dilating with 3 millimeter, it will not touch the wall of the left main. So left main is nothing is going to happen. And that in thrombus, you dilate only 4-5 atmosphere. You don't go high atmosphere. So always dilate the balloon in the left main, keeping 1 to 2 millimeter in the left main, and take longer balloon. Don't take smaller balloon. Either once it inflates, it will squeeze out the it will squeeze the thrombus to the circumflex. Please, I have seen at least 15 deaths because LAD of ostial thrombus took smaller balloon, squeeze out the thrombus, circumflex, LAD already gone, circumflex gone, till patient arrest. So please, always keep the longer balloon and always keep the balloon in the left main at least 2 to 3 millimeter and longer balloon. So it will not squeeze out because it will inflate with a dumbbell. It will protect the circumflex to the clot to go into the.
Amit, I think these are the cases where we should take upfront thrombosuction.
Yes,
Once
sir.
you pass the wire, do the thrombosuction.
No, so I work in periphery, so we don't have
LED ostium 100%, LED proximal large 100%, RCA proximal 100%. Cut off, you can't see distal vessel. Always do thrombosuction because you never know how much is the thrombus burden load.
Yes, sir.
And these tricks are all there, and these are the patients where thrombosuction can be game
Mic
changer.
is required again.
Yes, sir.
Once you dilate, don't pull the balloon. You go push the fish distally and flush with the 10 to 20 ml saline so that if thrombus should
Don't
not
come in
out.
the guide. Right.
So please, this is very important. These two techniques is very important.
Second question, you actually, when there was a BP fall and all, you used a vasopressor. What did you do when there was a? You told I have used something.
I increased I use ADR adrenaline because
ADR is given.
ADR because
Ideally, that is an ideal situation. Sometimes, actually, ADR is the best vasodilator in coronaries. That is number one, no doubt about it. But in some time, especially in anterior MI, you may get a VF. So you should have a DC defibrillator ready with that. That is only concern. Otherwise, it is very good. Number two, actually, when you inject, you should see that injection. Your catheter, the tip of the catheter was sitting on the LMCA wall. That means that injection can cause dissection there. Yes. So that actually, why I don't know why you people are using only JL catheter. Again, I am actually concerned about JL. This is actually JL support is not there and giving injection like this. Probably your nurse would have injected.
See, it was EBU, sir, I think.
That injection you see,
So
actually
EBU,
a terrific
sir.
injection.
So it was EBU, I think.
But 7 ml of 8 ml of contrast. What was your purpose of seeing? Just wanted to see the flow is there. Whether
Yes,
what is the problem there?
Yes, sir.
Just 2 ml of a small injection and see. Why to give that much injection? That injection create problem.
Yes,
And
sir.
but by that injection, with RCA is type disease, patient can collapse and go.
Yes, sir.
I also have a feeling that this was not the thrombus migration. It was probably the spasm because circumflex was so pristine after just without doing anything. It could be. It
No,
could
sir,
be.
it's a
But that
thrombolysis.
spasm could be a possibility also.
That is a high possibility, and adrenaline actually gave you.
Adrenaline
But
is
as
work,
he
yeah.
told, a thrombus aspiration would have given you much safer standing there.
Yes, sir.
That is what. Thrombus can come. Number one. Number two, you put a stent. Your stent is actually almost abutting into the LMC also.
Yes, sir.
Start the negative suction right in the guiding cath only. Yeah.
Yes, sir. Yes, sir.
Okay, sir.
And
manual aspiration catheter are everywhere available.
Yes, it's
if
available.
you are managing ACS, you should have thrombosuction. What is it is about being in periphery? You,
yes, sir.
But you
I,
should.
I have a slightly different
And
take.
another-
In your first case, you said the syntax score was 28, LV function was normal.
LV function was normal,
You
sir,
gave
yes.
a choice between angioplasty and bypass, and the patient agreed for it.
Yes, sir.
You know, there is a trial very elegantly presented by Greg Stone very recently. Huge trial. Not actually a trial, it's a registry data where they have shown that patients who didn't undergo bypass, they divided into 3 parts. One group, which didn't undergo any revascularization, had the highest mortality. The second group, with a very complex disease, underwent angioplasty, refused surgery, or were not told about the benefits of surgery by the cardiologist, and still they underwent angioplasty, has the second highest mortality. Patients who underwent surgery had the lowest mortality. So, you know, it's for everyone. We consider that we are the gods and we can do anything. And like what Dr. Pratap was saying, that a cosmetic result actually doesn't translate into long-term benefits always. So if you feel that this patient will benefit more by surgery, you should not do angioplasty.
Yes.
You can refuse. You can say that, no, I will not do angioplasty.
Yes.
But you have a fear that somebody else will do it. Let that somebody else do it. If you strongly feel that this patient should undergo surgery, you should send that patient for surgery.
But sir, there is a confusion. Syntax should be used only in stable patients, not in acute coronary syndrome.
The first case, the first case was a normal LV.
Normal, no.
LV function.
No,
The first case was normal LV.
No, LV is not, sir. ACS is not. ACS.
It can be used, sir. I think
No. ACS.
The first case was a normal LV.
syndrome. The syntax was not used in acute coronary syndrome situation. It should not be used. It should not be used.
Okay, sir.
So RD, it's not successfully doing it. It's the long-term results. And this, all of us should go through that. No, you must go through that study. It is, so for the first time, they have shown in this particular category where a patient eligible for bypass, so you just go through it. No, you just go through it. Most of our guidelines have a very strong registry base. They are not always trials. The registry data is always very important. Just go through that study and then we'll discuss it.
Final, just a one word about the LV angio that you showed in this first. Sir, LV angio in today's world where we can see everything on echo, with the quality of the LV angio that you showed, it should not be done. It should always be done with a pictal catheter,
So
with an power injector. Doing an LV angio with
So
end hole
it's done
catheter
at
and
Sinai,
end
sir.
injection.
It's
that
done
doesn't
at
help
Mount Sinai, sir. They do some Mount Sinai.
I don't know, if you talk to the Americans, they still do LV.
They do some
because
LV
they
angiography. I know.
always do
Routinely.
LV.
Sir, because they don't
All
know
the
how to do
angiography.
echo. Because they'll have to get an echocardiographer to do an echo.
Taking LV EDP should not be confused with LV angiogram. LV EDP, it is done regularly, but not the LV angiogram. Yeah.
No, actually, Dilip, he's planning to go to Mount Sinai, so actually he's thinking that he will do an LV angio now itself. One point I just wanted to tell you, all the Mount Sinai things are not correct, Last time also I had a fight with them.
Let's take LV EDP, come on.
That is another problem, They don't know how to do echo. You
Yes,
know
sir.
how to do echo.
Yes, sir.
Thank you very much, all the teachers. We have learnt a lot, and we are thankful to the organizer for honoring us to chair this session. Very exciting session. Thank you very much.
Thank you so much, sir. Moving on to the penultimate session for the day, the session on nightmares in cath labs. May I request Dr. Pratap Kumar N from Kollam, Kerala to kindly grace on stage. Dr. Hemant Narayan Ray, Professor and Head of Department from RIMS Ranchi. Dr. Manmohan, CTVS Surgeon from Ford Hospital, Patna. Dr. Dayanand, Consultant Cardiologist from Paras, Darbhanga. Dr. Priya Ranjan, consultant cardiologist from Begusarai, Dr. Rohit Kumar, consultant cardiologist from IGIC, Dr. Piyush Kumar, consultant cardiologist from Begusarai, and Dr. Rajesh Kumar, consultant cardiologist from Begusarai.
Actually, I like surgeons. So we are sitting. I am sitting near to a surgeon. Dilip, you can start. CSP. This is actually the next presentation. Huh?
Yes.
He has two presentations. Now he is actually a whiteboard. What man, you are a proctor for how many things? You make a lot of money out of the hospital also. You understand that all the young cardiologists sitting there, you understand that if you are a proctor like this, he makes more money than becoming a cardiologist. You should also try to do that. But he told that how he learned these things, spending 1 or 2 years away from the hospital to make money in the initial days. So you should all learn how to go and get trained properly with 1 lakh or 75,000. Anybody wanted to have training, approach me, I will give a job. But not more than 1 or 1.5 lakhs. A small marketing, Dilip, a small marketing I am doing in between.
Can you give this to the laptop, okay?
Okay.
So, I will try to make up some time for all of you, sir. So, it will not be a 14-15 minutes presentation, maybe 10 minutes presentation. So, let's begin. So, this is not a kind of, it's a familiar kind of angiogram where we see there is a access, normal access done from one side and contralaterally we are doing some scout, making a road map and going for a puncture. So these are large bore access, these are the gateway of structural heart interventions. If you can't go in safely and we can't come out safely, we are in trouble. Although the main job we do properly, like doing a TAVI, doing a impella assisted multivessel angioplasty, protected PCI or in cardiogenic shock, or doing even a micra pacemaker or mitra clip, you have done it, but you have missed your large bore access, then the final result is pathetic. So these were some of the cases where you see a large bore access giving us trouble, and many times you can find that your proglide suture has broken. And in this particular case, once the tower was done, while coming out, we saw that the proglide sutures were not working. It has come out. We were left over with one wire, and in the quick 2 minutes time, we did the stent graft. We saved the patient, but you can see the indentation in the urinary bladder shadow. There was a huge hematoma happened in just 1 or 2 minutes. Suppose what would have happened if we would have delayed this kind of life-saving grafting there, stent graft placement there. So these are large bore access which can kill the patient in a matter of minutes. Again, this was one patient where a tower was done and the safety wire was caught in the proglide, and ultimately we had to ask our surgical colleague to come in the cath lab and bail us out. So, and this was again a case where proglide sutures were gone and 2 angioseals were given, and finally there was obstruction and we had to do a stent graft, and finally we had to come out safely. So in our 30 cases, we had 3 to 4 cases where I had to bail out large bore access, the access site, and all of them could have been potentially fatal if we are not prompt. So what went wrong and how can we better it? Let's discuss that. So this was again a case. It's a very interesting case which I did recently. This case was sent to me, which had 7 leads, 2 leads protruding from the right side, 1 pulse generator protruding from the left side, and he was sent to me for a micra and removal of all the leads. So this was categorically told to me that you have to do a micra and remove all the leads. Okay, then I took up the challenge, and once I started doing micra, you can appreciate here these are the two arteries and the vein is there. This is the usual puncture site where the vein should be side by side. The vein was just behind the artery. So imagine if you puncture it and you take 26 French micra sheath through that, what will happen? There is no escape route if you have punctured the artery. Nothing can be, saved. So we went up. We went above the inguinal crease in the USC guidance, and then we could see that the vein is little medial to the artery, and we punctured here. So this is the importance of ultrasound guide puncture. You can't be going blind in all these large bore access, especially if you are going more than 7 or 8. So this was I did the micra, and same day I did removal of 2 leads tied through a tight rail, and next sitting I removed all the leads after 4 days. You can appreciate here, since the snare can only catch the device or entrapped structure when the end is free. So we had to free the end of all these leads, where this right atrial lead, which was of 8 years, 8 years old, I had to hook it with a EP catheter, and you can see here the snare. This is catching the other end of the EP catheter. So you're making a loop. So from right groin, the EP catheter goes. It hooks the right atrial lead, and the other end of the atrial EP catheter is caught by a snare from left groin, so that there is a loop made and it can take it down. And finally, with all these maneuvers, we started removing one lead, one at a time, and then we left over with this last. Since this was 11-year-old lead, right ventricle, which didn't come out, and final picture was this. So this was the final picture. There was a micra and a small piece of lead left over. 7 leads, we could remove 6 leads properly. So we need to have a proper knowledge of large bore access. So this is how we do ultrasound guided punctures. We can run through this video. So this is the vascular probe, and there is a marker here. This marker corresponds with a marker in the ultrasound. Marker is lateral, so lateral, this will go lateral, will correspond to that. And if it is medial, so this medial corresponds to each. So this is very important, how to orient your image with the probe position. Now once you are okay with that, now this probe is there. So there was jelly inside this sterile cover. Okay, and now you have to put some saline here to increase the visibility. Now you palpate the artery. We need to palpate the artery, and this pointer is up. So the P will be up, and you can see there. Now this is the longitudinal section, and you can see here the bifurcation. So this is the bifurcation. You can see here. This is the bifurcation. Bifurcating here. And now you just rotate this. Now we rotate the probe because that for cross-sectional view. Now you see there, you can see 2 circles, and this is the CFA. And once you come down, you can see here we can see the bifurcation. We go up, we see a single circle, and this is the vein. So this is the place where you need to. You can see here the artery is pulsating, and this is just the bifurcation. And you can also see there is calcification there or not. And to further make it more precise, you can put fluoro and can you have the sound of probe position below the head? Now this is double confirmation that you will be pointing right, and you can extra place a marker like this on fluoro, showing the fluoro here. So this marker will tell us that you should not go beyond that. So we will come down here. So femoral head will give you 2-3 markers, and then you can go and puncture. And we have confirmed in the Now we are planning to puncture here, and we have confirmed in the fluoro that
Dilip, you put a marker there.
So
it's
an
extra marker. Stop. So one second.
Is middle of the probe, so you go middle. Just extra safety. Like we saw the probe, you can see here, the place where we found that there is a cross-sectional area where there is a CFA. We have gone above the bifurcation. We just see in fluoro where exactly is this position, whether how much distant, how much is this in relation to the femoral head. So
then you just keep a marker, means how do you make a marker there?
Just a mental picture, sir. So how much marker will tell us that, but puncture in vision. Puncture in vision. Will come down here. So femoral head will give you 2-3 markers, and then you can go and puncture. And we have confirmed in the.
For 1 second.
Now we are planning to puncture.
I have a doubt that actually when you puncture, your puncture will be little not directly, So when you actually mark that place.
No, I don't mark, sir. It's just a guess estimate that what all you are seeing in ultrasound, whether this is corresponding well with the fluoro or not.
Correct.
Because many times the ultrasound, we are not seeing where how is it related with the femoral head.
Correct.
So we have gone up. There is a high bifurcation. So it is inside, above the inguinal crease. Then it is intra-abdominal. So retroperitoneal bleeding can happen. Then we can devise further strategies going left and right. If your CT assessment, you already know where you are, but giving us extra information. So, but we puncture it ultrasound guided, and we don't puncture it like this. We puncture it 45 degree.
45 degree.
Yes. And the probe position which is there, you are not puncturing just near the probe. You are puncturing 2 to 3 centimeter prior to the probe. Before the probe, again, which distance should be equal to the distance which you estimate the depth of the femoral artery. So with 45 degree angle, you pierce there.
But you will be even calculating that 2-3 millimeters extra also here.
Yes. So we estimate that if the patient is obese, we take it little 3 to 4 centimeter, and then because your the ultrasound probe is like this, it's going to see your needle. You can when it is coming in the vision of this. And if you are very near, you may miss it. So you have to come 2 to 3 centimeter prior. Then you have to go in with 45 degree angle. So that's what we see. And we have confirmed in the fluoro that we are well placed. This is the micropuncture set, and you see the image is middle of the probe. So you go middle and you make some distance. This just not abutting the probe. It should be at some distance, and distance should be akin or equal to the depth which you expect, assume. So you assume a depth of maybe 2 centimeter or 3 centimeter, you come and puncture it 2 to 3 centimeter below that, so that you are with 45 degree angle. Once your probe will show you, can you just unfreeze that? Unfreeze that. So it will go and puncture there, it will show the tip, not the shaft. Okay. So I am going inside, you see here, we are in the middle. Now you can see, I am reaching there, can you show the probe? And you see, just we are puncturing the anterior segment, and you see now, you see how the blood is coming. Just show it here, and then you make it little down. I think this puncture needs to be seen again. And you see now, you see how blood is coming. Just show it here, and then you make it little down. Once you come here, you have to make it little down, and then your wire will go inside. You see, this wire will go inside. So this is how we puncture, and then we do proglides. Exchange this with the bigger normal wire. You the normal wire? And preferably it should be long wire, but you can do it with this small wire as well. So the classic teaching is of long wire you should take. And then wait. Then give me a discharge. So we need to make a proper track, because many times proglides sutures they are getting trapped in subcutaneous plane. You have to increase the track so that your proglide should not get entrapped in the, and it has to be opened up with artery forceps. So you can take here, the artery forceps should be curved up a little better. Now you take the proglide, flush. And the proglide should go at 45 degree angle. These angles are very important. You see wire has come. 45 degree, You take the
wire,
proglide 45 degrees.
This is very important that the angle with which you are taking it down, it should be 30 to 45 degree. And now we are going in, then we can exchange this. Once we are there inside, we exchange, just take it out. Once the wire exit is there, now you go in at 30 degree or 40 degree, and you see where the blood is coming. You see the blood is coming, come out, you see the blood is coming. Blood is coming, then you just put on the foot plate and come up.
And then
you just gently pull it, and then you give the 2 or 3 steps, and needle will go in.
Your left
and
hand
then
should
you
be
just
fixed here.
take it out like this. Here, left hand should be fixed there, and it should be. You see there, it is tightened. Now you just cut it like this. Once it is cut, then you see you go in little bit, and then you
release the foot plate again.
Put the foot plate again down and come out. After you will see that 2 wires are there, you harvest the wires, and it should not be both wire relations should be the same. And then you take a artery forceps. Give me the artery forceps. Artery forceps. And you see, hold like this and put it like this. Now, once you are coming out, you can see again the wire port. You can see, can you just zoom it here? Come out, you come in. You can see these 2 markers, white markers, and then you can take your wire again inside.
Take again wire inside. We can take it out and again put a second proglide over that, the same continuity.
And through this wire, you just put it and take it again down. Okay? Now your proglide is there and wire is also there. You remove this, your proglide wire is there, and now you can
take the second
put another proglide and do the
process.
same procedure.
So this is how we do proglides. And another way of dealing with access are angioseal, and it's a collagen based device. And this is also 1.5 minutes video. We can see that again.
So you can see here, this is the wire, which is
this is for 7 French access or 8 French access, or
it
we have
comes
done
in
the
the
TAVI proglide, still there's some bleeding, then we can do
and
that.
now you see this is a obese lady. If you go for manual compression here, it can lead to little some difficulty you can expect. And now you see the bleeding which is there. And now we will take directly over this angioceal device. And this is the locator. Okay, so you can appreciate this logo should be up when you go in for reference. And now once the wire comes out, you see here you have to go in and wait for the blood to come. Going in, you see. Going in, you see the blood is coming. Come out. Just to locate where is the arteriotomy, the arterial anterior wall. Because once you are going in, the blood is coming, so and coming out and going in. This is the place where there is arteriotomy. Now here you fix the anchor, and now you take the plug. You see this is the angioceal device, the collagen plug, and now it will go in, and you just close this. This is a click sound comes, then you withdraw this. Now the entire assembly will come out, and this sheath will go in to push the plug over the arteriotomy wall. You can see here, and this black one, just this black part should be visible. Now this is enough. Now you can cut it. You cut this. Yes, cut. Yeah, cut. Give me this. Now you see here. Now you remove this and cut it. You can appreciate the bleeding which was there, and there is no bleeding now. So now there is a closure has already happened.
This is how we do proglides and angioceals. And I end here because Manta device is not available to us. Probably Teleflex has got. In my last conference which I did on large bore access, I asked them to show us and keep us in a kind of exhibition. But there was a regulatory problem there, and they will get it soon to license. Soon they will get the license soon to market in India. So before I end, 2-3 points which are important. One. Yes. Yes. And 2-3 points. One is you have deployed one angio seal. Then next you want to do intervention. Maybe next day the patient has a problem. What should you do? So you can do ultrasound guided puncture. You should avoid that area. You can do that. You can go for contralateral. You have to avoid going with at the same site where you have put the angio seal. In next 3 months you shouldn't do. 3 months it will take completely absorbed. Second is there are other questions are there like proglide sutures getting broken or snapping off. So there 2-3 tricks are there. The angle with which we are going, track should be generously prepared. Angle with which we should be going is 45 degree. It should not be 60. It should not be 30. At 45 you have to go. And once you are reaching there, it has to be one good plunger push. It should not be a hesitant 1 or 2 times push. It can break the geometry and can cause wire fracture. And then rest of the procedures are similar. So with these 2-3 tricks, we can avoid unnecessary snapping of this proglide wires. And third is, most important is, I asked the same question to one of these, Dr. Saurabh Gupta, who is a prolific TAVI operator. So these problems are encountering. He said to me, in Europe and America, the Pro style is available, the navy blue color. So it was a gray color. You see, the Pro glide which we are having probably is being replaced by Pro style. They have got robust sutures. They don't get broken off. Robust sutures. So there are new generation Pro glides called Pro style. So every US and European operator is using Pro style, but Abbott company is giving us the same Pro glide, and also the manufacturing.
No. We are using Pro glide. What they are using?
Pro style. Similar.
Spelling?
Blue color.
Pro style.
Pro PROSTYLE. Pro style.
Oh, style. Actually, yes. Like Yadav. Pro style.
Yeah. Pro style is the next generation Pro glide, which is navy blue in color, and they are the the characteristic and the quality of sutures are very strong, and they don't break. So these are some of the tips and tricks, and here I will end my presentation. Thank you so much.
Thank you. Actually, we will not ask any more questions to him because we have no time. Lucky that the first speaker is not presenting because I am sitting as the chair. So we will be going to the next presenter. We go to the presentation? Dilip, okay?
Yes.
Okay. We will actually go with Anil Kumar Singh for the first presentation, or the Pavan Singh? Pavan Singh. Silence before storm, massive air embolism. Can we take this all this cup with tea little left out? Can we remove this from the table, please? Make it clean and bring one more tea for everybody. That is okay, but not with the other people trying coffee and tea. Are you ready?
Yes, sir.
He came with a slide for.
Good evening to all. Coming to the case, is the 58-year-old gentleman. First slide first. First slide. Yeah. He's a 58-year-old gentleman, tobacco addict with the history of diabetes, presented with chest pain to the tertiary center outside. He was diagnosed NSTEMI, echo unremarkable, and he was done revealed triple vessel disease and referred to our center for the angioplasty. Next. This is the angiogram of the right coronary artery, showing the critical lesion in the proximal RCA lesion and the proximal PDA. The LED shows the critical mid-LED lesion. Next slide. We went ahead with the PTC of the RCA, started pre-dilating the lesion. The distal lesion was pre-dilated with 2 into 15 balloon at 10 atmosphere, and the proximal lesion was pre-dilated with 3 into 12 NC balloon at 12 atmosphere. After pre-dilating, adequate pre-dilating stenting was done. To the distal lesion, first it was the DES 2.25 into 28. It was placed across this PLV, and then post-dilatation. Next slide. Post-dilatation was done with 2.5 into 12 atmosphere distally, and the pot was done with 3 into 8 NC balloon at 12 atmosphere. The result was satisfactory, and we went ahead with the stenting of the proximal lesion, and 3.5 into 35 DES stent was deployed at 14 atmosphere. Result was good, and we thought that we will post-dilate with 4 into 12 or NC balloon. Till this time, everything was going fine, and there was the pin drop silence in the cath lab. While post-dilating with 4 into 15 balloon, we found out that it was not dilating, or there was not the balloon expansion was the suboptimal, and it was not expanding to its full capacity. And then I told my colleague to just deflate it and reinflate it, and again the same thing was happening. And then suddenly the patient started having the chest pain, and there was the ST elevation in 2-3 area of leads, and BP dropped to the 80 systolic, and the storm arrived, and now we have to manage this storm. There was the massive no flow and the air embolism, and this was the scenario, and the panic button just pressed on. Then we started managing with giving inotropic supports, 100% O2, massive aggressive saline purge, but there was no relief. And then patient went into bradycardia, followed by a systole. Brief run of CPR was given. Then we started a thrombustor. He used thrombustor 2 to 3 tons, and then finally with the intracoronary adrenaline, we got the TIMI-3 flow. We went ahead with this post-dilatation with 4 into 15 balloon at 12 atmosphere, and this was the final TIMI-3 result. This is the take-home message. Every case is different, and nothing is simple in intervention. Any case can be the Pandora's box. Balloon preparation is a critical step and should be done very meticulously. If balloon is not inflating to its full capacity without any obvious cause, then it should be removed before reinflation, and should not hesitate in the check shot. Buy time and maintain the hemodynamic balance. I think that the first 5 minutes of this managing air embolism is very necessary. If we try to manage the first 5 minutes or keep the patient alive, then we can manage this air embolism. Anticipation and the timely identification of any complication is the key for successful bailout. What is necessary that we should maintain calm, not to panic, act fast, and call for help. Success of any intervention depends upon good teamwork. Thank you.
Good. You have managed the case very well. But one question that how it happens.
Please, Dilip.
How it happens? The air embolism.
Sir, balloon was I think there was the air in the balloon, and it was the ox balloon, sir, and it was not inflating. There was a leak from the balloon.
Leak from the balloon.
Yes, sir.
Okay. And how did you come to know that it is air? Means.
Patient has started having chest pain, bradycardia. When we took the check shoot,
any sign of the means air entrapping?
The check shoot is showing the air embolism, the bubbles.
Bubbles, but it was moving up to and fro.
Yes.
That was a sign of air embolism. Yes. Okay.
Actually, your balloon was not inflated properly.
Yes.
So keeping the balloon and injected, or taken the balloon out?
No, sir. While it was not inflating, then I told must be some leak into that area to try to deflate it and reinflate it. I twice did it, and meanwhile the patient has started having the chest pain, and then I removed that balloon and then took the check shoot. And then
No. My question is actually, once the balloon is not inflated and actually balloon is ruptured, usually what we see is actually there will be when you cannot inflate the balloon again.
It was, sir, inflating, but to half capacity. It and never.
Your nurse did not. Who was inflating?
Sir, assistant.
Assistant. And they did not tell you that it is not going inflated. You are actually repeatedly. How can you repeatedly inflate that? If you have a balloon is not inflated properly, the blood will come out, right?
It was inflating to half capacity, sir. So then that the hub of this balloon, they reinserted.
Anyway, you did not identify. Okay.
Yes, sir. They reinserted that must be the loose connection. They reconnected it, then again reinflated it, and when again it was not inflating, then we.
One more problem is actually it's a 6 French catheter.
6 French catheter.
Usually 6 French with a balloon inside. Some people inject and there is air sucking is also a possibility. That is why that question comes. I think there is some comment from Pramod and Dilip. They were discussing. Probably you have some comments you can tell.
Balloon inflation.
No flow.
No flow.
And the air embolism has occurred once they injected.
No. Actually, he was telling the balloon was ruptured and that air is gone down. That is what he is thinking.
It was not showing any dye going down. So how can air coming out from the balloon? Balloon was inflated with the contrast. So
that is actually my doubt. Usually what happens, in a 6 French catheter where the balloon is there, when you just inject, there is a high chance that balloon air can suck in. And probably he would not have taken the balloon totally out. Keeping the balloon inside the catheter also he would have injected. That he may not be telling correct. That is what is my doubt.
No, sir. Actually, if you see,
you taken the balloon totally out or you keeping the balloon inside injected?
No, sir. After taking out the balloon, I have taken this solution.
How the balloon was inflated, that's important. If you keep the inflation device like this, you may not push the air. But if you your assistant is keeping the inflation device like up, so air will go up, and then once you're,
that is actually commonly happens. This actually always the cardiologist should see that it is in the position where the air is actually, the contrast and the fluid should be down. That actually may not happen most of the time. Number 2, in 6 French catheter, when you have a balloon inflated, you inject and see, then also air suck in. These are the major problems of that. You told there was an absolute silence when you are doing angioplasty. Why people are afraid of you? You told that statement before. And when there was a calamity happens, everybody was in anger.
Everything was going smoothly, sir, and we were.
So we were all happy, or that is the happiness is shown by silence. Actually, I just wanted to make a statement. When I do angioplasty, people are laughing. I talk with the patient. I talk with all the staff. When I actually go to Dilip also, you just tell that every staff in Dilip's cath lab is happy when I am there. Not he is there. He is like you. He will keep people silent. It is not good,
Yes. But on a serious note, sir, the most likely explanation in this case is air sucking in. That is the only thing I can make out. Because such a large column of air, it will not be happening due to rupture of the balloon. We could have seen bubbles in the balloon itself.
Correct.
But how it will leak through the balloon?
It has not ruptured, sir. It is a leaking balloon, sir. It is not
But
inflating, sir.
in the angiogram, we are not seeing the bubbles.
No, leaking balloon can cause. Actually, I will tell you, last week, when another cardiologist was doing inflating, then next shot, there is no LED diagonal flow is not there. Then I told whether the balloon is leaking. No, nothing, sir. Taken the balloon, I demonstrated her, it was leaking. Basically, when you balloon leak, even a small amount of air can block the vessels distally. That also can cause problems.
So that also, and whenever we exchange hardwares, especially larger stent balloons, larger post-dilatation balloon, we always black bleed through the 6 French catheter.
Yeah, these are all usually happen.
That is very important to check.
6 French catheter is actually dangerous in these things, because if you have a 7 French, you have. I think Yadav will make the last comment, then we will go to the next case.
Always check the balloon before introducing into the.
Yes, sir. We have checked it. We have checked it, but. Yes, sir.
Thank you. It was a wonderful case for discussion. We will call upon next Anil Kumar Singh. Spiral dissection. How to go presentation without discussion? We can. Actually, you want everything, You want laddu, you want jalebi, then you are telling that nothing will be paid. It is not possible. Time. Boss, you should be very fast in presentation. Then only we can have some laddu there. Fast presentation.
Case history, 38-year-old male
Sound.
smoker. 38-year-old male smoker presented with a chest pain injection, AOI class 3 for last 2 months. ECG, there is no significant STT changes. Echo, there is no RW में EF 60%. On coronary angiogram. Play the video.
Can you help us?
Previous.
Goes to the last image. That is what important for us. Next.
On coronary angiogram, in LED, there is insignificant immediately. In the LCS, OM3 has osteoproximal significant DG.
Can anybody help him?
Yes.
The real complication is not
In
coming.
RCA,
Okay.
there is a proximal significant DG. Now, on the basis of coronary angiogram, now plan to stenting of the RCA.
Next. Sure. Okay.
In RCA, there is a type A lesion proximally. Lesion was crossed with the run through floppy wire. After ballooning, there is a spiral dissection of RCA leading to digital complete occlusion. Patient becomes hemodynamically unstable with fall in the blood pressure and the development of complete heart block. Temporary pacemaker was immediately implanted. There is spiral dissection which extend up to the RV branch. Long stent 2.5 into 40 m was initially deployed digitally to first restore the blood flow by the 3.5 into 32 mm was deployed proximally. There is a good flow. Post dilatation was done and TPY sinus rhythm was achieved the patient.
We did not see the final shot. No. Just final shot.
Yes.
Go back. Show that final angiogram shot.
This is the final shot.
Anyway, discussion.
Yes,
Your
sir.
case is finished. We will. No. 1 minute.
Yes.
If you do now, what are the things you will be doing differently? You have done and you created a complication. You have read everything from the books now.
Yes.
Now you understood you are presenting in front of Yadav. You would have prepared mentally. So now, if you do the same case tomorrow, what are the differences will you make in that case? I just wanted to hear and then we will go to Yadav. Otherwise, Yadav will not allow you to. Yadav, 1 minute. Allow him. Now,
Sir.
if you are doing the case, you will do in the same fashion or different?
Yes, sir. What, sir?
Today you get the same case.
Yes, sir.
How will you do differently? To create no complication. That is what is our aim, you know.
अरे दोबारा अगर इसी केस को करना होगा तो कैसे करोगे? अब तो सीख लिए, एक केस कर लिया, अब दोबारा अगर ऐसा केस आया तो कैसे करोगे? ये सर पूछ रहे हैं.
Yes, sir. Must be
question is for
careful
everybody.
during the pre-dilatation.
No.
Sir. Must be
Why the
careful.
dissection has happened? This is the problem.
Dissection
Let
due
him,
to the
let him tell this answer.
pre-dilatation with the balloon, sir.
Balloon, pre-dilatation balloon will call spiral dissection.
That is the major point I am asking. How
Well,
do you get?
Can you run the cine? Cine run kar sakte hain, please?
It is actually if you create a spiral dissection by balloon dilatation, every case would have get balloon dilatation.
What thing you want to avoid in your next case?
Yeah.
For
Run,
prevent.
please
Yes,
run
sir.
before balloon dilatation, run Yeah, run. Next. After wire. Back. 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 Before. You see, there was no reflux. I have seen one of the angio where there is no reflux. That means he has injected when there is no pressure. Then, and that's caused the dissection. Spiral dissection is because of the guide induced.
So dissections can happen. Absolutely okay. So, but the thing is, you should not have injected again and again. Most important point, and you should have sealed the entry point first, rather than going.
The entry stent should be actually, Dilip, that is what I wanted to tell him, but he was not answering the question. But one thing is actually, your injection would have created dissection. Your balloon inflation, how can you create a spiral dissection? Everybody is sitting here using a balloon to inflate. Then every coronary should have a spiral dissection. It is not possible. Definitely, your catheter would have created the spiral dissection. There is no problem in that.
Before injecting, must see the pressure.
Number one.
This is the rule.
Number
If
two,
pressure is coming
if
regular
you create a problem in the ostial part, which area to be sealed first? That is the second point. You put a stent distally. Is it correct?
You stent first the proximal part,
that you
dissection part.
Yes, sir.
And where the rest hematoma will dissolve.
Actually, that is the same thing I was. Actually, you did not read the case after that also. You create a dissection, no problem. You should not sleep on the night. Why I create a dissection? And the dissection is created by the catheter. If I do second time, how I will do this case? Definitely, you should have read the books. I'm just telling you, entry point of the dissection, that spiral dissection to be closed first. It may not be requiring a second stent. With a single stent, you would have created everything. You take a 38 stent from the ostium to that part. Your lesion is covered, your spiral dissection is cleared. Only one stent. Probably that would have, that is what I wanted to ask you the question again and again. But I think you did not get it.
Before injection, always check the pressure. If the pressure is regular, then only inject. Otherwise, don't.
Otherwise also, whether regular or not, without BP, nobody can inject anything. No injection is allowed. That is basics in the angiogram. I think, thank you very much for the wonderful, and now I think, now you know how to do next time.
Yes.
Thank you. I think any comment from you? Any comments from you?
This is why the conferences are made for this.
Actually, everywhere we cannot call RD, you know. Without RD, what conference? Can you have any other comment? No. I think we will have the next presentation by G.N. Mishra. I think that our cardiac surgeon is actually understanding everything. We should not allow the cardiac surgeon to come sit here. We will be losing job. Sir, you don't do angiograms and angioplasty, sir. Please, for the sake of all the Arvind Kumar and all, you know, you should not allow him to do angiogram. Please.
Good evening, respected chairpersons, dear seniors and colleagues. Okay. Today we'll discuss a case.
Yeah, this case you should discuss. We will be complimenting.
Nightmares in catheter, complicated left main bifurcation stenting.
Girish, you come to the case.
Sir.
These are all okay. You actually decided to do angioplasty.
Obese patient admitted with complaints of chest pain, past history of hypertension and Parkinsonism. Top T was positive. ECG sensitive of anastomie. 2D echo, valve function is maintained, and valvular function was normal. Angio was done. That shows RCA 100%, left main distal 90%, LAD ostial around 80%, mid 40 to 50%.
Relatives refused because of the Parkinsonism?
Not ladies.
Relatives are actually telling not to go for bypass because of the Parkinsonism?
She was obese, Parkinsonism, not much mobile, so they were...
Obese, Parkinsonism, immobile patient. So not good for surgeons because he is sitting here.
They told us they might be afraid.
Okay, go ahead.
So we are planned for elective dedicated left main bifurcation stenting, and we planned for mini crus. This was the angio of the left side, that shows, and our plan was mini crus. So next. We took wire in both LAD and LCX. First we dilated, we done pre-dilatation of the LAD and left main, and next RC is 100%, sir.
RC CTO, that is actually he is not interested to show you.
No,
Please.
RC is 100%, and we tried to open it, but it was not open, not able to open. So we move on.
Oh, you tried initially RCA?
RCA first, sir, because it was 100%. Sir?
No, please, actually, allow him to talk.
Please, sir, actually,
No, please. Actually, just make him to present. Initially, otherwise his energy will go.
No, attendant is told ki whatever, even if survive for 6 months, please go ahead with PTCA.
Since RCA is CTO, 100% blocked, you are not.
Yadav, please.
You should have IIBP support to do the case.
Yadav, after that.
And actually, I am conservative type. I am not doing much CTO or lieutenant.
No. You go ahead.
But in this case, patients were admitted. Patient relatives were admitted, sir. And so we do pre-dilatation of the LAD and LCX lesion, and now we are planning for a stent. We are for mini crush. We are advancing a stent into the LCX lesion and LAD. But somehow the stent was not going, and so somehow I realized that my wire has got broken, especially LAD wire has got broken. So I was started with the drawing, and I was in false impression that the wire is coming with every, the whole system wire is coming along with that, but suddenly the wire is left behind in aorta somewhere, and guide was disconnected. So we tried for 1 hour about to catch this wire with the snare, but failed because it is very difficult to catch distal end with snare. So next, after 1 hour of try, again I hooked LAD and put another wire, same place where that another wire was.
Now the patient is stable.
Stable, sir.
Actually, you are working in Patna or?
Sasaram.
Assam.
Sasaram, Bihar.
Periphery. Okay.
And once 160 kilometers, no, Sasaram, Patna. And so I took another wire into the LAD and took one balloon from this catheter and inflated that, and along with that I tried to push a small size balloon. It was around maybe 2 or smaller than 2 size balloon, and then I was able to catch that wire, and now that wire is in aorta and that wire is in the guide. Look. This distal end is now cast with, now I have cast this distal end with snare, this soft end, and take out the whole assembly. The still patient is having some problem because already almost 2 hours was passed and having back pain and other things. So we thought that at least if you can stent left main to LAD, it will be of some benefit to patient. So at this point, the wire was not going to the LCX and so many difficulties. So first I tried to put a wire from a stent in LAD. By this time, patient was slightly becoming irritable. She was not able to lie down that much, and some chest pain. Otherwise, vitals were stable, sir. So we put a stent in the left main to LAD. LCS got pinched. Next, so we tried to rewire the LCX and put another stent with 1 to 2 struts in the left main. And we expanded, but suddenly we found that the flow in the, because of that wire, probably this stent was not going, so we withdraw that wire, and next shot, this when LCS open, suddenly found that the LAD has got occluded 100%. Again, patient was complaining of chest pain. So again, wire was passed, some flow achieved, and we took another stent of size 3 into 28 into the LAD, distal to that stent with overlapping, and flow was achieved. This is the next shot. Now again we rewire this. After removing the wire, we rewire this L6 and I did proximal pot in the left main. And again, rewiring was done in the LCX after doing pot and crushing. And now the kissing was done, LED and LCX. And after kissing, flow was good, but and that sort is not here. But in one place, near the ostium, the LED was underexpanded, and there it was slightly. It looks that the stent is not fully expanded, so we tried to expand it further with 4.5 size balloon. The stent was of size 4, and next shot we developed perforation. And perforation is at such places that neither we can occlude that with balloon prior to perforation. It was at such a bad place, but the good thing is that there was no effusion, and I just a small size balloon, if the stent size is 4, I took 2.5 size balloon and keep it inflated in for just 5 seconds, 10 seconds, and slowly, rapidly deflating it and inflating it, 5 seconds, 10 seconds, not more than that. And next slide, everything was fine. And patient has survived this episode and still comes into follow-up.
The first occlusion means
So you finished the case?
Yes, sir.
Yeah. Okay. So after doing the procedure, in a lady there was no flow. You have shown.
The flow now is what suddenly occluded.
Suddenly, how it happened?
Probably what I did was I took balloon of size 2 millimeter distal to that place, and I withdrew it, it deflated. It might have damaged the endothelium, and that have caused the thrombosis.
What was the ACT? No, name is Sumita.
Girish.
Girish, actually I will ask you small questions. I don't know whether you will get irritated by my questions, or if you are the chairperson, you will never call me again.
Yes.
But I will ask you a simple question. In a situation of this thing, I don't know how many people are working in your hospital, cardiologist. You are alone?
No, we two, me and colleague, Dr. Pankaj Prabhat.
But if you have such a very complicated case like Yadav told, RCA is occluded, LMCA bifurcation tight, I personally feel that you should actually have some more experience to do this case, because I think these patients can crash and die. Anyway, the patient party wanted to have an angioplasty.
Sir, I told them so many times that after angio they took 2 days to finally.
So, but you can tell that I will not do, you can take to any place. That is why I asked whether it is in Patna or not. Basically, when you have a lot of cardiologists around, you can take help of somebody. That is important.
They told me, so whatever you have to do only, we are not going anywhere.
You are such an believable doctor for them. Actually, I actually now I am 27 years post DM. Initially 3 years, actually for doing angioplasty, I pressurized these people to do angioplasty. I have no mouth like Yadav to be aggressive, so they will not listen to me. They tell that, okay, sir, we will take to another hospital. That was my initial practice. No,
living in a small place, sir. That is not very
small or big, but I just tell it is a very complicated case. In the angiogram, RCA occluded with LMCA bifurcation. In my practice, whenever there is an LMCA bifurcation angioplasty, even if there is an 80% disease in RCA, I usually do the angioplasty on RCA, keep the patient for 24 hours, then I take the patient, definitely not on the same attempt. I have done a lot of LMCA, but I learned these things, when you do these things together, the patient has a high chance of this thing. You are actually inflating the vessel, LMCA, because you have no RCA circulation. That is the number one. Why you got no flow down into the LED? Because you put a stent from LMCA to LED. The distal to the stent part would have dissected. That dissection is not covered by you, that is why. You told initially the patient was actually having a complication. If I was in your place, the wire I catch, I would have stopped there. I kept the patient for next day or another day. I will never do on the same day, because I will mentally prepare, pray to God, take somebody's help, and do after 2 days. Even if something happens, we can actually prime again, tell that there is a complication happen. there is a chance of complication is there, number 2. Number 3, when you did a dilatation of, you told your inflation was a 2.5 millimeter balloon inflation. In the last sort.
After perforation.
And I'm just asking, that is I'm going to tell.
Nothing,
you told, that is why I'm just telling.
I decided to.
No harm. Let me.
No, I decided, that was left main, we cannot take a full size stand because that will block.
But anyway, I have some more experience than you. Let me tell you. Sir. You took a 2.5 millimeter balloon. In a 3.5 millimeter stent inside, you take a 2.5 millimeter balloon. You just go with a nominal pressure. How the vessel can be opposed?
Sir, in the hope, there I was not able to do anything. Okay, I cannot take a full size balloon. I cannot keep it inflated for the more time.
How do you prevent a perforation?
So whatever.
It is not that. Actually, what you are not done in the right way. That's what I'm telling you. A balloon inflation actually is called balloon tamponade. A balloon tamponade requires 5 to 8 minutes of inflation. Then only you'll get a balloon tamponade. You are lucky that probably that was actually an intramural hematoma that was actually healed over time, not because of your balloon inflation. Yes. That is what I am telling you. You are not listening to me. A 2.5 millimeter balloon, you are actually having. Let me finish it off, please. That is why I told you, when you are the chair, you will never call me again.
But possible. मुझे लगा कि कुछ नहीं करने से कुछ करना अच्छा है, इसलिए
कुछ करने के लिए 3.5 balloon to be taken. Now you listen to me. I am actually now going to fire you. And now 3.5 balloon, actually you have to take a 3.5 millimeter balloon and dilate with nominal pressure. Go to 5 minutes, then only you get some result. No, you can't tell these things. Now I was actually thinking that I should be very, very soft. No, you can't tell that. This is actually done wrong.
Girish, actually we are here to learn from the masters.
Actually,
we should accept their
balloon tamponade is actually to be done 5 to 12 minutes. Then otherwise there is no meaning in balloon tamponade. 10 seconds, 20 seconds, deflate. How do you get? Luckily, this was not perforation. It was actually a intramural hematoma, which actually dye was there, which was healed over time. That is why you are seeing the result. It is not because of your balloon inflation. Even if you don't do anything, after some time, if you inject, you would have seen the same result.
Yes, sir. It is not because of balloon. I am accepting this. And balloon perforation has such a site, left main at the junction of left main LED. उसमें सर बड़े साइज का balloon फुलाना possible.
Which size balloon you took? Proximal LED. You which size?
Sir, for post or for
post dilatation with that led to rupture.
4.5.
4.5 is too big.
The stent size was 4, sir.
No. Basically, you should understand that. Let me tell. What will be the size of the LED? Now I will be teaching you for 2 minutes. Excuse me. What will be the size of LED?
It was, sir, 4.
4 maximum. 3.75, 3.5. Circumflex will be 2.75, 3.
3, sir.
How can you take a 4.5 millimeter balloon into the LED? Impossible. You should never take it. You can take a 3.5, maximum 4.
Yes.
Otherwise, if you did, you are actually going to rupture the vessel. Because with the high pressure, 4.5 is possible in the LMCA. That also without imaging, we don't know. And you have a calcium spicule there. You are going to dilate at a high pressure. And you should be very much worried about that.
You are lucky, really lucky.
And actually, I'm just telling all these things. The patient is doing very well. You have done a very good work. But I will appreciate 2 things in this case. 1, you are young. Number 2, you are young means you are enthusiastic to do the case. Even after 2 hours, you persuaded to do that. You are actually can become an excellent CT operator. I'm telling you, this persistence and perseverance is there. But you should understand that what we are doing, what we are actually, whether can we change my practice or whether I have done something wrong, that you should always ask in the evening. I always do that. Actually, in whatever I learned in this career is actually, I always ask retrospectively, what are the things I could have done better? Every CTO, I fail. I have a success only 87%. In that 13% failure, I ask this question every day. Can I do something separate? Can I do differently? I go to the conferences and sit in the hall from morning to evening. Unlike you, many people, I sit in the front, not because I don't know anything. I am thinking that I can learn something from you. That is should be the attitude. Then only we can try to learn. I don't dishearten and don't think that I am an idiot talking all these things. Please forgive me if I tell something bad. Thank you. Excellent case.
Thank you.
We'll call upon the next person. I think G.N. Mishra. Mishra is over. Now is Prabhat Kumar. I think I will avoid comments for the next.
Good evening, everyone. Good evening, Chairperson, Organizing Committee. After discussing on the adult cardiology, I have a small kid. My case is not nightmares. I can say it is challenges to doing the ductal stenting. And I have faced challenges in all three crucial steps of the PDA stenting. That's why I'm presenting this case here. Next slide, please. PDA stenting is a better and alternative option to BDT shunt in particular critical cyanotic congenital heart defect. It's a palliative treatment, not the definitive treatment. And cath lab is a place of uncertainty in sometime in pediatric cases, I feel. Had a nightmare in all crucial steps of stenting. And in this case, I have the most crucial step was the vascular access. It is said if you achieve vascular access, your case has been done in most of 90% cases. There is availability of hardware according to size of unit is essential prerequisite. Post-procedure complications are major determinant of successful outcomes in neonatal case. My patient, 23 days old, 3 kg of body weight, came in emergency with dyspnea and having the saturation around 65% in room air. On echocardiography, I seen the patient having the tetralogy fellow with the critical pulmonary stenosis and having the small tortuous PDA. On echocardiography, I measured the size, it's around the 12 to 15 millimeters of PDA. It's very tortuous, having 2 to 3 turns. PDA is vertical type, arising from the undersurface of the aortic arch, of left aortic arch. My plan was to do pedal stenting without going for doing the alprostyn infusion. My better option after echocardiography is to do right artery access in view of vertical ducts. If not possible, then last choice was the put the femoral arterial access. I used the hardwares which we use for coronary angiography. I used bare stent methods through the femoral artery access in putting the stent. My size of coronary stent was planned 3.5 into 18 millimeter of stent, single stent. I encountered the nightmares, all three crucial steps. My first nightmares was struggling to put the vascular access. It took around 1.5 hours to get the vascular access. And last option was chosen was the right femoral artery access, which I achieved. On accessing the artery, femoral artery, we do the angiogram of aortic arch and confirm the same type of the PDA which I seen in the echocardiography. It's vertical duct, have a tortuous nature arising from the undersurface of aortic arch and having the confluence stenosis. It's a still image that is depicting the profile of the PDA. In usual manner, we did angiography and with diagnostic JR catheter cross the coronary wires and park deep in the left pulmonary artery. After this, I have the nightmare. During removal of the coronary artery, during removal of the diagnostic catheter, suddenly coronary wires get removed. And my plan was to put the bare method stenting and not using the guiding catheter. Because of size of baby, I don't want to took the 5 French seats or guiding catheter. So this here, we tried multiple times to again negotiate the PDA through the impala end but could not get it. Then we tried the modification of the JR tip, slightly change the profile, and did the bended tip methods, and it get inside the impala ends of the PDA. You can see the depiction when it is shaping the shape in the aortic arch. The usual JR not getting inside the PDA. When I bended it and modified the profile, then it get inside the PDA impalide. But after getting inside and doing angiography, the wire is not going inside the pulmonary artery. Then I realized there could be the spasm of PA end or maybe thrombus inside it. So we did given the local heparin directly to the PA end. Then we tried again. This is the angiography after negotiating. There is a spasm of the PA end and too much tightening of the confluence of PA. Now we succeed to get inside the pulmonary artery, right pulmonary artery, crossing the PA end and make it straight. Then we took another coronary stent, Batik wire techniques to secure it deeply. We taken the stent 18 into 3.5 millimeter and deployed it. But here is the problem. We could not able to cover the aortic end of the PDA. It's slightly malposed. Then we planned to cover the aortic end. We took another small stent, 3.5 millimeter, 15 millimeter, and nicely covered the aortic end. On final angiogram, there is no much obstruction in the aortic arch. There is good flow in the pulmonary artery. After the procedure, baby on ventilator, having the SpO2 around 90%. Had the fair success with SpO2 average more than 85%. On angiogram and echocardiography has good flow in the pulmonary artery and aortic arch. There is no obstruction. Transfused blood because of the blood loss and took the 4 hours to do the procedures. Developed sepsis, AKI that improved after treatment and discharged after 7 days of procedure. My take-home message is the PDA stenting is better. Proper planning and post-procedure care is utmost important. We have USC guided access, could have saved time and stents, and training and training team is essential. I'd like to thank my adult cardiologist, Dr. Sabzali and Dr. Assis, and all my pediatricians. Thank you so much.
Good presentation. First is this patient was saved, and PDA stenting is, I think it is a usual procedure in cases of such cases where there is emergency. Vascular access, why it was difficult for? Means you have not exposed the.
I think a patient may be in the shock.
No, it's okay, but you have not exposed it. You have not taken the help of the surgeon to expose the vessels.
No, sir.
No. But usually we do, no?
No, sir.
If it is difficult.
We do the blind method, sir. With the puncturing, as usually the puncturing any vessels, we do blind procedures.
No, but if you have difficulty, then you told the first nightmare was this vascular access.
Yes.
Next was when you pull out the wire.
Yes, sir.
And third was the aortic end was not covered.
Right.
So three daymares. It was night or it was day? It was day. Okay. So I think that for the vascular access, you should have taken the help of the surgeon to save the time, number one. And rest of the thing you have managed well.
Surgeons can help you, that's what you want to tell. Only one point I just wanted to tell you. Which wire crossed finally? When you change the shape of the catheter, which wire crossed finally?
Same wire, sir, whisper wire.
Same wire only.
Same wire crossed.
Okay. I think if there is no comments, we can proceed. Thank you very much, because I am not familiar with these things. That is why I cannot ask many
No,
questions.
which technique you use for puncture the femoral artery? Which
Blind.
Blind method.
No, which needle?
Very simply, sir, using the cannula.
Oh, cannula.
Thank you. We will just go to the next presentation. Dr. Arvind. He is actually the organizing chairman. No questions from us.
So my colleague was supposed to present the case. Okay, my patient was 75-year-old lady, frail lady with lot of comorbidity, unstable angina, mild LV, 30% EF. He came to our hospital, recurrent chest pain, hypotension, LVF. Angio showed right was normal and left was having severe mid-shaft stenosis, mild ostial stenosis, and there was a severe D1 stenosis. LAD and LCX was normal. So we advised him to her to go for CABG. Our surgeon refused. I cannot do because of she is not fit, and because of financial problem, she wants PTCA to be done under Ayushman Bharat Yojana. So she doesn't want to go to some higher centers like Dr. Pratap Kumar Center. Okay, so our tragedy was just to take a chance. So second was patient had severe LV dysfunction, recurrent LVF. So we decided to put IVP. There was a lot of controversy, but IVP, Oxford IVP was put by my resident. Another issue. So then we decided to do angioplasty. Move karo bhai. Run. Idhar aa nahi raha. Okay, just okay. ये ठीक है? रुक है. ये पहला करो, back. Sure. This is IVP catheter scene. So you can see the left main with diagonal, and we next. Yes, we have put one wide in the aorta from 7 French guiding gel 3.5 gel 7 French catheter. One wire was put, floppy wire was put into aortic root to prevent inadvertent deep hooking of the catheter because there was a mild ostial lesion. ये रुक क्यों जाता है बार-बार? रनिंग होना है. Okay, then ये क्यों नहीं आ रहा? प्ले हो गया. Okay, नहीं रुक रहा फिर. So one wire was put into the diagonal because LAD was normal, so single wire was used, and we inflated by 2.5 into 12 balloon. Then same balloon was withdrawn to left main, again 2.5 into 12 at 10 atmosphere for only 6 seconds. Very short inflation was done to prevent prolonged ischemia. After 2 dilatation, this was the result after balloon dilatation. Then we again inflated up to the left main ostium because there was some disease there. Then we put one stent, 2.5 into 12. Tetrilimus Sahajanan medical technology stent was put at 10 atmosphere for 6 seconds. This was after putting a stent. Then we took a 4 into 16 size stent to just put 1 or 2 studs into the left main and just before bifurcation of left main. The size was chosen 16 millimeter, 4 into 16 at 12 atmosphere for 6 seconds. Then we do post dilatation by NC balloon 4 into 10. Size was 4 into 10 at mid shaft and then up to left main ostium. This was the result after post dilatation. But story doesn't end here. Back. We were so happy to perform my second left main angioplasty, but suddenly patient starts falling blood pressure gradually, and the patient develops hypotension. We didn't understand what happened. We took a check shot of the left main. Actually, then we felt that there was a groin hematoma at the site of IVP. We start manual compression, but the hematoma was continuous happening. It was well observed from outside, but it was an hematoma. Then we realized that Is it because of IBP side some complications? Because the check said so, didn't no problem in the LM and diagonal stent. So we took next another side puncture done, and then we checked the in meanwhile, due to some mistake of our staff, the IBP was removed by mistake. So we started manual compression, and then we took a check shot. We then find there's some leak in the femoral artery, and it was a very lower puncture. We realized that the puncture was lower, so that was causing hematoma in the muscular pain, which was not very obvious from outside. So we took balloon tamponade. We took a 3.5 into 14 coronary balloon and inflated for many minutes. This was not seen. Back karo to balloon और पीछे ले चलो और पीछे back और back. So this next. You see. Next. Manual compression, balloon tamponade for several minutes. Next. Next. And ultimately, then we decided this was the next. No, back. ये तो दूसरा का गया. This is the final result. Then we decided to put a prolonged manual compression, and meanwhile the patient's blood pressure improved, blood transfusion, inotox, etc. given, and second day patient recovered well and discharged on third day without any complication. So the take-home message is that the first issue, if in a poor resource setting, if there is no IVAS facility available, should we do angio left main or not? I have explained the situation why I have done the left main without IVAS support. Second is IVP should be used or not. There was no clear-cut data we should have not used, but because patient having recurrent chest pain, hypotension, LV dysfunction, so in our centers our team decided to put an IVP. Mistake was done, it was a lower puncture which causes lot of hematoma, and because of some mistakes by our IVP was prematurely removed from the sites and the hematoma aggravated, patient developed hypotension, though the result of left main and D1 angioplasty was satisfactory, but this complication was unwanted, and we have to suffer a lot for next 24 hours to manage this hematoma. Thank you.
I think, sir, wonderful case. Once it was detected that there is a kind of puncture there and there is a leak, since it was quite low, and the vessel was compressible at the femoral head. So what we do in our center, we give protamine. We totally reverse the heparin.
Yes, actually I forgot to mention.
We totally reverse the heparin, manual compression. Most of the cases they recover, sir.
We just try to do balloon tamponade, which might partially help. But manual compression and protamine, sorry to forget to mention. Many people say that once the stent has been put, why protamine has been given? There is a lot of controversy.
No, sir. When you are out of the coronaries, no hardware is there in coronary artery, then you can give protamine as a protocol cath lab. Absolutely.
Trust me, we are giving protamine.
No.
Dr. Dilip, in a left main stent, do we reverse heparin?
Yeah. There is no role of heparin once you are out.
Actually, that is what actually everybody should understand, a very important point. When your devices are out of the coronary, there is no need of protamine or heparin at all. You can completely reverse it. And there is no harm, even in a C2 intervention, any intervention. But my doubt is actually balloon tamponade with a 3.5 millimeter balloon is possible in a femoral artery.
In frustrated situation, nothing was available, so we are doing manual compression.
Then the best one is manual compression with the protamine. That was the ideal. 3.5 millimeter balloon.
That was useless. Balloon tamponade was useless, I agree.
Okay. Thank you very much. We don't have much discussion because nothing in coronary, Okay. So you should create complication in coronary and come. Next case will be Anupam Sambhani. After that, you will be seeing real complication. I will show you the complications so everybody can be happy. So after this, I will be showing real complications.
Thank you, organizing committee, to give me the opportunity to come and interact here. This is a very unusual kind of management of a case. From where do I have? Okay, right. Thank you. So clinically, this was a 56 years old gentleman presented with unstable angina and no risk factors, at least modifiable. ECG showed old inferior wall MI, which was probably silent because on interrogating, he did not give any history. He refused to have had any chest pain earlier. Echo showed all inferior and infralateral segments akinetic with EF of 48%. Angiogram showed RCA was diffusely diseased up to PDA and PLV, and none of the branches were graftable. LAD showed multiple significant lesions in proximal, mid, and distal segments. LCX was non-dominant and had borderline stenosis. This was the left angiogram. As we can see, LAD was diffusely diseased right from the ostium to the distal, and borderline disease was there in LCX. This is the angiogram. We can see very distal branches or subdivisions of PDA and PLV getting filled, but the vessels were not graftable. So we decided to do the PTCA to LAD. And there was no angiographically visible significant calcium in the left system. Multiple predilatations were done serially. Some dissections, spiral dissections were created, but they were non-flow limiting. So we decided to put stents. A 2.75 into 48 millimeter thin strut sirolimus eluting stent was being advanced towards the stenosis when it got entrapped in the aortic sinus LMCA LAD. It was neither advancing nor retracting despite maneuvering of the catheter into the deeply engaged position. Patient became restless, hemodynamically unstable, tachycardia, and BP dropped to 0. To perfuse left coronary artery, there was nothing else to do at that time but just to deploy the stent wherever it was stationed at that moment. Patient's hemodynamics improved, his BP became normal. Next challenge after deployment the stent was that the deflated balloon was also found entrapped. The only thing that worked at that time was deeply engaging the catheter, followed by pulling out the entire catheter balloon wire assembly, because nothing was coming out without pulling out the catheter and the wire. So now, after pulling out everything, we had certain challenges. One, there was a spiral uncovered dissection in the mid LAD and the distal LAD. There was an under-expanded stent in the proximal LAD and left main, which was definitely not matching the size of the left main diameter, and re-engaging the guide right into the mouth of a stent, 8 millimeters of which roughly was hanging in the aorta, which was fluttering in aortic sinus with each cardiac cycle, and advancing second stent through this freely hanging stent was next to impossible, and engaging the guide into the fluttering stent also was impossible. So options were send for surgery, crush the stent using another stent in LMCA by the side of the stent, but this would have plastered 3 stent layers in the LMCA, or crush and deviate the stent to create a fresh LMCA ostium through which second stent could be advanced to cover the long spiral dissection. So we decided to crush the stent at LM ostium. As can be seen in the left picture, about 8-9 millimeters of stent was hanging in the aorta. So we went by the side of the stent and crushed it to push it away from the left main ostium, and at the same time created passage for the hardware to cross this first stent, and so that it could be advanced to the mid and distal LAD. After post-dilatation with larger balloon and ensuring free mobility of hardware through the first stent, another 2.75 into 40 millimeter DAS was advanced to mid-distal LAD and was deployed. This time we did not face any difficulty in advancing the stent. Repeated balloon dilatations were done using non-compliant balloons to enlarge the LMCA part of the first stent, and to further crush the hanging stent away from the left main ostium. So this was the final result, and patient was stable and discharged after 4 or 5 days. So what we learned from this case is that probable cause for entrapment was manufacturing defect. We say that because one, there was no angiographically obvious calcium to say that a spicule was protruding. Second, a long stent passed easily through the same track after post-dilatations, and even the withdrawal of the stent balloon was difficult. So had it been something else holding the stent from advancing forward, at least the balloon would have not got entrapped. And whenever hemodynamic instability precludes surgical option, we should consider unconventional possibilities for handling this kind of situations. Thank you.
It can be a situation that the stent manufacturing defect. But the second time when you actually taken the stent, why you are telling that? You prepared the lesion, prepared the bed very well, especially when an angulated vessel from LM to LAD, and the proximal LAD was actually an angulated vessel. If you don't prepare very well and taking a stent, definitely there is a chance
Sir,
of...
we did prepare and we went to dilate.
But after the second stent, when the second time when you wired, you again balloon dilated the proximal part.
Yes.
So you created an excellent pathway. So that time your stent is easily going means you are actually, preparation is done very well. That is also one choice. But I think that part distal to the stent, there is something which is not allowing your stent to go. Next time when you prepared very well, it is gone easily. But what size of balloon you took for preparing the LMCA? Next time.
For the pre-dilatation? For
No,
LM?
after the post-stent.
After
You put a
post-dilation,
2.75 stent earlier.
3.5.
3.5.
Yeah. At very high pressures.
You actually thought about single stent strategy only in the initial attempt.
No, we intended to put 2 stents.
So
But
once you intended to put a 2-stent strategy, why do you take a 2.75 stent?
because the distal part of the LAD was appearing angiographically about 2.5, 2.6.
So you actually put a 2.75 stent, possibly after that there is a 2.5.
No.
You actually plan for 2 stents.
Yes.
So that proximal stent, you are actually taking this stent for the distal part.
Yes.
Okay. What I do in my practice always, I put a proximal stent first in every case. So I would have taken my practice will be totally different. Either a 3.5 or a 4 millimeter stent up to the septal artery, then followed by a 2.75 stent distally. That is what is usually I do. I never put a distal stent first. Many people do the reverse, but I don't do that. Anyway, it is nicely done, and escapism is actually, it is well saved the patient, and it is wonderful.
Thank you.
Any comments from, I think I'm not expecting any, one comment.
Sir, initial follow-up was there, but then after a couple of months we lost because we came to know that he had come across border from Bangladesh and he had made some false ID of India. So
you did not get money also?
No, we did get.
You got money?
Yeah, but actually we were strongly interested in the follow-up, so we called at the address noted by him in West Bengal, and then we asked the village police station also that please go to find this person at this address because we want to know what happened to him. But then police told us that he was one of those illegal cross-border persons, so we are not able, and this is a false ID.
Basically in West Bengal, lot of false IDs created.
So
actually, that is the main, Dilip is one of the person responsible.
So we are going to advancing our talk to our vibrant chairperson, who is going to create the complication.
Vibrant chairperson, but actually I'm just telling one request is there. Anybody ask any question, because it is, where is Yadav? Yadav is required for me, because this is actually can invite lot of questions. And it is not simple cases, really complex cases. I just wanted to tell you that everybody create complication. Making comment in that seat is very easy, but creating a complication and getting a lot of negative comment is not easy. Whatever I told negative comments, I heard multiple times. So that is why I improved. So I was thinking that whoever presented will improve by the comments. So stuck rotaber. I will be showing cases and then come back to you. It's a 54-year-old, 58-year-old man. Primary PCI done 2 weeks back. It was not done by me, but failed to open the lesion in the circumflex, not even 2.5 millimeter balloon. Can you take a photograph for me? I'm presenting. Dilip, take a photograph. So this is the lesion. Anybody thinking that any problem there? Oh, I am not. This was the lesion actually. Angioplasty tried 2 weeks back by another operator and then told, sir, it is, when I saw the angiogram, I thought, what is this big about? I can easily open it. So the confidence was there, but they could not dilate. So I immediately put a rota wire. So I put a 1.5 rota wire, moved down and not coming back. You saw it not coming back. The rota wire is rota actually 1.5 not coming back. It is stuck. And basically when you look at the angiogram, you never thought it is, I thought it is very simple. Not coming back. So you can actually see that when you remove, the catheter comes back. The wire is bending down and I was stuck bar. This is the first case I am showing. So what are the stuck bar? You can do manual extraction. You can put one more wire and the balloon dilatation, slit open the rota, that sleeve, and try to remove and keep it there and cut. Surgical extraction, we may be having a lot of methods. So this is actually the manual extraction I am trying. Only the catheter came out, the rota bar is sitting there. Rota wire removed, catheter came out. But the rota is stuck there. I actually, everybody wanted I have to show stuck bar, so I thought that I'll show stuck bar, a real stuck bar. So now again the catheter came back. I was actually afraid, I'm creating dissection in the LMCA. So severe chest pain, check LMCA for dissection. And I thought I lost circumflex. What next? The catheter, it is a 1.5 bar. What next? I put one more wire. One more wire and balloon dilatation. You should actually understand the 7 French catheter. By keeping the sleeve, one more balloon cannot accommodate a rota bar and a balloon. An additional catheter is on the way. That is one choice. That is what actually, and let me, if you have any comment, I can do the same thing. But you should see that it is come out. So, what I did is actually, you just look at, I taken the catheter deep inside and touching, it came out. This one way of taking out. Either a guide liner or the catheter taken inside. So slit open the rota catheter, pushing the guide catheter to the tip of the bar. That was the way it has come. Then actually I put the fill ref C wire, 3 into 12 millimeter balloon. Even if you do something, you will be creating 2.5 millimeter balloon, dilated, 2.75 into 28 down. I put another stent, 3.5 into 24, promise premier stent. And final result is like this. And we got an excellent result and came out. So the conclusion is that calcified lesion is a challenge, and I will actually, presence of mind. This is a second case, much more interesting. 68-year-old female, distal circumflex CTO, LAD diffuse calcified disease, proximal RCA CTO, came to me after doing an angiogram outside. OM1 and OM2 are graftable, RPD are graftable, LAD endarterectomy, patient denies surgery. One of the cardiac surgeon told you will die on the table by surgery. The plan, PCI to the codominant CTO and then PCI to LAD. That was my plan. Initial wire did not cross. The circumflex actually I put a Gaia second wire. Then I put a 2.5 into 12 millimeter balloon. You can see the dilatation. Nothing is dilating. I took a 1.5 bar. Actually that part, after that part, 1.5 bar is not going down. So I just wanted to open the circ first. Then I took a 1.25 bar. You can see that 1.25 bar is going down in the second frame. I dilated totally, 2.75 into 12 millimeter balloon. Then I put a 2.5 into 32 DUS, 2.75 into 28 DUS. 2 stent is done. got a very good result. So you'll be thinking that what this fellow is presenting. So the circ is done. I send the patient out. PCI to LED planned after 2 days. So this is an LED lesion. Filtrate wire crossed easily. After 3 days, I put a 1.5 into 15 millimeter balloon. Balloon ruptures. Heavy calcium. I was under the impression it is easy. Dissection. 2 into 12 millimeter balloon, not yielding. And even the patient party, in the initial level, I told there is a 25% death. They accepted everything. So after 3 days, they were under the hope that nothing will happen. You see, I took a 1.25 bar. That is the major mistake I have done. You just look at. Bar got stuck. It's a very small vessel, diffuse vessel disease. I thought I got stuck there. Stuck. So what is the next thing? Manual pulling. Catheter deep throttled. Pull the bar. Failed. Old lady, nothing is coming out. Increase the support. Guide extension, persisted pulling, failed. So you actually cut the sleeve there, cut the drive shaft as close as possible to the black rubber, then pull out the plastic drive and shaft, load the guide extension again, advance the guide extension against the bar, attempt to deliver. Next is actually not possible. Next, attempt to deliver a balloon next to the bar. Filter FC, and we put a Gaia second now to cross again. Balloon is not doing anything and the wire is on. 2 wires now. Flow reduction, LED hypotension. There is a subintimal dilatation. External crushing. I was thinking I will do a subintimal dilatation, external crushing. In the meantime, I called the surgeon. I don't refer any single case to surgeon, You think that the surgeon will be happy with me? He was telling you just get lost and you do whatever you want to do. Gaia third cross distally. So subintimal dissection. I just Gaia second not possible. Gaia third I went. I put a 1.2 millimeter balloon, 1.5. I dilated in the near the rota bar, created a subintimal part, 2 millimeter balloon. Patient is restless, hypotension on dual antibiotic, on NIV now. Pulled after 2 millimeter balloon. Failed. 2.75 millimeter balloon I trapped in the proximal part, in the second balloon. Then I inflated in the balloon in the catheter. I tried to put everything out, pulled back. Only the catheter came out, nothing came out. 2.75 millimeter balloon, trapping, pulling down, failed. These are all the techniques written in the textbook I applied. Everything failed. Restless, operator nervous, BP 70/40 on dual antibiotic. 2 millimeter balloon I put distal to the rotabar now. Trapped. That is actually in the subintimal part I am doing all these things. Failed. No flow, hypotension. The patient's battery is only 1% now. Removed guide catheter wire, surgical extraction, called surgeons, cardiac arrest in 30 minutes, and patient expired. So the burr entrapment should be avoided by gentle pecking movement, short runs of rotablation. Too high burr speed should be avoided. Halfway rota is one choice. Smaller size OPN balloon could have helped, we don't know. Call surgeons for help. Halfway rota is actually one. Even if you don't cross, you can just reach that point and then do rota, take a balloon now. These are the things. Whatever is written in the book, everything I tried. I failed. I have done more than 500 rota bar, 5 stuck bar, 1 death. I could extract 4 manual. This was the death I have shown. 2 patients has major slow flow. Actually, 1 patient actually has a single surviving vessel that has a slow flow. That also I lost. 2 patients died, and rest of the things doing very well. These are all actually in hospital complication I am telling. I think 512, the numbers I am going to publish now. We are actually on the verge of writing the article. I am just telling that rota is actually not a simple thing. all the rota stuck bar except one, that is 1.5. 4 stuck bar is with 1.25 bar. And one patient died, rest of the patients survived. But that doesn't mean that. You have to prepare the lesion, you mentally prepare for everything. But I learned one thing, in angulated vessel, never use a 1.25. Even if the vessel is looking small, never use that. Number 2, you can take a laser as the another mode of, once you cross the lesion, you can take laser, which is not available with me. I never used it. And number 3 is actually a small balloon dilatation and then taking the rotabar may help. In this case, what I could have done, I don't know. If this patient I could have left without doing anything also, probably the patient would have done very well because the circ was opened. I don't know. Any questions are accepted, and I finish my presentation.
Yeah. Yadav sir, questions?
I think it was so honest of you to show this presentation to us. But I, must tell that of all the complications, be it perforation, be it dissection, but the stuck rota, the kind of adrenaline it gives you, the kind of helplessness you find, it is second to none. You feel so helpless. I had 3 rotabars, and thankfully they all came after manual traction. And fortunately I didn't lose any patient, but the feeling, 5-10 minutes feeling was terrible. It's just pathetic you feel.
I think I have perforations, I have death in CTO complication actually last, and if you look at our complication rate, minimal complication, I was actually today morning, yesterday I presented the data in 187 retrograde CTO I have done. Only one patient died. 166 antegrade CTO are done in my hospital in Kollam. I do a lot of proctorship, so my number is very high. But that is in 2 years, I had 1 death. But then I usually tell whatever has happened to me, I have no problem in telling. This can happen. At the same time, this patient I told also on table death. But the first time they accepted everything. The second day, after 3 days when I took, they were mentally prepared that whatever this fellow is telling is false because he is exaggerating his complication and telling us. So they do not believe. And moreover, in Kerala, I have a decent name that this fellow does everything and he is a very stable and reliable operator. So that name also saved me. They did not create any problem and they did not pay the full money. That's all. But actually I'm telling, I was very much upset that I lost the patient. That was the most important thing. Since it is my hospital, somebody is not paying, I don't bother. But only point is actually once you lose a patient, I think it is a real tragedy part. I think he has a question.
Actually, whenever you are stuck with a rotabar, there is a huge adrenaline rush, and the operator also needs to prevent from syncope because the condition for 5 minutes, it is quite horrible. We have also experienced it almost 1.5 years back. We have a stuck rotabar. We were able to pull it by manual pulling, but eventually our vessel got dissected. There was no flow. Patient went into cardiogenic shock, but ultimately we were able to wire it with Felder XT, and then again we proceeded with the procedure. But in these kind of tortuous lesions with heavy calcification, what is your experience regarding orbital atherectomy?
Orbital atherectomy?
Yeah.
No, I don't have that. Actually, I have done only very few cases. I don't think these cases you can use orbital atherectomy also. Basically, it was a very, very minimal disease. You can look at the angiogram. The vessel is looking like a 0.25 millimeter or 0.5. I just wanted to open the vessel properly and then putting the stent down. Basically, the vessel itself, you could not take even IVS or anything. You were not even taking a 1.25 millimeter balloon, very difficult. So, but after creating a dissection, I just created the second part, the wire was in the subintimal part. You create a dissection, subintimal area is okay. And then you can put a stent. That is what we do in CTO. When you don't cross, you create a subintimal area in the side part, then you balloon dilate, then do an IVS. Understand that if it is away from the sub-adventitia, you can put a stent. If it is near adventitia, better to not to put a stent, you will create a massive perforation. So I think these are the rare situations, but if you get it, you get it. And nothing you can do it. If you don't, if you do more complicated cases, this is bound to happen. At the same time, you mentally prepare. You should prime the patient and the relatives beforehand and tell that these are the problems. Some of the patients, I have done an angioplasty on a patient of 16% EF with a retrograde CTO. I told the bystanders that 50% death on the table. Even then they allowed me to do. Patient is now doing it at 29% EF. Single vessel, LAD CTO, retrograde. So these things actually, when you tell these patients, I usually tell, but these are the things you can do in this case, nothing more than that. Everything I have done. That is what actually, like orbital atherectomy, they are planning the forward and the backward movement. They are actually telling is these things.
Sir, actually there is a new method of because rotabar
counterclockwise rotation. Actually, there is.
I'm not sure I've properly understood it. If you have seen this.
Actually, no. There is one European is actually showing a WhatsApp message. Actually, after this, many people showed me. This case I have shown in the last, we have a program in Kerala, ICCK. We have shown this case. Then everybody was telling, next day only that came. Counterclockwise rotation. You do a clockwise rotation, you do counterclockwise rotation and withdraw it. See, when you are in a trouble situation, you do a lot of wrong things. And you push the catheter down, and I tried everything. See, when your patient is going to die in front of you, you are trying to do everything, but nothing is working out. Actually, you don't know, I cut the rota bar also to keep it there, but nothing happened. Anyway, thank you for listening to me, and I'm just telling again, complications happen, but we should understand that how to tackle the complication. I wanted to show a death in front of you because don't think that only heroism happens. These things also happens to everybody. Many people does not reveal that. I reveal all these things. Thank you very much.
So with this interesting talk and some sort of sadness because of death of the patient, my boss is telling. Okay, so we conclude this session and let us go for the next session. Thank you, boss.
Thank you so much, sir. Thank you so much for your patience, and finally we are ready to dive for the final technical session, which is on pacing. For this, may I now request the chairpersons for the session to kindly grace the stage. Dr. Dilip Kumar, who is a chief cardiologist from Medica Hospital, Kolkata. Dr. R.D. Yadve, consultant cardiologist from AIMS Hospital, New Delhi. Dr. Birendra Kumar, consultant cardiologist from Bhagalpur. Dr. Bheem, who is an associate professor in medicine from IJIMS Patna. Dr. Ram Sagar Roy, consultant cardiologist from NSMCH Patna. Dr. A.K. Thakur, consultant cardiologist from Patna. Dr. Shashi Prakash, CTVS surgeon from Reuben Hospital, Patna. And finally, Dr. Nasser Abdali, who's consultant cardiologist from IJIC. May I request Dr. R.D. Yadve to kindly call on the first speaker for the session?
Dr. Dilip Kumar. So, first speaker is Dr. Dilip Kumar from Kolkata, Medica Hospital. He is going to talk about conduction system pacing for non-electrophysiologists.
So, thank you so much. I'm going to show you, something on conduction system pacing, which is probably going to replace normal conventional pacemakers in 5 to 10 years. So, it's not the right ventricle which is the target now, it is the conduction system which is the target. And all started with his bundle pacing. Now we have left bundle trunk, left interfascicle, septal fascicles and posterior fascicles, and also the left ventricle, septal, LV septal, septum from left side is also the kind of target. We have Medtronic catheter, we have St. Jude's, and we have Boston stylus-driven catheters, and they all gives us an idea to engage the conduction system and pace, and this is what comes out. You get a narrow QRS with a right bundle branch block, or maybe a very narrow QRS with a normal looking ECG. So we don't want deep septal pacing, we want LV septal pacing or LBB capture or fascicle capture. So these all are included in conduction system pacing, and there are ways to exactly know which site you are pacing, and I will not go in detail because a lot of participants are there who are not quite versed with these intervals, but I will show you the broader things. This is the catheter which all started the conduction system pacing 315 non-deflectable
sheath from Medtronic, and this was the stylusless lead which was used to do the conduction system capture. I will also skip these videos. We go in RAO projection, and we go just 2 to 3 centimeter down the usual his location towards the RV apex, and then we turn to LAO and we go perpendicular to the septum, and then we screw like this. You can see here the hand movements in the Medtronic. Many of the operators say that they can't take the catheter, the lead inside the septum, especially the Medtronic one. And Medtronic one needs a very, very fast and quick movement of your fingers, and then it will go. And the place where we should go in is the parahiston area. And how can you detect that? So from RV septal side, you should see that lead 2 should be upright when we're pacing, AVR AVL should be discordant, and W pattern or a notch in the nadir. So if you get these parameters, you should try to go in, and you can see your QRS changing to QR or an RS-RS pattern. So finally, you take out the lead and go to the atrial lead and position the atrial lead and do a dual chamber pacemaker. The kind of ECG you get depends on where exactly you are pacing. Where you're pacing the left bundle trunk or anterofascicle or posterofascicle, and recording R prime is not the, in lead V1 is not the left bundle branch pacing. You should not be confused, because sometimes the LV septal pacing can also give you a notch in the R, R prime will be there. But you need to know the engagement of left bundle. So this slide, I would like everyone to pay a little more attention, and whosoever interested in conduction system pacing should be knowing this particular slide, thoroughly. So what are the methods to confirm conduction system engagement? When we exactly know that you have hit the bullseye? So you need to know the potentials. If you are getting his bundle potential and you are screwing there, you are perfectly fine. If you are getting the left bundle potential when you have gone in the normal intrinsic conduction, then you are perfectly fine that you are at this right place. And when you pace, stim to QRS will be akin to the distance from where you are pacing. So you are pacing the his bundle, so the stim to ventricle capture will be almost around 40 milliseconds, will be H interval. And if you are pacing at the left bundle, it will be 30 milliseconds. If you are pacing the left fascicle, then it will be 10 to 20 milliseconds. So this is how stim to QRS will be there, small isoelectric line. And the paced QRS morphology should not be having any slurs and notches. And obviously there should be RS-RS pattern or QR pattern in lead V1, and there should be, it should be free of notch, slur, plateau. And then you see the R wave peak time in V1 and V6, and decides that you are you have engaged the conduction system or not. So this was a young gentleman of 42 years, DCM 28% ejection fraction with QRS of 180 millisecond. So I thought he is only 42, so I should be giving him the best possible QRS, and so I thought let's give a left bundle optimized CRT in this patient. And you can see a left bundle lead and a left coronary sinus lead in a proper branch, and then an RA lead. And you will be amazed to see the QRS. It is just absolutely looks like a normal. If I don't say that it was a paced complex, you will pass it as a normal ECG of a patient. So this is how QRS narrowing you can get. The baseline QRS 180, now patient has gone with 85 millisecond QRS. Patient improved drastically in 3 months' time, ejection fraction got normal. So amongst all the permutation combination, be it bi-V pacing, be it his bundle pacing, be it left bundle pacing, you get the narrowest QRS in his bundle, followed by left bundle, and then followed by bi-V pacing. So bi-V pacing, as of now, this is still the indicated one in less than 35% ejection fraction, but all the trials shows more robust LV QRS narrowing and end systolic volume reduction with left bundle and his bundle pacing as compared to your bi-V pacing. So these are all studies which shows the same thing. These are this is from International LBB Pacing Collaborative Study Group, where Shanmuga also, our own Shanmuga contributed huge number of patients, again showed that changes in LV is more prominent and in favorable side with the conduction system pacing than bi-V pacing. So these are all multiple evidence which I will be just flipping through. This is the outcome data from Dr. Vijay Raman,
that it also showed freedom from death or heartful hospitalization was significantly less in CSP versus bi-week pacing. So bi-week pacing probably is a matter of time that it is going to be changed with connection system pacing. This was one patient with 56-year-old male, class 3-4 symptoms, LBB, persistent AF, 28% ejection fraction, normal coronaries. So nothing was there to offer to this patient. This was the QRS of the patient. And then I thought, let's do a AF. So these were the options: AF ablation, CRT, AV junction ablation, CRT, AV junction ablation, his bundle, left bundle. I chose a junction ablation and left bundle because the patient has a large LA of 58 millimeters. So it is not going to be AF ablation, not a good patient substrate. So this was a node ablation and left bundle pacing, and you see here it was paced at 90 heart rate for 3 months, and patient improved, and the LV function improved drastically. So this is one group of patients. If you are going for node ablation and a bi-V versus CSP has got again better outcomes. This was a lady with LBB, intermittent CHB, ejection fraction 45%, and I did not know that patient is having severe scoliosis of spine. And then I took the patient, committing to go for a CSP, and finally I could do connection system pacing in these patients. I can appreciate here how bad the scoliosis of spine was. Every morphology of the heart was haywire, and I had to rely on my electrical parameters. I published that in a curious journal. Now the LOT CRT and HOT CRT, again you get the best narrowing of the QRS here. And sometimes when there is a RBB morphology with QRS of 110, 120 millisecond, not exactly 140 millisecond, these patients also do improve with connection system pacing. These were our series of patients published in our own heart journal, where LOT CRT in patients with refractory heart failure and non-LV morphology. These patients had a QRS of 120 to 150 milliseconds, not more than that, and they also showed improvement in our series. So finally, where are we standing? We have 2023 HRS guideline, which clearly endorses patients with ejection fraction of 36 to 50%, who we are anticipating substantial ventricular pacing. Like all CHB patients, they should be offered CPP, that is cardiac physiological pacing, where CSP also comes in. So it has become a class 2 indication. But for a conventional CRT indication, still CRT is the first choice, and in many cases you can't do CRT because you don't get an access, you can't get a vein, you can't go inside, you can't cannulate, then again a CSP is the option. So we have gradually building a lot of experience and evidence as well. So this is a final case of mine, which I did 1 month back, and you can see here the heart is in right side. The patient had a very bad pulmonary tuberculosis in the childhood, and since childhood there was severe fibrosis and the pulling of all structures, and you can see, and the patient told us that he is having a right-sided heart. So we thought it's a dextrocardia. Then we saw or situs inversus, his echo report showed situs inversus. Then we saw the ECG, there was a positive P in lead 1 AVL. We were quite confused what's happening there. And then we interrogated further. It was a pulmonary tuberculosis healed by severe fibrosis, and this patient had from childhood, after the pulmonary tuberculosis, his heart was in right side. And this patient, without knowing this, we had committed for a connection system pacing. We took him for CSP, and this was the venogram, which was, you can well appreciate here from left side, it is going to right. And the entire exercise happened in the cath lab. What is happening to this patient, why, and we are doing for a CSP. So what we did was, we had no idea what is happening there. So we put the RA lead to RV to get an idea of where the kind of tricuspid valve is, to get an idea about how the RV, which area is giving RV complexes. And that gave an idea for our final lead placement, which got a LVAT of 58 millisecond, and this was the final QRS, final position, and final QRS was something like 90 to 100 milliseconds. And patient is doing well, and we are free of this kind of fear that if suppose the patient develops a
pacing-induced cardiomyopathy. This patient will not develop pacing-induced cardiomyopathy for sure, and it is a done deal for the patient, and he is going to improve in his life. So with this, changing kind of balance, maybe in 5 years' time, the entire balance we see will be in favor of CSP, CRT, and pacing with CSP in most of the cases. Thank you so much for the patient hearing.
Any comments from House?
Sir,
thank you very much.
how did you place the chest leads for that
Yeah, so
patient?
it was just like
that is a biggest challenge.
Yeah, it's just like a dextrocardia. We placed it, and then we went for electrical markers. No, right side, not the left side. So V1 here, V2 here, V3, V4, V5, V6. So we have sent this our manuscript. We are probably sending this manuscript. We are getting preparing it ready for PACE journal, and this is one of the important point. So what were the challenges of doing a CSP in right-sided heart? So we had to puncture quite medially because you have a definite length of your hardware. So it was Medtronic one. It is not that long enough. So I had to puncture not extrathoracic. I went intrathoracic. I punctured quite medially so that it could reach there. I made an extra bend. I did the RA, right atrial lead, first into RV lead. I got an idea of tricuspid valve. I got an idea of RV. Then I went there, and these leads were properly placed just like a dextrocardia to give us an idea of how the 2, 3 should be there, the V1, V2 should be there. The LVAD, we measured what V5, because the V5 lead was lateral in the right side, not on the left side.
And second question is that conduction system pacing, left bundle pacing, we have come with a slate driven leads.
Yeah.
But there are multiple issues where we were used to Medtronic one. It is a softer lead, the sheath is soft, and initially our way was to initial 4 to 5 screws. You tend to
Go
make
faster.
it fast so that we puncture the septum. But the problem with these STL driven
It's not 4, 5. We just screw so that it's going, and we are seeing there how much it is gone in. So we can beat even 20 rotations quickly if it is not making a forward move. But for this stylus driven, you have
They
to be very
usually
careful.
cross.
We have to be very careful. Every turn or 2 turn, you can see there, you can see the QRS. And although the sheath is stiffer, it's stiffer than your Medtronic one, and you are fearful that once you are pushing it hard towards septum, you can do some problem, create some problem. But I think that a Korean guy had come to our center, and he was quite aggressive in pushing the sheath towards the septum. He said, if you are pushing towards septum, nothing is going to happen. It should not be towards anterior wall in the RV. It can cause trauma. So during in septum you go, and then you put a counterclockwise turn so it looks posteriorly, and then you take your stylus driven lead. You kind of give 3-4 turns inside the sheath so that the stylus comes out, and then you go inside, you touch the septum, and then your helix locking tool should be there so that the helix shouldn't come back, and then you give 2-3 turns, look at the EGMs, and then decide where you have reached the conduction system or not.
Actually, what troubleshooting we did for last two cases of STL driven leads, we went through and through. So we thought that no, this is a very stiff turn.
No.
The
It's
sheath
not
is
like
very stiff. The stylet is very.
It's not like Medtronic. It has to be 1 or 2-3 very gentle movement, and see what is happening. You see the advancements, and finally EGMs, and impedance.
Actually, what we did, we gave 1-2 turns so that we enter the septum. Then we pulled out the stylet halfway to the leads so that extra support is removed. Then we were able to get to the proper point.
So with experience it will come. I tell you, initially to start with any hardware, you have some challenge. But 10-12 cases, I also started with stylus driven. I think it was in our device update, it was launched. The CPS locator 3D catheter was launched in India in our device update last December. And then we did some cases. In last 3-4 months, I am getting more confident on that. And maybe we will be doing a workshop here in Medica. So we'll call you.
Sure, sir.
Excellent. Excellent. Thank you very much, Dr. Dilip. Now, next speaker is Dr. Ashish Ranjan Jha from Devar, and his topic is pacemaker implantation in DORV. Dr. Ashish Ranjan Jha.
respected chairperson, I will thank BIC for giving me opportunity. This is a case. Here it not coming. This is a case of transvenous pacemaker implantation in adult outlet in main pulmonary artery hypoplasia. It is not coming. Display नहीं आ रहा. So it is challenging case for beginners. This is a 50-year-old male was referred from local hospital in early 3 a.m. in emergency department with complaint of chest discomfort and recurrent episode of dizziness and syncope for 1 day after tooth extraction. Past history of some congenital heart disease as told by doctor 25-year old, but he was neither on any treatment or any follow-up. He had no any previous medical record also. On clinical examination, SpO2 was 88 to 92%, heart rate was 42 on regular on isoprenalin infusion 2 ml per hour, blood pressure was okay 60. He has a pain digital clubbing, mild central cyanosis. On systemic examination, cardiovascular examination, so S1 normal, S2 single aortic, and there was a grade 2 ejection systolic murmur at aortic area, and other system were unremarkable. This you saw this presenting ECG is that it shows that ventricular rate 40, complete heart block, right axis deviation, T wave inversion was in 1 AVL, troponin was negative, hemoglobin was 19. So we thought this echo, because he had very poor cardiac window mesocardia, we could bidirectional large VSD with overriding aorta, pulmonary artery bifurcation could not visualize there. So we suspected TOF physiology, but we have committed, it was in emergency at 3 am. We thought we will go for the TPI and see if we could do the angiogram also. So provisional diagnosis CAD with unstable with complete cyanotic congenital heart disease, TOF physiology, probably VSD pulmonary atresia, and TPI temporary pacemaker and angiogram we thought. This is by femoral artery we could not cannulate, but radial artery we could cannulate. TPI also was very difficult because it was on fluoro it was showing an abnormal position, but electrophysiology we achieved a correct position. So somehow electrophysiology it was normal epicardial coronaries. So this black. So post TPI, it looks look like LBB of morphology. So it TPI is supposed to be right place, and it has a good electrophysiology. It was correct. So then because patient was in Ayushman Bharat, so we have to decide it. We have to go for further. We should go for epicardial or transvenous, or if any supravenous obstruction, because they are associated with some type of other anomaly like isomerism. So we have informed them that we could go for the epicardial, and we have to go for that surgeon also. So we have gone for the TPI, so we can proceed for the transvenous pacemaker also. So we that time before puncture, we assured that SVC was normal by putting a right cubital vein 6 French angiographic tip regular length thermo guide wire we put at that, we suppose that it was SVC was patent. So the right subclavian extrathoracic puncture was made, and by very methodically we have to try, and after many we have to get a good threshold and impedance. VVIR Medtronic MRI conditional pacemaker was implanted, and it was a difficult process, but somehow we got. This is the final ECG, but you see that what is you can see that this is the post implantation ECG. and this looks like ECG. This lead is abnormal. This is the X-ray, but here you can appreciate it is lead is opposite. So this is post PPI TPI. So after 2 weeks, patient was discharged on third day with heparin, warfarin. For 2 days we have kept in on heparin because of his high thrombotic occlusion, because it is told that it has a more thrombotic episode with transvenous. After 2 weeks, we done the CT pulmonary with cardiac angiography that shows feature of large VSD pulmonary hypoplasia with many MAPCAs was there, and so correctly it was a DORV with many MAPCAs. So take home message: an adult with complex cyanotic congenital heart disease with symptomatic complete heart is a rare event, but now with advancement we can get congenital heart disease, also adult congenital heart disease. Decision regarding transvenous or epicardial pacemaker implantation are controversial and can be very challenging. Transvenous pacing is less invasive and more durable than epicardial system, but with a slightly high risk of thromboembolism. So it is advocated, so we should give them warfarin for whole life. Close surveillance for the recognized comorbidity and lifelong follow-up at a specialized congenital heart disease is recommended. It is very essential, and lead complications were not significantly different from epicardial versus endocardial. It is shown by many studies. Thank you very much for.
Thank you very much, Dr. Ashish. Now next speaker, Dr. Ashok Kumar from Patna. Topic will be planovative solution in patient with mechanical tricuspid and mitral valve needing permanent pacemaker.
Good evening, everybody. So this is my case. 51-year-old female had undergone for mitral valve and tricuspid valve repair in 2012. Then again there was problem, so underwent DVR with both mechanical valve on mitral valve as well as on tricuspid valve, and the valve was ONX. And comorbidities associated with hypothyroidism, dyslipidemia, coronaries was normal, ejection fraction was normal, and C was having atrial fibrillation, was on rate limiting therapy as well as with anticoagulations. Having history of hip fracture in recent past, for that undergone for open reduction and internal fixation, and she was having some pain at the surgical sites. From last 3 months, she is having some sort of pre-syncope. For that, she was evaluated and Holter study was done. That has shown a high-grade AV block with a pause of 2 seconds. And that's why she consulted to his treating surgeon, and they had already advised for epicardial pacing. But she presented in our emergency with this ECG and one episode of syncope. So our resident was ready to put temporary pacemaker, consulted to my colleague, and he asked, just hold on, don't post TPI in patients who has already having a mechanical valve on tricuspid as well as on mitral position. So there were lots of issues. First issue was TPI. So we refrained from putting TPI. So next we put the patients on transcutaneous pacing, but that was not the solution. So we kept isoprenaline solution by the side. Next issue was patient was already on warfarin and therapeutic dose. So there was problem in RV pacing. So we thought how to help her, and so RV pacing was very difficult as she was already having bileaflet valve at tricuspid position. Then we searched. There was one case report of putting leadless pacemaker in those situation, but that is also tried and not indicated as well, but costly and a bit tiring work. So we left with only epicardial pacing, surgical, and we will agree that we all will be agree that epicardial pacing is not a good choice always for long term. So we decided to go do epicardial pacing through coronary sinus. So this is her angiography, and we see that coronary sinus was good. Then we did coronary sinus cannulation very gently with thermo wire, and we regular sheath we entered the coronary sinus. So we entered the coronary sinus without touching tricuspid valve, and we introduced the sheath in coronary sinus. Then we put it the wire, regular which wire we whisper wire was there. So we just searched, and we did the LV pacing. In the meantime, while we were doing manipulations, the patients again started atrial fibrillation with high rate. We checked the parameter, and that was satisfactory. So we stopped here and shifted the patient to CCU. Then we got call from our duty doctor at night with this video. There was diaphragmatic pacing. So yeah, so that was the video. Then again we decided to reposition the lead, and as the next day we are going to reposition, that will be again a challenging thing, because the patient has undergone 2 times thoracotomy, and that was always expected that fibrosis should be more and more, and that's why it was expected. So what we did, we tried very gently different method, different site, but we could not get a good threshold. Threshold was very high, or most of the time the vagus nerve was stimulated, diaphragm was pacing. But fortunately we find a good position this time. So we just changed the direction, and in different vein we gently pushed this lead, and you will see the so here we were lucky enough to get good site, good position, good threshold. So this was, here we stop and we end our procedures. And this was the parameter. Here we got pacing threshold of 0.4. So we were quite happy, and the team who found this was VS. After completing the job, we went for a long drive. Thank you.
Thank you, Dr. Ashok. Any comments? This is the way to go, because both the valves are metallic valves, so you cannot go through the metallic valve. You have to go through the CS into LV pacing. Thank you. Actually,
the patient has undergone twice thoracotomy, so there were lots of fibrosis. Yeah.
Actually, the posterolateral vein, the first he went into the posterolateral vein,
yes,
where the chances of diaphragmatic capture is higher. If you go more lateral, then so you go up is more lateral, so the diaphragmatic is less.
Yeah.
No, lateral wall of the LV.
Thank you.
Thank you, Ashok. Now I call Dr. R.D. Jadhav sir for CRT tips and tricks.
First of all, I thank the organizer who brought me here. Every intervention meeting, they call me.
So I'm going to talk about the challenging CRT cases, tips and tricks only. So if you see, CRT is effective and class 1, still class 1 indication in 2023 guideline where it is clear-cut indicated. Although 30% they are non-responders, but it's still the number 1 treatment at the present moment. But with the advancement in pacing, particularly left bundle branch area pacing, where you fail CS lead implantation, you can do CS lead implantation, you can do the left bundle pacing. So just here one patient, 55-year-old male, DCM with ejection fraction 30% and global hypokinesia, and this is his ECG. And first, we don't, will it run? How to run? Oh, how to? Okay. So, no, it's not running. Okay. So, great. We don't do selective CS cannulation, and no angiography, because if you will do angiography through the CS and if it is wedged, then you may cause dissection. And it is with the levophage, we can see the vein, where is the target vein, and here is the lateral vein is our target vein. This is the lateral vein, and there is some posterolateral vein. We prefer lateral vein as a first choice, this lateral vein. So here we do the angiogram so that we can puncture by seeing it, and we went into the lateral vein of the CS for the CRT lead, CS lead. But here, after we slit it, the lead is coming out. With each contraction, lead is pushed out. So how to keep this lead there? This is not a screwing lead. Although another company, can I go back? So this technique I do. I took out, I put two Teflon wire inside the CS. In one wire, I put your delivery sheet like this, and one wire is raw, and then this wire we put the lead. And another wire we put the right coronary guide catheter with a seat inside here, and then put the PTCA wire in this through the right coronary catheter, guiding catheter, rotate it, put the RCA tip towards the lateral vein, and then put the stent and entrap it. It doesn't going to do any harm to the patient or lead. It doesn't cause any insulation defect or anything like this. Guide is there, PTCA wire went distally, and here stent is deployed. So this is the way to entrap the stent so that entrap the lead so it will not come out. So this is the technique which I developed. Similar thing has been done, and thereafter this is the ECG improved. Then another patient, similar clinical indication, left bundle branch block, left axis deviation, dilated cardiomyopathy, ejection fraction 20-25%, and this is the desynchrony is clearly seen, and dilated LV typical of DCM. Here restrictive filling pattern, and then same technique. We hook the CS by decapolar is our choice, but you can use it multipolar angiocatheter or 6 French, or you can use the AL1 guide catheter. And same here, this is the lateral vein was chosen. Same technique here, the same thing happened. It was with each systole it is coming out. Again we put the stent by another guide catheter into the wire, same technique. So it entrapped it, and this is the final result. Then another, so these are the way how to put the stent, which already, nothing happens. Now venoplasty, like here, vein is very good, but at the origin there is some haziness in the vein, so the lead was not going here. Lead was not going, so we took sub-select, still not going. So we took the PTCA balloon there, dilated the os of that vein, and then with the sub-select, the lead went there and then slitted out, and then we did the CRT pacing. CS dissection. Here, same technique, levophage. With levophage we took deca. This is the decapolar. We take prefixed decapolar to hook the CS. We hook the CS. We put the lead, but this lead came out. Somehow came out, and then tried to hook. This is done by my colleague, and when he hooked, again it was not in the true lumen, but it was in the dissected part. You see, CS is different. CS is away, and guiding is ahead. So whole CS is dissected. Anyway, re-hooked the CS and put the lead properly and did the case. In persistent LSVC is another problem. Again, similar case, LBBB, DCM, this is the ECG, and this is the echo, dilated cardiomyopathy. Yeah, here same levophage. We saw the vein, no problem. We thought we will do it, but when we punctured, there is a persistent LSVC, no connection with the SVC. So here putting the RA lead is very easy. Putting the RV lead is the most difficult. So for that, what I do, I take right coronary angiocatheter through that, rotate it, put the thermo, put the whole thermo into the PA, and then on the PA we put the catheter, and then take the long delivery sheet for CS. For long delivery sheet for CS, and through that we put the RV lead and allow to drop from the PA to RV, that is the RV, and then screw it there in the septum. So same way, and here this is the vein. We found out the vein here, introduced it, the quadripolar lead, and this is the your lead of RV lead into the septum, mid septum, RA lead, and LV lead on the CS lead on the lateral side of the. So this is the final result, and this is the ECG, relatively narrow but not that amount, and this is the ECG. Now another case which just did few 1-2 weeks back. There is a we have to do the lead extraction, and DCM. This patient is a pacemaker, and DCM, and there is a since the pacemaker induced occlusion of the vein is there. So we took out first. We took out the this lead, both the lead extracted, and after that we did the angioplasty, and thereafter, sorry, just a minute. No. Okay. Will it run from here? Yeah. It's running, but आगे नहीं बढ़ा सकते हम. You have to keep with, because it is whole recording is in the this is video from the mobile, so you have to wait for all the whole thing you can see here. One more case and that finishes. A video from the forward कर सकते हैं? Last 10 seconds only to see the lead. यहाँ से नहीं आ रहा. Anyway, we put the 3 leads after that, and patient is doing fine, improved. So I'm going to show another. This is another patient, again DCM, and here we did 4 lot CRT, which already discussed by Dr. Dilip, where there is 4 lead, one ICD lead, another is the left bundle lead, left bundle pacing lead, where this is still driven, and another is the LVCS lead also, and an ATL lead. So there are 4 leads. Lot CRT, there should be 4 leads into the heart to make it ECG like this. This is almost narrow QRS, and lot CRT is indicated when there is a muscle-to-muscle conduction defect. Rather than conduction system defect, there is a muscle-to-muscle conduction defect, and with the left bundle branch, QRS is not narrowing down, then you have to put ideally the CS lead. So very less indicated. Another persistent LSVC, where I did in Patna, I think 4 or 5 months. This is going into the inferior vena cava. This is one branch, again persistent LSVC. One branch is going to inferior vena cava, another one is going to the CS, and another connection is the that is innominate vein. This is innominate vein. So what I decided, because putting the RV lead is more difficult. So here CRT-D was planned. So what I did is this route I took for ICD. This route I took for ICD, and this is the vein where lateral wall supplying the lateral wall. So that vein I took for CS lead. So this is the super selective intervene. This is sub-select from the Medtronic. This is Medtronic device, and this is the ICD lead from that vein, innominate vein, and then this is the lead. So ATL lead, RV lead, and this is the lateral CS lead. So this is the last case in persistent LSVC with innominate connection. And thank you.
Thank you very much, sir. Any comments from?
Thank you. Actually, I have to go.
Okay, now next topic will be pulse field ablation in atrial fibrillation. For that, I call Dr. Ajay Sinha. Please.
Oh. Okay. Yeah. So good evening, friends and chairs. Most of the chairs are, known to me very well. Birender ji, Dr. Yadav. Evolution of atrial ablation in atrial fibrillation has been the story of about 30-35 years. And the first thing which came in was classical thermal radiofrequency ablation, followed by cryoablation, and then finally the newest innovation in this field is pulse field ablation. Why I thought about this topic is I requested the CSI people, the Bipin and all, that because I have seen this procedure being done by one of my colleague friend in USA, so I thought why not discuss this topic with you all. Let me thank all these people who have inspired me in the field of electrophysiology. M.K. Das, Dr. Das was the first person to do ablation of atrial fibrillation in Patna. And you remember in about 2015, we had a national conference in Patna where 2 workshops were conducted. For structural heart disease, it was from All India's IJMS, and for EP, this was done from Paras Hospital. Dr. B.P. Singh would be remembering it. And Dr. Mithlesh Das was the first person who did AF ablation, and we borrowed carto mapping system from industry. Mintu Turakia is a very famous guy with whom in Stanford several times I have gone in the lab doing ablation. And so is Sanjeev Narayan, a big person in the electrophysiology. Of late, Sunil Jha is the guy who was doing pulse field ablation, and I was there in the lab with him recently in the month of March only in Memphis. He works in Memphis. And finally, I have put 2-3 pictures who have supported me in my learning. And one of them is Dr. Narasimhan, and I must not forget, I say my Gurudev, because he has, I have learned a lot from him. When I came to Patna from a district town, Dr. B.P. Singh was there, and we were together, I would say, as a friend or philosopher or a guide. Now, this global epidemic of atrial fibrillation is very well known, and we are having a prevalence of maybe around nearing 59 million. So that is the number of people. This is known to all of us that AF management has got 3 pillars: anticoagulation to avoid stroke, better symptomatic control, and comorbidities, taking care of those.